ಡಾಕ್ಟರ್ ಮಿನಾಲ್ ಕೇಳಿ
ಶ್ರೀ ಲಲಿತಾ ಅದು ಕೇಳಿದಿರಾ?
ಇಲ್ಲ ಸರ್.
ಲಲಿತ ಸಹಸ್ರನಾಮದು
ಇಲ್ಲ ಇಲ್ಲ
ಇದ್ರದ್ದು ಶ್ರೀ ಲಲಿತಾಂಬಿಕೆದು ಒಂದಿದೆ.
ಓಕೆ ಓಕೆ.
ಚೆನ್ನಾಗಿದೆ. ಶ್ರೀ ಚಕ್ರರಾಜ ಸಿಂಹಾಸನೇಶ್ವರಿ ಶ್ರೀ ಲಲಿತಾ ಅಂಬಿಕೆ.
Sir, we are live.
Oh, go ahead.
Okay.
Yeah, okay. Thank you.
You're putting any folder, Neelam?
Yes, I have. शेयर करेंगे बटन है. મને એમ કે મ્યુઝિક નથી આવતું.
मुदाकराटमोदकं सदा विमुक्तिसाधकं कलादरावतंसकं विलासिलोकरक्षकम् अनायकैकनायकं विनाशिते बदैत्यतं नताशुभाशुनाशकं नमामि तं विनायकं नमामि तं विनायकम्. नथेदरादिभीकरं नवोदितार्कभास्वरं नमत्सुरारिनिर्जरं नतादिकापदुर्धरं सुरेश्वरं निधीश्वरं गजेश्वरं गणेश्वरं महेश्वरं तमाश्रये परात्तरं निरन्तरं परात्तरं निरन्तरम् समस्तलोकशङ्करं निरस्तदैत्यकुञ्जरं दरेतरोदरं वरं वरेव भक्त्रमाक्षरं कृपाकरं क्षमाकरं मुदाकरं यशस्करं नमस्करो नमस्कृता नमस्करोमि भास्वरम् नमस्करोमि भास्वरं मुदाकराटमोदकं सदा विमुक्तिसाधकं कलादरावतंसकं विलासिलोकरक्षकम् अनायकैकनायकं विनाशिते बदैत्यतं नताशुभाशुनाशकं नमामि तं विनायकं नमामि तं विनायकम्.
Neelam, you're putting the folder? Okay, Vishwanath, you can start.
So, good morning, all of you. Good morning, all the senior faculty and senior members of our group, and all the postgraduates and all the delegates who have logged in. So, it's indeed my pleasure to host this event. And generally they say you should not start a day with an argument, but Dr. Aravinda thinks the other way. He wants to start the whole kick off this event with debates. First of all, I thank Dr. Senior Consultant Dr. Murli Mohan from NH and Dr. Shrikant Hegde for accepting to be the judges of this event. And we all know how good their critical reviews are, or any articles or journals. Probably that's why we thought they are the best persons to judge the event. And secondly, I thank all the head of the departments from BMC, Dr. Ravi, who obliged me, and Dr. Manjunath from PIMS, Dr. Anil Kumar from Ramaya, my own college. And in JSS, we took the liberty to call Dr. BG himself and also Dr. Subhash Chandra. So I thank all of them. for allowing their postgraduates to participate in this. Finally, I welcome all the postgraduates to this event. So if it's okay, I think Dr. Arvind, we can start the first debate.
Vishwanath, first of all, so greetings from Dr. Arvind Diabetes Center, Basaveshwar Nagar, Bangalore. Thanks everybody for being a part of this postgraduate diabetes league. Dr. Vishwanath, I'm sure is the master in organizing this quiz and diabetes league and all. So he's the right person to organize this event. I thank the judges for being a part of this. Dr. Murali Mohan from Narayana Hrudayalaya, Bangalore, Dr. Shrikant Hegde from Shivamogga. I thank wholeheartedly for being a part of this conference and giving your consent to judge the postgraduates. I think this never, any program do not end if there is no postgraduate activity. I always believe in this. Like, postgraduates are the backbone of our medical field. So they have to be aware of these latest happenings in the field of diabetes, and they have to be aware of these virtual events which is going on in the field of medicine across India. And this gives them an opportunity to compete among themselves with regard to the scientific subject. So all the best for the students, Dr. Priyanka, Dr. Vijay from MS Ramaya, Dr. Deepak, Dr. Sudha from BMC, Dr. Arshita and Dr. Manvita from JSS, Dr. Javgal and Dr. Danish from KIMS. All the best, do well. This is just a competition. I'm sure all of you, you will be able to judge yourself, and you'll be ultimately the winner is the science. You always remember that. Dr. Vishwanath, you can go ahead now.
Yeah. So I think the first debate will be between Bangalore Medical College and Ramaya Medical College. Dr. Priyanka and Dr. Vijay Balaji from Ramaya, Dr. Deepak and Dr. Sudha from BMC. So I request the BMC team to do their first 5 minutes of presentation. So Dr. Murali Mohan and Dr. Shrikant Hegde, first 5 minutes of BMC followed by first 5 minutes of Ramaya. Then there will be a rebuttal. I think we can have your reviews and comments, and even Dr. Shekhar has logged in. So please help us in finalizing the winners. Yeah, I think I request Dr. Sudha and Dr. Deepak to start the first 5 minutes of presentation.
Sir, good morning, sir. Am I audible, sir?
Yeah.
Sir, shall I start, sir?
Yes. Yeah.
Good morning, honorable judges and respected teachers. We, the postgraduate students of BMCRI, presenting at the ADC Postgraduate Diabetes League, and we are speaking for the older insulins. Our references are basically from ADA 2020 with international trials and experiences. My first question is, do healthcare systems and payers need novel insulin? I am hereby quoting an article published in the British Diabetes Journal. It says, annual sales of insulin worldwide increased from $2 billion in 1994 to $20 billion in 2014, over 20 years. Much of this is explained by the increasing number of patients being treated with insulin due to the increased prevalence in diabetes, as well as the changes in the attitudes of the physicians, which are triggered by DCCT and UKPDS studies. In other markets, increasing demand for a particular technology leads to increased competition, thus triggering a downward pressure on the prices. But this trend has been largely absent in the insulin space. Thus, the healthcare systems and payers require a clear demonstration of value for any novel insulin products. In other words, if the premium demanded by the manufacturers is high, the payers would rightly seek the evidence for added values, which I am currently seeking from the colleagues of the team. Now, this was the 80th scientific session of the ADA, which was conducted in June 2020, where there was a symposium with the topic, older insulin formulations are back in the spotlight. Well, the topic of the symposium at the highest decision-making authority of the world for diabetes itself is the moral victory to the older insulin. Let me also quote the words of Dr. Destrans, Director of Diabetes Care Center of Washington. She said, there was a reason why newer insulins were developed, but as time has gone on, people are returning to these older insulins. My second question is, do patients need insulins? Patients need more of education and support from healthcare professionals, allowing better use of existing insulins more effectively rather than newer insulin. I would like to draw a comparison. Providing an amateur golfer with the most expensive set of clubs will not make him a champion golfer. Thinking the diabetics as the amateur golfers, it is important to make the patient understand how to self-administer correctly and how to self-titrate insulin rather than providing simpler, easy-to-handle devices. Now, my next question is, why do insulin manufacturers need novel insulin? Note here that manufacturers of computers and mobile phones actively remove older models from the market as newer models are launched. That is because even though the cost of the newer ones are high, the newer models definitely give a visible benefit over the older ones. Now, I would like to keep this point open because Lispro was approved by the FDA in the year 1996, and even after 24 years, the older markets are not out of the market. And I would like to ask if it is just because it has not proven superior to the older ones. Moving on to the ADA guidelines, these are the questions to be asked by any treating doctor before starting any anti-diabetic medications. First thing is the efficacy. When we compare the efficacy of both older and newer insulins, the efficacy is high for both. Hypoglycemia is present in both. Weight change, there is gain in both the insulins. Cardiovascular effects, both are neutral. Route of administration, both are subcutaneous. Renal effects, in progression of DKD, both are neutral. Dosage consideration in CKD, both require dose adjustment. Additional considerations like injection site pain, lipodystrophy, etc., both can cause. And cost, of course, everybody know, and I have promised that I'm not going to speak about cost. Moving on to the trial, in 2018, Guillermo et al. From Georgia, University of Atlanta, conducted an RCT, multicentric trial. The results said glycemic control improved similarly in both groups, wherein the first group was given detimer aspart and second was given NPH regular. In fact, in this study, the blood glucose target of 140 milligram per deciliter before meals was achieved in 45% of the patients in detimer aspart group, whereas it was achieved in 48% of patients in the NPH regular group. Interestingly, 32% of the patients in determer aspart group had at least one episode of hypoglycemia, where it was just 25% in the NPH regular group with a p-value of 0.34. There was also a study in type 1 diabetes, wherein glycemic control with detimer aspart was HbA1c of 7.88, and with NPH regular, it was 8.11, the mean difference just being 0.22. Now, ADS Summit said that newer insulin were brought into the market for the simple reason that the episodes of hypoglycemia were much less. Let's move on to the evidence of the same. The Landmark study conducted in 2006, the aims were to focus on the changes on HbA1c. The secondary focus was for diurnal glucose profile and symptomatic hypoglycemia. It was held for 36 weeks, and at the end of 36 weeks, HbA1c was 7.14 with glargine metformin group and 7.16 with NPH metformin group. Hypoglycemia was lower in glargine metformin group only during the first 12 weeks of the study, and thereafter there was no significant difference between the two groups. Next actually is the large trial. This trial is published in JAMA in 2018, conducted by Lipska et al. In Northern California. I call it a large trial because it was conducted for 9 years from 2006 to 2015, and the sample size was 25,489. Out of this, 1,928 were started on analogs and 23,561 were started on NPH. After 1.7 years of follow-up, 39 incidents of hypoglycemia related emergency visits that will account to 11 events per 1,000 person years occurred in analogs group, and 354 occurred in NPH group, accounting to 8.8 events per 1,000 person years. The study concluded that among patients with type 2 diabetes, initiation of a basal insulin analog compared with NPH insulin was not associated with the reduced risk of hypoglycemia related emergency visits or hospital admissions or with improved glycemic control. These findings suggest that the use of basal insulin analogs in usual practical settings may not be associated with clinical advantages for these outcomes. So with this, I conclude my presentation. Thank you, sir. Over to you, sir.
Thank you, Deepak. Dr. Deepak, it was a really very good presentation. I think a great start to this event. Now I request Dr. Priyanka from Ramaiah to present her viewpoints. And please note, now The other teammates, Dr. Balaji and Dr. Sudha, you need to note down the points, what all your opposite team tells, and I think for the rebuttal that will be useful. Okay. Yeah. Dr. Priyanka from Ramaya. So she will be speaking for the novel insulins. Yeah. So Dr. Deepak and Dr. Sudha, you can note down the points, and for the rebuttal, it will be helpful for you.
Yes, sir.
You can start, Dr. Priyanka.
Good morning, sir. Good morning, everybody. So we are from the College of Ramaya Medical College. So we will be talking for the novel insulins. Before I go in, just a short note on the analogs that we will be talking for. The Lispro, the Aspart, with an onset of action of 5 to 15 minutes, the peak action of 30 to 90, and an effective duration of 4 to 6 hours. And the long-acting being the Glargine and the Degludec. So I will be talking in term with regard to four short topics: the short and the sweet, the physiological, the low sugar, and slow and steady wins the race. Now coming to short and sweet. So as he was mentioning, why is the speed important? Where does the speed matter? So his regard of topic was in terms of the type 2 diabetes mostly. So we will be taking into account a lot of other patients with a lot of other comorbidities with respect to diabetes and requirement of insulin. The first being the CKD and the CLD patients. The CKD and the CLD patients have a very low appetite to start with. And secondly, they also have a decreased metabolism of the regular insulin, and it can lead to a prolonged hypoglycemic episode for which they're already prone. The second point would be elderly. Elderly people and altered sensorium patients, patients on rice tube feeding, and pediatric population do not have a regular time of intake, and they have erratic timings of food intake. And for these patients, this short acting insulin forms a very important role. And coming to the next point being the pregnancy. The pregnant females have to achieve a target of 140 within the first hour. And also in these pregnant ladies, a short acting insulin is not just important for achieving this target, but also to prevent the hypoglycemic episode that can occur 2-3 hours later. So the next point I would like to highlight is the high glycemic index. Indian population, the Indian food diet that we have a high carbohydrate diet, a very high glycemic index diet. And in such population, we have to focus on the postprandial hyperglycemia, which could be detrimental in the patients. The last point, which was something we all witnessed in this COVID pandemic, was the caseload. In patients, when there are cases in large numbers, nurses are quite busy. In order to administer too late would be too bad, and too early would also lead detrimental. So these are the points for the speed and why speed really matters. Coming to the next point, physiological. My point would be that rapid acting insulin in combination with the basal insulin would mimic to the closest to how a body would produce insulin, and the graph speaks for itself. So that would be my second point. And my third point being, again, the pregnancy, lesser hypoglycemic episodes, as well as lesser intermittent hypoglycemic episodes. Now, there is another point that I'd like to make. We all know that insulin is an anabolic drug, so which causes naturally weight gain. And to prevent in a patient with a metabolic syndrome, when the patient is already suffering from a lot of dyslipidemia and elevated weight gain with insulin resistance, such insulins which are short acting can actually, there is a concept called snacking, defensive snacking, which means that a patient with hyperglycemia, when given insulin at a point of 4 to 6 hours, can develop hypoglycemic episode, following which the patient will, obviously the sympathetic system is stimulated, and the patient will start developing hypoglycemic episode. For that, the patient start to take in more and more food, And this eventually leads on to an increased weight gain in the patient. Such episodes are very minimal in cases of rapid acting insulin, because it's not only the onset of action, but the duration of action is also very, very less. So in next, coming to the CLD and the CKD patients, I'd like to talk about the Indian Journal of Endocrinology and Metabolism, the guidelines which says that the dose of insulin needs to be titrated to requirements to reduce the risk of hypoglycemia. And the second important analysis they have made is the newer insulin analogs may be preferred as their pharmacokinetics is unaltered in the chronic liver disease and they have a low risk of hypoglycemia. And the same with the chronic kidney disease, it has been found that the newer insulin analog may have a better pharmacokinetics, and because of this, they have low hypoglycemic episodes and are actually preferred in cases of chronic kidney disease patients. My other side of the topic would be the slow and steady wins the race. This was about the short acting and why the speed is important. Now I will talk about stability and why the long acting is important. Firstly, there is no peak action. The long-acting insulins do not have a peak at all, because of which the hypoglycemic episodes are not present. Second, there is no erratic action. We have seen in NPH that there are 2 peaks, and because of the non-compliance and increased pricks that the patient will have to take in case of the regular insulins is not present in the long-acting insulin. So because of that, there is an increased compliance, a lesser erratic action, and a lesser glycemic variability, and obviously the longer the duration, only once a day injection, which the patient will be happy about. And we all know that severe hypoglycemia can also cause cardiovascular manifestations, and the patients, these patients are already cardiovascularly compromised, so such patients can have a grave effect. And it is very important in an Indian setup because most of the hypoglycemic episodes get either unnoticed or undocumented. And a very important point which is I'd like to make is that safety begins with compliance. No matter how much we discuss about which is better, it is always how compliant the patient is to whatever medication that we're giving the patient. So the lesser the pricks, the better is the compliance. And with I would like to mention that with degludec, the flexibility is very high. It's not that we have to take it at one point. Between 8 hours of interval, we can take it at on 2 different days. It can be taken with a greater flexibility than where the regular insulins are taken. So with all of these points to be considered, not just the type 2 diabetes that we usually talk about, with all the other comorbidities and the other factors included, with other type of populations included, we definitely have to ask ourselves, is old always the gold? Thank you.
Thank you, Dr. Priyanka. I think, again, another good session. So now I request team from BMC to probably you can, so she has put a question to you now. Is all old always gold? So you can go ahead and you have seen her presentations. Probably if you have anything to comment on those presentations, you can please go ahead and tell. So she has put a question, is old always gold? And she has taken 6 points: flexibility, speed, different population. Of course, I already told you pharmacoeconomics is something most important for all, but we cannot discuss in this short time. So other than that, anything else you want to really comment on?
Dr. Vishwanath, can I request you to leave them to do their own summing up?
Yeah, sure.
Otherwise, it helps them to, if they've not been good enough at noting it down. Thank you.
Am I audible, sir? Sir, am I audible?
Yes, ma'am.
Okay. So, good morning, everyone. My worthy opponent, Dr. Priyanka, has very thoughtfully put up regarding physiological effects of newer insulins and regarding low sugar. What I would like to talk henceforth is more evidence-based rather than the theoretical or the hypothetical effects of newer insulins. So all my references are from ADA or from the latest trials. Speaking of tight glycemic control, like my colleague had mentioned before, sweet and short and sweet, it was uncertain whether short-acting insulin analogs were better than regular human insulin for long-term blood glucose or for reducing the number of hypoglycemic attacks, as evidenced by the Cochrane review up to 2018 that included 10 RCTs. Also, there was no clear effect of insulin analogs on health-related quality of life or on diabetic complications. Secondly, let me quote a reverse situation also. When patients shifted from insulin analogs to human insulins, that is in a study with sample size more than 14,000, the results showed that intervention resulted in a very small increase in the population level HbA1c, which was 0.14%, which was statistically insignificant, and even the increase was within acceptable range of HbA1c. Plus, there were no events of significant hypo or hyperglycemia. This was observed in a landmark study conducted in Arizona, published in JAMA 2018. Also, coming to intensive glycemic control or efficiency, if someone wants to still quote the DCCT or the UKPDS study regarding strict glycemic control for microvascular complications, here's what we have to say. Firstly, the ADVANCE trial. It was seen that there was no significant outcome in terms of cardiovascular outcomes despite intensive glycemic control, unlike what my worthy opponent had mentioned before. Also, according to the ACCORD trial, the trial terminated its glycemic control study early because of the finding of increased mortality in participants randomized for very intensive glycemic control. ADA also states that ADA also states that less stringent A1C goals, such as 8%, may be appropriate for patients with a history of severe hypoglycemia, limited life expectancy, advanced microvascular or macrovascular complications, extensive comorbid conditions, or long-standing diabetes in whom the goal is difficult to achieve despite monitoring and effective doses of multiple glucose-lowering agents, including insulin. Let's accept not all of our patients are newly diagnosed diabetics. Also, hypoglycemic unawareness, which is seen after a long-term course of diabetes, a part of autonomic dysfunction. In these conditions, strict control itself is detrimental. Coming more about cardiovascular outcomes, the more recent ORIGIN trial, that is outcome reduction with initial glargine intervention, in which glargine failed to show any cardiovascular benefit over its comparatives with the recent onset diabetes mellitus with high cardiovascular risk. In contrast, the ORIGIN was found to have, there is increased evidence of hypoglycemia and only modest and modestly increased weight gain as well. Also, in contrast, the manufacturer of Digludec, that is Novo Nordisk company, was handed over a rejection letter in the beginning from US FDA denying the approval because of an increased risk of composite endpoint, including cardiovascular deaths, non-fatal MI, non-fatal stroke, and unstable angina, and not many actually know about this rejection that was handed over. With this, I would like to conclude that both new and old insulins are neutral when it comes to cardiovascular complications, and the newer ones can have detrimental effects too. Moreover, the DIGAMI trial, that is diabetes mellitus insulin glucose infusion in acute MI, that was done to look for any advantages of insulin over cardiovascular mortality, design of the trial did not allow the exact the study did not allow to know the exact benefits of insulin itself. Now, yet another microvascular complication, renal, like our opponent talked about CKD. There are yet no RCTs that have compared the effects of two, that is, our regular older insulins and the novel insulins on renal outcomes, or either on slowing of the progression of DKD or on renal safety parameters as for that matter. Yes, there are studies which have been conducted on insulin, were there other agents, be it OHs or other agents, but in between older and newer, there have been no RCTs yet so far, which is why I would like to keep a neutral opinion when it comes to progression to CKD with either of the insulins. Also, Moving on to diabetes care in ICU setup, the AD and the American Endocrinology Association consensus statement on IP glycemic control was, in the critical care setting, continuous IV infusion has been shown to be most effective method for achieving specific glycemic targets, which can be done with regular insulin itself. Now the question is how feasible it is to administer any of the newer insulin IV and in an Indian setting. Hence, is human act rapid still an option in such cases? Coming to outside of the critical care, that is our regular ward cases,
I think Dr.
RCT
Shiva,
conducted in Latin.
I think 5 minutes is up. So because we are just having that time, if you want to sum up in a line or two. Yeah.
Just one last thing, sir. In pregnancy, either of the efficacy of either of those haven't yet been put forth. So again, there is a neutral opinion when it comes to pregnancy. So I would like to sum up, also including telling that also as my opponent put up regarding compliance. Yes, when something is more cost effective, I think the compliance in Indian setup automatically increases. And speaking of high glycemic index in Indian foods, yes, ADA recommends food that is more comfortable and more local for the patient, rather than commenting on Indian food as high glycemic index. Yes, it is, but it is a physician's responsibility to counsel regarding appropriate medical nutritional therapy, and rather than going for something that is not sustainable in the long term. With this, I would like to conclude. Thank you, everyone.
Dr. Balaji and Dr. Priyanka. Dr. Balaji and Dr. Priyanka.
Yes, sir. Can you hear us, sir?
Yeah.
Yes, sir. So my point would still remain, sir. The main focus of the studies that were shown by the other team was regarding the type 2 diabetes mellitus. And I would still stick to the guidelines that I had put in the first talk, in which the KDIGO guidelines 2019 released the article saying that the Lispro is much better compared to the regular insulin with regards to the hypoglycemia. And also I'd like to quote the American Diabetes Association, which released a study in 2007, which also says that the newer insulin analogs are much better in comparison with the regular insulins with regard to both compliance and hypoglycemic episodes. So their main focus of study would be type 2 diabetes, and I completely agree with a lot of the records that have been shown where the regular insulins have been better with regards to type 2 diabetes. But when it comes to the comorbidities that the patients come with, it's not only type 2, it is type 1, it is chronic liver disease and chronic kidney disease, and the pediatric population, and these are the populations that we are focusing about, and which is why the room for improvement for such insulins is what we would still keep our focus on, and say that the novel insulin is a better it is a new approach to how we can treat insulin. And the point about the diet regarding the Indian population is already prone to the cardiovascular complications of the metabolic syndrome, and in such patients where the compliance and the educational status of the patients is very, very low. So in such a situation, I think that going by the novel insulin would be a better approach to how we have so far not been able to control the diabetes in the population of our country.
So do you want to sum up? That's it?
From our side,
hello. Okay, I think Dr. Priyanka has made a case. So now I request Dr. Murli Mohan and Dr. Shrikant Hegde, even Shekhar sir, to have their comments on this event. And probably the marking, you can just message me, sir. Yeah, I request Dr. Murli Mohan and Dr. Srikanth Hegde. I think that sums up the first debate.
Dr. Hegde, sir, please go ahead.
Thank you, sir. First of all, I would like to thank the organizers and Dr. Arvind, Dr. Vishwanath for giving us this opportunity. I would say it was an excellent presentation by both the teams. Both have presented their cases well. They have argued well for the point which they are defending or opposing. To start with, probably the evidence of, maybe I would carry my bias. I shouldn't carry my bias in this topic towards the debate, and it should not influence the outcome of the decision. So I would be trying to be as neutral as possible without giving my views on this topic first. Second, both the participants from BMC as well as MS Ramaiah, they presented case very well. Evidence as such is talked against the conventional insulin. If you go by evidence, the evidence is talked so far is talked against the convention, against the novel insulin. There is nothing to so far. There is nothing much to say that novel insulins are better in terms of glycemic ability, glycemic control, or in reducing the risk of hypoglycemia. This point was very well made out by Dr. Deepak and his team. They have brought out all the evidences from various trials. As the one thing they left out was a large Cochrane analysis, which also looked into these factors, which showed there was no significant benefit with novel insulin over conventional insulin. They summed up their argument very well. On the contrary, though they were disadvantaged from the beginning itself with the lack of evidence, the team from MS Ramaiah also did very well in defending the physiological aspect of the novel insulin, as well as the compliance part, especially with regarding degludec, where they can take insulin, where the flexibility of insulin is much more convenient compared to conventional insulin. They brought out those points very well. They also brought out the point of, they expanded their scope from just type 2 diabetes to type 1 diabetes. If you look at, I would be happy if they had quoted some evidence in favor of those, in favor of novel insulin, especially in type 1 diabetes. If you look at evidence in type 1 diabetes, there is slight advantage of novel insulin over conventional insulin, especially because hypoglycemia in children is a serious risk factor, as well as the flexibility is more convenient with the children. So, and there are some studies to show in type 1 diabetes that novel insulin fares slightly better than the conventional insulin. Probably they should have brought out this fact to further strengthen their argument. That is where, and the second thing is, people may, both the team didn't comment much about the cost. Of course, the cost, there is nothing much to say that conventional insulin are cheaper and the novel insulins are costlier.
No, we had told them not to dwell into pharmacoeconomics, because that would be a disadvantage for the novel insulins.
Both the teams did very well in the even short time of 5 minutes.
Yeah, that's right. That's right.
The 5 minutes, they defended both well. And regarding the counter argument, especially the BMC, I think they diverted from the topic by going into the control aspect. They diverted into the topic by dealing with ACCORD and advanced trial. Probably their point was to say that intensive diabetes control, that's a different topic as such. Now we're discussing whether control with insulin, either conventional or novel insulin. So, but even then they defended about the compliance part, they defended about the diet, and the counter argument by Ramaiah, they also justified well. So overall, it was an excellent debate by both the teams. They presented their points well. And who wins is, of course, it's a difficult thing. Only one has to go forward to the next levels. So let the judges and others will decide it later. But I'll compliment both the teams for done an excellent job. Thank you.
You want to do a super over, sir, by any chance?
We'll see.
if it is a tie, we can do a super over.
If it is a tie, you can have a super over.
1 minute argument for both of them.
Argument. Yeah, sure.
Dr. Murli Mohan.
No, I'll wait till the end, and right at the end, I would like to sum up for both teams, how debating skills can be improved. So I think Dr. Srikanth Hegde has brilliantly summed up this debate. So I don't think I need to add anything.
So can we have 1 over 1 minute match?
No, I mean, let us score them first.
Score them,
Then,
and maybe
if
the
they are
tie-
tied at the end of that, then only the super over.
Yeah, sure.
Just 1 minute before we score, and then we'll pass it on.
Yeah, sure. So I think we'll move on to the second debate. Dr. Shekhar sir, any want to, because just sum up.
Shekhar sir is not online at the moment.
Okay. Yeah, so we'll move on to the second debate then. Can we move on to the second debate?
Yeah. As per the judges want to take some time, or we can move on to the second.
Just a minute. We'll score. Otherwise, we'll forget the point.
Yeah. Sure. So, BG sir is also there, I think. Ravi sir, but Ravi sir, his team is there, so I don't know.
BG sir, any comment?
No comments, Dr. Vishwanath. I'm just a spectator.
BG sir, any this one comments about the debate? First
excellent debate that is
semi-finals.
going on, very well conducted.
Sir, good morning.
It is an opportunity for the PGs to take active participation. I'm eager to see the next debate.
Yes, sir.
So once Dr. Srikanth Hegde sends me the marks, I think we can go ahead. Or we can go ahead with the second topic, sir. Murli Mohan sir is anyway has sent it already. So I think we can go to the second debate because time will be there.
Okay.
Yeah. So I now request teams from KIMS and JSS to be ready. So the first presenter will be from JSS. There is Dr. Harshita and Dr. Manvita, both are there. So kindly start your topic and please stick to the time. I'm going to 5 minutes because we need to finish it before 10 o'clock. So I request the team to start their first 5 minutes of presentation. Yeah, you can start. Dr. Manvita and Dr. Harshita, start.
Good morning, everybody. We are from JSS Academy of Higher Education and Research, debating for intense glycemic control in elderly. Considering the population shift towards the elderly population, and most of them, 30% of the population aged above 60 years being diabetic, the concern regarding the glycemic control in elderly is emerging. The number of diabetics is above 60 years of age is expected to double by 2045. So this becomes an area of interest. Intense glycemic control, even though there are certain studies which have been done regarding the glycemic control in elderly, most of the other studies have considered age of less than 60, and most of them have excluded more than 60 in view of various comorbidities. The studies which have studied glycemic control in elderly is UK PDS trial, ADT trials, advanced trial, and ACCORD study. Intense is important. Intense glycemic control in elderly population is important as we now, since there is increase in life expectancy because of improved medical care, we stress upon the health-related quality of life of the elderly. Poor glycemic control can lead to problems like dehydration, electrolyte abnormalities, urinary incontinence, dizziness, falls, and acute complications of uncontrolled diabetes in elderly, which lead to hospitalization of them. So to combat these issues, intense control of sugars in elderly is important. what are the various areas where intense glycemic control has been proved to be efficacious? One most important variable is cognition among elderly. There are so many trials which have been proved that better glycemic control and intense glycemic control have patients with these glycemic controls have better cognition and lesser decremental in cognition. And the ARIC study, which was done among 5,000 patients, also proved the same thing, that better glycemic control patients have a lesser cognitive disabilities. Mexican Health and Aging Studies, which in BMC Geriatrics, which was published, had proven that a HbA1c of more than 8% or poorer glycemic control has worse cognitive performance. A part of the ACCORD study, that is memory in diabetes trial, also showed poor glycemic control has decreased cognition, and MRI proof of decrease in cerebral volume in patients with poorer glycemic control. The other variables where intense glycemic control becomes important is because of geriatric syndromes. There are geriatric syndromes which are dependent on various factors, and one of the factors is glycemic control. These geriatric syndromes have a massive effect on the quality of life of the elderly. People with poor glycemic control have found to have adverse geriatric syndromes, especially the symptomatic hyperglycemia, where they have dehydration, electrolyte abnormalities, and hospital admissions because of these. Frailty and functional outcomes involving the speed of walking, the psychomotor reflex, and infections leading to more of hospital admission, and urinary incontinence, which is compromising the quality of life. These adverse geriatric syndromes have been found to worse than in people with poorer glycemic control. Tackling the lows, the glycemic control in critical areas as well as outpatient basis in elderly has to be tackled, as we are all scared of hypoglycemia. It is shown that even though hypoglycemia is more common in elderly, but there are also adverse effects because of hyperglycemia. In this pandemic era, we realized that there was poorer outcomes of COVID-19 patients in elderly with poorer glycemic control. We have poorer outcomes in other critical illness also with patients with the poorer glycemic control. In outpatients, even in the outpatient population, there are variables which the patients are suffering, like having adverse geriatric syndromes, depression, increased hospital admissions for infection, and functional disability with poorer glycemic control. What we are all scared of to intensify the glycemic control in elderly is hypoglycemia. Since in this era, most of our population is educated regarding diabetes, and we have drugs which have lower risk of hypoglycemia, like metformin, thiazolidinediones, DPP-4 inhibitors. We think we can tackle the hypoglycemia. Screening of the patients for their cognitive ability, for their ability to overcome, identify hypoglycemia and to overcome the same. Screening for self-monitoring of blood glucose. Screening of the patients for their ability to understand the disease is important when we decide to intensify the treatment. Educating the people, educating the population regarding hypoglycemia and how to tackle the issue will help us intensify our glycemic control and to help them with other variables more than worrying about hypoglycemia. To individualize, we have to do a complete geriatric assessment and see whether the patient can he can benefit from the intensification of the glycemic control.
Dr. Harshita, can you summarize? Because
yes, sir.
Yeah.
The summary of ours will be, there are, even though there are drawbacks of hypoglycemia with intensification of glycemic control, we have, our focus is on increasing the quality of life. Intensification of glycemic control will increase the quality of life by decreasing the cognitive disability, decreasing depression, decreasing infections, increasing the functional outcome.
Yeah. So I think thank you, because we're a little this one. So can I request the next college, that is KIMS team, to present their 5 minutes? Dr. Harshita and Manvita, please note down the points, whatever KIMS people are going to put up, and in the rebuttal, you can always comment on that. Okay? Yeah. Thank you. Dr. Danish and Dr. Amit. So
yes, sir.
kindly start your presentation. Yeah.
Sir, regarding the slides, the other team, can you please remove the slides? I need to share the screen.
Yeah, yeah.
Yeah, thank you. Which is conducted in the diabetes and aging study, where the glycemic control, complications, and death in older diabetic people they have taken into consideration, where the study says that the target of HbA1c less than 8 for older patients is better when compared to keeping HbA1c level of less than 6, where there is increased mortality risk. So this study states that strict glycemic control has mortality in elderly when compared to the standard group. So this is one study.
Amit ji, hello.
Hello, hello.
Yes,
hello.
Now you are audible. Yes, yes.
Oh, sorry. Yeah, sure. Should I start from beginning, ma'am?
No, you start from here. Major cardiovascular outcome. Yeah.
Yeah, sure. So here, from major cardiovascular outcome, so there is a study. This is called as VADT study, which is conducted. It shows that here there is they have seen the macrovascular complications which are seen in the people who are having intense glycemic control and standard glycemic control. It says that intense glucose control in patients with poorly controlled type 2 diabetes had no significant effect on the rate of major cardiovascular event, death, or microvascular complications, with the exception of progression of just albuminuria. So next, the same study, it was extended for another few days, so that concluded that there is 10% reduction in the combined outcome of major macrovascular and microvascular events, primarily as a consequence of 21% reduction in the nephropathy. So there is, so this is the follow-up trial. The initial trial showed that there is a decrease in the mortality benefit. Here, after follow-up of the same trial, it showed that there is no evidence that intensive glucose control during the trial led to long-term benefits with respect to mortality on macrovascular events. So this is so next, there is the ACCORD trial. So ACCORD trial, it was stopped early. So because of increased all-cause mortality in the intensive therapy group, the intensive therapy group had an increase in the cardiovascular mortality. But when this data was reanalyzed, the studying the modified effect of the age, they have considered age less than 65, more than 65. It was found that more hypoglycemia occurred in the older groups. And we all know that hypoglycemia has a lot of side effects in the elderly people. So which I'll be speaking in the next slides. So when it comes to microvascular events, so there is a study which is which is published in the BMJ, which says that effect of intensive glucose lowering treatment on all-cause mortality, cardiovascular death, and microvascular events in type 2 diabetes. It is a meta-analysis of RCTs. It showed that there is limited benefit of intensive glucose therapy on all-cause mortality. So there is no extra benefit of intensive glucose therapy, and it also showed that the harm which is associated with severe hypoglycemia is more dangerous, or more it has it might counterbalance the potential benefit. Whatever the study has benefit, so that benefit is counterbalanced mainly by the severe hypoglycemia and its side effects. So here data even from UKPDS, VADT, Advance, and ACCORD trial showed reduction in the microvascular events in the intense therapy group. However, it should be noted that all these events were very few, and in the ACCORD trial, the composite microvascular outcomes were not different in the both groups. So when it comes to cognition, so there is a study which is done. So even in here, it is the study which is done in the association between hypoglycemia and dementia. So which is in a biracial cohort of older adults with diabetes mellitus. It shows that among older adults with diabetes mellitus, there shows to be a bidirectional association between hypoglycemia and dementia. Hypoglycemia causes dementia, and dementia itself causes hypoglycemia. And this is a Accord Mind trial. Though in Accord Mind trial, there is the total brain volume remained normal, but the significant cognitive outcome were not different between the standard as well as the intense. So just we cannot take into consideration regarding only the brain volume, but Mind trial did not support using intensive therapy to reduce the adverse effect of diabetes on the brain in patients similar to Mind participants. So here we'll not just take into consideration of the total brain volume. We just need to consider the composite cognitive outcome, which was not different between the two groups. And when it comes to functional disability, so there is an article which says that the people who are having HbA1c of 8 to 8.9 showed a better functional outcome when compared to HbA1c of 7 to 7.9. So when there is a better functional outcome, the persons will be better in their day-to-day activities. So next will be the falls. So the relationship between glycemic control and falls in elderly people, here it says that there is higher risk of fall because of hypoglycemia in tighter glycemic control when compared to the standard group. So
can you summarize?
Yeah. So here the falls are more, the fractures will be more in the hypoglycemic group. So and even hypoglycemia will have the per se will cause increased CVS risk. So and there are few things even so as to summarize, even the lot of guidelines, the ADA, American Geriatric Association, the AEC, and International Diabetic Federation, everything will have all their guidelines for the elderly people will have a relaxed HbA1c level rather than an intense group because of cognition, falls, fractures, everything. So I go in the point that we have to have a relaxed glycemic control than a strict control, so which will help the elderly to lead a better life. So thank you.
Thank you. So now I request team from JSS if you have any rebuttal comments on whatever Kim's team has presented. You'll be given about 2 or 3 minutes. You can pick up anything and you want to comment. Please go ahead.
Good morning, everyone. I am Dr. Manvita Nadella from JSS Hospital. And I would like to point out that optimal glycemic control is one of the major goals that all of us are trying to achieve as physicians, be it in the elderly or be it in any age group. We cannot be ageist here. And that is one of the points that I want to highlight. And in majority of the studies that my opponent has pointed out, those studies, they haven't taken into account regarding the drugs that were used to achieve intense glycemic control, and that plays a major role. What drugs that are used to cause control the glycemic levels. So most of the drugs that have to be used, as my colleague had said, the treatment should be kept. It should be kept in mind that there should be drugs like pioglitazones or SGLT2 inhibitors which do not cause hypoglycemia. These are the drugs that have to be used. And again, the prevention for hypoglycemia was not taken into account into most of these trials. Again, the VADT trial that you have pointed out, they did not comment upon, they did not explore the difficulties or the cardiovascular events on an age-related basis. So that does not count exactly to the geriatric population. And coming to the next trial, that the Accord trial, which was aborted, when they went back and they have analyzed, it has shown that the overall mortality was increased in the younger age groups due to cardiovascular events, but not in relation to the individuals who were aged more than 65 years. So again, here we do not exactly know if there is any significance to that. If hypoglycemia is the only reason as to why we are not achieving intensive glycemic control in the elderly, as obviously there are microvascular benefits as shown by all of these trials, and also certain geriatric syndromes, especially frailty, which is associated with increased infections in the elderly and increased mortality in the elderly. All of these are battled by intensive glycemic control as shown by these studies. But if hypoglycemia is the only limiting factor, I think we should reconsider, and there should be more and more studies exploring this effect with respect to the drug profile of the patient and also with respect to the awareness and with respect to the precautions that were taken, which was not done in any of these studies. Thank you.
Thank you, Dr. Harsh. That was very nice rebuttal. And now comments from the KIMS team.
Good morning, everyone. I would like to start my rebuttal regarding the points raised by my colleagues. I want to base my points mainly on 3 points. One is the age criterion. My colleagues have mentioned elderly as more than 60 years, whereas in the International Diabetes Federation, American ADA guidelines, and as well as the American Geriatric Association, the elderly, the criteria they take is more than or equal to 65 years. That is one thing. Second thing, the trials which have been done. There are mainly 4 trials which are done in this per se, which includes VADT, Advanced trial, ACCORD trial, and the UKPDS trial. In the VADT trial, there is no decrease in diabetic complications compared to both the groups. Only a difference is in diabetic nephropathy. Whereas there have been other studies which shows that diabetic nephropathy, once it sets in, once microalbuminuria sets in, the further glycemic control in the elderly does not affect the further progression of microalbuminuria. And second one, coming to the advanced trial also did not show any significant difference in the effect of glycemic control in the elderly compared to the 2 groups. And the third one, the ACCORD trial. The ACCORD trial had to be discontinued because of the effect, the adverse effect which happened in the elderly group because of the strict glycemic control. The trial itself could not be finished because of the side effects which the trial caused. That itself is enough of evidence to know that we should not do strict glycemic control in the elderly, people more than or equal to 65 years. And the final point is regarding the financial aspect. For a patient who have to have strict glycemic control, the insulin and the OHAs which require, it will affect the compliance, especially in the Indian setup.
One more thing I just want to note. So hypoglycemia is not just the only thing which is the issue here. Hypoglycemia per se will cause cognitive decline. So cognitive decline is very important in people who are having more than 65 years. So cognitive decline is required for proper adherence, and even the hypoglycemia itself will increase the cardiovascular risk by causing inflammation, and it also it also causes proliferation, and the per se will cause atherosclerosis. So these 2 points. So hypoglycemia is not just the only one thing. The hypoglycemia per se can cause a lot of side effects, which can cause ill effects in the elderly people, because elderly people so very difficult to maintain. So more than 65 years, along with these things, they have other comorbidities like renal problem. So the liver dysfunction, everything will be there. So because of all these things, we would like to tell that so relaxed glycemic control is better when compared to standardized intensive therapy in people with elderly. So
okay, thank you, Dr. Danish and Dr. Amit. I think both of you made a very valid point. Now I leave it to Dr. Murali Mohan and Dr. Srikanth Hegde for the final comments. Meantime, you can also send me the markings so that we can finalize the winners who are going to play the last match. Dr. Murali Mohan.
Again, I will sum up right at the end after the final. Okay.
Yeah. So Dr. Srikanth Hegde, any comments?
This was another brilliant performance by both the teams, and I'm sure this will go to a tiebreaker. Both the teams presented excellently. As in the previous discussion, to start with, the evidence is talked against the intensive control, because most of the evidence comes in favor of a relaxed control. Even the ADA guidelines recommend a relaxed control in elderly population. And the team from KIMS, they highlighted all those studies very well. They highlighted the fact of declining cognitive function and all cardiovascular events with advanced trial, VADT trial. They summarized it very well. And the team which argued for, the team from JSS, which argued for intensive control, they had a difficult task from the beginning, but they did it excellently well. They highlighted the points about the cognitive dysfunction, they presented the facts about increasing risk of infection, increasing risk of other comorbidities with less control of diabetes state. They highlighted the point very well. But when it comes to the rebuttal, the points, evidence which anyway, when you are swimming against the current, when you are swimming against the evidence, you have to be very strong. And there was a brilliant rebuttal from the JSS team, which argued for intensive control. They rebutted they brought out various facts which are lacking in the trials which were quoted by the KIMS team. Like all these advanced trials, they were done much earlier. They were done at least 10 years earlier, when the drug profile of those patients were important. Most of the trials were done with insulin, sulfonylureas. None of the newer drugs like DPP-4 or SGLT2 inhibitors were tried in those patients. So they brilliantly brought up that point to counter the arguments and counter the evidence from the earlier trials. So even coming back again, the team, in their rebuttal for the KIMS team, they also brought out the point about going beyond just hypoglycemia with increasing risk of cardiovascular events with hypoglycemia. So it's, in a way, both the teams participated very well. It's a debate. The point is, you have made your point very well. Both of you have made your point very well. And there is no definite answer for that. Whether it is intensive control is better, how much, if it is intensive, how much intensive? Are we trying to bring blood sugar, HbA1c to 6.5 in an elderly person, or we are trying to bring even up to 8.5, which is the recommended? Most of the people who do not maintain diabetes status well, even their HbA1c maybe 9, 10. So even bringing it up to 9 also matters. 8.5 or below 8 also matters, where the risk of hypoglycemia is taken care of. If you are, so I think this will go for a tiebreaker. Let's see the other judges.
Thank you, Dr. Shrikant. Sir, I think both of you can send me the marks immediately. Sir has sent. If you can send. Meantime, I request BG sir, who is there, can add to it, because by that time, Dr. Shrikant and Dr. Murali Mohan will send me the markings.
Thank you, Vishwanath, and thanks the judges for excellent handling of the session. I'll be refraining from any comments because our team is there, and only disclaimer is that they have not shown the presentation and we have not influenced their presentation anyway. All the best for all the good performers. Let the better performer who has a little edge win the debate.
The first team, the first between BMC and MSR, Dr. Murali Mohan and Dr. Shrikant have sent their marks, sir. And depending upon that, BMC has scored 28 out of 40 and MSRMC 24 out of 40. So BMC enters the final league. So I think that is the one. Now they're deciding between JSS and KIMS. So once they decide, we'll have the last podium finish. Yeah.
Dr. Vishwanath, can I have some comments?
Yes,
Yeah,
sir.
please.
Regarding the first one, which has already been adjudged.
Yeah.
I am so surprised and pleasantly happy with the level of postgraduate understanding when it comes to the current clinical trials. Very, very fantastic. Congratulations to all of them. Regarding the insulin, old versus new, the BMC has really done a good job, because they have brought in the, what happened with MS Ramaya was they just told about RCTs, in the controlled environment of how a clinical trial is done. Very little was talked about real world evidence or real world activity, which BMC to a certain extent brought out. It's very important when you look at it. There is 2-3 things that we have to look at. One is called as price conundrum. I'm not talking about pharmacoeconomics. Price conundrum. In Italy, it costs you about 60 euros. In Canada, it costs you about 100 Canadian dollars, but in America, it costs around $1,500. Not pharmacoeconomics, the conundrum. You all know about the type 1 diabetes in America, the problem they're facing. This is one thing BMC attempted to talk about. The second one is, in real world, does it really matter? You have the answer from Germany. They said no, unless there is a compelling evidence, newer insulins have no role. This is my
one more. I would like to add, probably when I was a postgraduate, maybe nearly 28, 29 years ago, if I was asked to discuss about these things, definitely I would have failed. I would not have presented. That way, I'll give full marks for all the 4 participants. They have done an excellent job. And regarding this insulin, again, one more point is, there is what is known as patent, evergreening of the patent. Even after 100 years, nearly 100 years of insulin discovery, we do not have a patent-free insulin. It is because every 3 years, every 10 years, there's a slight modification and it goes on with newer insulin. Oh, okay. So, sir,
Dr. Srikanth, I sent you one message.
Yeah. Oh, it's...
how to go about now? It's...
If it is a tie, we can go for super over. We can give 1 minute chance for the each
you have
team.
the time set?
It's not tie, actually. It's a slight, maybe.
Or Dr. Shekhar or someone can decide it.
Yeah, they can put a mark. They ask them to put a mark, and so you can sum up the 3. Right? It's not a tie. It's almost a tie. I can say it's almost a tie.
Almost a tie.
Almost a tie.
Anyway, I think it's 0.5 more for JSS, so I think we will go ahead because you have given 15 out of 20 and sir has given 15.5. So I think JSS, it will be finals between JSS and BMC.
Okay.
So it was really narrow margin.
I think that's very fair, because when I was scoring, my overall impression was that JSS did a slightly better job. Both teams were excellent, as Dr. Srikanth Hegde and others have said. And I'm actually in awe of our students, postgraduate students. I would never have been able to do something like this as a postgraduate, quote so confidently from papers, from previous studies. I'm not even sure I knew of the Cochrane review when I was a postgraduate till quite late. So very impressed with them. But I put JSS just marginally ahead. When I was actually totaling it up, it came to the same. But
just 0.5 marks.
I think my impression. So I think that's fair. I think we should go ahead JSS versus BMC.
Yeah. No, I
so
request,
it was just like a last ball, whether it was a 4 or 6.
Yes.
Just a narrow margin.
Yeah. They
ball fell on the line.
They were swimming against the current, but they did it well. That's where I scored them little ahead of the other team. Not that the other team didn't do well, but especially when you are speaking a topic where evidence is stacked against you, that matters.
I think. Shall we go ahead with this one, sir? Final, because time is something. Which,
yeah. We can go ahead with finals.
Yeah, I request BMC team to start the presentation. It is SGLT2 as second line versus still sulfonylurea versus second line. Dr. Deepak and Dr. Sudha, you ready with the finals? And I request you to kindly restrict it to less than 4 minutes, because some of we need some comments from the judges at the end, because that will be very useful for us. Dr. Deepak, you can start.
Sir, am I audible, sir?
Yes.
Yeah, you're audible. And kindly restrict it to 3 or 4 minutes. Yeah? Okay.
Good morning, honorable judges, and we are in the final of the ADA Diabetic Debate League, and we, the students of BMC, speaking for versus sulfonylureas. Now, straight away, I will start with the ADA recommendations. ADA recommendations 2020 says that metformin is the first choice of drug, and the second drug metformin. These are the first thing is the atherosclerosis dominant. Then the preferable choice of second line LP1 or SGLT. If the patient has got heart failure or the preferability will be SGLT2 inhibitors. If there is a compelling need to minimize hypoglycemia, even then either a DPP4, GLP1 or an SGLT is the drug of choice. And even when there is a compelling need to minimize weight gain or to promote weight loss, even then the choice will be SGLT2 inhibitors. Now, as I mentioned in my first debate, these are the points that a physician has to think before starting any antibiotic. Hypoglycemia, weight change, cardiovascular effect, cost, route of administration, and renal effects, and of course, the additional consideration. If we put SGLT2 inhibitors under these headings, there is no hypoglycemia, there is loss of weight, and there is benefit of atherosclerotic cardiovascular disease with canagliflozin and dapagliflozin. And in progression of CKD, there is benefit of SGLT2 inhibitors. When compared to sulfonylureas, hypoglycemia is more, there is weight gain with sulfonylureas, and for progression of DKD and cardiovascular disease in both these conditions, sulfonylureas are neutral. And also FDA has got a special warning on increased risk of cardiovascular mortality based on sulfonylureas. Remarks in ADA 2020 were for patients with established atherosclerotic cardiovascular disease or high risk of ASCVD, established CKD, heart failure, an SGLT2 inhibitor with the demonstrated CVD benefit is recommended as part of glucose lowering regimen independent of A1C levels. To add to this concept, the prevalence of atherosclerotic cardiovascular disease in type 2 diabetes is around 45%, and the population at risk of this is around 17% worldwide, totally making the tally up to 63%, which means that all these patients need SGLT2 inhibitors as per the ADA guidelines. And also, the prevalence of CKD stage 2 or more in type 2 diabetic patients above the age of 60 years is around 47.1%, again makes SGLT2 inhibitors as the choice in this group. Recommendations 12.11 in older adults with type 2 diabetes at increased risk of hypoglycemia. Medication classes with low risk of hypoglycemia are preferred. This is from the ADA. Sulfonylureas and other insulin secretagogues are associated with hypoglycemia and should be used with caution. SGLT2 inhibitors which are administered orally, which may be convenient for older adults in diabetes. In patients with established disease, these agents have shown cardiovascular benefits. It's not just ADA. Let me go out to few trials. This is a cardiovascular outcomes of SGLT2 inhibitors in patients with type 2 diabetes. It concluded that using population-based data, incident use of SGLT2 inhibitors was associated with a decrease of CVD compared to use of or DPP4 inhibitors. These findings were consistent between dapagliflozin and canagliflozin, suggesting that CVD reduction is a class effect of SGLT2 inhibitors and not just of a single drug. In addition, lower risk of hospitalization because of heart failure when compared with sulfonylureas and DPP4 inhibitors, and lower risk of extremity versus sulfonylureas. This is a JAMA landmark study conducted in Florida, association of second-line anti-diabetic medications with cardiovascular events among adults with type 2 diabetes. The sample size was 132,000 plus with type 2 diabetes. The conclusion and relevance were among insured adults with type 2 diabetes initiating second-line anti-diabetic therapy, the short-term cardiovascular outcomes of GLP-1, SGLT2 inhibitors, and DPP4 inhibitors were similar. Higher cardiovascular risk was associated with use of sulfonylureas or basal insulin compared with newer ADM classes. Hence, clinicians may consider prescribing either GLP-1 receptor agonist, SGLT2 inhibitors, or DPP4 inhibitors more routinely after metformin rather than sulfonylureas or 132,000.
Dr. Deepak, can you just summarize?
There was a meta-analysis of yes, sir. Yeah. SGLT2 compared with sulfonylureas. Despite similar glycemic efficacy in both the groups, long-term use of SGLT2 as add-on had more benefits. In addition, SGLT2 inhibitors produced less hypoglycemic events and led to greater reduction in both weight loss and blood pressures when compared with sulfonylureas. I'll just sum up with the Indian meta-analysis also, where they have shown these advantages of SGLT2 inhibitors. First one is mechanism of action is independent of beta cell function and insulin sensitivity, lower risk of hypoglycemia, low chances of drug-drug interaction, better therapeutic outcome as compared to other combinations, achievement of a comprehensive metabolic control, including weight loss, blood pressure control, and uric acid reduction. And there is improvement in cardiovascular outcomes as demonstrated with empagliflozin. Thank you, sir.
Thank you, Dr. Deepak. I request the team from JSS. You have 3 minutes or 4 minutes at the most. Can you please present your part?
Can you please stop the screen sharing, Dr. Deepak?
Yeah.
Good morning, one and all. I would like to kickstart this presentation with a quote: "A known enemy is better than a new friend." And yes, I'm talking about sulfonylureas. As you can see, there's a timeline here. For the first time in 1937, it was identified that certain sulfur-containing drugs used on patients caused an adverse effect of hypoglycemia. In 1950, that was turned to benefit, and we use them as oral hypoglycemic agents. From the year 1950 to 2020, it has been identified that oral hypoglycemic, that sulfonylureas have been the forerunners of controlling diabetes, not just in India, but globally. And that we have to keep in point. And there comes my first benefit of sulfonylureas over SGLT2 inhibitors. The experience that we as physicians have with sulfonylureas. It is almost 7 decades. That's longer than a marriage. So we definitely know which are the pros, which are the cons. And it is also very important to know that a lot of expertise is not required in using these drugs. So in a country like India, where the pandemic is shifting more towards the rural population, in the primary healthcare centers, even a medical officer can prescribe sulfonylureas and they can expect what are the outcomes of using sulfonylureas in these patients. The next important benefit that we have is the glycemic control. Obviously, in almost all the trials that they have used, whatever we discussed in the previous debates about ACCORD trial, etc., sulfonylureas were used in the intensive arm. That means they explain the good glycemic control. And here are 31 trials that were analyzed, which included about 3,956 patients. In a median duration of 16 weeks, HbA1c reduction was found to be 1.5% as compared to a placebo, 1.62% as compared to metformin and other combination drugs, and 0.46% compared to that of insulin. Again, another meta-analysis of 11,198 patients with minimal duration of ECT being around 3 months, contemporary sulfonylureas were found to be efficacious, if not superior to that of other OAPs. Coming to the cost factor, of course, sulfonylureas are way cheaper when compared to SGLT2 inhibitors. And yes, as my colleague Deepak did not fail to point out the cardiovascular risk of sulfonylureas, I want to address this question that everyone seems to be having in the recent years. And for the first time in 1970, the University Group Diabetes Program they have conducted a study where they saw that patients being treated with tolbutamide observed for approximately 8 years. They have found that 75% there was an increase by 75% in the cardiovascular risk. And not everyone were convinced because sulfonylureas were being used so commonly. So in 1977 to 1997, UK prospective diabetes study was conducted, and that showed a HbA1c reduction of 1% can reduce all-cause mortality by 12%, microvascular complications by 25%, and risk of MI by 16%. And again, there comes the question of older sulfonylureas and newer sulfonylureas. And newer sulfonylureas definitely showed that they do not interrupt the ischemic preconditioning, thereby not causing the cardiovascular risk that was expected of the older ones. Coming to the landmark trial, the Carolina trial that compared linagliptin and glimepiride, which helped pharma companies by not pushing out sulfonylureas out of the market. It showed that linagliptin and glimepiride, when it came to cardiovascular effects, were equal. There was not an increased risk with that of glimepiride. And in fact, linagliptin had showed that in individual numbers, there were more cardiovascular effects as compared to glimepiride in the Carolina trial. And that was not statistically significant, but it also shows that sulfonylureas that are in use right now are not providing any significant cardiovascular risk. And coming to adverse effects, hypoglycemia and weight gain, we can easily tackle them. Hypoglycemia, again, with awareness and combination drugs and monitoring regularly, counseling about diet and counseling about simple things like do not exercise in the night if sulfonylureas are being taken at night. Coming to the other
Ashita, can you summarize?
Yes, sir. Coming to weight gain, combination drugs can help, and using precision medicine again like neonatal diabetes and MODY can also be helped. Coming to the conclusion, I would like to say that in the current scenario, especially in India, with the trials not talking about the safety of SGLT2 inhibitors completely, because we have very short duration trials on SGLT2 inhibitors. Sulfonylureas do weigh higher, and there are other drugs to use for cardiovascular benefits in diabetics and the renal benefits. So I definitely say we have to go with sulfonylureas as of today in the current scenario. Thank you.
Okay, thank you, Dr. Harshita. Dr. Deepak and Dr. Sudha, a minute of rebuttal. you want to comment on Dr. Harshita and Dr. Manvita's findings? Yeah, you'll be given a minute. It's more like a super hour because not much time. Yeah.
Okay, that's fine.
Good morning, everyone again. Since our colleague Dr. Manika had talked more about Indian studies, let me start again with the evidence since we are comparing a newer drug with an older one. So Indian meta-analysis found out that in a comparative systemic review that included 14 studies, the results were shown that there was greater reduction in HbA1c, fasting glucose and body weight from baseline with SGLT2 inhibitors than with DPP4 SD inhibitor than with DPP4 without increasing the risk of hypoglycemia. Also, like my colleague talked about control. Breach Candy Hospital conducted a study with canagliflozin 100 mg versus sulfonylurea, which brought out that there was an approximately 14 patients surviving every year per 1,000 patients, and the quality adjusted life years was also increased in terms of 0.43, and there was improved body weight and reduced risk of macrovascular and microvascular morbidity over 20 years. Also, like my colleague mentioned, Carolina trial, let me tell that the Carolina trial involved linagliptin sulfonylureas, and it did not involve the study with SGLT2 inhibitors. Like to question, and diabetes is all about protecting the end organs, in which case liver, kidney and cardiac mortality. This is something new, that as in we all know that diabetes is associated with NAFLD and the incidence is 54% sadly. However, in type 2 diabetes with NAFLD, compared with SGLT2 and metformin gliclazide, SGLT2 administration resulted in less, administration of metformin and gliclazide resulted in lesser improvement in LFT and reductions in HbA1cs as well. Also, the pleiotropic effect and safety of SGLT2 inhibitors was seen, and this study is not. There are recordings from the latest ADA 2020 virtual conference that has told that SGLT2 has a major benefit in preventing and yes, sir. I would like to summarize by telling that yes, known enemy is better than a newer friend, but since we already have Indian evidence and we need more and more studies, we have to allow room for a newer agent when it protects virtually every organ, that is kidney, liver and heart, like the other cardiac studies when it comes to SGLT2 inhibitors. So we need to motivate more studies so that we would rather come up with something new that is lesser end organ damage and more of protection. Even if it is a newer agent, it is our responsibility to train the rest of the physicians regarding these newer agents and bring this into the market. Cost, I would not like to talk. And even speaking of Credence trial, the risk of primary outcome was lowered by 30% when it comes to renal parameter. And the trial was stopped early due to overwhelming benefit of this agent. So this itself, I think, is enough to substitute my point that I would like to consider diabetes not just as a glucose control, but as an entire body. Thank you, sir.
Thank you. Thank you. Thank you very much. Dr. Harshita and Dr. Manvita, your comments. Yeah.
Yes. Even though SGLT2 inhibitors have the benefit of low risk of hypoglycemia and increased cardiovascular benefit, if we talk about the adverse effects of SGLT2 inhibitors, one thing, we all have less experience. We don't know the long-term effects of SGLT2 inhibitors. A prominent adverse effect, urinary tract infection, especially people with diabetes presenting with UTI, mostly going in for complicated UTI, adds to the morbidity of the disease. SGLT2 inhibitors, the capacity of this to cause severe dehydration, which usually in patients who are dependent on others for hydration, like comorbid patients with CVAs, CADs, where it causes severe dehydration, severe hypernatremia, accounting to its morbidity. And regarding cardiovascular benefits, when other drugs like ACE, ARBs combined with anti-OHAs are giving a cardiovascular benefit when in comparison to SGLT2 inhibitors. keeping in mind the urinary tract infection, severe dehydration, and euglycemic diabetic ketoacidosis, which cannot be managed in primary healthcare centers, I would say we would go with sulfonylureas being the oldest gold.
Sir, just one word, sir, because they have mentioned UTI, I would like to quote a systematic review and meta-analysis which was conducted for 77 RCTs, which concluded that the impact of SGLT2 inhibitors on the risk of UTIs remained uncertain, sir. And even the EMPA-REG trial also did not have a statistical significance for UTI in SGLT2 inhibitors, sir. Thank you, sir.
But Dr. Deepak, we are talking about an Indian scenario where UTI is a significant problem, especially in the female patients. And we cannot deal with in the current Indian scenario, we cannot deal with the complications of SGLT2 inhibitors in a remote area like a PHC. And by the time patient requires adequate care, it is going to be a full-blown sepsis, and there are high chances. So we do not know much about this drug as of now. So in today's Indian scenario, we would recommend sulfonylureas, do top it. And coming to the cardiovascular and the renal protective effects that SGLT2 inhibitors offer, we do have more research drugs like ARBs and AC inhibitors that give the same kind of benefit for a much lesser cost. So that's one more thing that we would like to highlight.
Thank you. I think you can go on and on. Really,
it's a tough fight. It's a tough fight.
Yeah. I think both the teams did really well. Now it's left to Dr. Murali Mohan and Dr. Srikanth Hegde to decide.
I'm sure both of them have a tough job.
Meantime, sir, by the time they decide, Dr. Shekhar or Dr. Ravi can add a few points, or Dr. Basavangowda can add a few points.
Dr. Jayant also joined there. Dr. Anil is there.
Jayant has joined. Yeah, he can.
Dr. Anil is there. Dr. Abhyuday is there.
Dr. Vishwanath, I just want to comment. Yes. I think it was a wonderful postgraduate league. I think Dr. Arvind had this innovative idea. So probably it has worked well. And now it is very difficult for the judges to decide. So I think I don't want to influence the judges, but I think it is a very difficult thing. Maybe again a tiebreaker here. So one more thing with the whatever, I think I have given a lot of talks on this SGLT2 inhibitors. Whenever I give a talk on this SGLT2 inhibitors, I see a lot of doubts in the mind of so many doctors in prescribing SGLT2 inhibitors. Now, if I just see the this discussion between the young minds, maybe there will be a paradigm shift in the management of type 2 diabetes in future. So that I think we can definitely have after seeing this young minds discussing about SGLT2 inhibitors and sulfonylureas. Thank you.
Yeah. So just
both the teams had done excellent presentation, and the counter argument, the defense and the counter arguments are both done extremely well. Both have highlighted their points. I would not go into the detail because already the match was truncated by several overs. Even the judges' comments are also truncated. I would give it a tie. I think
as Arvind said, you can go for a super over.
I would call it a tie. Maybe I'll ask.
The time is not there. Go for joint winners.
Ultimately, in a debate, we should get knowledge. We should get knowledge out of the debate, which is because the topic is debatable. Even when the ADA says the ADA ESD recommendation, when they give SGLT2, the compelling indication is when the patients have atherosclerotic cardiovascular disease or renal disease. And the next end, you see the cost when they say weight gain and other things. Next, when the cost is a concern, probably then the first choice becomes sulfonylurea. Those points were well brought out by the point which argued for sulfonylurea. I think I'll leave it to the other judge. Dr. Murali Mohan, please, your comments, sir.
Dr. Vishwanath, can I go ahead, or you want
please,
to?
No, you go ahead. First. You go ahead.
Yeah. So I'm going to spend some time. I hope you don't mind. First thing, as Dr. Srikanth Hegde said, very importantly, and Dr. Anil also mentioned, this is a debate. And the purpose of this is to bring out knowledge. However, it is still a debate, and a debate is a competition. So I think it's important to focus on the competitive aspects of this. Two, this is new technology. If this had been done at any other time other than COVID time, you all would have been there in person. We would have all been in the hall listening to you. And using Zoom technology is very different, and you need to adapt to new technology. Our cricketers took some time to adapt from test matches to one-day internationals to T20, and only those who adapted have succeeded. So some like Sachin, who could do everything wonderfully, have done well. Those who, were in the old style have been left out of things like Cheteshwar Pujara. So you need to learn to adapt to the new technology, which means, your presentation has to be different. Dr. Deepak, your presentation the second time was full of knowledge. It's brilliant. I mean, the content that you had was excellent, but, we couldn't see your slides. So what is the point in putting up a slide that people cannot see? On the other hand, Dr. Manvita, I think, had slides which had one word on it, which is really the way to use a PowerPoint presentation, especially if the audience cannot see. However, Dr. Manvita would have really liked a little more detail on your slides, because otherwise everything depends on how you present it. Similarly, if you have, a statement made, if you make that a visual presentation, it makes it far more effective. And that is absolutely needed to reach this audience when you're talking on a medium like, the internet. There is a fundamental rule in PowerPoint presentations, which is a 666 rule. I don't know if you've heard of that, but the 666 rule is 6 lines in a slide, no more than 6 words in a line, and no more than 6 text slides. Your 6th or 7th slide should be a visual presentation. And I like both your presentations, JSS. I thought they were very well made. The PowerPoint presentation. When you're in a competition, find out how the scoring is going to be done. Okay, and for example, the rebuttal carried a lot of marks. And I think it's very important that the rebuttal should be properly made. And I think especially the final, I think both your teams did an excellent job on the rebuttal, but you shouldn't stick to a pre-prepared rebuttal. Okay, when you make a pre-prepared rebuttal and you're not able to really rebut the other person's arguments, that becomes a weakness. Okay, so you should be able to anticipate what the other person says. And in fact, that is the purpose of a debate, that you can see both sides of the picture, that you weigh up yours, you make the arguments in favor of yours, but you anticipate what the other side is going to say. Look at the proper points and also look at the weak points and bring out the weak points that they're likely to make. So even if you make a pre-prepared presentation, that's what you need to do. Very important to capture the audience's interest from the beginning. So when my colleague, we were doing a presentation on allergy, I spoke on asthma, he spoke on allergic rhinitis. This was a personal talk. Everybody was waiting to settle down. People are talking to each other, moving chairs, noisy. He came up to the podium and gave one huge sneeze. Okay, and when you hear a sneeze on a microphone, amplified, everybody stops and they looked at him and he says, that is going to be the subject of my talk, sneezers because of allergic rhinitis. And he had the audience grabbed from the beginning. Very, very important is to use your hands. Don't, most of you have your faces there. So stand back away from the cameras so they can see at least half of you. The hands and the eyes are a very important part. So when you're talking, look at the camera, use your hands to make a point. Okay, don't be happy with just saying things. A presentation is you making a presentation. Otherwise, you could write an article and people could remember it. Okay, so it's very important when you make a presentation to make your presence felt there. Very, very important. Rehearse, rehearse, rehearse. If possible, make a video of yourself rehearsing, because then you're obvious, you're all that, which can be quite irritating online. Will, in fact, it gets magnified online, then you can make an effort to correct yourself. Last of all, stick to time. Okay, all of you overshot time and overshot time badly. In fact, in the last Capicon, where Dr. Vishwanath and I were both involved, we subtracted marks for people who overshot time. That is very important. You have to respect your audience, even when you're making a public presentation, stick to time. And in a debate, that becomes very, very important. In most debates, time is of the essence. I think, I've just given you criticisms, but I must appreciate your knowledge. I mean, your knowledge was outstanding. And especially in the last rebuttals that both of you came out with, I thought you all exhibited your knowledge, that you all really knew your topics well. So hats off to both of you. Last of all, some 3 comments for the organizers. Excellent initiative, Dr. Arvind and Dr. Vishwanath. I think this is brilliant. I'd love to see more of postgraduate debates. We always have a lot of pro-con debates, but I'd love to see most of postgraduate debates, and I think they can teach us quite a lot. The second suggestion is, because they were overshooting time, Dr. Vishwanath, can next time you organize a warning bell at 4 minutes or 4.5 minutes, so they know they have to sum up. Okay, so that will be very, very useful. And last of all, a rebuttal is such an important thing that I want next time we can give them about 2 minutes to prepare their rebuttals. So they have time to sit down, maybe make a PowerPoint, 3 or 4 PowerPoint slides, which will aid their presentation, but really think about how they're going to rebut the whole thing rather than launch immediately into the rebuttal. Because again, for me in a debate, the rebuttal is as important as the initial presentation. Okay, thank you all so much.
Thanks, Dr. Murali Mohan. That was an excellent sum up of whole program, whole session. That was really a very apt one for the postgraduates to come up with the corrections and the knowledge. I'm sure all of them have did very well, because I'm sure when I was a postgraduate student under Professor BG, I'm sure you would agree that like doing a presentation itself in the journal club was a big issue, and forget about the scientific analysis, statistical analysis. We were very not up to the mark at that time. Nowadays, these postgraduates are very well up to date with the statistics and the latest development in the field of medicine. That is really good. Now over to Dr. Srikanth Hegde and Dr. Murali Mohan to declare the winner.
I sent the mark to Vishwanath already.
Okay. Dr. Vishwanath, you can declare.
Again, I thought Dr. Murali Mohan. Okay, so both have been marked same. I think this is the second time JSS is edging the other team by 0.5 marks. So I don't know. So it is just 13, and 12.5, something like that. So finally, JSS is the winner according to this one. Yeah, congratulations.
So congratulations.
I'm very happy. I think all the teams did well. Whether teams Ramaya or BMC and JSS, I think as Dr. Arvind said, fantastic. Really, we could never imagine ourselves doing such a wonderful presentation on RCTs, Cochrane analysis, which still I am unable to understand. So, yeah.
So congratulations, JSS team, Dr. Arshita and Dr. Manvita. Equally well played, Dr. Deepak and Dr. Sudha from
I think Dr. Deepak did a fantastic job. I think we should appreciate him.
Yeah, he was an extempore speaker. I think the confidence in him was very good. I think man of the match we can give to him.
Yeah.
Good.
Thank you, sir. Thank you for the wonderful opportunity.
Sure.
Thank you.
Sure. So I should also mention that even MS Ramaya team, Dr. Priyanka and Dr. Vijay, and Kim's team, Dr. Javgal Amit and Dr. Danish Ahmed, they did a very good job. But it's not that, don't worry about winning or losing. The way you participated in a debate is an important aspect. And ultimately, imagine within this 1.5 hours, you gained a lot of knowledge with regard to science. And I'm sure it will help you in your exams. Good luck for all of you. And congratulations, JSS Medical College, Mysore, for being the victorious today. And BMC, Dr. Deepak and Sudha for being the runners-up. Thank you. And I'm sure we will be awarded the prize money as well as the memento, as well as the certificate for your participation and success. Congratulations again.
Thank you, Dr. Arvind, for giving me this opportunity.
Thank you, Dr. Vishwanath. Thank you, Dr. Srikanth. Thank you, Dr. Murali Mohan, for being a part of our conference and being a nice judge which was very difficult. I felt it was very difficult to judge this situation. Very aptly, the point score you did, and deciding the match by 0.5 is always a tough job. Even the semi-final was like that. Even the final was like that. I was just remembering the finals of like England and New Zealand match. I was just remembering that match where it went over super over and super over. It was the feeling like that. So ultimately, one has to come out as a winner. So congratulations. Thanks for being a part of the conference.
And thanks to all of you for inviting us. It was absolute pleasure. It was a learning experience and, an absolute pleasure being here. And thanks to my fellow judge, Dr. Srikanth Hegde, who's always, such a pleasure to be with, such an honor to be with.
Thank you, sir. Thank you. Thank you. Thank you for giving me an opportunity. And I thank Dr. Murali Mohan, Dr. Vishwanath, and Dr. Aravind, and all the participants. I wish all the students good luck and a bright future. Thank you.
Thank you, sir. So moving on to today morning session, we have a speaker from Dr. Nisha Naigil from Canada. Sorry for keeping you waited. This is we had a postgraduate quiz, so that is the reason we made you to wait. I know it is late night in Canada, Saturday night, so sorry for making you wait. Today, the topic for the first opening batswoman. Yesterday, when we started the program, also we had a opening batswoman. Today also we have got a opening batswoman. We always say ladies first. So that is the thing we are carrying on today as well. To make this honor today, the speaker is Dr. Nisha Naigil from Canada. To chair this session, we have got Dr. Jayant Kumar Panda. He is a consultant diabetologist from Cuttack, a very academic person, very active in RSSDI and scientific oriented person. He always does programs oriented to patients as well as for the diabetologist. And the second speaker, Dr. Brij Mohan from Kanpur, but because of some technical glitches and some work, he was not able to join. Dr. Abhyuday Verma from Indore has kindly given the consent to moderate this session as well, along with Jayant Kumar Panda. Thank you, Dr. Abhyuday, the consultant endocrinologist from Indore. So over to Jayant and Dr. Abhyuday to chair the session and take over the further proceeding.
Thank you, Arvind. We are already late, so we should start without any delay. The diabetes management is moving towards technology-based. More we are advanced in the technology, more we want to use the technology in the diabetes care. And the present day focus is how we can make it very systematic so that there will be no chance or no slip in the management of the diabetes in our patients. So to speak on the topic, we have Dr. Nisha Naigil, who is an endocrinologist and an internal medicine specialist. He's interested in the osteoporosis, diabetes, general endocrinology, clinical practice and diabetes osteoporosis research, and clinical faculty and researcher at NOHM, the Knowledge Translation Fellow, PSI Foundation, Canada, a Young Investigator Award, Endocrine Society, USA. And the topic is the health care technology in diabetes 2025. So I request my co-chair, Dr. Abhyuday, to start the session.
Yeah, good morning, everybody. Thank you, Dr. Arvinda. Really very good topic. And I think without wasting much of time, I invite Dr. Nisha to kindly deliver the lecture.
Dr. Nisha Naigil.
Yeah, good morning, everybody. I'm waiting for the admin to give me permission to share the screen.
Yeah, please share your slides.
Yeah, so I'm waiting. I'm not able to share the, because I think I need the permission from the admin.
Yeah. Neelam, kindly do the needful.
Dr. Neelam, make Nisha a co-host.
Yes.
Yes.
Okay. Ma'am, you can share.
Okay.
Now that you are a co-host, you can share, Dr. Nisha. Please
Yep.
go to please go to share screen.
Trying. Let me see.
Go to share screen and select your PowerPoint.
So now it says that only host can share. So I'm a host, right? Yeah.
Yes,
Yeah,
ma'am, you can share.
You make her a co-host, Neelam.
Yes, yes, everybody can share, sir.
No,
Oh, yeah.
only co-host can share. Host and co-host. Please make her a
No,
co-host.
no, sir. I choose all panelists. All.
All?
Ma'am, yes, ma'am. Please click on share button.
Yeah, yeah, I'm trying, but it's not working.
Yeah.
Okay, it's coming, okay? Yeah,
Yes,
thank
yes,
you.
coming.
Sorry. Thank you
Yeah,
so
yes,
much.
we can see it.
All right, so let's get started. And a big thank you to Dr. Aravinda Jagdisha for this opportunity. And so I'm a faculty at the Northern Ontario School of Medicine in Canada. So this is about 4 hours from Toronto. Toronto is the largest city in Canada. We are in a lockdown now. Okay, so these are my disclosures. So I have had speaking engagements with pharma companies, and some of these names will be discussed during today's talk. But I think the other important disclosures that I did my MD Medicine from KMC Manipal, and of course before doing my DM from SGPGL Lucknow. So that's my attachment to Karnataka. And so we know the future of diabetes is going to be totally different, and endocrinology has been one of the fields blessed with all the advancements in technology, and compared to other fields in medicine, we are witnessing the developments real time, and we are able to use some of these technological advancements in our clinical practice. So I think we are already way ahead compared to our contemporaries from other specialties. But the problem is that the pace of development in this technology is extremely rapid, and many of us are finding it difficult to catch up, right? And even in the academic world, by the time a study is completed on a new device, you're seeing newer versions. It's like seeing a newer version of the iPad or things like that, right? So even for research personnel to keep up, it's been a struggle. So I guess it's very important, even for us as practitioners, faculty, and also our trainees to be up to date with all the technological advances that's happening in the field. But let's be reminded that the most important component in this battle is patient. And we have to make sure that the technology selection must be appropriate for the individual based on access to technology, based on their background, educational level, and based on whatever support system they have around them, right? And we do know that simply having a device or application does not always change outcomes. And we as a human being, we need to have creative, positive health behavior aspects to get maximum benefits out of these devices. And I think most importantly, we as healthcare providers should assist the patient in transitioning to such tools, but make sure that the expectations are realistic. But then at the end of the day, self-care task and self-management is a very important part of diabetes care. But then with these tools, we are finding it easier to manage diabetes. And we all know the way we bank, the way we do shopping, and the way we search for information, everything has changed, and it's so different based on innovation and technology. And so there's no doubt that we should adapt to latest advancements in managing, especially chronic diseases like diabetes, right? So, and then we are also focusing on not volume-based, but a value-based and more individualistic care system. So I'll give an overview of technology in diabetes care. We'll go through the different continuous monitoring devices and insulin pumps, mostly, and some aspects of diabetes prevention and also diabetic complications. So most of this is triggered by this term called Internet of Bodies. So we know Internet of Things, that's the Google and the Internet as we know it is. So Internet of Bodies is based on wearables. So humans are increasingly connected to device that can be worn or implanted or swallowed, things like that. And the best example is a smartwatch. So currently the economy and the market is around 13 billion. It's expected to grow by 18 billion, probably more after the pandemic is settled. So because of all these wearables, we are seeing vast amount of physical data, which can be put into good use to assess individual health profile and effectively monitor and treat patients, and also alter healthcare behaviors, let's say exercise or diet and all that. So it is projected that these wearable medical devices maybe reach 67 or 70 billion. So these are some of the big players and companies working on wearable devices. So we are familiar with the Fitbit, that's very popular in North America. Garmin, there are also other companies from Korea and world over working on fitness trackers, even eyes, body devices, smart watches, not just Apple, we also have numerous other players, and some of them are going to be used in diabetes as well. So skin patches, a lot of those stuffs. So, and these are the smart watches, some of them individually. So I will not, in the interest of time, I will not go into the specifics of each one. So coming to individual aspects of diabetes. So we're looking at, new devices. We do know that we're not always doing a good job with pain management in diabetic neuropathy. So expect to see a new device, which is going to help with neuromodulation and pain control. So, and this is also being used in regional anesthesia and other aspects of neurology, but this is coming up as a popular device in managing chronic neuropathic pain from diabetes. And then there are other devices that can accurately predict the biomechanical aspects of diabetic foot and pressure distribution, etc. And you can individualize custom insoles. So that's coming, and all you need is an iPhone-based picture, and the app will generate individualized custom-made insoles for you. So that's for diabetic foot screen. Another device which is going to be available probably in a year or two. It's called Mimosa Diagnostic System. It's like a small camera that can be attached to your iPhone, takes pictures, and it gives you pressure sores and other areas of altered blood flow and oxygenation. And we do know that these are indicators of tissue injury and possibly predictors of diabetic ulcer. So these are very small cameras that can be clipped to the iPhone. And then we do know there are advancements in therapies of foot care, negative pressure wound therapy, which is probably getting popular, and other electrical stimulation, and also cellular and tissue-based therapies, which are focused. This is another interesting device, again, developed by a technological advance. So the device is called a Sugar Pod. This was a winner of the Alexa Diabetes Challenge this year. So it's actually a voice-enabled scale, and you put the foot on the device, and it gives you pressure points and risk scoring for diabetic foot. So it's like a painless device and gives you accurate algorithms and scores for diabetic foot assessment. And now coming to diabetic retinopathy, one of the fields in medicine which is going to be changing rapidly is ophthalmology based on artificial intelligence-based algorithms that are being rolled out, similar to radiology. So all you need is a small camera and a special software. So the camera will take retinal pictures, and it will be sent to a cloud-based system, and you will get a report probably within a short span of time. So this is like an in-office screen for diabetic retinopathy. You don't have to wait for the ophthalmology doctor to send you a report. So you can immediately screen these people in the clinic, because most often we know we lose these patients. Patients refuse to go see an eye doctor, ophthalmologist, etc. So that's another advancement. And there are numerous other companies that are working on various AI-based diabetes screening devices for retinopathy. And again, these are all mostly small cameras that can be attached to your smartphones. And then, in Canada, we have started using glucagon nasal spray in case of severe hypoglycemia. So there's another advancement in the form of a glucagon pen. And currently, we were only using intramuscular glucagon injections, but these are available for children when we need glucagon mini dosing. And also, this can also be put into an insulin pump. So I'll come to details of that later. So those are advancements in glucagon delivery. And now in terms of clinical care delivery, we are seeing more of especially during the pandemic, probably this is going to be a future in many centers, virtual care model using connected devices, wearables, advanced cloud computing softwares, and also where you can get data based on your analytic stuff, based on your patient population, etc. And this is definitely helping us to improve lifestyle and clinical interventions. So there's this company I specifically named because it's run by a parent company from Google called Verily. So all these high-tech companies are definitely interested in diabetes technology and diabetes care delivery. And then clinical trial environment is also going to be changed because diabetes is one field we see a lot of randomized controlled trials, right? We've seen so many trials in the last 5 years with all the different medications. So the clinical trials are also going to be slightly different. You can have virtually conducted clinical trial, and it's also going to be artificial intelligence based. So that environment is also going to be changing because of the wearable. You can get new large big data analytic stuff derived from large databases too. So That's going to be changing as well. And then I think some of us are already doing the simulation-based virtual clinic. So that's going to stay. This technology is already there, simulation-based virtual clinic. And then again, this is kind of a summary for artificial intelligence in diabetes. As I spoke just now, it is being used in retinal screening, and it is also used as a clinical decision support, especially in hospitals where you struggle with managing inpatient diabetes. So many electronic medical health record systems have now have integrated algorithms that can adjust the insulin dosing based on last week's sugar readings and trend, and also those algorithms are already being validated, so that's getting popular. And then predictive population risk stratification based on subgroups on age, pregnancy, other chronic kidney disease, and genetic aspects. Genomics are going to play a big role in precision medicine and patient self-management tool and telehealth. Now, precision medicine, I have 5 or 6 slides on that. This is one area which is garnering a lot of attention. Probably, there's a lot of ongoing research, and it actually refers to collecting specific information about a patient and prescribing a specific treatment. The advances are being useful because of the changes in genomics. So that's why this area is advancing fast. So you're going to see more advancements there. And especially in diagnostics, right, where we often struggle with differentiating LADA or MODY or different genetic types of diabetes, et cetera, et cetera. So these algorithms and diagnostic testing can help with simplifying the diagnosis. And then there are other scenarios too, where you can use precision medicine. For example, a lot of people, for example, with ACE inhibitor or SGLT, we do use them for proteinuria. But then, is there a genetic component that can predict the outcome of favorable outcome of these medications? So all these aspects can be incorporated into precision medicine therapeutics. So, why is some patient A having a good response to a particular drug rather than another patient, things like that. So again, biomarkers are being used for type 2 diabetes stratification. Biomarkers are being used to predict the treatment response, etc. And also, we do know not everybody develops diabetic nephropathy or retinopathy, so there are biomarkers that can be used to predict the risk of progression or onset of complications. So I'm going to skip this slide because I went through it already. And then, so these are, I think every area of diabetes is going to be modified in some way or other with the impact of precision medicine, not just diagnostic, but the monitoring and other treatment efficacy. So eventually the goal will be to have, use an individualized plan, come up with medications that give least side effect, and we are looking at maximum benefits and behavioral modifications. So then in future, we are going to see predictive algorithms where, how you can protect and have patients and their outcomes and less mortality based on these algorithms. And now coming to the most interesting aspect, which I think all of us are familiar, but I'll wind up some of the newer aspects. So wearable technology, and we do see that Libre meter is being widely used now in India. In Canada, it is widely available now along with Dexcom. So wearable technology and real-time continuous glucose monitoring is very popular, even in people with pre-diabetes. Some of them are using these as a motivational tool to adjust their diet and watch their exercise, etc. Real time. So flash glucose monitoring, but we know this as Libre system. We are all familiar with it, and there are some advances with the flash glucose monitoring. Currently, the Libre glucose meter does not give the alerts, right, when the blood sugar goes up or down. But I think in future, the Libre version 3 or version 2 is going to come out with alarms similar to the Dexcom continuous glucose monitoring device. So thanks to these continuous monitoring device, the way we look at glycemic target has also changed, right? Of course, HbA1c is a glycemic target based on various guidelines, but now we know that time in range is also a target for controlling diabetes. We are not just looking at HbA1c. It's very, very important to look at time in target, and these are reasonable goals. 60 to 70% reading should be in target to at least say that we are achieving a glycemic target at all levels, less glycemic variability and less risk of hypoglycemia. So this is a 90-day. We know that Libre patch stays for 2 weeks, and this is a 90-day implantable sensor. And this is like a removable sensor. You can remove and reattach, whereas Libre it has to stay for things like that. So there are a lot of advances. And there's a lot of interest on this device. This is something to watch for because this has no pain, there's no needle. So this is called as a non-invasive CGM device for people with diabetes and pre-diabetes. As I mentioned, there's a lot of interest on this product. I think it's going to be rolled out of Europe. So that's how small the patch is. And again, it's called Sugar Beat, and it's waiting for FDA approval. So it's like a small peel and place, and the warm-up period for the sensor is 25 minutes. So in 25 minutes, it's ready to start rolling. And then you do get also some predictive graphs. It's going to predict how your sugar readings are going to change in the next 20 minutes. And there are alarms, and there are glucose trend lines, and then using the cloud-based mobile app, we can also input other data, which is not always possible with Libre or Dexcom. So it's an advanced version now. And this is another interesting device, like a glucose sensing dog. So it can detect fluctuations in blood glucose based on the breath. And another one is coming out is Dexcom CGM G7. Currently we have G6, but this is Dexcom is collaborating with Google. That's previously called Google Life Sciences, and it's now called Verily. So they are coming out with a sensor that can be worn for 14 days, but interestingly, it's very thin and it's fully disposable. So it's a very smaller sensor that's coming out with Dexcom G7. And then this is the Eversense, an implantable glucose sensor. It'll be implanted under the skin. You have to go to your doctor's office, and it's again a 90-day CGM. It is also coming with full approval. And this is one of the tiniest glucose sensor that you're going to see. This is like smaller than a sesame seed, they say, and it goes into under the skin 2 to 3 centimeter, whereas the other sensors go up to 10 millimeter deep, and some people develop skin reactions from Libre or Dexcom. So this is very, very tiny. Another very, very tiny implantable CGM coming out soon. And this is another one, again, totally non-invasive wireless device. So no needle, no pain, nothing. It's like a patch that it's like a sensor which squeezes the skin between the thumb and the forefinger. You can even use the earlobe to measure glucose level. So this is also in progress. And so as I mentioned, we do have a lot of devices now competing for the market, and also really good patient feedback based on these devices. I'm not going to individual aspects. And then all of these wearable transmitters can be used in tandem with insulin pump, or also your insulin regimen, even with tablets when patients want to adjust their diet. And most of the data can be evaluated cloud-based, sitting in your office. Patient need not come into the office. You can see all their readings through the computer. There are platforms. And now, many of us are using devices like Alexa and Siri at home. So, these devices are being trained to using cloud-based interface. You can just ask these questions, Alexa, what is my sugar? And it's going to give you an average adequate reading based on the current CGM dosing. So it takes one more app to be added to your phone. And so this is going to be a future. So Alexa will be able to tell you the sugar readings. So these are some of the questions, based on your treatment aspects. These are some of the questions that or interaction that you can do with Alexa or other technologies that are in voice recognition softwares that we use at home. And Roche Diabetes Care is coming out with another tool which is going to be very specific for diabetes. But not everything has been very positive. Unfortunately, we heard the news that Google's company was working with Alphabet. They have stopped working on a contactless-based technology which was being projected to test blood sugars. I think that was not successful. So there has been some setbacks too. Now with CGMs, we see that the accuracy has improved. The devices are getting more accurate and you don't need to calibrate them every day. So things are changing. And of course, these are being translated into improved HbA1c and less hypoglycemia and more motivation, right? And now coming to the insulin delivery. So we're talking about artificial pancreas and insulin delivery systems, automated insulin delivery. We're looking at closed loop and bionic pancreas. So these are the currently available ones. Now in Canada, we are using the 630 and 670G Minimed Medtronic pump, as well as a tandem basal IQ. And then, as I mentioned, 670G. So those are the different aspects of, and also Omnipod. And this is another micro pump, which is a very, very tiny device that's going to be coming out probably next year. But then the micro bolusing is one important aspect of these insulin pumps. So you can go up to 0.2 to 0.5, especially in children, you want to do micro dosing adjustments. And these are easily detachable and you can rewear them. So that's another feature. And the basal rates can be programmed in 5 different ways. So there's a lot of advancements there in this tiny pump, and it can hold up to 200 units, but there are other pumps that can hold up to 300 units. That's another patch pump. Again, you must have seen these demonstrations when you go for AD and other meetings. They usually have booths displaying all these patch pumps. A lot of companies from China, Korea are all working on these. And this is the Korean company, another patch pump. And again, you can do all the commands on your smartphone. And then this is another colorful version. This is a Swiss-based pump, dual pump. Again, they're getting tiny, smaller, and Ella Lilly is working on their own pump, which is also a smaller device. Again, you do all the commands mostly on your phone or a small handheld device, but it's like more user-friendly, and it can hold up to 300 units of insulin. So it might be useful for type 2 diabetes as well. And this is artificial pancreas at a glance. So you will have a wearable device and then the pump patch as well. This will be communicating to each other through Bluetooth-enabled technology. We are already using it, and we are seeing good benefits for insulin pump. So overall, we can see that there's less hypoglycemia, better overnight glucose control, less dangerous hypoglycemia at night, and reduced severity, and better time in target with the insulin pump delivery system. So this I briefly mentioned. So we're looking at Medtronic 6mdg and tandem insulin pump, and then the Omnipod pump, again in tandem with Dexcom continuous glucose monitoring. And also sometimes you can do a do-it-yourself loop software and make it work as an artificial pancreas without having to spend a lot of extra money. So these are the Loop DIY systems. These are open source free software that you can download and link your pump to your continuous glucose monitoring device as well. So again, this is the Omnipod. This is another patch pump, no tubing. And again, this is integrated with the Dexcom, and you make all the adjustments on your phone. But you change with the Omnipod, you change this every 3 days. Okay. So, and then another interesting development, which you're going to see soon, is that a biohormonal dual hormone system, because the same pump will have insulin and glucagon. So when the glucose level is dropping, the pump will self-administer glucagon. So that's called the dual chamber pump. And this is going to be a major advancement and a lot of excitement there. This is being developed by Boston University, and this is called Beta Bionics iLet pump 4th generation prototype. There's a lot of excitement about this pump. And we do know, we just had a session on SGLT inhibitors, and there's a lot of therapeutic advancements in the field of diabetes pharmacotherapy. So I'm not going into details. So these are the new ones. Probably, we are going to see PPAR, alpha gamma agonist, and GPR agonist. All these new medications being ready to be rolled out after final phase 3 trials. So in conclusion, we do have an array of options that focuses on behavioral aspect, self-care, and treatment that can be tailored to each patient. I mean, this is a very vast topic, and I could only cover so much within this time frame. And thank you for listening.
Thank you, Dr. Nisha. Very lucid and crisp presentation. I think, yeah, you have done quite justice to the vast topic, and very nicely explained about the latest technologies which will definitely help physicians in taking care of their patients well, and patients also to understand the diabetes. Our scenario in India, a lot of patients are still unaware about how to manage and what all to do regarding diabetes management. But with these technologies, I think our patients would become more aware regarding their diabetes. The role of these advanced technologies will make them more into the diabetes management. Otherwise, I think we all know that management of diabetes is totally a job of physician in India. A lot of people, they don't understand the diabetes management. So with these artificial technologies, patient would be definitely, it will help a lot. Precision medicines definitely will help a lot of us physicians in individualizing the therapy, cutting down on the side effects of various medications. So thank you, madam. A very lucid presentation. And over to Dr. Jayant now.
Thank you, Professor Abhyuday. And it was the best update in the health technology in diabetes. I congratulate Dr. Nisha. I didn't know that she has a Karnataka background. I thought how Arvind has invited show her. Arvind has now overseas friends more than the friends in the country. So it's a very good presentation, and I'll tell this is futuristic. This is what the world is going to follow in the coming days in diabetes management. Arvind, can we take a couple of questions?
Yeah, sure. Dr. Nisha, that was a very good presentation. Like always, when you gave me the topic, this topic, I just, if you remember, I just asked you whether 2025 is correct, because I was just remembering Robo 2.0. In the sense, in the coming years, like you showed us the various aspects of the technology which is happening all over the world. That is so good. Only thing I want to ask, would that be very feasible? Like, I think even in Canada, it should be a problem, but would it be economically feasible, especially in our country?
Yeah, so Canada, in contrast to US, we are very, very careful about the economic aspect. You know, all these technologies, there's always a delay in us getting all these newer stuff, because they will always weigh the risk and benefit, because it's free, right? Even the insulin pumps are free for all patients with type 1 diabetes. Libre is free. They get everything, all the medications free here. So in India, I do see a big hope for these pumps and all these CGM devices, because there's a lot of healthcare startups, especially in South India, right? Once the patent is over, they can easily develop and deliver it, in a very cheap fashion. And now that the internet is also so cheap, right? I do foresee that this is going to be a future, at least in bigger cities, and even with the remote care. I mean, it's a matter of us getting trained and helping people, right? I think usually the biggest barrier is us as physicians adopting these technologies.
Yeah, because very aptly said, because recently we have that CGMS, real-time CGMS, which is available in our country as of now. But at the same time, as you rightly pointed out, that education among the doctors is most important. Most of them are not aware of these technologies at all. So you are rightly pointed. Dr. Jayanta, you wanted to say something?
Yeah. Because the things are improving. If you have seen during this COVID time, our healthcare system has already revolutionized this teleconsultation and the digital platform. Even a common man knows what pulse oximetry, what the Anirod machines, and the monitoring system has evolved, and people want to know more about health, and many have become health conscious. I'm sure this will be taken up, if not by the government, individual patients, and at least 50-60% of the diabetics in India will be able to understand and afford. The most important challenge is the IQ to use this health technology, because the youngsters are very good in digital equipments and they are using them, but the little elderly people who are 60 plus or 70 plus, they are little behind. They'll take the help of the grandsons and son for that, and I'm sure in 2025 this will definitely be a major way of intervention in India. So she has done very good. Yeah, ma'am. Something
I'd like to point out though, like, you do think that, in the Western countries, people have high level of education. It's actually not like that. When it comes to something like this, people have no clue, right? Even technology, many of our seniors are really, really behind. But then in India, what I do see that the family, kids and grandchildren are very much involved, right? So they can have all these readings on their phone and call them, okay, listen, it's time to take your insulin. So when the family is very much involved, and then I think our seniors now slowly adapting with the WhatsApp and all that. At least they know how to use the phone now. All you need is a good app. Yeah, they will adapt.
And then the caregivers are very sincere in India. The family support is very good. Yeah, that's a positive point. So I think
I will usually sometimes, like, instead of adding a new medication, I will just give them this Libre glucose meter, and they come back in 3 months. Usually we see like a 0.5 to 0.8 drop in reduction just by giving them Libre.
Yeah. This must strike the physicians of the country who are practicing diabetes at primary care level to initiate the technology-based approach, so that gradually patients will take up by 2025. I'll conclude that, and I think it's time. So I request Dr. Arvind to just sum up.
Thanks, Dr. Nisha Naigil, for being a part of the conference. I am much appreciated. We always see your post in the Facebook. You are so active in the field of diabetes and endocrinology in Canada. We make you make India proud in Canada as well, I'm sure. Thanks for being a part of it. And sorry for keeping you. I'm sure it is 12 o'clock in the midnight, Saturday midnight. sorry for keeping you awake, but it is so nice of you to be a part of our conference. Thanks, Dr. Jayant and Dr. Abudai, for chairing this session. Thank you so much.
Well, I have to tell you that I'm very grateful to my training in Manipal, and I'm very active with the education here with the Kannada community as well.
Oh, thank you, Nisha. Thank you so much. So nice of you. Yeah.
And it was a nice session. Take care. Stay safe.
Yeah.
Thank you. Take care. Bye.
Next, moving on to the next session. We have an interesting session now. It's a big debate once again. Yesterday we had witnessed one of the biggest debate. I'm sure this will surpass that big debate. Once again, it is the nation wants to know. Like it is always said, nation wants to know what is happening. So in the field of diabetology, so in the same way, nation wants to know atherosclerotic diabetic dyslipidemia, what the science says, which is important. That is the debate today. We have three eminent speakers. Dr. Supratik Bhattacharya from Kolkata will be speaking on LDL. Dr. Sunil Kota from Berhampur talking on HDL. Dr. Tejas Shah from Mumbai talking on triglycerides. To chair this session, we have three panelists. Dr. Prabhakar is a professor of medicine from Kolar, from Devarajas Medical College. He's a very good of mine, always active in academic activities, especially when it comes to teaching with postgraduates and medical students. And Dr. Puttraju is a consultant physician and diabetologist from Tumkur. Is very actively involved in spreading awareness about diabetes in Tumkur. Dr. Dinesh Kamath, consultant physician and diabetologist from Bangalore. He always is a good advisor and a highly motivating person to all of us. Over to the chairperson for the further proceeding. The kindly note the speakers will have 12 plus 2 minutes. So you have the chance to rebuttal as well at the end. So all the three speakers are dynamic, I'm sure, waiting to roar this debate. Over to the chairperson, please.
Good morning. Am I audible?
Yes, yes.
Am I audible?
Yes, Dr. Prabhakar.
Good morning, everybody. At the outset, I would like to thank Dr. Aravinda and his team for giving me this opportunity to chair this section. Okay. And I also appreciate from my heart for conducting this excellent virtual conference. Congratulations, Dr. Aravinda. Topic for today's big debate is ADD, that is atherosclerotic diabetic dyslipidemia, what the science says. As all of us know that most of the type 2 diabetics have both quantitative as well as qualitative dyslipidemia contributing to atherosclerotic cardiovascular disease, which is responsible for nearly 75% of mortality in diabetic patients. To participate in this debate, we have three eminent endocrinologists from all over India. It's my pleasure to introduce these speakers. Dr. Supratik Bhattacharya is eminent endocrinologist. Is a director of SKN Diabetes and Endocrine Center, Naihati, and also visiting lecturer endocrinology and diabetes in UK, and consultant endocrinologist Apollo Sagar and Ambry Hospital, Kolkata, and best diabetes. And he is honored with the Best Diabetes Awareness Prize, Diabetes India 2017. Multiple international publications as first auditor, and he remains a speaker at various international as well as national endocrinology conferences. It is over to Dr. Supratik Bhattacharya to debate and to support the role of LDL in the atherosclerotic cardiovascular disease, dyslipidemia to atherosclerotic cardiovascular diabetic patients. It is over to.
Thank you, Dr. Prabhakar, for your kind words of introduction, and a big congratulations to Dr. Aravinda for this fantastic scientific feat that he has pulled off. I've been listening, and it's absolute pleasure listening to all the scientific talks that are going on. I was actually taken off because I thought that initially it's going to be a 16-minute talk, but now we have 12 minutes, but we'll try and do the best we can. So just give me a minute when I share my slides. So hopefully the slides are visible at the moment. And so this is what I'm going to try and prove within the next 12 minutes. I'll be skipping slides very fast because initially I'll be going to the basics and then taking it on from there. So LDL cholesterol, the culprit and the target in atherosclerotic cardiovascular disease, and why we need to treat that is what I'm going to talk about today. So what is LDL? We know that it's called the bad cholesterol, but there's something beyond that. LDL and HDL are the carriers to the cholesterol as well as the triglycerides, back and forth from the hepatocytes. And size does matter when it comes to LDL. And smaller, denser it is, it's bad for your heart. So smaller LDLs actually can slip through the endothelial cells and gain access. And that's the ones that we should be worried about. Now, there are certain tests that may or may not be available at this point of time, but the NMR lipo profile test is one such kind which looks into the size of the LDL particles. And this is very, very important because even in spite of having the same LDL cholesterol levels, your risk of future cardiovascular events actually depends on the size of the LDL cholesterol as well as the density. So if you look at the curve, you can clearly see LDLP, which represents your small dense cholesterol, would actually predict your future risk of cardiovascular events as the years go by, and this has been proved beyond any doubt. LDL cholesterol causes atherosclerotic cardiovascular disease, and we have RCTs, we have animal studies, we have familial hypercholesterolemia studies, Mendelian randomization studies, and epidemiological studies. LDL cholesterol also increases with age, and so does atherogenesis. This is one of the slides that's very important to see. If you have familial hypercholesterolemia with high LDL cholesterol levels, you will have a cardiovascular event or a death at a very young age. But if you initiate a statin at a much younger age, you see that you will be delaying or halting the process. And even with cardiovascular risk factors and LDL cholesterol of 130, if you initiate statin, you'll be delaying the process. But if you hit it really hard and bring it down to the levels of 30, you'd actually cause a regression. And that's why you should be very, very aggressive in terms of LDL management. I would not go into the details regarding the pathophysiology, but what I'll try and make you understand is that LDL is the causal factor for atherosclerosis, and we do have prospective cohort studies and randomized controlled trials. And if you look at the numbers, it's very, very convincing. So Mendelian randomization studies with a follow-up period of about 50 years, and look at the numbers that you have in here. Prospective cohort studies, median follow-up of about 12 years, and look at the number. And again, RCTs with a median follow-up of 5, with the N being 196,552. So it's a huge number of evidence that we have to actually say that LDL has a causal relationship with atherosclerotic cardiovascular disease. If you're still not convinced, let's go to this particular study that done by Brian A. And it's been cited more than 1,000 times, which talks about the low density lipoproteins causing atherosclerotic cardiovascular disease, and evidence from the genetic, epidemiological studies, and clinical studies. So I think this is the most convincing slide I have so far, and look at the evidence grade. All of them are grade 1 evidence regarding plausibility, regarding strength, biological gradient, temporal sequence, specificity, consistency, coherence, and reduction in the risk of intervention. All of them go beyond any doubt to prove that LDL has got a causative relationship with atherosclerotic cardiovascular disease. And if we do actually hit LDL very, very hard from the very beginning and bring it down, we will be doing justice. So another important factor is to realize that there's increasing CVD mortality in India, and this is on the rise. And why are we different from our Caucasian counterparts? Because of the genetic makeup, and we have high prevalence of small dense LDL particles, and that's the area of concerns that we have. So approximately 40% of the Indians with coronary artery disease are less than 40 years old, and approximately 25% of those dying with coronary artery disease are less than 40 years. So we have to be aggressive. We can't sit complacent. We need to start early. Again, LDL cholesterol analysis is recommended as the primary lipid analysis method for screening, diagnosis, and management, and we do have class 1 level C evidence for this. This is the genetic causes leading on to LDL quantity or LDL quality differences, and we have identified various loci. And one of the most important causes, of course, remains the receptor of the LDLs, and then you have the various other causes that I don't want to go into the details about. But what I want to emphasize, of course, is that Lipid Association of India recommends the other forms like the non-HDL cholesterol still as the co-primary target. And first, you have to achieve the LDL cholesterol goal. How low to go? The target LDL cholesterol less than 50 milligrams per deciliter is recommended because it causes a risk reduction of almost 19% for all major cardiovascular events. IMPROVE-IT trial actually showed that if you started with a baseline of 70 as the comparator and you added simvastatin and ezetimibe combination and brought it down to the level of about 53, there's significant risk reduction. Clearly, ODESSI trial is another trial again with alirocumab, which shows that, of course, that if you're bringing down the levels of LDL cholesterol to about 50 mg, there was significant MACE reduction. Again, we have shown clearly that goal of LDL cholesterol has to be 50 mg or less as proposed by the Lipid Association of 2016 guideline. But one thing that you have to recognize is that the IMPROVE-IT study that has been done over 6 years did show that even if you brought down the LDL cholesterol to the levels of about 50, that probably is not good enough because there would be still certain residual risk, and we probably need to evaluate the LDL targets, especially for the high-risk population. So the need to reduce LDL cholesterol levels to less than 30, where the data has shown CV benefits at this level. So this is the consensus. This is 2020 consensus, which has been published in the Journal of Clinical Lipidology. And as you can see in here, there's a risk categorization. So, let's go to the right box where you see extreme risk. And it has been divided into category A, where coronary artery disease with more than one feature of high risk group, or category B with coronary artery disease with more than one feature of very high risk group. So we'll be concentrating on these particular groups. And as you can see in here, if it's the category A of the extreme risk group, you're probably okay bringing down the LDL to the levels of about 50 or less. But if it's a category B, then you need to push the LDL goals to less than 30. So to summarize, if you can look in here, even if you have low risk, it's justifiable that you bring down the LDL to less than 100, moderate 100, high risk 70, very high risk less than 50. But when it comes to the extreme risk category, you need to push even farther, possibly to the levels of 30 mg or less. And do we have evidence for that? Treatment protocol for very high risk and extreme atherosclerotic cardiovascular risk. How do we go about pushing it down? So if you have used statins and even then LDL cholesterol is persisting more than 50, you have to think about adding in ezetimibe. And in spite of that, if it remains more than 50 and it's a category A, then it's your clinical decision whether you want to leave it like that, or if it's a category B, then you need to do better by adding a PCSK9 inhibitor. So target LDL cholesterol less than 30, do we have evidence for that? And of course we do, and this is the Fourier trial that has been done, and you can see in here clearly there is a definite risk reduction from baseline of 93 if you brought down the LDL to 30 or less. Efficacy of intensive LDL cholesterol lowering has been demonstrated in terms of MACE reduction. 21% reduction in the MACE in patients who has achieved LDL cholesterol level less than 30. Again, if you look at the hard evidences in terms of percentage atheroma volume or fraction showing regression, if you added evolocumab on top of statins, then you saw that there was a definite hard evidence in terms of both atherema volume reduction as well as fraction showing regression. So justification of Lipid Association of India recommendations. So look at the numbers needed to treat. Now you have two cohorts, one with diabetes and the other without diabetes. And of course, improve it. You see the number needed to treat in the cohort with diabetes is only 18, and absolute risk reduction is about 5.5. Similar studies with Odesi and Fourier. If you have diabetes, absolute risk reduction is more, and the number needed to treat is, of course, less. Also depends on how many vascular beds are involved. If it's 3 vascular beds, the number needed to treat is only 8, and 2, it's 52, and of course, if it's 1, it's 71. So safety of PCSK9, it's absolutely similar to the placebo. There's no additional risk in terms of safety. So in conclusion, we are born with LDL cholesterol levels of 30. Hunters and gatherers, our forefathers had low cholesterol with very low prevalence of CAD, and Indians are unique in their atherogenic class, and so probably we should have a different definition and target levels of LDL cholesterol when it comes to our LDL. So thank you so much for your kind and patient hearing, and I'll wait for the rebuttal. Back to the chairperson, please.
Thank you, Supratik Bhattacharya, for that excellent talk in support of LDL as a major risk factor for atherosclerotic cardiovascular disease, for causing diabetes dyslipidemia, contributing to the atherosclerotic cardiovascular disease. Now I would like to invite my fellow Dr. Puttaraj to introduce the next speaker, Sunil Kota. It is over to Dr. Puttaraj.
Thank you, Dr. Prabhakar. At the outset, I would like to thank Dr. Aravind Jagadish for involving me into this conference. I think it's a very great initiative involving all the international faculty into this conference and making a very good scientific extravaganza. Your dynamic and enterprising personality is very inspiring to us. Thank you very much for that. Now, coming back to the academic feast, as we all know that atherogenic diabetic dyslipidemia is a triad of abnormalities, two quantitative and one qualitative, as one speaker has already discussed about the qualitative defect, that is the small dense atherogenic LDL. Now we have two quantitative defects. One is the low HDL, other one is the increased triglycerides. To speak on the role of HDL and diabetic dyslipidemia in relation to cardiovascular risk, we have Dr. Sunil Kota, a renowned endocrinologist from Behrampur. So he is a prolific researcher and a writer. He has more than 75 peer-reviewed publications and 85 conference abstracts. He has been an author of several papers and text presentations. He has been awarded many awards, both national as well as international, and research grants from several renowned organizations, as it has already been demonstrated. So now I invite Dr. Sunil Kota to go for the presentation. Thank you.
Is it visible to everyone now?
Yes, yes, yeah.
Yes, yeah, I have rightly stopped the video share so that the presentation becomes a bit hassle-free. First of all, very good morning to the respected chairpersons, to the respected audience. And I'm here to talk in favor of high-dense lipoprotein and atherogenic diabetes dyslipidemia. And I'm going to talk about ADD in the virtual summit by ADC. So thanks, Aravinda, that is awesome, Aravinda, for inviting me over here and asking me to talk on this. And on the backdrop, we all understand that from a macrovascular complication point of view, the hypertension is predominantly linked to cerebrovascular complications. Dyslipidemia is predominantly linked to cardiovascular disorders, and hyperglycemia is predominantly linked to peripheral vascular disorders. And amongst the several parameters, we all understand that diabetes is associated with 2 to 4-fold increase in cardiovascular risk occurrences. And if I may take all of us back to our MBBS days, we were told HDL has anti-atherosclerotic properties thanks to its reverse cholesterol transport from macrophage by ABCA1 and ABCG1. It has anti-inflammatory and antioxidant properties. It decreases the expression of adhesion molecules. It has anti-apoptotic property. It ameliorates endothelial dysfunction. But all these protective benefits are lost whenever there is hyperglycemia-induced glycation and oxidation. So today's topic is what the science says. So probably I'm not going to debate with any of my friends. I can see three of us together, Dr. Tejas sir, my dear friend Supratik, and myself. I'm not going to indulge into any war between different markers. I'm going to point some facts before you, and we all are esteemed enough to understand what they are. So with this brief preamble, I'm going to start off my topic proper. First, let us look at what exactly is atherogenic diabetic dyslipidemia. It is a constellation of LDL more than 100, triglyceride more than 150, and HDL less than 40 in males and less than 50 in females. And it is associated with reduction in particle size for both LDL and HDL. And when we talk about the concentration, the LDL goes up and the HDL goes down. And there is a predominance of VLDL triglycerides and ApoB. And this was way back in 2002. This was a study comparing Native Americans versus the Asian Indians staying there. And you can see in comparison to the Native Americans, Asian Indians tend to have higher triglyceride, lesser HDL cholesterol, and higher lipoprotein A. And of course, this presentation would be incomplete if I do not show you this cartoon. Because of insulin resistance, there would be more of triglyceride formation thanks to the stimulation of hormone-sensitive lipase. There would be increased packaging into the VLDL. The triglyceride then gets transferred to HDL by CETP, so that the HDL becomes small dense and the ApoA1 gets excreted in the kidney. On the other hand, the VLDL transfers its triglycerides to LDL and makes it converts it from a larger buoyant form to a lesser, smaller and denser format. And if you talk about the etiologies, diabetes, obesity, hypertriglyceridemia, then we have a lack of physical activity, smoking, high consumption of refined carbohydrates and fatty foods. There are some medications and hormones to blame as well. Those are beta blockers, the benzodiazepines, progestins, and anabolic steroids. And if we look at the prevalence, what exactly is the prevalence of low HDL? So sometimes people occur in the form of LDL, which is the class 1 defined by all these societies. Do we need anything else? I would say yes, more the merrier. We all love increments on top of the predefined salary. And look at the number of countries studies, and you can see India stands tall with respect to the prevalence of low HDL cholesterol at around 70%. And if I may take you back to 1990s, the Framingham Heart Study, you can see both men and women, persons with diabetes tend to have higher triglyceride, lesser HDL, and lesser LDL compared to the normal population. And if you look at the UKPDS, which we all have been referring to time and again, bit different, but it says that patients with type 2 diabetes, irrespective of their gender, would go on to have higher LDL cholesterol, higher triglyceride, and lesser HDL. This again is a study in 2005 Diabetes Resident Clinical Practice, the IDF journal, and what it says is that they have compared basically the patients with and without diabetes, and only significant difference between these two is that patients with diabetes would go on to have higher triglycerides and lesser HDL cholesterol. So if you look at only the dyslipidemia component of this Asian Indian phenotype, we all understand this is a low HDL level associated with high triglyceride and high levels of small dense LDL. And we all understand the R.M. Parikh et al. Study, which says that probably 9 out of 10 Indian diabetics would have dyslipidemia. And here in this ICMR INDIAB study, you can see the most common abnormality was low HDL cholesterol found in a staggering 72.3% of people. It was followed by hypertriglyceridemia in 29.5% of people, and high LDL in only 11.8% of people. And it is across the region, cutting across urban and rural population. And again, just for the completion's sake, I'm just showing this slide. You have a number of studies starting from 1994 to 2006. The prevalence of low HDL is estimated to be somewhere between 14 to up to 70% as well. This is one more Indian study, the multicentric fit heart study. You can see both men and women have chances of low HDL. And this is one study from Odisha, which we will be definitely be proud of. And it is a study on young patients with angiographically proven coronary heart disease. The predominant abnormality was high LPA followed by low HDL cholesterol. So what are the evidences that we have? So these are some of the epidemiological studies. You can see it dates back to 1986. The British Regional Heart Study says there is an inverse relationship between HDL and incidence of coronary heart disease. The coronary primary prevention trial, the MRFIT and the Framingham Heart Study say 1 milligram per deciliter increase in HDL cholesterol is associated with decrease of 2% in men and 3% in women of CHD. And in the Lipid Research Clinic Prevalence Mortality Follow-up Study, again 1 milligram per deciliter increase in HDL cholesterol was associated with significant decrease in fetal CVD, both in males, men and female. And you can see there are this slide again is depictive of the fact that as you go higher up in the quintiles of HDL cholesterol, there is less chances of major cardiovascular events. Similarly, again, one more study in 2003, which again says as the HDL cholesterol level goes up, the chances of CAD incidence goes down. This again is an epidemiological study. As the HDL level goes up, the chances of hazard ratio of having a coronary cardiovascular disease is getting down. But again, there are some demerits that the relationship is not linear. And HDL more than 60 is not showing any benefit in terms of cardiovascular disease reduction. So overall, what we can say is that compared to LDL, which says 1% decrease in LDL reduces coronary heart disease by 1%, but 1% increase in HDL cholesterol reduces CSD by 3%. So we all have been talking about the residual risk. So we have to take care of that. One among them is low HDL cholesterol, and the other one is being to be alluded to by Dr. Tejas Sir. So now let us look at what are the drugs and HDL, and do they really change the course of the coronary artery disease? So these are the non-medical way of management, the physical activities, smoking cessation, weight loss, alcohol and intake of Mediterranean diet, and it increases HDL to the tune of 5 to 15%. And if you look at the lipid lowering drugs, the fibrates, some of the statins and niacin are the ones which are increasing HDL. And if you look at the anti-diabetic drugs, only the thiazolidine, especially pioglitazone, is associated with increase in HDL. Of course, this again is a study which say in 2003, which says as you go up, some of the statins, especially the rosuvastatin, pravastatin and simvastatin, are associated with increase in HDL. The mechanism put forth is they increase the flux of ApoA1 and also they inhibit the action of CETP. This is a very recent one, International Journal of Cardiology 2020. What it says is that rosuvastatin 40 versus rosuvastatin 10, it increases the plaque expression of ABCA1 receptor, which basically is important for efflux of cholesterol from macrophages. And then we have some of the studies like Greece study, which says probably the statins, if it is like atorvastatin, when they increase HDL cholesterol, they reduce the coronary events up to 2 years of follow-up. And one part of the Jupiter trial also says that treatment with rosuvastatin increased both HDL cholesterol, HDL particle number and size, and it has a significant association with cardiovascular disorder. And of course, this slide is again going to be alluded to by Tejas sir, but again, the group of population where there is a the triglyceride is more than 204 and HDL is less than 34, there is a 35% relative risk reduction of cardiovascular disorder with TG lowering therapy, but that benefit is also attributed to some increase in HDL cholesterol. But do we have the evidence that we claim? Because we all understand the HAT study, the Arbiter 2 and 3, the coronary drug project and the Stockholm ischemic heart disease trial, all of them raised some hopes with regards to niacin, but they bombed with the AIM-HIGH study over a period of 5 years when niacin was used alone, or the HPS 2 Thrive study when niacin was used along with laropiprant for a period of 3.9 years, but it was actually not useful. Again, the so-called wonderful molecules, the CETP inhibitors, the dalcetrapib, tolcetrapib, evacetrapib and anacetrapib, all these trials, despite being associated with increase in HDL cholesterol, were not associated with reduction of major CV events. So much so that the directly infused HDL mimetics, though increased plasma HDL cholesterol, were not associated with ultrasound demonstration of reduction of atherosclerosis. So probably this is the last article that I'm going to project, which is going to tell us why it is not helping us. A big study, a total of 52,268 men and 64,240 women, And this is the takeaway point that says probably you have got a U-shaped relationship between HDL cholesterol and occurrence of ischemic heart disease, MI, and ischemic stroke. And if you talk about the mortality, on left half, you can see the cutoff for men and women. It is the 74 for men and 93 for women. So below that and above that, you are going to have increased chances of mortality. That probably is the explanation why extreme high HDL cholesterol is somewhat detrimental. So that brings to the that brings me to the concluding slide. Yes, we have a primary target that may be debated by my friends, but that does not only do the justice. You have to take care of the secondary targets also, and for you need secondary ammunitions and ammos as well. So HDL is an anti-atherosclerotic, no doubt about that. And the atherogenic diabetic dyslipidemia is associated with low HDL, high triglyceride, and predominance of small dense LDL particles. There are epidemiological evidence showing inverse relationship between HDL and coronary artery disease, but unfortunately, Mendelian studies and randomized control trials are failing to demonstrate any benefits arising out of HDL cholesterol improvement. And drugs raising HDL cholesterol unfortunately had no impact thanks to the AIM-HI Arbiter and the TRAPIB studies, but probably the European Heart Journal study tells us we need to get to a target value of HDL cholesterol up to which we can increase. After that, probably we are not doing any good to the patient. So I am not here to fight with anyone. I am not going to prevail here. I am let the science win. Let me win the hearts. Let me not win the debate. Thank you all.
Thank you, Dr. Sunil, for that succinct presentation. You have clearly demonstrated that low HDL is an independent risk factor, apart from having small dense LDL cholesterol, is an independent risk factor for cardiovascular risk. Now, moving on to the next topic, I request Dr. Dinesh Kamath sir to introduce the topic and the presenter. Thank you.
Good morning, everybody. At the outset, I would like to congratulate Dr. Arvind for a wonderful conference and well-chosen topics. I thank him for giving me an opportunity to take part in this conference. Now, moving ahead with the debate of atherosclerotic diabetic dyslipidemia, to give the views of role of triglycerides, I invite Dr. Tejas Shah, eminent endocrinologist from Bombay. Over to Dr. Tejas Shah for his opinions.
Thank you, Dr. Dinesh. Thank you, Dr. Event. I always call Arvinda the rock star of the. So excellent coverage by both my co-colleagues to cover about diabetic dyslipidemia. And as Dr. Sunil rightly started off saying that hum science ki taraf se hai, I agree with that totally, that we are not here to debate more or less. We are trying to complement each other because we all know that how important all the three parameters are in terms of diabetic dyslipidemia. But my focus is going to be today on triglycerides, primarily because in the world of LDL and statins, I think this is one area which is getting forgotten quite a bit. And so my role is going to give you certain important highlights about why we should not be forgetting this important aspect of dyslipidemia, and that is triglycerides also. So we all know how the importance of LDL is. There are enough trials which have shown, and Supratik has very clearly demonstrated the importance of LDL reduction and the importance of statin trials. What we also know is that there is a considerable amount of residual risk remaining, and which has been shown in clinical studies, which tells us that in spite of a reduction of LDL to the target goals of less than 70, there is a considerable amount of atherosclerotic disease present, especially in diabetic individuals also. And therefore, our focus has to be on other parameters, as a wonderful slide shown by Sunil in the last with the Ramayana characters telling us about the other parameters. And I agree with that too, that parameters like low HDL, high triglycerides, lipoprotein, smoking, genetic predispositions, all these factors are responsible and which are need to be targeted along with the low LDL. So hypertriglyceridemia is one of the very common association in dyslipidemias. If you look at the US data, 53% of US adults had a lipid abnormality, with almost 30% having a higher triglyceride levels. When you talk about the Indian dyslipidemia, we know that we call ourselves the Asian Indian phenotypes, and we know that we are different in terms of a higher triglyceride, a low HDL, and a high LDL. And as the years are going by, with the metabolic diseases increasing, the incidence of diabetes increasing, we are surely going to have higher and higher people with hypertriglyceridemia in the long run. The categorization of hypertriglyceridemia is more or less stable in terms of different guidelines suggesting mild different values, but more or less agreeing on the fact that anything between 150 to 199 is considered to be borderline or high or on the higher side. 200 to 499 is classified as the high triglycerides, and more than 500 is considered to be very high, with an increased association of pancreatitis is what is mainly association. Now, the association between triglyceride and atherosclerosis is a bit controversial because there are earlier days there were not enough studies which directly correlated triglyceridemia to atherosclerotic risk. Primarily also because the accumulation of cholesterol in the arterial wall is different. The triglycerides are mainly present in the different molecules like chylomicrons and VLDL, and the ones which are present in chylomicrons are the larger part of the triglyceride or the larger molecules which cannot penetrate the arterial wall or the intimal wall and therefore do not accumulate and do not cause atherosclerosis. However, the smaller particles, the one present in the VLDL, are the ones which diffuse inside the interior intima wall, and they are the ones which can cause more or less the atherosclerosis. So there have been recent studies which have clearly shown a stronger association between triglyceride and atherosclerotic disease. One of the data from the ProCam study, which looked at hypertriglyceridemia in a subgroup of population, it showed that it was more common, almost 20% in males and almost 4 to 5% in females, but the incidence increase in postmenopausal women, and with age, the association in the subgroup of people with almost 5,000 people showed that the hypertriglyceridemia increase or was the highest association with atherosclerotic at levels between 400 to 800. There was another data from the Framingham study right back in the 70s, which showed again that the impact of triglycerides on relative risk of coronary artery disease kept on increasing as the triglyceride levels went higher. It was more common in females as compared to males in the Framingham study. Various studies or various mechanisms by which the triglycerides again can cause the increased CHD risk, mainly the accumulation of chylomicron remnants. It is mainly the remnant or the low lipoprotein particles which are responsible for this generation of smaller dense LDL. It is not the higher dense, but the smaller dense, smaller particles which are more atherogenic. We know that. And the increased triglycerides are more or less transported and converted to the small dense LDL, and that causes the more accumulation. There is increased coagulability, increased PAI activity, increased factor 7 activity, conversion of prothrombin to thrombin, which all plays a role, because of which hypertriglyceridemia can lead to atherosclerosis. So whether a high triglycerides causes atherosclerosis, there are points associated with it. If you look at the points, the cardiovascular disease shows weaker association. And it is partly HDL dependent. Severe hypertriglyceridemia is more from high chylomicrons, which is not related to increased CVD. The triglyceride accumulation is not seen in atherosclerotic plaques, and triglyceride lowering drugs are not completely showing decreased CVD. But if you look at the pros towards it, the triglyceride-rich lipoproteins are more atherogenic. The ones which are present in VLDL, the hypertriglyceridemia causes atherogenic changes in LDL and HDL, which makes it more prone to the disease. The triglyceride lowering drugs decrease cardiovascular disease in patients with low HDL and higher triglyceride value, and there are studies which have shown that. And anything triglycerides between 100 to 800 are more often associated with hyper-ApoB, and which is a more pro-atherogenic state. This was another study which looked at association of high triglycerides irrespective of the HDL factor, and which clearly showed that with the triglyceride levels on the higher side and when they negated the HDL, low HDL risk, still the association or the relative risk of causing atherosclerosis went up to as high as 11 to 14 hazard per relative risk. And that clearly showed a significant association with this. Yes, there are unmet needs and which need to be looked at. This was a very important study which looked at patients who were not eligible for statins. A considerable group of population, 58,000 individuals, which were free from ASCVD and stroke with major cardiovascular event, without any major cardiovascular event was studied here. The statin non-eligible individuals with the triglycerides above 64 were compared to statin non-eligible individuals with a triglyceride level of less than 264. And also there are patients who are statin eligible here. The relative risk primarily for myocardial infarction and most MACE was found to be significantly higher. The hazard ratio was more than 2 for MI as well as MACE here. So statin non-eligible individuals with more than triglycerides of 264 had an increased risk of ASCVD, and it was similar to the statin eligible individuals. There are other clinical studies. I will not go into detail much because of time, but this is a comparative data between patients without diabetes versus diabetes. And if you look at the hazard ratio in all these clinical studies, those with on statin still had an event rate almost as high as patients without diabetes. So clearly patients with diabetes are at an increased risk. In spite of being on statin, they have a residual risk of developing atherosclerotic disease in spite of reaching the target control of LDL of less than 70. There is some debate regarding fasting versus non-fasting triglycerides again, but these are two important data from the Copenhagen Heart Study as well as the woman analysis, woman health study, which had more than 26,000 population, and both clearly showed that non-fasting hypertriglyceridemia had showed an increased CV risk, and a hazard ratio was found to be higher, and there was a clear increased association with increased CV events. Now let us come to some other factor of hypertriglyceridemia, and that is also acute pancreatitis. There is an important association. We know that the risk of pancreatitis increases as the triglyceride level goes up. Almost there is an incidence of almost 8% if the triglyceride levels are more than 800, and almost more than 15% if the triglyceride levels are more than 1700. The mechanism of action is different of why it causes, and the hypertriglyceridemia causes pancreatitis, and there are various theories to it. The guidelines regarding hypertriglyceridemia clearly are clear. If the optimal level is to reach less than 100 and normal is less than 150, some of the guidelines looking at borderline targeting the levels at 150 to 199. Diet and lifestyle is the first recommendation. Decreasing the sugar intake, increasing the fiber intake, decreasing the fat intake have clearly shown to reduce the triglyceride levels. Increasing physical activity and walking, weight loss has shown to have important aspect on triglycerides, and decreasing alcohol intake on any individual with a higher triglyceride level is recommended. You need to rule out the secondary causes of hypertriglyceridemia: diabetes, nephrotic syndrome, chronic renal failure, estrogen replacement therapy, alcohol intake, and you need to target these secondary factors. There are medications which can increase the triglyceride levels. You need to be careful about that. Oral contraceptives, oral postmenopausal replacement therapies, systemic glucocorticoids, some antiretroviral medications, antipsychotic medications are all need to be targeted. Our focus primarily should be to choose the LDL goal based on the risk factors. If the triglycerides are less than 400, you target the LDL first, bring down the LDL, give diet, weight loss, and exercise therapy. After the LDL goals are achieved, you assess the triglyceride level and try to bring the triglyceride level to less than 200. If the triglycerides are more than 400, you need to again focus on triglycerides and bring down to less than 200. If the patient is diabetic and with a severe hypertriglyceridemia, insulin is something which helps in reducing the triglyceride levels initially, and that can be given or offered to the patient. Some important trials related to triglyceride drugs. The lipid accord trial was done with fenofibrate. It's an important study because that was a trial where patients were already on simvastatin and randomized, and the LDL cholesterol was brought down. There was a modest trend of 8% decrease in ASCVD events seen with fenofibrate. But per se in the sub-analysis where the patient had a higher low HDL and a high triglycerides of more than 204, there was a considerable reduction or clinically significant reduction seen in the ASCVD risk. There was another trial, which is the field trial, which is done with fenofibrate again. These again were patients which were randomized to receive fenofibrate, and patients were already on statin, and again showed a reduction of around 17% in the trial here. Omega-3 fatty acids is the another therapy which is promoted for hypertriglyceridemia. The JELLY study and the REDUCE-IT study are the two important studies which have shown that if you where the dosage of omega-3 fatty acid used was at a higher level of 1.8 in the JELLY study and around 4 grams in the REDUCE-IT study, and both clearly showed or clinically significant reduction in the ASCVD risk in the primary endpoint. These were patients primarily with a higher triglyceride level at the baseline, and these are two important studies which are now laying a lot of stress on using omega-3 fatty acids to reduce the triglycerides level. Niacin has been used in the HPS Thrive study, which did not show clinically significant much change here, and that's why we plus the association of niacin with blood sugar disturbances is because of which we do not use the drug much now in clinical practice. So whether the role of triglycerides in CVD, we need to evaluate, we need to understand that elevated triglyceride represents elevated remnant rich in cholesterol, which upon entrance into the edema can lead to low-grade inflammation and lead to more of oxidative stress, endothelial dysfunction, and more of atherosclerotic plaques. And therefore, along with reduction of LDL, these also needs to be targeted. Whether fasting or postprandial triglyceride, again, is a matter of debate and requires a different discussion. So is elevated TG rather than a low HDL a cause of CVD? There have been studies which have failed to show the importance of low HDL, and hypertriglyceridemia is known to show this importance. And most would agree that it is not TG per se that causes CVD, but often debate that it is a remnant cholesterol combined or whether a certain subfraction which is important or causing the development of TG. And whether the TG should be treated, there's a difference of opinion exists, but I think we all three panelists today will agree to the fact that diabetic dyslipidemia is something which needs to be targeted aggressively. You target the LDL first, but you also do not forget the triglyceride levels. The primary aim of medical therapy is to reach the LDL goal, but secondary aim is also to reach the non-HDL goal. And in patients with CSD or CSD equivalent, the tertiary aim of therapy is to reach the HDL goal. So when TG is not sufficiently lowered with the above measured, a non-statin drug, preferably a fenofibrate, should be used. Thank you very much.
Thank you, Dr. Tejas. I think we all know that all three are very important for atherosclerotic diabetic dyslipidemia and its associated problems. LDL being high and triglycerides high and HDL low. So Dr. Tejas brought out the points very well to support his cause of triglycerides next to LDL. Now I think we'll go for the rebuttal.
Anything to do, Supratik? LDL is always the question, always the highlighted point. Anything you say about that?
So I think we have already decided that we are on the same team, and there's not going to be a big fight. I'm slightly at an advantage, I must say, because I got the LDL as compared to Dr. Kota and Dr. Shah. But one point I must emphasize on a lighter note is that the country has to have a president or a prime minister, and then you have all the other persons working for you. So the prime importance has to be on the LDL, and we have proven it beyond doubt. And we have more than 200 studies looking at more than 2 million patients with more than 200 patient years behind us from the study that I quoted. And I think we have proven beyond doubt that LDL has got a very strong association. Now, yes, of course, low HDL is a risk factor, but the point is, even in the high risk group where low HDL is a risk factor, we have to treat with statins or other molecules like PCSK9. And we have seen that there is definite risk reduction if you can push it to the levels of 30 or less. And Indian being genetically predisposed, I think we need to do better in terms of LDL risk goal achievement. When it comes to fancy things like HDL, it's nice, but then we don't have molecules to get your HDL up, unfortunately. So it's nice to hear, but we don't have anything to do about it. But when it comes to triglycerides, not all patients are hypothyroid or diabetic individuals where the triglyceride levels are high to begin with. So we need to consider, here we are debating about LDL, HDL and triglycerides, not diabetic dyslipidemia per se. So that has to be taken into consideration when you're judging. And of course, we do not have strong association between triglycerides and atherosclerotic risk, future risk or cardiovascular events. So I think it's a co-primary target to be the best, if at all.
Sunil, anything you have to say? I think you're in Goa. Your background looks like the trees. This one's beach is there. You're looking like you're in Goa.
Yeah, trying to enjoy virtually also. So actually, yes, Supratik has rightly stated, but actually the main topic of discussion was role of HDL, LDL and TG in atherogenic diabetic dyslipidemia. That's what was the main topic. Yes, agreed that none of the marker would go alone. Yes, we there is a person who should lead, but there cannot be a single man army who can do all the wonders. It needs secondary and tertiary targets as well. And as sir has rightly stated, JJ sir has put across a good message on the chat box. Do we have any added benefit of raising HDL or lowering TG in people with type 2 diabetes at LDL goal of less than 70? We do not have any evidence as far as I am aware. And apart from that, even in that subgroup also, there remains a residual risk for people to have coronary artery disease. So we need to address that. As of now, we do not have drugs to raise HDL, which will be associated with reduction of cardiovascular disorders. But maybe the European study in 2017 says probably we need to have a cutoff beyond which, if you increase that, again, you are pushing the patient to higher chances of cardiovascular disease. So yes, we can be supplement to Supratik, and I think Supratik would be happy to piggyback us.
Dr. Tejas.
Over to Tejas.
Yeah, actually nothing, agree with both of them. And yes, we are here, as JJ has put, that we need a sync of everybody to control all the three factors. And yeah, my only point is that yes, there is a considerable residual risk, no doubt about that, in spite of controlling the LDL well. And plus there are, as we are seeing more and more metabolic diseases, things like fatty liver increasing. I'm sure in the future does hold that there will be some future data coming out regarding the importance of hypertriglyceridemia and its role, especially in Asian Indian phenotypes. And there are some studies with the drugs like pemafibrate, which is going on, which is a PPAR gamma thing, which is going to tell us a lot about the importance of reducing triglycerides and its role in reduction of CV risk. So let us hope that some new data comes out still better. But agree with Supratik that our first role is to target LDL, and then we look at the other parameters in our army and how to tackle with it.
Over to the chairperson to sum up.
It was an excellent, I won't call it as a debate actually. All the speakers defended the role of the respective components towards atherosclerotic diabetic dyslipidemia. In fact, they have complemented each other. I could say, instead of going for a debate, they complement each other. But as a treating physician, primary care physician, I always feel like that whenever the patient comes with debate reports, when they come for follow-up, so my opinion is we should not only looking at the LDL levels, but also looking at the HDL and as well as the triglyceride levels. So most of the lifestyle modifications or the medical nutrition therapy or the drugs, whatever we give like statins, they not only target the LDL, but in fact, they also do good for the reducing the TGL as well as increasing the HDL also. So I hope that in the future, yeah, maybe the more RCTs are necessary to prove that even though we see most of the time, most common abnormality we come across whenever we're reading the reports of high triglycerides and low HDL and LDL remaining normal. And most of the times we don't have facilities to qualitatively analyze the LDL levels. So we are only analyzing the LDL as well as HDL and the triglyceride levels. So most of the times we put the patient on the statins. And yes, this is also going to be helpful for the targeting other parameters also. Maybe in the future we may come with some drugs or some interventions where the HDL and also triglycerides also may be taken care of. And thereby, at the end of the day, what is our target should be the health of the nation or health of our diabetic patients, so that we can prevent the majority of the mortality, morbidity related to the atherosclerotic events in diabetic patients by combating the dyslipidemia in these patients. I think thank you once again, Arvind, for giving me this opportunity. It was an excellent debate. So over to my fellow colleagues.
Atherogenic diabetic dyslipidemia is a triad. So most important thing is the small dense LDL cholesterol. I think that should be targeted, but the associated risk factors like low HDL and high triglycerides, as we already discussed, statins are very good at reducing the LDL cholesterol, but we do not have good pharmaco agents to improve the HDL. Whether reducing triglycerides will have an impact on the cardiovascular risk, there is no strong evidence. The role of fibrates, the role of niacin, I think niacin has already lost the battles. And even the 2020 standard of care ADA guidelines say that the adding fibrate to statin has no benefit in terms of improving the cardiovascular mortality. So it is mainly the optimizing the statin dose, categorizing the atherosclerotic cardiovascular risk. So those who requires intensive high dose statin therapy, who requires moderate intensity statin therapy, I think that should be the main goal. I think the role of reducing triglycerides only to prevent the pancreatitis risk. That is what is the present evidence. So the management paradigm is from glucose centric to preventing the vascular complications, targeting these risk factors, glycemic control, lipid control, and blood pressure control. I think that would be the approach. I think now there is some evidence to combine ezetimibe. So because I think that was not discussed. Apart from fibrates, I think ezetimibe combining, it is both cost effective as well as it has shown some benefit in terms of reducing the cardiovascular mortality also. I think the speakers can add on to it.
No, I think it was already shown, sir. So it was, initially it was shown during the LDL presentation, the role of risk reduction.
Yeah, I think it's more of a holistic approach. We'll have to target all the three. We cannot go by a single, though LDL is the main factor and we have more evidence and more treatment values for LDL. But when coming to the individual patient, because diabetes is having 2 to 4 times high risk of developing cardiovascular events, I think better go for a holistic approach, and according to the risk stratification, go for the higher dose of statins and see finally the outcome should be an individual patient who should get the benefit out of this. So we don't call this as a debate, but actually all the 3 points are very important for the final treatment of these patients. Thank you.
Thank you, everybody. I should say splendid Supratik, Super Sunil, and Cool Tejas. So all of them did the debate wonderfully well. So it was it's a total sharing of the topic about the atherosclerotic diabetic dyslipidemia rather than a debate. But it's a very good knowledge shared. I hope the audience will be benefited from this. Thanks, Dr. Prabhakar, Dr. Puttraju, and Dr. Dinesh Kamath for chairing the session.
Thank you.
Thank you so much.
Thank you.
Thanks, everybody.
Thank you, Dr. Jagadisha, for this wonderful event and invitation. And thank you, Dr. Kota and Dr. Shah. Pleasure
Thank you,
listening
everybody.
to you.
Thank you,
Thank you, JJ, for your
Arvinda.
Take care, everyone.
Next, moving on to the next session, we have an interesting topic: the common errors in the use of insulin. Very practical topic, because we always, as a doctor, we put some insulin injections and forget about what is happening with the patient. To discuss about this, we have a very dynamic speaker, Dr. JJ Mukherjee from Kolkata. Very humorous person, very lively person, always on the toe, and a very good, I should say that he's a very good singer too. So to chair this session, we have none other than Dr. Sanjay Reddy, a close buddy of mine. He is from Bangalore, a very active member. I'm sure all of you know him, and about his capability of organizing the conferences, and is a very active member of RSSD as well. And as we have Dr. Subhash, he is my classmate. He is from Patna. He is my MBBS classmate, very active member in RSSDA Bihar. He is the secretary of RSSDA Bihar chapter. So very nice to have you both, Dr. Sanjay and Dr. Subhash, to chair this session. Over to the chairperson for the further proceedings.
Thank you, Arvind. And I will ask Subhash to take over. Subhash will do the honors first. Yeah. Subhash, you're muted.
Unmuted, sir.
Subhash, you're muted.
Not able to hear you, Subhash. No.
Sir, connect your audio, please.
Connect your audio, Subhash.
I think Sanjay can.
I think before
do the initial honors, and Subhash can do summary.
Subhash can take over, and thank you.
You can summarize. You can go ahead with that.
He wanted to do that before, and thank you, Arvind, for inviting me to be part of an important topic, and none other than our good friend JJ going to speak on it. So I need not introduce J.J. Mukherjee to this audience. He's been, can I have his bio, please? He's an endocrinologist from Calcutta, previously trained at St. Bartholomew Hospital, London. He did his MD from JIPMER. He's very well known in the National Faculty Circle for giving excellent talks. He's been has more than 55 publications in high impact journals. And over to Dr. J.J. Mukherjee to give his deliberation on common errors in insulin use, those very common but uncommonly told. Over to Dr. J.J. for your talk.
Thank you, Sanjay. Good morning. I'm audible?
Yeah.
Thank you.
Yes.
Thank you, Aravinda. I've been reading all the comments. I've been quietly in the background reading all the comments. Fantastic, boss. You have just pulled the rabbit out of the hat. Well done. I just listened to the sessions in the morning and I really enjoyed myself. So I was asked to give some topics to speak on, and I gave quite a number of topics to Aravinda. Some complicated ones, some RCTs, etc. He said, and by mistake I gave him this topic also. And he latched on to this. Aravinda said, JJ, this is the topic I want because this is very practical. This is what people want to hear. As you know, the whole debate, whole presentation is about nation wants to know. So that's what Aravinda said. Nation wants to know common errors in insulin therapy. This is a topic which, if you open a textbook, you won't find it. You go and look for a review article, you won't find it. So it's a little bit of a topic which is, as you rightly said, it's the gist of your clinical experience. So what I'm going to share with you today is my experience, and I'm sure we have some very eminent people in the panel, Vatsava Gowda, Sanjay, Aravinda himself. If you have any more tidbits to add to the common errors, please add, because this is what came to my mind, because it's something which you don't find as a written up kind of an essay. So my screen is visible, Sanjay?
Yes,
okay.
Very well.
So here I start. So this is what happens. We know this slide, time in, time out. Fasting starts going, first PP starts going, then fasting starts going up, insulin resistance. But it's only when the beta cell function starts going down and the insulin secretion starts going down that diabetes manifests. There's some error in this graph. Here it shows that your beta cell function is still about 60%, which probably is not true. If you see the UK PDS data, you probably have lost beta cell, 50% of the beta cell function by the time diabetes is being diagnosed. And if you see this, the very nice work done by Dr. Ralph DeFronzo, he has suggested that you probably have lost 80% of your beta cell function by the time diabetes is being diagnosed. So most people with diabetes, if they live long enough, will require insulin. And this is the biggest tragedy of our lifetime. Insulin is not used early enough, often enough, and aggressively enough. I would have loved to make this statement and say this is J.J. Mukherjee's quote. Unfortunately not. This has been said by Dr. Mees et al. Way back in 2006. So we have to be a bit more aggressive with our insulin use. And these are the steps of insulin therapy. Everybody knows initiation, you start insulin, you titrate, and then you intensify. So question is when, how, and which insulin to start, and when and how to intensify. So this is the error. This is where error starts creeping in. You have decided to start insulin. You want to start insulin. Now what errors you make? The errors can happen at three fronts. It can happen at the physician level. It can happen at the dispensing errors, and it can be from the patient side. Now, since I'm speaking to a physician audience today, I will be focusing mostly on the prescribing errors, the errors that you and I make day in, day out when we prescribe insulin. I will touch on one or two slides about the dispensing errors and the administration errors. So coming to prescribing errors, I think it is our duty to tell a patient with type 1 diabetes never to stop insulin. I think some of us fail in this. I've been guilty once or twice as well. I have a patient of my type 1 diabetic who came with DKA. And while going back, I realized I'd never mentioned this to my patient, that he never stop it, my friend. So you have to spend a little bit of time with sick day rules. No matter how many diabetic specialist nurses you have, you are practicing in India. This is not the Western world. In India, patient listens to the doctor. So it is our humble duty to at least spend 1 minute telling our type 1 diabetic what is a sick day rule. If they are sick, nausea, vomiting, diarrhea, they get the wrong concept that sugars are going down, they stop insulin, they end up in DKA. So we have to reinforce this. Second, I think the biggest error which physicians, not only in India, but worldwide make is delayed initiation. Whether that is a lack of knowledge or lack of time or plain indifference. This is when you should be starting insulin. At diagnosis, in the presence of associate features, if somebody comes with AMI, sepsis, stroke, because of severe hyperglycemia, if they come with HHS, of course, you're starting insulin. The third point is at a research level, every type 2 diabetic, you start insulin at the very beginning to preserve beta cell function. I will leave that out. Complications and hospitalization in pregnancy. We had this nice debate in IDL where metformin lost out. And of course, the commonest indication for starting insulin is failure of oral hypoglycemic agents. And this is where errors creep in. Now, it says when type 2 diabetes control is unsatisfactory despite lifestyle modification and maximum oral hypoglycemic agents. This is where errors happen. Now, unsatisfactory glycemic goal. Many of us in our busy day-to-day clinic probably don't focus on it. We don't set our target. So I think the first thing when you see a first time the patient with type 2 diabetes on the top of your case sheet, you should put what is your target. Whether it's 6.5, 7, 7.5, 8, 8.5. Somebody 90, 92 years old, 80, 85 years old, you're happy with 8.5. Somebody with underlying very bad diseases, conditions, you will be happy with 8, 8.5. Whereas if you're seeing a 35-year-old with no cardiovascular baggage, your target should be 6.5. And in some people aim at for 6%, but that is we are out of the guidelines. So I would stick to 6.5%. And another error happens with maximum oral hypoglycemic agents. We keep mounting 1, 2, 3, 4. I have seen 6 anti-diabetic medicines, 2 of the same class, before insulin is being considered. Should not happen. Now, here the guidelines don't help you. Some guidelines say 2 OHA start insulin. Some say 3 OHA start insulin. I think we need a good study on this. We don't have a study on this as to when exactly would you say maximum oral hypoglycemic therapy is failing. I mean, actually, you can't do a study. It's common sense, really. So generally speaking, we don't have enough data on this from our day-to-day practice as to whether we start adding insulin after failure of 2, 3, or 4 OHAs. My request to you would be start thinking of insulin once 3 OHAs start not to give you the target HbA1c goal. And then there is this big psychological insulin resistance, both from the patient side and from the doctor side. As I said, I'm talking to physicians, so I will stick to the physician PIR, physician psychological resistance. And these are the various things which go through a physician's mind. Efficacy of insulin type 2D. You'll be surprised. Yes, these are surveys done. I've not just taken that from my mind, that this is properly research data. Efficacy of insulin type 2 diabetes, concerns about hypoglycemia, yes, concerns about weight gain, concerns about insulin may be bad for the heart because there's a lot of epidemiological observational data which suggests that, but we have now randomized controlled trial, unfortunately only with basal insulins, only with Glargine and Degludec, not with the other insulins that we use with regard to cardiovascular safety. Concerns about patient adherence to complex regimens, lack of time. I think this is one big one, lack of time. And then the concept by our colleagues in primary care, and I don't blame them, is because of the volume of work they have, the amount of time they can't give to a patient, because to initiate insulin, you need 20, 30 minutes of your time, which a busy physician in India does not have, especially during the last 8, 9 months during the COVID times. So they think it's the job of the specialist, they push to the specialist, and there's a delay, and concerns about losing the patient, which is a fact in our country, which we need to accept. So once we have gone over this error of initiating insulin late, some of us start making wrong choice of insulin. We get confused whether to use human insulin, analog insulin, whether we should basal insulin, whether we should pre-mixed insulin. I think all of us in the panel must have seen some very funny prescriptions of insulin during initiation or during intensification. Now this slide is a picture slide which tells you all the insulins that you have available in our country. We have so many basal insulins available, NPH, Determinate, Glargine, Degludec, 100, 300. U200 is not available to us, Degludec. We have pre-mixed human analog. So all this insulin that is available confuses us. For us specialists, endocrinologists, people who are doing diabetes practice, is probably not so difficult. But for primary care physicians, for junior doctors, it might be a little confusing. Look at the number of dishes you have to eat. You know, it would be nice if you have only one dal, one sabji, and one rice to eat. But there are so many things to choose from. So you have to classify the insulins carefully. What is basal, what is premix, and what is prandial insulin. Look at the different prandials you have. You have regular, you have rapid acting, and you now have ultra rapid acting. One of them is already available to us, which is rapid acting Aspart. So this is one slide which tells you between human and analog insulin. There's a big confusion amongst us because most of the guidelines, if you see, they say analog insulin. Why, I don't know. So this is the small chapter Sujoy and I wrote in a very recently published Insulin Analogs, RSSDI, Sanjay would know, where we said that convenience and use of administration is 1 point in favor of analog insulin, marginally better efficacy, marginally better safety profile with regards to nocturnal hypoglycemia. All this comes at a cost, increased price, and some of them are prohibitively so. So as such, you have to individualize. If you have somebody who wants convenience and who has been having recurrent nocturnal hypoglycemia, you should think about analog insulin. And that is exactly what NICE guideline says. NICE guideline is a very practical guideline. NICE guideline favors a little bit to what we practice in India. India is out of pocket. NICE guideline is out of NHS. So you can think NHS is also out of pocket because NHS is always under stress with regards to finances. So what NICE says is starting insulin therapy, short-acting regular and NPH, switching to pre-mixed analogs when, if a person with type 2 diabetes prefers injections immediately before meals and can afford it, postprandial blood sugars are markedly high, or hypoglycemia is a problem. That is the time when you can think about analog insulin. Basal insulin analogs in adults include innovative rich HbA1c with NPH insulin because of significant hypoglycemia, occurrence of frequent hypoglycemia with NPH insulin, or somebody who cannot, generally 40 to 60% of people on NPH will require twice daily insulin. So somebody doesn't want to take twice daily, cannot take twice daily, you go for once daily. Now, when you're initiating insulin, my humble request is please initiate. We do not initiate. There's an average, there are a lot of studies that did not show the average gap is 5 to 7 years before we start insulin. We keep thinking, we keep discussing. Patient keeps telling every 3 months, next time doctor, I will do this doctor, I will exercise doctor, I will stop eating doctor, I will come back with a good HbA1c doctor. And this 3 months ends up to being 5 to 7 years. So you could start with basal 1, basal 2 and intensify, or you can start with premixed insulin, whichever one you prefer. There are certain pros and certain cons. Pros for basal insulin is simple to start, low incidence of hypoglycemia, lower chance of weight gain. Cons are it's not controlling PP very well, less control of HbA1c, and you have to add a different prandial when you want to intensify. Pros for premixes, again, you can start with once, it's simple. Effective HbA1c controls both fasting PPG, option to intensify with the same insulin. And cons are exactly opposite of what were pros for basal. So there is slightly higher chance of hypoglycemia and slightly more chance of weight gain. So let's come to the fourth error now. Fourth error, I think I am guilty also. It is pre-injection assessment about the dexterity of the patient, cognition, literacy, eyesight, whether there are any abdominal scars. I don't know how many times you just ask the patient to show their tummy, but when you're thinking about giving them insulin. Only day before yesterday, I had a pregnant lady who had very big stretch marks, and she said, "Doctor, where to inject my insulin?" So these things we need to think about. Generally speaking, these errors get taken care of because in India, we still have a very nice society where family comes in. This probably applies more to the Western world because if cognition is an issue, dexterity is an issue, the daughter-in-law, sometimes the son comes in and gives the injections. We need to be careful about the eyesight. I have been caught out once or twice with the eyesight. I didn't realize, the guy sitting in front of me, I've happily started a basal bolus insulin. And then the next visit, the daughter comes and tells me, I'm giving the injection. Why? He's such an able man. The doctor, he can't see with his eyes. By that time, the retinal check had not been done, visual acuity check had not been done. So if in a tertiary level hospital, this is a problem, I can very well imagine at primary care center where you have 2 to 5 minutes to see the patient, this might be an issue. This is an oft-quoted, this is mainly when you're in a hospital practice, is still happening. All the people who are listening to me today, please get off the habit of writing you. It's still happening in my hospital. What can I say to you? People are still writing 80U, 60U, sometimes it's 600, 800. I have seen one patient personally in UK where 100 units of insulin were given to an elderly lady. Big hoo-ha, I won't go into any further details. So please write units. I will say this again. It's happening in every hospital. So please stop writing you after insulin numbers. Inadequate education of the patient. We do not spend time. Some of us are lucky. We have a diabetic specialist nurse, but majority of you do not have that. This is one big bugbear for me in India, starting insulin. We need enough diabetic nurse specialists. We can keep shouting the rooftop, you won't get them. So it will be our job as physicians to tell them how to inject, where to inject, relation to meal. People still take human insulin after meals. In my clinic, I find patients taking the human insulin after meals. You check your patients, you will find inadequate education regarding management of hypoglycemia and weight gain. And what happens is, I won't take names, but if you see, in some clinics, they get 5 to 10 pages of material to read. And I've asked these patients, one day I should publish this, that how many pages have you read? And they said, Dr. Sahab, I got this and I put it on, in the Almirah, and here I am bringing it again to you. So what I would suggest is make a simple 1 A4 sheet education material. And that's what I have done. And I'm sorry to say that even this is not being read by my patients. So I have 3 sections, 1/3, 1/3, 1/3. On the top, I not scare them. I educate them about the diabetic complications. The next one, I tell them that my role as a physician is only 1/4. Rest everything is your job: diet control, exercise, and monitoring. And the last 1/3 of the sheet is how to manage hypoglycemia. It's a 1 A4 sheet education material. And one of these is, I think I should do a survey. Even this A4 sheet is not being read by my patients. So there's an error there in educating our patients. Now coming to the next error. Wrong combination of insulin during intensification. During discussion time, we can have it. How many of our panelists have seen premixed insulin in the morning, premixed insulin at lunchtime, and a high dose of basal insulin at night time? Or basal insulin 3 times a day. I had a patient just last week getting basal insulin 3 times a day. So all sorts of wrong combinations happen. This slide is very common. Everybody has seen. Sensible combinations are basal plus or basal bolus. If you want to change to premix, stop basal, change to premix. You can do premix once daily, twice daily, or you can use prandial. How many times we have seen only prandial without a basal? In some patients with advanced chronic renal failure, where you may get away with 2 or 3 prandial insulins, but majority of the time we need a basal insulin as well. Now, with the remaining time that I have, it was about 20 minutes I was given. Dispensing errors at the pharmacy level. This you and I are not concerned with, but you and I have to be aware about it. Because the other day I had one patient where he's a type 1 diabetic, doing very well. 10 years later, he comes saying that all my sugars are 400 for the last 3 days. Luckily, education worked. He knew that if his sugars are high, he should be reporting. He came running. Everything we checked. The insulin is dispensed correctly. The insulin has been stored properly. You can read the slide while I'm talking. Insulin has been stored properly. He's injecting the insulin properly. Everything is correct, and still sugars are 400. I'm scratching my head. Are you on steroids? Are you injecting at the wrong side? Is there hypertrophy? Everything is okay. So we said, okay, you just change the insulin. Just buy a new lot today and inject it. Within 24 hours, all sugars are controlled. So despite everything, this insulin must have missed the cold chain at some point, despite all the boxes being ticked. So this is an error which can happen. So most insulins remain potent and effective for up to a month. This is another error which happens. Our patients think that every time they take the pen out, the pen has to go back into the fridge. No. Once the pen is out, the pen can stay out for 28 days happily, as long as it is not in a place where sun is shining on it, as long as its room temperature is 15 to 25 degrees, up to 30 degrees is allowed. There is a very nice study from Vellore. If they want to put the pen back, the needle has to be taken out, and then the pen has to go back into the fridge. Insulin should never be frozen. We know that. Discard vials or cartridges if they are discolored, flakes are seen. This is another small issue here in our country, because we are told that once you open a vial, once you open something, after 28 days you have to discard. And there are people who are getting say glargine 4 units to 6 units per day, and 300 units are not going to finish in 30 days. So what do you do with them? Again, storage of insulin refrigerators, etc. This is a big issue in our country because many of our pharmacies do not have a fridge. They do not have electricity at night. We've written a very nice NIS kind of a summary is being published regarding all the storage issues. And of course, administration errors, I don't want to go into detail. We have discussed this 100 times. One of the commonest ones in our country is mismatch between the vial and the syringe. 100 IU 40 unit syringe, 40 IU 100 syringe. Handling of the device, storage, which I've just discussed. This is a big bugbear, a big error in our country. Patients do not do SMBG. We had a nice debate in IDL about what SMBG we should do. We should do what you call continuous glucose monitoring, SMBG. Are Baba, 80 to 90% of patients don't even do SMBG. What we are debating about SMBG and continuous glucose monitoring. If they don't do SMBG, the purpose of insulin therapy fails. So as a physician, if you are starting insulin, you have to spend time educating them that they have to do SMBG at home. If they can't do it twice a week, at least once a week. If they can't do it once a week, at least once a fortnight, so that they can titrate the insulin. Non-adjustment of insulin dose is because of not doing SMBG, injection site issues. So I think all of us give this sheet to the patient as to where to inject. Despite that, you'll be surprised. I had a patient from a neighboring state who continuously injected through her dress. Despite telling her 150 times not to do it, she would keep injecting it through her salwar because she could not do it with the after lifting the salwar. Fortunately, she never had any infection. And my last error, I would say, is inertia, both from the patient side, but more so from the physician side. And this is the number 2 point, why there is the inertia. You ask yourself, when you see a patient tomorrow, day after in your clinic with an HbA1c of 8% on 3 OHAs, ask yourself how long this has been there and how long you have not discussed insulin with your patient. So with that, I will stop. I have discussed about mostly physician errors, little bit about the dispensing errors, and little bit about the administration errors. With that, I'll stop. I think Sanjay is already doing
No. I'm just telling this. Thank you very much. You got out very nicely the physician error, prescribing errors, the dispensing error, and administration errors. All of us have stories about different types of stories about patients doing the mistake or seeing prescriptions which you have been enumerating for such a long time as to how different they are. And the commonest thing, using 100 IU with a 40 IU syringe and a 40 IU to 100 IU syringe. Just want to share a small example. Now we have many of these caregivers, especially in elderly population. So whenever the patients are admitted, you train the caregiver. But my nurse forgets to ask, who's the caregiver who's going to stay with him and train somebody else? And this our gentleman goes back home and doesn't know how to take it. This is one. The second, SMBG, as you pointed out, that if you don't titrate, there's no point in you giving insulin to the right, to the target which you want to achieve. And one of the things which you can use best for titration and which have been successful for a long time using technology. So every day asking them to report back, though it is not something which is remunerative or it takes up too much of your time if you have a lot of patients. But if it is reported back to the nurse or something like this. Now, before 5 years ago, when I started taking care of post-CABG patient, every day I used to get a call from the department saying that the sugars are 400. We put in a proactive approach. I don't get even a call now. The whole idea is titration and saying how you do this. And I know we all have our stories and they can go on and on. Thank you, Dr. JJ, for enumerating that wonderfully, and not a topic which everybody speaks, and it's in symposia and it goes away. Anything for Subhash to comment on? And I don't know if Subhash is there.
Subhash, audio is an
still
issue.
having a problem. Okay. Thank you very much. Not an easy topic also to speak on. It's not something which is there, but it's common errors.
Dr. Mukherjee.
Thank you. Yes. If you have any
Dr.
questions.
Mukherjee, can I make one simple comment?
Please,
yeah, Dr. Aloke, please.
Yeah. I think the biggest mistake we do is that when we write a prescription, we leave it everything to the pharmacist, that he will tell how to inject, where to inject, how to keep. This is the biggest mistake we do because of lack of time. One very interesting instance I would like to share with all of you. In my clinic, I have trained my staff. I also ask every patient that whenever you come with your insulin pen or insulin vial, insulin syringes. And every time I repeatedly ask, where do you inject? Show me the site. How do you inject? So that it may be reiterated every time, reinforced. Few days back, a lady came who was put on insulin for the first time. And after 10 days, when patient came, her sugar went up 50 or 100 milligram from the previous reading. So we were very much worried that why, despite giving insulin, instead of coming down, it has gone up. And despite all the things being checked. We asked to inject in front of us. The patient injected nicely. The insulin cartridge was also emptied as per the dose written. Where do you keep it? I keep it in the fridge. Where do you keep it in the fridge? In the door. So I was also not able to ascertain that what has happened. So I just said that change the cartridge, as Dr. Mukherjee has said, and prescribe the same dose. A little bit I increased to 4 units. But later on, my staff came and said that, Doctor, don't change the dose. You change the cartridge only. The fault has been caught. So what is the fault? She had come with 2 sons. The younger son disclosed that they have bought a double door fridge. Now, think about it. We have bought a double door fridge. We are keeping it in the door, but we are keeping it in the door of the upper compartment, the freezer compartment. So partially the patient was correct. The insulin has been kept in the door. So now onwards, I always ask my patient, do you have a single door fridge or a double door fridge?
I thank you. I will add this in my talk next time.
It's a nice thing to know.
I have Sanjay with me.
You never know.
I have a small comment.
Yeah, please go ahead.
So every day you learn something.
Dr. Nossi from Egypt, please, sir.
For me and for my experience, I found that the injection in the abdomen is the best site for injection.
Yes.
Because the patient will take much care to inject himself or other to inject him in the abdomen. But for in the side or in the arm, they just simply do it quickly, and most of the time it comes in the muscular department. So for me, I found it is the best area to inject is in the abdomen.
That's a very fair comment, and thank you, Dr. Alok. I will include that double door, single door, and Sanjay, you're an RSSDI boss. See, what India needs is an army of diabetic specialist nurses, an army of what Dr. Alok said. I mean, this a doctor cannot do, no matter how much we say. I mean, I may feel proud that I do it, but it's okay. I see very few patients. I have a lot of time.
Even I do it.
But majority of my physician friends do not have that time. So no point saying bring all this. We need foot soldiers, boss. So can RSSDI take it up? You're also quite active. So
they're going to roll out a program on the same, on diabetic educator. They're going to be 1, 2, 3. It's going to be announced on Thursday or Friday during the inauguration, and after that it's going to be a free program too. It is an association with the Indian Dietetic Association and the IDF. In fact, the content and everything has been, I was also part of the content making and also vetted the content with the Dietetic Association and IDF. I think they will announce the program, and we know, and we were part of training 800. We were part of training 800 of them in Project Hope a couple of years ago. 800 nurses, but the problem is they did not remunerated enough for them. That is the whole idea. Now, all of them have gone back. Though this year is nurse and diabetes, all of them have gone back to doing their own nursing. They're not core nursing, rather than pursuing something or in a clinic teaching diabetes patient. I think there are multiple issues in this. Let's see. We keep on training and more and more people know about it.
Can I make a 30 seconds comment? 30 seconds. I completely agree that nursing, we need a lot of training in the nursing staff. I can share my today's experience in the ICU today. We use an infusion pump where they mix up 40 units of insulin in 40 ml of normal saline, and it keeps running. And I tell you, the infusion pump started yesterday evening at 6 o'clock. Is still running in the morning with 6 ml per hour. So the infusion pump got finished, and the patient is still having a note that she's receiving infusion of 6 ml per hour, and the sugars are still the same. So I think the nursing staff should know the basics, that if the infusion pump is going on for 6 ml per hour, that infusion needs to get over in 6 to 8 hours time. That is very, very important, which I think is not been trained well. So the nursing education and the educators all need to be very much strengthened now to actually enhance the proper insulinization of our patients and to improve the outcome in long run. That is.
I did not touch the errors in the hospital because there are so many. This was a general audience, so I just stuck to outpatient insulin administration. In hospital, there are so many other errors. So
you keep changing every day. You don't know who to train and who not to. I keep doing it once in 3 months. And last comment, Dr. Sunil wants to say something. Yes, Dr. Sunil, go ahead.
Congratulations, Dr. JJ. But this particular topic of educator is really very close to us. So just wanted to comment on that. That National Diabetes Educator Program is running almost since 9 years now, and we have almost 30 centers across the country, and we are creating almost 20 students every year, and it's a 10 months course. That's one thing. Second, as Sanjay has said, that we are coming out with the nutrition with ID and Indian Dietetic Association, RSSDI, and of course IDF as a backup. But we are also coming out with another RSSDI educators program. Now this IDA program is with dietitians who are qualified dietitians, only for them. Sanjay, we are coming out with, we have already launched last year. Now will enroll all the modules. There are 5 modules we already created, and that will be again launched in this for this educators program. As what JJ said, we don't need only nutritionists. We need
will get everybody.
Technicians. We need anyone who's 12th plus, preferably from the science background, technicians, all those other RMOs, they all can be trained as educators.
Sunil, can I just ask, you have trained 20 per year for 9 years, so 180, how many of them are still on the job?
Not 180, sir, not 180, 30 centers, 20 per annum, so more than 6,000 educators now.
Where are they? Are they still on the job, or have they left?
Yes, they are on the job. They are at various centers. I'm not sure about Bengal, but we are sure that in this part of the country,
we trained 800 people, and we can hardly find them. Few of them practicing.
Yes,
that is the
majority just run away, boss.
Yeah, we still need more. Many of them get married, and we understand that.
Okay. Now this is a topic which will never end. We can keep on discussing. Thank you, Dr. JJ, for this, and all the other panelists for their comments and sharing their experience. It was wonderful listening to all of you. And over to Arvind. Thank you, Arvind, and please take over. And then we have to the next topic. Thank you very much.
Thanks, JJ, for being the part of the conference. I think much practical topic you discussed in a very good way. Thanks, Dr. Sanjay. Dr. Subhash unable to connect because of some audio issues. Thank you all for being a part of the conference.
Thank you. Thank you, Arvind. Thank you, Chichi. Bye.
Moving on to this next session. The topic is a foundational place of SGLT2 inhibition in empowering cardiorenal risk modification. To speak on this subject, we have got Professor S.S. Iyengar, consultant cardiologist from Bangalore. To chair this session, we have Dr. Bijay Patni, consultant physician and diabetologist, HOD, Diabetes Wellness Care, visiting consultant at Birla Heart Research Center, Bilowi Nursing Home. He is the founder, Diabetic Research and Welfare Association, organizing secretary and scientific chairperson of annual conference of DRWA since 2014. He is a regular faculty at various local and national symposium, and is a life member of RSSDA, DRWA, DIPSI, and DFSI. Along with Dr. Bijay, we have Dr. Kiran Nidagundi, a consultant physician and diabetologist from Bangalore, to chair this session. Over to Dr. Bijay and Dr. Kiran for the further proceedings.
Thank you, Dr. Arvinda. First and foremost, I thank you for such an excellent ongoing symposium and making me a part of it. So yesterday evening, I would say, we had an excellent and energetic deliberation by Dr. A.K. Singh on the CVOTs and the renal outcomes trials with SGLT inhibitors, giving us probably the insight into almost where these various molecules can be used, giving those practical aspects as well. Now, taking it forward, we would like to hear our esteemed speaker today, Dr. Iyengar, who probably needs no introduction, but I'll request Dr. Kiran to introduce him. He's going to give an insight into the role of SGLT2 inhibitors in reducing the cardiorenal risk.
Thank you. Thank you, Dr. Patni.
Yeah, I asked Dr. Kiran to introduce Dr. Iyengar.
Thank you, Dr. Patni, and thank you once again. Thank you, Dr. Arvind, for giving me the opportunity to chair this session. So today's our speaker, he doesn't require any kind of introduction. Dr. S.S. Iyengar, sir, is a physician to Chief of Air Staff, Indian Air Force, New Delhi, cardiologist, Command Hospital, Air Force, Bangalore, professor and head of cardiology, St. John's Medical College, Hospital, Bangalore, He has Vasistha Seva Medical Medal Award by the President of India in 1982, Life Member of Cardiology Society of India, Fellow of Indian College of Cardiology, and many more titles on his name. So over to you, Dr. S.S. Iyengar, sir.
Good morning, Chairman, ladies and gentlemen. Kindly permit me to share the screen. After that interesting talk on insulin, now we shift to SGLT2 field. And I thank Dr. Arvind and his team for this opportunity. Foundational place of SGLT2 inhibition in empowering cardiorenal risk modification. What does foundational mean? It is not that we are talking about the type of makeup that is spread over the face before you put on more and sometimes to hide the unwanted marks. But what we are talking about is the basic ideas and structures from which something important develops, or the fundamental principles on which something important is developed, or the basis on which it develops. Let me go through a few words of introduction, then burden of DM, heart failure, and CKD, then clinical trials of SGLT2 inhibitors. How do they act, these wonderful drugs? What are the mechanism of action of these drugs? Then there are guidelines, of course, there are plenty of them, and few concluding remarks. Now, we all know the alarmingly increasing burden of diabetes in India. It is 8.8% in prevalence, and population is about 72.8 million, and is likely to increase to 151 million, 15.1 million in 2045 in South Asia. Now, heart failure poses a significant global disease burden. There are more than 60 million patients worldwide who are suffering from heart failure, and it is the #1 reason for hospitalization in patients aged more than 65 years, and 24% get hospitalized within 30 days of discharge again. And approximately 50% of patients diagnosed with heart failure will die within 5 years. And heart failure has a wide clinical implications. It is also including the potential for kidney damage. Because of the RAS activation, consequently sodium and water retention, vasoconstriction, there is kidney injury. There's decline in kidney function due to kidney hypoperfusion, subsequent GFR decline, and tubular cell toxicity. Diabetes in kidney, more than 40% people with diabetes are likely to develop CKD, including significant number who will develop kidney failure requiring dialysis or transplantation. Now we know that diabetes increases the risk of coronary artery disease and cardiovascular disease, and cardiovascular disease, heart failure, and CKD, that are all interrelated. And they progress along the risk continuum, ultimately resulting in cardiovascular death, starting with endothelial. These are the risk factors, diabetes being one of the important ones: endothelial dysfunction, albuminuria, chronic kidney disease, heart failure, and cardiovascular death. And SGLT2 inhibitors are a unique class of drugs that show beneficial effects across the cardiovascular risk continuum in patients with diabetes. For example, you have, it reduces the clinical risk factors like HbA1c, body weight, and blood pressure. It reduces the kidney progression of kidney disease. It reduces the cardiovascular events. It reduces the hospitalizations for heart failure and all-cause hospitalization, and it reduces mortality. It has evolved over a period of time, starting from prevention to treatment of heart failure with all these various trials: heart failure prevention, heart failure treatment. Now, SGLT2 inhibitors, as all of us are aware, initially developed to improve glycemic control, and we cardiologists and nephrologists should be very thankful to the diabetology and endocrinology community for having given us this drug for the treatment of many of our patients. And SGLT2 inhibitors, they act in the proximal axis, called PCT segment 1, and SGLT2 inhibitor act in segment 2 and segment 3. 90% of glucose absorption we know is at SGLT2 level. And there are various mechanisms that have been described which sort of explain how they benefit in all these outcomes. Now, looking at clinical trials, now SGLT2 inhibitors have shown multiple cardiovascular benefits in large randomized controlled trials. Now, these are the initial ones with EMPA, CANA, DAPA, and empagliflozin. If you look at the 3-point MACE, it was reduced significantly by empagliflozin and canagliflozin. Though reduction is there, it is not significant with DAPA and ERT2. Death or heart failure hospitalization was reduced by EMPA, CANA, and DAPA, less so with empagliflozin. When it came to heart failure hospitalization or hospitalization for heart failure, it was seen with all the gliflozins: empagliflozin, canagliflozin, dapagliflozin, and empagliflozin. When it came to cardiovascular death, it was seen only with empagliflozin, and kidney outcome was better with EMPA, CANA, and DAPA, though it was there, it was not significant with empagliflozin. Now, CREDENCE is a trial which looked at patients with type 2 diabetes and albuminuric CKD. And it showed the significant reduction in the primary composite outcome of end-stage kidney disease, doubling of serum creatinine, death from kidney cause for cardiovascular death by 30%. It also reduced vascular death or hospitalization of heart failure, 3-point MACE, and hospitalization of heart failure significantly. The SGLT2 inhibitors not only reduce the risk of hospitalization heart failure in patients with diabetes, but it reduces it rapidly. If you look at all these trials with CANA, EMPA, and DAPA, very early in the course of the disease or the course of the drug exposure, there is a separation of the curves in all these 3 trials in the first few weeks. There is a separation of the trial indicating that it acts rapidly, it is independent of glucose lowering, and it is insulin independent. When you look at the meta-analysis of SGLT2 trials in type 2 diabetes, when you look for hospitalization for heart failure and cardiovascular death stratified by history of heart failure, those who had history of heart failure, the hospitalization of heart failure and death were significantly reduced. Even in those who had no history of heart failure, it was reduced significantly. Then when you looked at the renal worsening and end-stage renal disease or renal death stratified by the presence of established ASCVD, those who had established CVD, it did reduce the renal outcomes. And those who had only risk factors and no established CVD, also it reduced the kidney outcomes. Now then the SGLT2 inhibitors in patients with heart failure, with diabetes or without diabetes. This is the meta-analysis of this is over. This is the empagliflozin. It is effective in heart failure with reduced ejection fraction in patients with diabetes or without diabetes. It reduces the primary endpoint by 25%, that is the death or heart failure hospitalization. It reduced secondary endpoint, that is first and recurrent heart failure hospitalization, because this is a major problem with us, patients getting re-hospitalized after being discharged for heart failure. There's 30% risk reduction, again, statistically significant. And they also reduced secondary endpoint, there is a composite of worsening renal function by nearly 50%. Empagliflozin thus prevented both serious heart failure events and serious kidney events. Then the DAPA-HF trial, also again in patients with and without diabetes. In patients, there are about 4,700 patients. It reduced the primary outcome of worsening heart failure and CV death by 26%. It reduced the heart failure hospitalization by or CV death by 25%. Heart failure has total death in the heart failure hospitalization. Then the quality of life improved considerably. Composite of kidney outcomes reduced, all-cause mortality reduced with the DAPA. So DAPA also prevented serious heart failure events, serious kidney failure events in this trial. Now, when you combine these 2 trials, what they found was SGLT2 inhibitors in patients with heart failure with reduced ejection fraction the meta-analysis of this EMPEROR reduced and DAPA trials. Total, if you see, first heart failure hospitalization and or CV death was significantly reduced by 19%, 11%, and cardiovascular death again significantly reduced. Then first heart failure hospitalization significantly reduced in this meta-analysis. All-cause death, again, significant reduction in this meta-analysis of both EMPA and DAPA. And first kidney composite outcome, that is more than 50% sustained decline in eGFR, end-stage renal disease or renal death, were also significantly reduced in this meta-analysis done with EMPA and DAPA trials. Then there's a DAPA CKD trial, the second randomized control of an SGLT2 inhibitors among patients exclusively with CKD. Means these were CKD patients with type 2 diabetes, 68% of them, and they were without diabetes also in 32%. And all of them had albuminuria. And baseline eGFR varied from 25 to 75. In this trial, it was reported that dapagliflozin 10 milligram daily reduced the risk of primary composite outcome, that is the sustained 50% reduction in eGFR, kidney failure, or renal or cardiovascular death compared with placebo. The reported benefits with regard to primary outcome were similar by diabetic status and across baseline levels of albuminuria or GFR. Then secondary outcomes also including all-cause mortality were also significantly improved. Now, a few thoughts from the nephrologist aspect. For them, the foundational therapy of any diabetes with CKD starts with exercise, nutrition, smoking cessation, lipid management, blood pressure control, and glycemic control in all patients. And most patients will have SGLT2 inhibitors and RAS blockade. And some of them will have antiplatelet therapy. So renin-angiotensin therapy is recommended for patients who have albuminuria and hypertension. So physical activity, nutrition, and weight loss, and all of them will get metformin and SGLT2 inhibitor. So this combination of metformin and SGLT2 inhibitor is logical because they have different mechanism of action and neither carries increased risk of hypoglycemia. Even if there is a glycemic target is achieved with metformin, an SGLT2 inhibitor should be added in these patients for the beneficial effect on CKD progression and cardiovascular outcome. So we all have a lot of sentimental attachment to metformin, and it has a lot of historical value, so it will remain with us for a long time to come. The only thing, metformin has to be discontinued if GFR falls less than 30 or patient goes on to dialysis, and SGLT2 inhibitors should not be initiated if eGFR is less than 30 or patient goes on to dialysis. Then there is a meta-analysis which looked at association of SGLT2 inhibitors with cardiovascular and kidney outcomes in patients with type 2 diabetes. It looked at EMPA-REG outcome, CANVAS program, the CREATINI, CREDENCE, and VERTIS. These are the numbers, and the reduced kidney function was less than 60 ml per minute per 1.73 square meter. And if you looked at the risk reduction across study population, patients with ASCVD, a significant benefit. Patients without CVD, there is a significant, there is a benefit, but it is not significant. Look at the reduction in the cardiovascular death in ASCVD patient. Again, there is significant benefit in patients with ASCVD. There is a benefit which is not significant in patients without ASCVD. And this risk, decreased risk in cardiovascular death was mostly driven by EMPA-REG outcome study. Looking at the decreased risk of all-cause mortality in ASCVD patients, patients with ASCVD significantly reduced. Again, this was basically driven by the EMPA-REG outcome. Patients without ASCVD, reduction is there, but it is not significant. Consistent improvement in hospitalization heart failure outcomes across all the SGLT2 inhibitors in this meta-analysis, patients with ASCVD, patients without ASCVD. Consistent improvement in clinical kidney outcomes across SGLT2 inhibitors in this meta-analysis, If you see patients with ASCVD, patients without ASCVD. Now, how does it do all these miraculous things or very gratifying results with SGLT2 inhibitors? When it comes to the benefit in the kidneys, there is a natriuresis and change in tissue sodium handling, tubuloglomerular feedback, glomerular afferent arteriolar constriction that decreases the intraglomerular pressure and decreases the intraglomerular hyperfiltration, resulting in decreased albuminuria and decline in GFR initially. And of course, the various effects are there to explain the risk of heart failure, that is decrease in hematocrit, decrease in blood pressure, improve in vascular function, decrease in uric acid, of course, the body fat, ketone body production, the myocardial energetics, all these will have beneficial effect in reducing the risk of heart failure. Now, this is just to emphasize that we know that it reduces the epicardial fat. It also reduces the total body, central body fat. This epicardial fat and central body fat are highly inflammatory sort of organs, and by reducing that, it reduces the inflammation in the body. There's also a theory that it increases the erythropoietin, which has got beneficial effects on the myocardium, neuroprotection, as well as the bone marrow. And if you look at the effect of empagliflozin on glucose oxidation, ketone oxidation, fatty oxidation goes up, the glycolysis decreases. So that improves the cardiac energy production. Another important thing is the sodium hydrogen exchange. These SGLT2 inhibitors block this sodium hydrogen exchange. They reduce the cytoplasmic sodium and calcium, thus offering cardioprotection. They differently regulate the interstitial versus intravascular compartment when compared with loop diuretics. Here, the SGLT2 will decrease sodium, they decrease interstitial volume much more than the intravascular volume as compared to loop diuretics. And this has been explained that it reduces the intraglomerular pressure for nephroprotection. So the unique diuretic effect is it selectively reduces interstitial volume with minimal change in the blood volume. There is no counter-regulatory stimulation of renin-angiotensin system. There is no hypokalemia. There is improved renal function, reduces uric acid levels, no hyperglycemic effect. So now what do the guidelines say? The guidelines Gallo and 2019 update says if a patient high risk of ASCVD, CKD, heart failure, if ASCVD predominates, they go for GLP-1 RA or SGLT2. But if heart failure or CKD predominate, they prefer SGLT2 inhibitors. AACE, lifestyle therapy, and glycemic control, then independent of glycemic control, if established ASCVD is there, high risk is there of ASCVD, CKD is there, or heart failure with reduced ejection fraction is there, one should start GLP-1 analogs or SGLT2 inhibitors with proven efficacy. And what do the ADA say? Of course, the first-line therapy will continue to be metformin, then consider independently of baseline A1C and individual A1C, the SGLT2 inhibitors. Whereas European guidelines are a little more aggressive in the use of SGLT2 inhibitors in patients who are drug-naive patients, they recommend SGLT2 inhibitors as even a monotherapy. Now, heart failure and ESC update recently announced when they assessed the landscape for the use of SGLT2 inhibitor in the prevention of heart failure, it can include canagliflozin, dapagliflozin in EMPA and HER2 have consistently demonstrated to be effective in prevention of heart failure hospitalization in patients with type 2 diabetes and established cardiovascular disease or those who are at high risk. Whereas DAPA and EMPA have been recommended to reduce the combined risk of heart failure hospitalization, CV death in symptomatic patients with heart failure and reduced ejection fraction already receiving guideline-directed medical therapy, regardless of presence of type 2 diabetes. Now, these are the 5 pathways and 4 foundational pillars for management of heart failure. These are the 5 pathways: ARNI, ACE, MRA, beta blocker, and SGLT2. And we have got 4 pillars because ACE and ARBs are combined with ARNI, and we've got mineralocorticoid receptor antagonists, beta blockers, then MPA and DAPA are the 4th pillar. So these are the 4 pillars or 4 foundational pillars for the therapy of heart failure. When someone would like to add 2 more pillars, that is ICDs, CRT, and research in this field of heart failure, diabetes, and kidney disease. Now, SGLT2 inhibitors is a drug with cardiorenal benefit, and it also lowers blood sugar, is what a neurologist said. Now, in a roundtable discussion in ADA in 2020, they said, have you lost SGLT2 inhibitors to cardiologists? I think nobody should have this discussion. Our medical community is the winner when we have this SGLT2 inhibitors. So we all should no longer look at only glucose reduction. We need to look at the pump, pipes, and filter, the heart, vessel, and the kidney. So we should put our heart and kidneys into diabetes care. So SGLT2 inhibitors, the new drug class, improved for treatment of diabetes. It has efficacy on top of excellent background therapy, including neprilysin inhibition. It has rapid onset of the benefit. It is efficacy is independent of glycemic status. There is a new drug which has come, sotagliflozin, which has dual SGLT2 and SGLT2 inhibitors. One is a SOLOIST trial, other one is a SCORE trial. Both are very positive trials. This is done in patients with heart condition. This is with patients with CKD. And no talk is complete without talking about COVID. COVID patient who has COVID and in intensive care, we have to stop SGLT2 inhibitors because there's a sick day rule, what is called the risk of volume depletion, hypotension, ketoacidosis, potential drug interactions. But there is a potential for the future, SGLT2 inhibitors and organ protection in diabetes and outside diabetes, heart failure in CKD, lung diseases, ongoing RCTs to assess organ protection in COVID-19. Thank you very much for your kind attention.
Thank you. Dr. Patni sir, over to you. Dr. Patni sir. Yes, sir.
Thank you, Dr. Iyengar. As expected, he probably covered everything. We can take few questions, and I have a small query as such. Whether SGLT2 leads to AKI, this is a very common stuff which is asked every time. So can you highlight on that particular point?
It doesn't lead to AKI. Initially, there is a dip in the EGFR, but gradually it comes back to normal. Period, it protects kidneys.
Dr. Kiran, you want to take any questions from the chat box?
No, sir, nothing. How to see the chat box? I'm just missing chat box here, sir.
If there's any nephrologist here, probably.
Arvind, how to check the chat?
You can add
questions here.
No questions in the chat box.
No questions. Okay.
Right. So it was always a cardiologist would have taken over SGLT2. Now I think the nephrologist might also ask for this molecule because in the DAPA CKD, probably without diabetes also they have shown those reduction. So can it be considered as a drug for nephrologists in the patients without diabetes?
Yes. It is going to come as a drug even patients without diabetes and patients with diabetes and non-diabetic microalbuminemia, it has shown benefit.
I think Dr. S.S. Iyengar has rightly aptly said, it's not a question of diabetologist or a nephrologist or cardiologist. Ultimately, the medical community will win with this new molecule. Thank you,
yes, you are
Dr.
Right.
Yeah, thank you, Dr. S.S. Iyengar, for giving this wonderful talk. And thank you, Dr. Kiran and Dr. Pijay, for sharing this session. Thank you so much for being a part of this.
Thank you, Iyengar, sir. Thank you very much. Thank you.
Thank you. Thank you.
So moving on to the next session by Dr. Sunil Gupta from Nagpur. To chair this session, we have Dr. Anil Kumar is the consultant diabetologist from KIER, that is Karnataka Institute of Endocrinology and Research Center in Bangalore. He was the past president of KRSSDI and is the current president of Diabetes Club. And we have Dr. Satish Ramanna, is a consultant physician and diabetologist from Bangalore, very active member of IMA. And to chair, over to the chairperson, Dr. Anil Kumar and Dr. Satish Ramanna for the further proceedings, please.
Thank you, Arvind. I think it's a wonderful conference. We are having a scientific feast. Now, I think we have the next lecture by Dr. Sunil. I want the CV slide. Of course, Dr. Sunil Gupta, if we see the CV slide, I might require 5 to 10 minutes to read the CV. So probably I will highlight some of the important aspects of CV of Dr. Sunil Gupta. He's the diabetologist from Nagpur, Sunil Diabetes Care and Research Center, Nagpur. He has many published, I think 193 articles, a huge publications, and 6 consecutive Best National Research Paper Awards, honored with several orations, presidential orations, and his center is recognized as the IDF Center for Education and Excellence in Diabetes Care, and is the national treasurer of RSSDI in 2019-22, national president DIPSI, and he was awarded the only diabetologist of the country, honored with outstanding young person. And then he has several other awards. I think for want of time, over to Dr. Sunil Gupta for the talk.
Yeah, thank you very much, Dr. Anil Kumar. I'll just take 30 seconds for the sharing. Yeah, I can share the slides. I feel slides are visible.
Yeah.
Yes, Dr. Sunil. Yes, Dr. Sunil.
Yeah. So thank you very much once again, Dr. Arvinda and his team. And it's always a pleasure to be there with you. And I still remember that I had been to your place last time and delivered the oration. It was a wonderful experience. And once again, I'm here to talk on something which is little different than routine. And in this era of SGLT2 inhibitors majorly, and also to the extent on gliptins, I feel sulfonylureas are being little sidelined, but still despite that, we have some good data to share with, which possibly is a new data for most of us. So what is the improved relevance of low dose modern sulfonylureas with the background of COVID pandemic? That's what is my talk today. And congratulations, Dr. Arvinda, wonderful program, wonderful academic feast, you and your team. When will we call sulfonylurea as low dose and that to be a new sulfonylurea or model sulfonylurea? So we have only glimepiride with us, which is a modern sulfonylurea, which we traditionally call it as a newer or modern sulfonylurea. Low dose means possibly it is our country, and then some more data available from across many part of the world, that earlier we had only 1 milligram, 2 milligram, and then 3 and up to 8 milligram of glimepiride is being advocated, can be used as a maximum dose of glimepiride. But I feel all my clinician friends should know that once the 2 milligram of twice a day maximum 4 milligram of glimepiride works, then it stops working. Then 5, 6, or 8 or 7, nothing works. So the maximum dose, I don't think we all, no one of us nowadays gives more than 4 milligram per day of glimepiride. But when we talk about the lower dose, the 0.5 milligram combination is available in our country, and now we have many of the people who are preferring this combination, maybe with the fear of avoiding beta cell exhaustion, beta cell apoptosis, or some kind of hyperinsulinemia in patient with type 2 diabetes, with that due and low risk of hypoglycemia, low risk of weight, less weight gain, and possibly the cost is one of the important parameter why low dose sulfonylurea is being more preferred. And in view of this COVID, do we have some data to share that what kind of which particular molecule is being preferred more often when you have almost 10 months lockdown across the world. So let us see some of the surveys which are in record, not published, but I would like to share here. There's a survey conducted amongst the healthcare professionals in our country. And what are the changes we have seen amongst doctors during this pandemic? We don't have a comparative data, but we have some surveys which are opinion of various healthcare professionals. This was done in July, around 150 healthcare professionals. And if you see here, the modern sulfonylureas is glimepiride and metformin fixed drug combination is being used by almost 80% of them. They prefer using it. DPP-4 inhibitors around 53%. So you might see an overlap of these percentages because few of them might have a combination of preferring combination of the two. That's why it has been taken from various medical professionals across, and there can be more than one answer given to in this survey. And so around 50% DPP-4 inhibitors, metformin 40%, insulin 37%. Modern sulfonylureas like glimepiride alone is around 1/4 of them. SGLT2 inhibitors is still only 20%, and glitazone around 8%. So still in our population, in this July, when it was a mid kind of from after almost 3 months of the lockdown, they still prefer sulfonylurea, possibly because of easy accessibility, affordability, and availability across even all the corners and urban and rural places of the country. What could be the reason of this combination being featured in almost around 80% of the population? And there are 5 questions which were asked: whether it is good glycemic control, whether it is weight neutral benefit, less hypoglycemic risk, cardiovascular safety, or can it be a safely prescribed drug with the insulin or other oral drugs? And if you won't believe, almost 75% of the healthcare professionals have said that all of the above. That means people amongst our colleagues, they believe that this is a combination which gives a good glycemic control. They believe that it is not causing weight gain as we expect from other sulfonylureas when they are given full dose or the higher doses. So there is not much of the concern of weight gain when you have a glimepiride combination, especially in lower doses. Risk of hypoglycemia also gets lesser when you use lower doses. Of course, we have a carmelita data now available with us which has shown the CV safety, and then can be a safely prescribed drug along with insulin, we all know. And so most of them, they have answered and believe on these characteristics of glimepiride. And when we talk about the low dose uses, increase in the use of the low dose, almost 85% of them, they believe this is around this September 2020, and 460 odd healthcare professionals have been actually surveyed for this question, that what do you feel that there is increase in the use of low dose glimepiride? Instead of writing 1 milligram, people are using 0.5 or 1 milligram rather than writing 2 or 3 milligram. So people have almost 85% of the of our colleagues, they believe that during pandemic, because patients are unable to reach to a doctor, and due to this pandemic, they have to take care of one important message, that they should not land up in the drug should be easily available, and drug should not cause any hypoglycemia. And possibly that is the reason low dose of glimepiride is being used more often in this pandemic. What are the top reasons for increase in the uses of this low dose glimepiride plus metformin combination? So almost 50% says it is the efficacious and safety. Hypoglycemia, affordability, I'm repeatedly talking about affordability in our country is also one of the reasons. And of course, the availability of the drug across. So there are various reasons which have been given. Now, when you talk about glimepiride plus metformin combination, in that situation, if you talk about various components, I just have to, patient pool is in which kind of patient they are being used. So in newly diagnosed cases, almost 1/3 patients who are marginally uncontrolled. So any mild to moderate kind of disease, new onset cases with not HbA1c is not very high. I feel in such patients, early type 2 diabetes, elderly people population, you don't want to have hypoglycemia. Even in patient with long duration of diabetes, but very less number, majority of them, they feel newly diagnosed cases, and those patients who are marginally uncontrolled with the existing therapy, or even early type 2 diabetes, and some of the elderly population. In patients who are long duration of diabetes, associated comorbid condition, and hepatic or renal impairment, this drug is not being preferred. And that is what we should be knowing about, that this drug is basically contraindicated in patients who have renal impairment or advanced renal impairment and even advanced hepatic disease. So why we can prefer low dose sulfonylurea and metformin in this pandemic is the efficacy, that it is efficacious. It is almost similar to gliptin, where there is some data available on this. The risk of hypoglycemia is much less. I will not say it is no risk of hypoglycemia, but certainly risk is lesser than the 2 or 3 milligram or other sulfonylureas, especially when you compare with glibenclamide. It seemed to be weight neutral when it is being used in a lower doses. It is of course affordable and accessible to almost everyone at all the corners. Now, this is a data which actually I have gone through for the first time, though it's been available since almost 13 years now, because most of us now are busy in spreading on SGLT2 inhibitors, gliptin, since last almost 1.5 decades, and that is why this remained cornered. But there's small data of around 50 to 60 patients where they have used a low dose 0.5 milligram of glimepiride significantly has reduced the HOMA-IR and HOMA-beta, have improved the HOMA-beta cell function. So metformin plus low dose glimepiride significantly improves the homeostasis model assessment, HOMA-IR and beta cell function, insulin resistance and beta cell function, without causing hyperinsulinemia in patient with type 2 diabetes. This is HOMA-IR. This is metformin alone, and this is metformin with glimepiride. There is reduction in the insulin levels and improvement in the insulin sensitivity, as well as in HOMA beta model. They could show little improvement here in this beta cell health. So there is certain benefit which seems to be there in low dose, and they say that it is when you use a lower dose, then actually there is an increase because of use of metformin. Along with it, of course, metformin is an insulin sensitizer, but we all also know that glimepiride has shown some data to actually have some peripheral insulin sensitizing capacity, and it might downregulate the escape of insulin receptors. So you have more insulin receptors available. So 63.5% reduction in the HOMA-IR and no beta cell hyperfunction and resultant hyperinsulinemia because you're using a lower dose of 0.5 milligram, and improves beta cell health in the HOMA beta cell data. So we have at least small data, but it is available to us that it is actually not causing hyperinsulinemia to those type 2 diabetics who are already hyperinsulinic. And this is metformin plus low dose glimepiride significantly improves the homeostasis model assessment of insulin resistance and beta cell function without hyperinsulinemia in patient with type 2 diabetes. This is a paper which is worth going for. Metformin plus low dose of glimepiride plus maybe plus diet plus physical activity is more effective treatment for type 2 diabetes than metformin plus diet therapy or physical activity alone. So when we give dual combination of small doses of sulfonylurea along with metformin, possibly it is better. It has a benefit not only on the glycemic profile, but also the beta cell health and the insulin resistance. It is inexpensive, reliable, less invasive, less labor intensive method. This is a mathematical method. They have calculated this by measuring fasting glucose and insulin levels and the beta cell health have been. So this is a mathematical model they have used. And now you have a global evidences, whether it is a Williams textbook of endocrinology or whether it's American Journal or many other journals, they have come out with various articles published on this. And this is a text from Williams endocrinology textbook, and what they have shown is a small dose. This is a 12th edition, where they have shown that a small dose of sulfonylurea, maybe 0.5 milligram to 1 milligram of glimepiride or 2.5 milligram of extended release glipizide are remarkably effective, particularly in patients receiving concomitant insulin sensitizing therapy like metformin. Similarly, you have a data which was published in the Indian Journal of Endocrinology Metabolism 2015, and this is Joe George, who's from Kerala, and he also says that there's a data of around, they say the first Indian study using glimepiride 0.5 plus metformin. There's Indian data around 900 plus patient. They have been followed for 3 months, and the therapy was well tolerated, no reports of hypoglycemia or weight gain. And initiating therapy with combination of glimepiride 0.5 milligram plus metformin 500 can be considered suitable in patient with early type 2 diabetes, and it does not give rise to beta cell exhaustion. There is, of course, reduction in fasting and postprandial blood glucose. So it could be one of the choice apart from other choices you have. So low dose glimepiride is effective even for the pancreatic beta cell health. And as I've already told you, through HOMA-IR and HOMA-beta model, your low dose glimepiride may not add an extra burden to the beta cell, leading to stable glycemic control. And this is small amount of increase in insulin levels postprandial, and glucose levels are coming down. So this again another publication in the Diabetes Journal. There's also a data which is showing, along with the combination of sitagliptin and low dose in Japanese individuals, and they have shown that whether you use the high dose versus the low dose of glimepiride, the reduction in the now if you use the baseline of around here around 8.1, and here it is around 8.4, the reduction is almost similar of 1.1% of HbA1c, and it was statistically significant. So change in the HbA1c after 24 weeks, the actual mean HbA1c in 2 groups were shown. The values have shown that there is statistically significant reduction of p-value of 0.01, even with the lower dose of glimepiride with 0.5 milligram glimepiride with 500 milligram metformin versus the high dose. So low dose proves durable as an add-on to even sitagliptin, and the low dose of glimepiride with sitagliptin improves glycemic control without dose dependency in the patient with type 2 diabetes, inadequately control on high dose of glimepiride. So this is what we want. We don't want to have more beta cell exhaustion. So instead of going for 2 or 3 milligram, you use 1.5 milligram or 1 milligram per day. So combination of sitagliptin with low dose of glimepiride and metformin might also be a good combination. And here is sufficient for glycemic control as compared to higher dose sitagliptin. Here they have not used metformin. What are the cases where can we use this? The clinical utilization pattern of multiple strength of glimepiride and metformin fixed dose combination in type 2 diabetes. So 50% of the type 2 diabetes patients were on low dose of glimepiride and metformin, which was 500, 850, and 1000. Here it is 0.5 and 1 milligram. And this is JAPI 2020 July publication. 29% by Dr. Unnikrishnan, 29% of younger population are 18 to 44 years, and 17% of elderly population with type 2 diabetes are on this drug in combination. And 64% of T2DM, either newly diagnosed or less than 5 years, were on this combination. No hypoglycemia observed amongst these patients. So this is being very aggressively used across the country, and people have accepted this combination, this Indian scenario. So finally, it seems that there is also a consensus statement from various organizations that this can be one of the combination, one of the drug of choice. We always have an apprehension of using a long-acting drug, especially sulfonylureas in elderly patients or even patients who are obese. and even in early mild renal impairment patient. But when you use a lower dose of glimepiride, whether it's elderly patient, whether the person is at high risk of hypoglycemia, possibly when you use lower dose, that can also be taken care of. Early stages or early newly diagnosed new onset type 2 diabetes, which is mild on the beta cell function, when your dysfunction is not too bad and where beta cell are still preserved. Even obese type 2 diabetes, where affordability is an issue and hyperinsulinemia is an issue, low dose can be used with possibly little higher dose of metformin might help. And if you want to add, of course, SGLT2 inhibitors, you can certainly use that. And in very, very early stage of eGFR of more than 60 or even 45, small doses can be used. Below that, I feel we should not use it. So finally, it's a very brief talk. The take-home message from this is, because it is very focused on COVID era as well as a small dose, so I could not enter into other part of the glucose lowering therapy. Dynamics of diabetes management are changing due to COVID pandemic. It is important to choose right approach to offer appropriate diabetes care according to your setup. Consider low dose option as an important tool in your diabetes management. They are effective, they are safe, they are tolerable, affordable, and freely available. We have learned some ideal candidate patient profile who will benefit from this newly relevant formulation, which is now available across the country. Actually, I stop here. Thank you very much, Dr. Aravinda, once again for this honor.
Thank you. It was an excellent presentation by Dr. Sonil. Of course, he had a lot of evidence in favor of low-dose sulfonylurea. I think I want to add one thing. Of course, along with low-dose sulfonylurea, glimepiride 0.5 to 1 mg, we have modified release gliclazide also. I think gliclazide maybe 60 mg is also a low-dose sulfonylurea. So of course, if you see the gliclazide when compared to glimepiride in some meta-analysis has shown better cardiovascular benefit and less hypoglycemia. I think we can have both these drugs. Probably in India, glimepiride is being used more than gliclazide. But if you go to European countries, I think gliclazide is the commonest sulfonylurea they use there. So I think, as you said, the percentage of usage in one of your survey, about 80% of usage of sulfonylurea. I think in one of the US studies published in Diabetes Care in 2006 or 7, it was 60%. Now it has 46%. I think still sulfonylurea is the first most commonly used drug. Maybe in India, still 80% means it will be about 60% in future because of the reduction of cost of SGLT2 inhibitors and DPP4 inhibitors. Now we have dapagliflozin, the patent going off, and we are getting at a lesser price. And probably we have vildagliptin also at a lesser price. Now more and more people may use DPP4 and SGLT2. But I think sulfonylurea, low-dose sulfonylurea will still remain in India because of the cost. And also in rural areas, if you see, I think most of the people are prescribed sulfonylureas and metformin. Still, SGLT2 inhibitors have not entered into the rural market. That's what I feel. I think one question I want to ask, what is your experience of low-dose sulfonylurea, either glimepiride or gliclazide with insulin?
So gliclazide, when we talk about the low dose, when it is 30 milligrams sustainably, it is equivalent to actually 80 milligram, and 60 milligrams is equivalent to actually 160 milligrams. So we cannot call it as low dose. When we talk about low dose, I feel glipizide makes more sense because it is a short acting drug and low dose of glipizide. And gliclazide, if you use immediate release, possibly we'll have 40 milligram will be called as low dose, which is immediate release.
What about your
experience? Yeah, US market gliclazide is, for our other delegates who are not aware, that in US market gliclazide is not available. It is only available in Europe and available in, of course, India. But our experience with patients who are renal impairment, patient with some more comorbid condition where compliance is an issue, sustained release preparations are being used. But both of the drugs are equally good. But in renal impairment patients, I'll prefer gliclazide over glimepiride.
No, Dr. Gupta, his question was that when we start premix insulin, would you keep the sulfonylurea on board, or you will stop completely, or would you like to tap?
He asked about insulin. I'm sorry, Meena, I possibly skipped. So when in combination with insulin, we prefer both actually. Honestly, we prefer both. If you go to any of the other recommendation, they say that sulfonylurea should be fully stopped, and they just want to give metformin along with, of course, you can now use gliptins and SGLT2 inhibitors along with insulin. Now we have a lot of choices, but still most of us are using lower doses of sulfonylureas, not glibenclamide, of course, but lower dose of sulfonylurea is still being used, because the moment you withdraw sulfonylurea, sometimes your blood sugar may go haywire. So my experience is, in some patient, we try metformin along with insulin and gliptins and SGLT2 inhibitors, but sometimes we need to, I feel, continue or may add on in rare situation. But of course, we don't go more than 2 milligram 24 hours. In rare situations, 4 milligram of glimepiride. But gliclazide also being used along with insulin. In principle, in India, still we are using sulfonylurea in combination with insulin in lower doses.
Yeah, thank you. I think, as you said, if you stop sulfonylureas, the blood sugar will go haywire. Yes. We have to use low dose sulfonylurea. Probably, of course, if you get a lot of hypoglycemia, maybe we have to stop, but you should not stop suddenly. We have to taper, and maybe in future when the hypoglycemia increases, then we have to stop sulfonylureas in the Indian setup.
Dr. Gupta, what about chronic liver disease?
He has already talked.
Sorry, I'm so sorry. I joined in late. I'm extremely sorry. Okay.
Any comments from Dr. Satish, my co-chair?
Dr. Satish?
Dr. Satish, I think he is muted.
Hello, I'm audible?
Yeah, Satish, yeah.
Am I audible, sir? An excellent presentation by Dr. Sunil. And he covered extensively the topic in precise time. And I should thank Dr. Aravind for giving an opportunity to chair this session. And it was an excellent summit attended by maximum attendees and with speakers from across the globe. And I have to congratulate Dr. Aravinda, an excellent summit, Aravind. So I've been part of your this CMS earlier also from ADC, but this was excellent. And online, I didn't expect the crowd. It was 1,000 plus, almost 2,000 plus, I feel. So nice. I thank you so much, Dr. Sunil Gupta, for an excellent presentation. I thank you, Dr. Anil, also. So thank you.
Thank you, Dr. Sunil. I think we have to close the session because I know Dr. Aravind is very keen on time management. Thank you, Aravind.
Thank you. Thank you.
Thank you, Arvind, once again. Thank you.
There are two Arvinds now.
Yeah. Thank you, Dr. Sunil Gupta, for wonderful talk. Thanks,
we have
Dr.
received
Anil.
The memento before the. Thank you very much. We received the mementos before I delivered the lecture. So that's great.
Thank you, sir.
Arvind is showing from there.
So moving on to our next session is by Dr. Arvind Gupta. To chair this session, we have Dr. Ravi Kirti, is a consultant physician in Bangalore, very close of mine. He is one of the marathoner as well. He runs miles together, 41 kilometers, full marathon and all we'll be doing. He's a very active person in diabetes awareness. And along with him, we have Dr. Kashinath Dixit. He's a consultant physician and diabetologist, very closely associated with us in various activity in spreading diabetic awareness. Over to Dr. Ravi Kirti and Dr. Kashinath Dixit for the further proceedings, please.
Yeah. Congratulations, Arvind, for an excellent program. Virtual conference, hardly we sit from morning to evening. Probably this is the only conference we are sitting for hours together. Thank you, congratulations. And thank you very much for giving me an opportunity to chair this session with my close friend, Ravi Kirti. We'll come to the topic proper. The topic looks very interesting, very encouraging. The topic is learning. Learning. Learning is learning. Yeah. Unlearning. What is this unlearning? Dr. Arvind Gupta is going to tell us. We'll wait and see. And relearning. So learning, unlearning, and relearning in type 2 diabetes. I request my co-chairman, Dr. Ravi Kirti, to introduce Dr. Arvind Gupta. Dr. Ravi Kirti, please.
Thank you.
First, congratulations to Arvind for such a beautiful organization, and thanks for giving me the opportunity. And let me introduce the speaker, Sir Dr. Arvind Gupta. He's a director and a consultant physician at Jaipur Diabetes Research Center, Jaipur. And he is awarded with RSSDI Oration Gold Medal in Hyderabad. And he's organizing secretary for the 31st annual conference of RSSDI, and is a member of the project review committee of ICMR New Delhi. Is a visiting clinician at Mayo Clinic, Rochester, and he is a regional faculty diabetes course for the PHFI India. He has presented various papers in many conferences. He has got over 72 research publications in national and international publications. He is also a member of AACE and API, IMA, and RSSDI. So over to Dr. Arvind Gupta for the presentation.
Thank you. Shall I share my screen? Do you have my slides?
Yes, yeah, it's visible. Yeah,
okay, okay. Let me. Thank you, Dr. Arvinda, for the nice conference. And really, it is an academic conference, what I have seen for last 3-4 lectures, starting from Dr. Iyengar, Dr. Sunil Gupta. So my chairpersons, they have, let me first thank Dr. Arvinda for inviting me to for this wonderful conference and for the wonderful gifts he has already sent to us. Thank you very much. My chairpersons were very keen to learn about what is learning, unlearning, and relearning. We know that medicine is ever-changing science. So we learn from our own research, our own predecessors, scientists, and all these things. We relearn most of the things what we have learned earlier because we have the new facilities. Molecular understanding is very good. The modern understanding is very good. So we'll relearn what we have learned earlier from our predecessors. But unlearning is again very important. We know our computers have a limited capacity. You can't go on and go on. So once you have learned something, you have relearned something, you have to unlearn. That is very important. And I'll let you know in few moments what is my take on this particular subject. My disclosures, I don't have any potential conflict of interest, especially for this presentation. So, dear friends, what we have learned in type 2 diabetes so far. If you start from the history of diabetes, the Greek were there, our own Charak and Sushruta were there, and they have given us the beautiful definition, the understanding of the diabetes, the Greek for passing water like a siphon, beautiful diabetes meaning. Mellitus is a Latin word for sweetened with honey. So we knew about these things from our predecessors, the scientists, and then Ebers Papyrus, the Egyptian in 1500 BC, the first depiction of diabetes mellitus. Beautifully understanding the modern era is started from this Ebers Papyrus, that urination of excess amounts and manipulation of diet therapy can probably manage this type of situations. Then we knew about the physiology and pathogenesis of type 2 diabetes, and very clearly we knew about that there is a gene, metabolic, environmental cross reactions. So because of the gene and environmental cross reactions, we know that it may lead to impaired insulin secretions, and some genes may lead to insulin resistance. Probably till date, we are still learning about this particular phenomena, the gene environmental reaction, the cycle. And actually, ultimately, we knew that insulin impaired secretion and insulin resistance are the key factors for pathogenesis or causation of type 2 diabetes. Then we knew about when the electron microscope came and the beautiful staining of few scientists have done few staining of these cells are there, and we knew that these are the alpha cells and these are the beta cells. Beautifully we'll know from the staining that now these are the cells responsible for glucose metabolism. And this is the beautiful diagram. We know it is a photograph from electron microscope, which shows the typical release of insulin from the beta cells. See here how the beta cell releases the insulin, that is from the PI granules, the insulin is released. Then in obesity, what we learn about the insulin resistance, previously nobody knew about this term that insulin resistance is there for causation of diabetes. Earlier, everybody knew that it was the insulin deficiency or your beta cell defect may lead to diabetes. So insulin resistance may be an underlying cause of diabetes, especially type 2 diabetes, was the first advanced by Wilhelm Felter, and it was published in Vienna in 1931. So this term was there since 1931. And this theory was confirmed by Sir Harold Preswell Hemsworth from the University College Hospital or Medical Center in London in 1936. So these things we knew from these the big scientists, which they have worked throughout their life to coin this insulin resistance. And then the definition came by all these scientists' work that insulin resistance is defined as a failure of target organs to respond normally to the action of insulin. Insulin resistance is a condition in which the cells, particularly those of muscles, fat, and liver tissue, display the resistance to insulin. So they fail to take up the utilization of glucose for energy and metabolism. Then we knew that now the things are spending. Previously, the obesity was not known. And then suddenly the obesity upsurge in the globe. And if you see here, all the countries here, that there is an upsurge from 1960 and the projection to 2030 is enormous. So even obesity prevalence is increasing. And then we understand what we learn about the fat metabolism. The intra-abdominal or visceral fat, probably earlier it was not known. Now it is known that it is visceral fat, probably is one of the important fat which is responsible for atherosclerosis. And it is the dangerous inner fat. So visceral fat nowadays, because of new facilities, we have the MRA and the CT scans and the other scans. We know that it is the visceral fat which is responsible for atherosclerosis. And then there are certain studies which showed that the waist circumference, it correlates beautifully with the intra-abdominal obesity. And if you have this type of subcutaneous fat here and visceral fat here and if you correlate this with this waist circumference, so nowadays we can say that waist circumference, if it is more than 40 inches, it is more risk for the atherosclerosis. Then previously, again, we knew that it was the insulin defect. And now we know from new studies that insulin resistance is the root cause of diabetes, especially for type 2 diabetes. The genetic factors and again environmental factors like obesity, age, diet, especially the Western diet, or you have a more calorie diet and lack of exercise, along with if you have a family history and ethnicity, probably you are 80% having risk of insulin resistance. And then Randall in 1963 beautifully depicted or provided us the mechanism how the glucose provides the energy through the TCA or tricarboxylic acid cycle. And it was the free fatty acid overload along with the glucose that is now glucose metabolism. Probably for the first time we knew by this, and this is the Randall cycle. And then it was a free fatty acid theory came into the existence, and of course there was a weak correlation between insulin sensitivity and plasma free acid concentration. Of course, if you see the CC, it is less than 0.6, and if you see the rate of fatty acid oxidation in the skeletal muscle, of course we understand by this that local lipolysis of triglyceride stores in skeletal muscle is one of the reasons for insulin resistance. So now we are still learning the molecular mechanisms, and I'm taking you from the base, the physiology in 19th century. Now we are coming to the 20th century. And for the first time, we came to know about the PPAR gamma. And we know that prevention of fat overload in non-adipose tissue is because of this particular very beautiful enzyme, the PPAR gamma versus PPAR alpha activation. If you see the mechanism here, whether it's a liver, skeletal muscles, or in pancreas, it is the PPAR gamma which may lead to the shift in lipogenic burden, and that may be reason for insulin resistance. Then insulin actions and secretion in type 2 diabetes. Probably previously we did not know about that. Not all obese subjects develop type 2 diabetes. So what was the reason for that? Ultimately, it is the beta cell dysfunction in type 2 diabetes, which is the basic reason for diabetes. Then this is the first beautiful experiment by the Robertson and Porte, which published in 1973. And what they told us that it is the acute insulin response to IV glucose. Probably this is the first experiment whereby we came to know that there is a difference between IV insulin, IV glucose and the oral glucose, and probably the existence of incretins came into the existence. So dear friends, we learned from in 19th century the physiology and pathology or pathogenesis of type 2 diabetes, obesity, the fat mechanisms, and the insulin resistance probably. Then the new 20th century, the late 20th century and early 21st century, whereby the first time they say that we have actually, I have not enumerated the existence of the oral drugs for the first time in 1960s. In 1950s and 1960, the oral drugs came to. 1920, the insulin was there. And in 1950s and 60s, it is the oral drugs. And we were continuing with the oral drugs for so many years. And then suddenly FDA thought that it should be a cardiovascular outcome trials. And until and unless a drug passes the cardiovascular outcome trials, they will not approve for the general management for the population, general population with type 2 diabetes. So if you see the timeline of major diabetes outcome trials, right from 1995, the late 90s to the 21st century, the early 21st century, and if you see so many cardiovascular outcome trials have come. Right from, if you see from DCCT to UKPDS to stop NIDDM for the acarbose, proactive for the pioglitazone, accord VADT, advanced trials, which have given us the insight about the tight control of diabetes, whether tight control is helpful. DCCT and UKPDS told us tight control is very important, intensive diabetes control. But accord VADT and advanced told, no, it is a moderate control of diabetes, which is good for the middle-aged and the elderly population because of the comorbid conditions. And they found the increased mortality if you have a intensive control of diabetes in this age group. Then the first time the origin study came, probably for the first time, insulin being used in the pre-diabetic population in the origin study, and they wanted to know whether at the pre-diabetic stage, if we give the insulin, can we prevent the type 2 diabetes occurrence? So this is probably first study, origin study. And then the cardiovascular outcome studies with the different drugs, the DPP-4 inhibitors and SGLT2 inhibitors and GLP-1 receptor agonists. The trials, I'll give you the brief of each and every trial to give you a glimpse. We have already learned about SGLT2 inhibitors by Dr. Iyengar and low-dose sulfonylurea by Dr. Sunil Gupta. But I'll give you the brief of all the cardiovascular outcome trials, because we learn and unlearn and relearn by these cardiovascular outcome trials right from, if you see here, 2008 onwards, we have good outcome trials with the drugs. So it was mandatory in 2008. FDA guidance mandated for the assessment of cardiovascular safety of any anti-hyperglycemic agents, and they have to do the randomized controlled trials for at least 2 years, and they have to see whether they have effect on the major cardiovascular events or the primary endpoints with the mortality, with the cardiovascular deaths, non-fatal myocardial infarction, and non-fatal stroke. And then this terms, for the first time, it was coined as it is a non-inferiority or it is the superiority of the drug. So it was first time these terms were coined to see the cardiovascular outcome trials with the drugs. So non-inferiority, we know it was seeing the 95 confidence interval. If it is more than 1.3, it is a non-inferior. But if it is less, 1, then it is a superior drug. So let us see some of the clinical outcomes with these type of newer drugs. What we have learned so far, I have given you the 19th. Now it is the 20th century and early 21st century, whereby we had the cardiovascular outcome trial. The first trial was published in the TCOS. So it was a trial evaluating the cardiovascular outcome with the sitagliptin. And what were the key results for this? It was a median follow of 3 years. It was non-inferior to placebo. First time we found a drug non-inferior to placebo for cardiovascular outcome. So it was a cardiovascular neutral drug. And there was no difference between sitagliptin and placebo in incidence of infections, cancers, renal failure, hypoglycemia, and non-cardiovascular death. Then another drug, which actually gave us the new vistas for a new drug, that is the sexagliptin, and it was a SAVOR-TIMI trial. And what was the SAVOR-TIMI trial? It was again medium follow-up for 2.1 years, and endpoints for sexagliptin, whereby we have to achieve the 7.7 in the sexagliptin group, and placebo it was 7.9%. And the cardiovascular outcomes were beautiful there. The primary, if you see the HR, it is significant. Again, in the secondary HR, it is again significant. But here the little issue was that there was a higher incidence of heart failure hospitalization in the sexagliptin group. And probably for the first time, we knew that gliptins can have this type of possibility. But ultimately, we wanted to know the side effects, and it was no difference between the groups in incidence of acute and chronic pancreatitis. But few cases of pancreatic cancer in sexagliptin were found. Later on, new studies were done, and it was negated, this type of cancer by the DPP-4 inhibitors. Then this is what the SAVOR-TIMI for the first time gave us, that a drug can have the risk of heart failure hospitalization as compared to placebo. Then a new era has come with the EMPA-REG outcome and LEADER, one of the SGLT2 inhibitors and the GLP-1 receptor agonist. So they not only gave us the cardiovascular neutrality or safety, but their cardiovascular benefit. So probably for the first time in the world, we came to know two drugs can have the cardiovascular benefit other than the glycemic control. So if you see the EMPA-REG, it was again a median follow-up for 3 years. And it, of course, the HbA1c reduction was the weak, but cardiovascular outcome, if you see here, the enormous benefit to the tune of around 46% benefit. If you see the secondary outcomes, very significant, p-value 0.001. And there was a significantly lower rates of all-cause deaths, cardiovascular deaths, and heart failure hospitalization with empagliflozin. So we have already seen, I don't want to go into the details because Dr. Iyengar has given us the beautiful about the SGLT2 inhibitors. And we now, not only the cardiovascular benefits, now for the first time, we have seen with any drug, the renal benefits. And if you see the renal outcomes here, it is 39%, 44%, and 38% less to the incident of worsening nephropathy, post-hoc composing outcome, and as well as progression to macroalbuminuria. So not only benefit the cardiovascular benefits, but also the renal benefits. And if you see the clinical outcomes with the empagliflozin, enormous. But side effects were there, and we know about the genitourinary infections, which are very common with the SGLT2 inhibitors, but they were already mild infections. Then the canagliflozin, CANVAS study, and again the clinical outcomes with the canagliflozin was enormous, and endpoints again showed it was a cardiovascular benefit with the canagliflozin. And if you see again the serious safety aspects, and of course canagliflozin has shown for the first time the maybe possibility SGLT2 inhibitors can have the bone fractures, amputation, and probably we don't know still what was the reason for little amputation and bone fractures by the canagliflozin. So we learned so much with the cardiovascular outcomes. Again, lixisenatide has come and it has shown the cardiovascular outcome benefits also. Not only that, of course, there was increased rates of gastrointestinal events in the lixisenatide. And with rates of little serious adverse effects were there, including severe hypoglycemia, pancreatitis, and still, the studies are going on. Then the leader, for the first time, a GLP receptor agonist for the liraglutide have shown the cardiovascular benefit. Again, the exenatide has shown the beautiful things. Sustain has shown us.
Arvind, sorry to interrupt. Your time is done.
I think this is the last one,
okay.
Almost. So this is for the first time, not only the GLP-1 injectable, but probably the oral semaglutide has come into the way. And with the next year, when we will have the oral GLP-1 receptor agonists like semaglutide, I think the scenario will change with the anti-hyperglycemics. So semaglutide has shown again the enormous cardiovascular benefit. And the DEVOTE now and DAPA HF trial, not only these cardiovascular safety, renal safety, but even these drugs can be used in the non-diabetic population. So we have already seen with the SGLT2 inhibitors. So my dear friends, and these are the deglutitic clinical outcomes, and deglutic have again showed good cardiovascular benefits. So dear friends, in 80s and 90s, we learned the physiology and pathology of pancreatic beta cells. In 20th century, we learned about the ominoxapatate, insulins, oral anti-diabetic drugs, and we were so happy. Unfortunately, you see the epidemic of diabetes still continues. In 21st century, we learned about the insulin analogs, DPP-4 inhibitors and SGLT2 inhibitors, and the beautiful cardiovascular outcome trials. But dear friends, last time, the unlearning of the initial understanding about the physiology of pancreas, which we have seen from our predecessors. And now the era is changing from beta cells to the alpha cells. and glucagon era. So probably in the future, we'll be not talking about the beta cells, we'll be talking more about the alpha cells and glucagon, which are responsible for sustaining insulin secretion and the glucose metabolism. So dear friends, we have to unlearn something. Beta cell, we have been beta cell centric for so many 100 years, but now probably we'll be having the alpha cell concentration and move away from the beta cells. So this is my take on to learning, unlearning, and relearning about the type 2 diabetes. Thank you very much.
Yeah, Ravi Kirti, you want to say anything?
No, you can go ahead, please. No.
Yeah. Dr. Arvind Gupta, in the first slide you showed, diabetes is a Greek word and mellitus is a Latin word.
Yeah.
When somebody is talking something, if we don't understand the ABC of that, we call it as he is talking Greek and Latin. You got my point. But you are so clear. You are so clear. In a short span of 20 minutes, you covered so many recent landmark trials in the diabetes. So many landmark trials in the diabetes. And rather than relearning, you made us, our mind freshened up with these recent trials. It was an excellent talk. And one thing I like this, unlearning about beta cells and learning about alpha cells. Yeah, it's an excellent future because I'm in the practice since past 30 years. In 1980 to 83, we had only metformin and glibenclamide and insulin, bovine insulin we had.
Yeah.
Porcine insulin we had, nothing else we had. But now it has advanced so much.
Yeah.
It was advanced so much. And I have got a lot of general practitioner friends. About 10 years back, they used to tell me, these gliptins, this SGLT2 inhibitors and GLP-1 analogs, they're all left to you consultants and super consultants. We general practitioners, we can't write those products. But the prices have come down so much, especially SGLT2 and DPP-4. So any GP can afford. Anyhow, I don't think there are any questions. Arvinda Jagdish, there are no questions, no?
No questions.
No questions. Excellent, sir.
That was Dr. Arvind Gupta. That was really an excellent talk. Something different, out of the box talk, actually.
Yeah. So my take on just last sentence, because I told you initially, our computers have a limited capacity. So we have to unlearn, Dr. Dixit, what you have asked earlier. Unless we unlearn, we cannot have the relearning.
Yeah, that's true. Even our brain has got some capacity. Beyond that, it can't. Yeah.
Exactly.
Excellent.
Thank you.
Thanks to both Arvind Jagdish and Arvind Gupta. Thanks to my co-chairman Ravi Kirti.
Dr.
Alok.
Dr. Arvind, very, very rightly you have said that you have to unlearn. And a perfect guru, when you reach him to learn something, he first make you unlearn. He cleans your slate so that he can write his own carvings on your blank slate. So that you have done today. Thank you so much.
Well said, sir. Well said.
Computers you can delete, sir, but from brain it is very difficult to delete, sir.
Vinay, we have to delete. Brain से भी delete करना पड़ेगा. नहीं तो फिर मुश्किल है. नया कैसे आएगा?
सर मैं अपनी मोबाइल नंबर को भूलने की कोशिश कर रहा हूँ सर 2 साल से. वो पुराना वाला फिर से याद आ जाता है सर.
पुरानी याद आती है, नया याद नहीं कर सकते.
Sir, unlearning is very difficult, sir. Very, very difficult to put in new habits and to give up the old ones is very, very difficult, sir.
Thank you, Dr. Arvind Gupta, for the nice talk. Thanks, Dr. Kashinath Dixit and Dr. Ravi Kirti for being a part of this session. Thank you so much.
Thank you. Thank you.
So moving on to the next talk, we have an interesting talk from Professor Nasir Yusuf from Egypt. He has joined all the way from Egypt and he has given his kind consent to be a part of our conference. It is so nice of him. To chair this session, we have got Dr. Vinay Dandania from Ranchi, a consultant diabetologist and a very close friend of mine, and Dr. Alok Kumar Gupta from Gorakhpur. I'm sure It's a lunchtime. Alaka Gupta, Kumar Gupta is very fond of cooking as well. He would send some recipe and food virtually. So over to Dr. Vinay and Dr. Alok Kumar Gupta to do the further proceedings.
Thank you, Arvind, for making me a part of this academic piece, which I'm enjoying since yesterday. And the topic which we are now going to cover is about the management of dyslipidemia in children and adolescents diabetes. A few decades back, diabetes in adolescent, we usually used to have type 1 diabetes. But now with the more and more of lifestyle changes and metabolic disorder, adolescents are coming with type 2 diabetes also. So with type 1 of diabetes, most of the time, it is something different. Dyslipidemia with type 2, it is something different. So this all will be talked by about Professor Noseh Yusuf, who comes from one of the land of the most ancient civilized country, Egypt. So I will request Dr. Vinay to kindly read his credentials.
Yep. Thank you, sir. Thank you. Good afternoon.
Thank you.
And a pre-lunch session. Dr. Yusuf, he's received his master degree in internal medicine 1984 from Cairo University, Egypt. His MD cardiology 1991 from Ain Shams University, Egypt. He's approved ACC member in 1999 and upgraded till international fellowship in 2009. Is joined by many international scientific societies in cardiology and diabetes as active member. In 2016, founded international Facebook group, Cardio Diabetes Secrets, which include now more than 20K healthcare professionals only, and is a president, Egyptian Cardio Diabetes Association. We welcome you for this meeting, sir, and over to you for your presentation.
Thank you very much. First, I would like to thank Dr. Arvind and his board for inviting me to this session, this great conference. Thank you very much, Mr. Chairman, for your nice introduction. Now, I can share my slides.
Yes,
yeah,
sir.
Please.
You just need to make it full screen, sir.
PowerPoint mode, yeah.
Yeah.
It is okay.
Yep.
Yeah.
So, good morning from Egypt and good afternoon from India. Today we are speaking about this beautiful girl. This beautiful girl is unhappy because she has some problems, and we wanted to manage and know how to solve this problem. She is diabetic and have dyslipidemia. So what we can do more? First, I have no disclosure to see. Pediatric diabetes is a very difficult diagnostic specialty because it includes many of the types of diabetes, type 1, type 2, childhood obesity, monogenic diabetes, diabetes with other syndromes. So it is difficult to be diagnostic specialty and to see this. This is my agenda in 4 points. First point will be lipids in children and adolescents. And this slide, I like it very much because to summarize the LDL levels from in utero and after birth and in the other years. So in utero, by the end of the uterine life, the LDL will be low. In the early months, in suckling, it will be more higher. This graph is more clear. Either suckling natural breastfeeding or artificial breastfeeding, artificial feeding. So in natural feeding, the LDL will be more higher. Then after weaning, the LDL will become more low. This is the opposite in the formula, which can make it more higher when it weaned from the formula. LDL concentration and the cholesterol in children. At birth, total cholesterol around 70, LDL 30, and HDL is 35. In first 2 years of life, total cholesterol at least will be doubled. Then between 9 and 11 years, it peak up to 170 milligram. And during puberty, total cholesterol level decrease, then increase thereafter. And in young men, HDL falls permanently. There is ethnic differences, and the black children have higher HDL and lower triglyceride than white Hispanics and non-Hispanics. In youth, the child, in a child adolescent trial for cardiovascular health, it shows that the prevalence of total cholesterol more than 200 was found in 15.6% of girls and 11.1% in boys. Other two studies, Muscatine study and Brugalia's heart study, both are respectively showed 75 and 70 of children with elevated lipids, they track into adulthood life. So lipid screening, when we do test for lipids for children under the age of 2 years, lipid screening is not recommended at all. But from 2 to 8 years, screening is recommended only if there is high cardiovascular risk present, either personal history of diabetes or high blood pressure or basal metabolic rate greater than 95 percentile, or smoke cigarette, or strong family history of early coronary heart disease, lipid disorders, high blood pressure, obesity, tobacco exposure, diabetes, or chronic kidney disease. Then from 9 to 11 years, universal screening is recommended, either fasting or non-fasting lipid profile. From 12 to 16, universal screening is not recommended because it is a puberty period and it is much increased and decreased. From 17 to 21 years, universal screening is recommended again. Second point, we'll show the evidence of a statin for treatment of dyslipidemia. LDL is closely related to coronary heart disease event in statin trials, either in primary prevention trials or in secondary prevention trials. It shows decrease in the incidence of the CHD once the LDL is more lower. If we take Jupiter trial as example, we'll find that this very significant decrease. It decreases LDL 50%. High sensitive protein decrease 37%. Triglyceride decrease 17%. And HDL increase 4%. The primary trial endpoint was decreased 44% in MI, stroke, unstable angina, revascularization, coronary heart death. Also, it decreases 47% both in myocardial infarction, stroke, or cardiovascular death, or in arterial revascularization, hospitalization for unstable angina. Fortunately, statins have pleiotropic benefits. Anti-inflammatory, antioxidant, improve endothelial function by nitric oxide, plaque stabilization, antiplatelet, fibrinolytic, antiproliferative, and many other items more. We should emphasize that pleiotropic benefits are dose dependent, and it is more evident in the higher dose of a statin. And pleiotropic effect appears to be much act before the lipid lowering effect start. All of us know that the statin will start around after 4 weeks from the start of its administration. If we look here to see the LDL reduction by different statin in same doses, we can see here the first, the fluvastatin, paravastatin, lovastatin, simvastatin, atorvastatin, and rosuvastatin by these different colors. So in this same dose, we'll see that the most clear here is the most powerful is rosuvastatin, and the most less is fluvastatin. And this is comparison of the all doses of a statin. Third point, what do the recent guidelines say about the statin and treatment of dyslipidemia? In 2019, normal and abnormal childhood lipid values are appeared, and they said acceptable, borderline abnormal. And I would like to stress on one point here, how to interpret the lipid profile. First, we look to the LDL. Second, we look to the non-HDL, which is the all atherogenic cholesterol. And third, we look to the triglyceride. And then in children, triglyceride will be different from 0 to 9 years and from 10 to 19 years. In 2019, the European Society of Cardiology, European Atherosclerosis Society guidelines have made very clear, simple sentence: lipid modification to reduce cardiovascular risk. This is the aim, to reduce the cardiovascular risk, and they take aggressive approach to see. This slide, I like it very much because it shows the intensity of lipid lowering agent. Here, if we look to the high intensity statin, for example, rosuvastatin plus ezetimibe, it reduces LDL by 65%, almost 65%, which is more than PCSK9 inhibitors alone, which decrease 60%. This shows us the effect of the high intensity statin plus ezetimibe. This slide is very clear and showed the LDL and the patient either low or moderate, high or very high risk. For example, in high risk patient with diabetes without a target organ damage, or with diabetes with duration more than 10 years, or another additional risk factor, patient with familial hypercholesteremia without other major risk factors. These are high risk group, and the LDL should be around 70 or less than 70. And very high risk group, which is diabetes with target organ damage, or at least 3 major risk factors, or early onset of type 1 diabetes of long duration more than 20 years, or familial hypercholesteremia with atherosclerotic cardiovascular disease. All these are very high risk, and LDL should be less than 55. Also, the American in 2018, all the societies have shown the guidelines also, and they also recommend in children and adolescents with familial hypercholesteremia, even lipid profile can as early as 2 years to detect the familial hypercholesteremia. Also, they said that fasting lipid profile or non-fasting can be done from 9 to 11 years and from 17 to 20 years. In 2017, the American Association of Clinical Endocrinologists and the American Cardiology of Endocrinology have put these guidelines for children at risk of familial hypercholesteremia. Screening should be at the age of 3 years, from 9 to 11, and from 18 years. Screening adolescents older than 16 years old can be done every 5 years or more frequently if they have more risk factors like atherosclerotic cardiovascular disease, overweight and obesity, other element of insulin resistance syndromes, familial history of premature atherosclerotic cardiovascular disease. And they put the pharmacotherapy, they put it on more than 10 years for children to start pharmacotherapy if satisfying the following criteria: LDL more than 190 or from 160 plus presence of 2 or more risk factors and family history of premature cardiovascular disease or having overweight, obesity, other element of insulin resistance syndrome. Traditionally, blood sampling, we have to do, it is fasting or non-fasting. Traditional blood sample for lipid analysis has to be recommended fasting for 12 hours. But now, in the last 2 years, the recent systematic studies compared the difference and found the difference is small for most lipid parameters. Non-fasting samples have been used in large population basal study. Most studies showed that non-fasting sample display higher triglyceride level of 27 milligram per deciliter. And this is of no clinical significance. Indeed, a number of guidelines recommend non-fasting sample. And the practical advantage of non-fasting sample, better patient acceptability, have at least the same prognostic value as fasting, overweigh the potential impressions of patient with some patient. In non-fasting sample, can we use in most studies, but in metabolic syndrome, diabetes, hypertriglyceridemia, we should be careful to calculate LDL for interpretation. But if the triglyceride is more than 400, it should be repeated fasting. Our last point is LDL. How low should we go? And is it safe to go for this low? What is the concern about using statin in pediatrics? Cholesterol is an important factor in the growth and development of children. And we cannot use neurological safety data should not be extrapolated for adults to apply for children. And if we look, lovastatin and simvastatin are the most lipophilic, which is readily translocated across the membrane, whereas paravastatin and rosuvastatin are the most lipophilic ones. Cholesterol synthesis also sensitize also steroid hormones, and this concern about a child CNS, energy function, growth, sexual hormone. So these points for concern about the use of statin in children, we have the answer, and very good answer from Improve It study. And Improve It study, it is the mega trial, only mega trial, which it changed the guidelines alone without another guidelines almost with it. And here we show the clinical safety endpoints. They compared the LDL less than 30, from 30 to 50, from 50 to 70, and more than 70 by these colors. They compared the hemorrhagic stroke, heart failure, hospitalization, non-cardiovascular death, and the cancer. All these have no significant difference in between the 30 to 50, 50 to 70, and more than 70. Also in myalgia and increased CK, adverse effects and discontinuation of a statin, increased liver enzymes more than 3 times, gallbladder stones and gallbladder adverse effect, neurocognitive function. All these have no significant difference between decreasing the LDL from 70 to 30. This means that the statin is very safe. And I will ask all of us, does we have in our bodies one cell which cannot manufacture its own cholesterol? I think the answer is no. Tolerability of a statin is very, very high, from up to 80%, and the only confirmed intolerance 5 to 6%. And the suspected tolerance also should we have some interaction with some drugs. Risk of the discontinuation of a statin is very, very highly significant point. If we look to this graph, patient with no statin, if we have a statin to continue statin, so the incidence of event will decrease much. But if we discontinue statin, it is almost increase more than 3 times continuous of a statin and 1.5 times the no statin group. So, Mr. Chairman, our key points and the take-home message: atherosclerosis has its origin in childhood, and the children under the age of 2 years, lipid screening is not recommended. Universal screening is recommended for all children from 9 to 11 years old and repeated from 17 to 20 years old. Pharmacological treatment indicated for children more than 8 years old, meeting the cut points. And the cut point of statin, first choice. Rosuvastatin, our first choice, recent confirmed data showed safety of very low levels of LDL down to 15 milligram. Combination therapy with ezetimibe, usually after the highest tolerable dose of statin. Treatment strategy for elevated LDL in children and adolescents with diabetes. Diet, maximize glycemic control, weight reduction if indicated, medication, manage cardiovascular risk factors. And now we make our beautiful girl very happy because we have given her the statin and her LDL was controlled, and the medication indicated more than the age of, if the age is more than 10 years, LDL more than 190 or 160 plus 2 risk factors, and rosuvastatin is the ideal choice. And last point, fibric acid derivatives indicated if triglyceride more than 1,000 milligram per deciliter in children. I will leave you. Thank you. And this is a talk of our eminent Eugene Braunwald, that inhibition of PCSK9 production actually prevent cardiovascular disease if begin early enough in life. And he advised to administer regular once or twice a yearly basis of everyone over the age of 30 years old to achieve this one with inclisiran. Thank you very much.
Thank you, Dr. Yusuf. Thank you for such a beautiful, lucid presentation. I have 2 points to be clarified by you. Number one, you have said in your lecture that there is a gray area of age, 13 or say 12 to 16, where the interpretation of lipid profile is difficult because of the age of puberty. Now, suppose if a patient, a child of 14 years, 15 years, has got strong grounds to be investigated for cardiovascular risk and to start a statin, then should that child be investigated? And if yes, then how to interpret those investigative results?
Yes, thank you very much for this beautiful and important question, because universal screening without any risk factor, we should change our mind. We should first screen from 7 to 11 years and from 18 to 20 years old. These two group of ages, we should screen all our children, irrespective of the risk factors. But if the risk factor is present, cardiovascular, so we can investigate earlier than 7 years old. From 3 years to 7 years old, we can investigate if there is high risk factor. So I think my point is to change our mind and start screening all our children from 7 to 11 and from 18 to 20 years old. Because as early as we can detect the atherosclerosis, we can manage and can prevent the pathological atherosclerosis.
Thank you so much. Another point is that your experience about pitavastatin as compared to rosuvastatin, which is also a newer statin with minimal drug interaction.
Yes,
do you have any experience with pitavastatin?
Rosuvastatin, usually it has a minimal interaction with other drugs because it is the most hydrophilic statin. And for my experience, we have given so much rosuvastatin accompanied with ezetimibe for many patients, children and adolescents with familial hypercholesterolemia. And I think nobody has discontinued his medication for any problems or side effects.
Thank you so much. Vinay, over to you.
Sir, thank you very much for that excellent presentation. We learned a lot of new things with your presentation, sir. Sir, if we see type 1 diabetics with high HbA1c like 13 or sometimes even 11 or 12 have very high triglyceride values and very high cholesterol values. But the moment we treat them and try to bring down their glycemic control, their lipid starts coming down without any intervention. And does this transient dyslipidemia in a poorly controlled type 1 diabetics is a very high risk for atherosclerotic disease?
Yes, actually, this is in all the children and adolescents diabetes. I think why it is coming echoes. This
okay
means
now.
that the patient in these age groups are more vulnerable to have the LDL lower and have the benefit of to choose a healthy life for them. And the LDL will be more clear and more down to reach the normal levels compared to the other diabetic patient. And in type 1 diabetes, exactly, the insulin injection, insulin is known, it is the most highly clearable agent known for the lipids. So in type 1 diabetes, almost we did not need to have a statin, except if in case of familial hypercholesterolemia.
Sir, and what about ladies who plan for pregnancy or who are pregnant? Do they need to continue statins, or we need to stop their statins in spite of having high LDL values?
Thank you very much. It is very good question. Actually, up till now, statins are not contraindicated in pregnancy and in lactation also. So in pregnancy, it is clear that it is not indicated at all. If they are going to conceive, so they have to stop statin and to make other measures for diet and exercise and body weight reduction. In lactating ladies, I think they should also stop statin. But now few papers come that they can continue statin in some doses, but clearly and recommended now is they should change to formula feeding, or they can stop taking statin until they breastfeeding have ended.
I think thanks, Dr. Professor Nossi, for the wonderful talk. I think thanks for accepting our invitation and being a part of our conference. It's so nice of you to deliver this talk. Thank you so much from India. And thanks, Dr. Alakya Gupta and Dr. Vinay for chairing this session. Thank you so much and being part of our conference. Thank you so much.
Thank you very much. Thank you.
Thank you. Moving on to next session. We have Dr. Vinod Mittal from Delhi. Always is a dynamic person when it comes to academic. He was the very close friend of mine. We always wanted him to be in Bangalore. Unfortunately, this year, because of the pandemic, we are having pleasure in having him in this virtual conference. To chair this session, we have Dr. Karthik Munichudappa. He's a consultant diabetologist from Bangalore. He is an eminent diabetologist and very active persons in academics, and he is the secretary of Diabetes Club, and he is the executive committee member of KRSSDI. And we have Dr. Vishnu Priya, who is my classmate from MBBS days. She is consultant diabetes in Bangalore. Over to Dr. Karthik and Dr. Vishnu Priya for the further proceeding, please.
Thank you, Arvind, and congratulations. It has been a truly successful International Diabetes Summit over the last 2 days. And thank you for having me, part of this ADC and many more such conferences in the future.
Thank
you. Coming to the topic, the prevalence of diabetes in children and adolescents is increasing worldwide and even in the South Asian countries. It has profound implications on the long-term health of the individual and the society. The diagnosis and management of diabetes in youth is certainly a challenge. And many of us, we are not familiar in how to diagnose and manage such cases, as we are more accustomed in dealing with middle-aged and elderly patients with diabetes. And to educate us today, we have Dr. Vinod Mittal, who is a well-known diabetologist, and I would ask my co-chair, Dr. Vishnu Priya, to introduce him.
First of all, thank you very much, Arvind, for making me a part of this excellent scientific symposium, and really proud of you, the way you, organized this symposium. So it's my pleasure to introduce Dr. Vinod Mittal. He is a masterclass in diabetes management from Royal College of Physicians, UK, postgraduate program in diabetes from Johns Hopkins Institute, PG Diploma in Diabetes Management from Middlesex University, UK, the Senior Consultant Diabetologist and Head, Center for Diabetes and Metabolic Diseases, Delhi Heart and Lung Institute. He is the Director at Delhi Diabetes Care Center, New Delhi, Senior Visiting Consultant at Sir Gangaram Hospital, Advisor and past Chairman of RSSDI Delhi Chapter. He's been practicing for more than 30 years and with special interest in the field of diabetes care, education, and research. He's received various awards, a couple of them being Diabetes Awareness Initiative Award in 2017 from Diabetes India, National Award for Excellence in Diabetes Care 2018 from RSSDI. He's a speaker in number of national and international diabetes conferences, and he's having various publications in national journals and also authored chapters in various books. Over to you, Dr. Vinod Mittal, for your presentation.
Thank you, Dr. Vishnu Priya, for those kind words. And I also convey my thanks to Dr. Arvinda. It's really a great academic feast and, clinically relevant topics. So I would just share my screen and start discussing. Yeah, is it visible now?
Yes.
Okay, my screen is, so am I audible, clear?
Yes, you're audible, sir.
Okay. So I welcome you all to this great international scientific event, virtual, because of COVID. And I would be sharing my knowledge with you all on diabetes in young. It's really a big challenge because when a patient comes, a child, say around 13 year, 14 year, or up to 18 years, we always think it's type 1, and it is not always type 1. So there are two aspects. One is it's a challenge, and the prevalence is increasing every time, and every minute or every year. And then again, the challenges are that once it is there in early stage and we don't know the diagnosis, the complication rate is very high. So prevalence is increasing, challenges regarding diagnosis, then cooperation, compliance, very difficult to treat these children. They are non-compliant, and complications are more severe and more common. They've been, a registry for diabetes in young, and it has been seen that these children, they have more oftenly they have complications compared to adults, and they are very, very severe, very difficult to treat these complications. So correct diagnosis and aggressive management becomes very important, and a patient-centered approach is the only way. So we have to have a comprehensive risk reduction to prevent long-term complications. So we can see this, so as the time is passing, there is gradually increase in the prevalence of diabetes in adolescents and young children. So I would be discussing 4 cases in short, and would try to show the importance, like how we diagnose and how we address this diabetes in young children. So 15-year-old boy came with the recurrent boils for last 2 months, history of polydipsia, polyuria, polyphagia for 1 week, fever, weight loss for last almost 4 kg in last 1 month. Fasting and postprandial both are high, A1C 10.3, urine ketones positive. Family history of diabetes, father, it's there. So overall, if we see, we treat such patients as type 1. The only thing I want to convey here is that never be in a hurry to label the patient as type 1 or 2. First, treat the patient and take your time, say 1 to 3 weeks time, a gradual follow-up, and then, diagnose the patient, and then accordingly manage later on. So first we manage the acute condition, and later on we try to diagnose. So an examination, weight was 64, BMI 25. So he was on a obese side, which goes against type 1, but no signs of any insulin resistance. C-peptide 0.2, it's on the lower, borderline. Anti-GAD antibodies 10. Normal we take as less than 8. So they are high, but not very high. So this patient was managed with antibiotics, insulin infusion, and he was discharged on basal bolus treatment. Okay. Now, revisit after 10 days showed that C-peptide now increased from 0.2 to 0.6. Fasting and postprandial had come down. So this time we reduced the dose of insulin, and seeing, some features of type 2, so obesity and family history, father is positive, we started the patient on metformin, 500 milligrams sustained release OD. So next visit, we saw again sugar, and it was well controlled, glucose. So insulin was stopped, and metformin was continued. So in other words, I want to say that, never be in a hurry to diagnose. So this patient was basically a case of ketosis prone diabetes, that is Flatbush diabetes, which is a neighborhood in Brooklyn, near New York City in US. So first case was diagnosed there. So overall, like it is type 2 diabetes, generally it's more commonly in children, but it can happen any age group. So it is type 2 presenting like type 1 with ketosis for the first time, and there are not many features of type 2. So we should keep our fingers crossed, and like we should keep our mind open that it may be anything, and slowly over the time we can diagnose. So basically, like short, the differences, type 1 generally is very, very abrupt onset, and patient is non-obese, no family history. C-peptide, either it is non-detectable or very low. Anti-GAD generally more than 30. So in this patient was 10. So there were certain features in favor of type 1 and others in type 2. Then same, in type 1, if age is more than 30, a slow onset, generally patient can be on oral anti-diabetic agents for 6 months, and ultimately they need insulin. So that's LADA. And type, so basically, we have to do antibodies, and we should try to find out beta cell function also by doing C-peptide. So these are two important tests. So if antibodies are there, beta cells, no C-peptide or non-detectable, it is type 1A. That is type 1 diabetes, autoimmune. But sometimes, even autoantibodies are not there, and C-peptide also is non-detectable. So it is type 1 idiopathic. So that also, sometimes we have patients like this. And then if antibodies are not there and beta cell function is there, it's typically type 2. And in LADA, autoantibodies are present. Beta cell function is also there, but patient cannot sustain on oral anti-diabetic agents for more than 6 months. So in other words, if a child comes for the first time with ketosis, don't take it as a type 1 always. It may be type 2 also. Now I come to the second case. 18-year-old girl having type 1 diabetes was diagnosed at 8 years of age and on insulin treatment, basal bolus, well controlled till last 1 year, A1C 7.2. So for last almost 10 years, patient on insulin well controlled. Now, presently, she came now with recurrent UTI for last 2 months on antibiotics. Sugars have gone up now, maybe infection and maybe something else also. Then A1C 8.5, BMI now 26.5. On examination, blood pressure 130/84, skin tags present. All other systemic examinations normal. C-peptide 0.3. Cholesterol, again, lipid profile, if we see, it is on a higher side. So cholesterol is high, triglycerides high, LDL. So basically, we see a type 1 diabetic patients coming with recurrent UTI, but there are signs of some insulin resistance also now, and C-peptide is also now a plus. So in other words, like such patients, and now with the availability of very good insulins, insulin analogs, and good devices, the lifespan of type 2 diabetic patients, type 1 diabetic patient is quite high, and they live up to maybe 70 years also. So what I want to say, and they later on, as they grow old, because of junk foods and other lifestyle, sedentary lifestyle, they also develop the features of type 2. So such children may require metformin later on. So that's the only point, and it has been mentioned in the literature, it is a double diabetes. So type 1 will never not remain type 1 forever. So these children may develop features of insulin resistance later on, and then maybe you have to add metformin in such children. So type 2 generally, although it's the patients, people are obese or overweight, there's a family history of diabetes, C-peptide is generally high because of hyperinsulinemia. Anti-GAD antibodies are absent, but they may be present in 10 to 15% of the patient. Like in our first case, a boy, 15-year-old boy, anti-GAD antibody level was 10. So it may be there in 10 to 15, but the levels are not very high. That's the important thing. And gradually over the time, when you keep on evaluating, you would definitely come to know. So what is the type of diabetes patient has? So let's come to the case 3 now. A 15-year-old girl came to us with UTI for 10 days. History of polyuria, polydipsia for 10 days. She was detected to have diabetes at the age of 13 years, so 2 years back. Because she presented with UTI that time also. There's a recurrent history of UTI. And she was put on insulin, basal bolus, like, generally what we do. So that's a kind of a mistake generally done. And when you label a patient with type 1, it's very difficult, the subsequent visits and other doctors also, sometimes we don't, have time, and we don't try to think that, it may be something else. So never put a label on, the diagnosis. It can take some time, maybe 2 weeks to 3 weeks or a month, not more than that. By the time you can get all the tests done. So fasting plasma glucose was high, postprandial high, A1C 9.2, ketone bodies were absent in this girl, and there was a history of diabetes in mother. On examination, she was lean, BMI 20, no features of insulin resistance, and vitals were normal, systemic examination. So overall, she fits into type 1, but mother is having diabetes. So that's one point which goes, and with high sugars, ketones are negative. And on insulin, sugars are still high on basal bolus regime. So, so these 2-3 points are against type 1. So let's see, what happened in this patient later on. So lab investigations were normal. Chest X-ray, abdominal X-ray, ECG was again normal. Biothiometry, Doppler study was normal. C-peptide 1.0. So now this is an important point, important test which clinched the diagnosis that it is at least not type 1. Okay. So with this, the thought came that it may be MODY because mother is having diabetes, patient did not have ketosis, and then C-peptide normal. So such patients, we should think of MODY and try to, further evaluate such patients. So when this pedigree chart was made and it was found that, this is the patient here, the bottom we can start. So her sister was also having diabetes. Mother, as I already told you, was having diabetes, and all other mother's sisters on this maternal side were having diabetes, and maternal grandmother was also having diabetes. So there are 3 generations. So only on clinical history, if we take properly, we can clinch the diagnosis, but definitely you have to do genetic testing before you make a final label of MODY. So this patient, once we diagnosed this patient, genetic testing was done and it was found it was MODY type 3. So glimepiride was started in this patient, and slowly, we could see there was a fall in A1C, remarkable fall, and slowly even insulin was withdrawn. So what I want to convey that sometimes we do come across patients who are small children, 15 year, 13 year, appear lean, and they are not type 1. So sometimes, because if we don't, what our brain doesn't know and our eyes don't see, we can't diagnose. So we have to know that these are the possibilities, and among these children, some percentage of patients may have MODY. So that's an important point, a take home from this. So MODY, or a monogenic diabetes, rather we should call it, but we've not been able to abandon MODY. So it's more oftenly understood, and although specifically it's a monogenic diabetes. So the diagnostic criteria are age is generally less than 25 years, autosomal dominant inheritance, 3 generations. I told you, we had in this patient absence of ketosis, and patient is lean, no ketosis, less than 25, family history. And patient can be controlled without insulin, and especially, certain types of sulfonylureas are, and others are also there in MODY, where we don't even need any kind of treatment, only impaired fasting glucose is there. So clinical features, patients are generally lean, they don't need insulin, and there are almost 14 or 15 types of MODY. Generally MODY 3 is more common, and they are basically NHF4 alpha or 1 alpha defect. And there is one defect which is MODY 2, which is very mild. As I just mentioned, that there's a defect in glucokinase gene, and though no treatment is required here. Then type 5 and others, which I won't be going into detail. So these are various types, and in fact more are added now. So it's almost 14 or 15 types now. So we have discussed a case, a boy. Now I'm going to present a 4th case. So the first case, there was a young boy presented with ketosis, not type 1, it was found to be a KPD. So it was basically type 2. The second case, it was basically type 1, but she gradually developed type 2 with development of insulin resistance because of sedentary lifestyle and junk foods. And 3 we have just discussed is a case of monogenic diabetes. Okay. Now we come to another case, and a 23-year-old male who came with diabetes for last 2 years, recurrent pain abdomen, passing oily stools off and on, no family history of diabetes, no smoker, and no consumption of alcohol, and patient is on OADs for 2 years but no control. See, again there's a mistake. What we do is generally people who are more than 20 years and presenting with diabetes, we generally take them as type 2, all of them. So that's again a mistake done. So there again we keep our minds open, and like careful history taking is very times and again. Now the younger generation I've seen, they generally, they're not bothered, they go more for the test. So history taking is again very important, even in diabetes, and a careful history taking examination will at least would be a pointer towards the diagnosis, and then accordingly we can go for certain tests and diagnose and act accordingly. So patient on OADs, poor control. On examination, BMI 19, BP was normal, ketones were not there in the urine, lipid normal. Abdominal ultrasound was done and it showed grade 1 fatty liver. So clinical diagnosis, again, it is not going in favor of type 2 and patient on OAD. So we have to go for further testing. So basically, when there's a history of pain abdomen, oily stools, FCPD, which is more in south, fibrocalculous pancreatic diabetes. So we should keep in mind, and immediately X-ray should be done in such patients, or maybe even ultrasound, because now ultrasound is as freely available as X-ray. So what X-ray would definitely, would reveal pancreatic calculi, and we can see these calculi at the level of T12 and L1. So then ultrasound was done, which, again, careful ultrasound will reveal, pancreatic duct dilatation, atresia, calculi. So this patient basically, was now started on insulin in view of basically not responding an FCPD diagnosis. And such patients may also have deficiency of, or impairment of exocrine function of pancreas. So there, such patient, they may need even a higher calorie requirement, and maybe sometimes they may need a pancreatic enzyme supplement if there's an exocrine pancreatic involvement also. So revisit, his A1C came down to almost normal, and so basically, this FCPD is uncommon. It's more common in say tropical countries and southern part of India like Chennai, Kerala. And diagnostic criteria: tropical country, recurrent pain abdomen, steatorrhea like oily stools, and abnormal pancreatic function test. X-ray abdomen, ultrasound would show pancreatic morphology and absence of other causes, obviously, of chronic pancreatitis. You have to rule out alcoholism, like history. I told you there's no history of alcohol intake, and then other hepatobiliary diseases. Important point is that such patients, they have a very high risk of pancreatic carcinoma. So you have to be very, very, careful in managing diabetes, as well as keep screening and managing such patients, for the development of pancreatic carcinoma. So overall, I'll just take 2-3 minutes more. So overall, diabetes in young, it can be anything. It's a Pandora, like a magician's box, where everything in a small box can be hundreds of things. So it can be type 1 diabetes, it can be type 2, MODY, FCPD, LADA, even malnutrition, modulated diabetes, GDM. Endocrine causes can also be there, like Cushing's disease, pheochromocytoma, glucagonoma, genetic syndromes, and neonatal diabetes, which is there in neonates less than 1 year of age. So what I want to say, there's so many, but at least we should keep the first 4 or 5 in mind: type 1, type 2, MODY, FCPD, and LADA. They are very common. I mean, they are not that uncommon, I should say. And otherwise we would be having only fixed idea that type 1 or type 2. That's not the case. So this is, I'll just take 1 minute to describe this. So there are mainly, 4 or 5 important things when a child comes to us with diabetes. The first is a family history. If there's a family history of diabetes, it goes either in favor of MODY or it goes in favor of basically type 2 diabetes. In general, I just want to say. Then the second point is the ketones. If ketones are there in the urine, then generally it is in favor of, basically type 1 diabetes. Then C-peptide, again, very important test. A very poor level, non-detectable type 1 or lower borderline, generally in type 2, they're very high, but in MODY, they are normal. So C-peptide can also, but definitely, as I mentioned in my opening remarks, that C-peptide in patients with type 2 presenting in emergency with ketosis due to glucotoxicity may be very low. So like in our first case, C-peptides were 0.2. What I want to convey again, that C-peptide, one value alone cannot tell us the diagnosis. So this has to be kept in mind, that even type 2, if there's a lot of glucotoxicity, sugars very high, then C-peptides, because of glucotoxicity, insulin deficient state, they may be low. Okay. Then other important test is autoantibodies. So 4 things are important: history, ketones, C-peptide, and autoantibodies, and that will tell us the diagnosis. So friends, the takeaway messages are very clear that diabetes in young is now common. Prevalence has been increasing. All cases need not be type 1. Diagnostic dilemma is always there, not easy to classify, and you should not be in a hurry to diagnose or classify at the onset. Treat the patient, take your time, and at least 1 to 3 weeks, maybe a month, and then you put a label, and then accordingly, you can classify these patients at either, whichever type they have, and then accordingly you manage. So accurate clinical history and examination, I think, will never go away. Whatever the, gadgets we have, then detailed pedigree chart, few biochemical tests, use of algorithm, which I've already just mentioned. Challenges are there because these children, they are, adolescent age as such, the way they're non-compliant, they don't understand the gravity. So we have to take the family into confidence, and, education is very important. Then complications are more common. There is a young, adolescent registry in India, and that is shown the complication, the incidence is more common compared to adults, and they are more severe. So this class, we have to be very aggressive, and a lot of screening, counseling, education is important in handling such patients. So awareness, education, intensive counseling among the community, the family will go a long way in prevention of type 2, or at least managing diabetes in young. So with this, I conclude, and I convey my thanks to everyone for your patient listening and your presence. Thank you very much.
Thank you, Dr. Vinod Bhushan, for an excellent talk and teaching us that we need to be cautious when dealing with the patients who are in younger age group. Now we have a question by Dr. Praveen, who asks us, what about off-label use of SGLT2 inhibitors in patients with type 1 diabetes with obesity? And
can you repeat the question again?
So Dr. Praveen is asking. So he says.
No, can you repeat the question? Can you repeat the question?
It's echoing, I think.
Maybe somebody is.
I'll repeat the question. Dr. Mittal, can SGLT2 inhibitors be given in a type 1 with obesity who has stigma of metabolic syndrome?
Okay. So as of today, so as of today, there is no indication, and they are contraindicated. As per the NICE guidelines, they have recommended in certain category of type 1. So one is they should have features of metabolic syndrome, one, and already on insulin. See, all these patients have to be on insulin before we put them on SGLT2. So patients on insulin treatment type 1 and having features of metabolic syndrome and A1C more than 8.5. The certain, category of these people may be started on SGLT2 inhibitors, but they should never stop or, suddenly stop insulin, because type 1 means insulin deficient state forever. So that's the only thing that, so insulin continues. Maybe when you add SGLT2 inhibitors, especially, sotagliflozin, we have in tandem 1 and in tandem 2 studies. 2 studies are there which have shown some role. So they can be, no doubt. As I told you, double diabetes. So there would be some type 1 diabetic patients on insulin, not getting controlled, having features of metabolic syndrome. But again, I will repeat that don't stop insulin. You may reduce the dose of insulin initially. There may be hypoglycemia because when you suddenly add SGLT2 inhibitor, a reduction of glucose is there. So that's the only small precaution one has to take. But as of today, no recommendations.
Dr. Mittal, my question is.
Yeah.
There is echoing, Arvinda. Can you do something about it?
No, your voice is echoing.
Manilam, why is it echoing?
Even your voice is Dr. Arvinda.
विनोद सर, आपने 2 डिवाइस से लॉगिन किया है क्या?
हेलो
विनोद सर, 2 डिवाइस से लॉगिन किया आपने, एक का म्यूट कर दीजिए आप।
क्या हो गया?
हेलो Can you listen to me?
Yeah, it's better now. Yeah, 2 devices.
Yeah, Meena.
देखो ये खाना खाने से पहले
Nice,
या
nice
बीच
seeing
खाली
you.
है निकलने से पहले ये वॉमिटिंग सेंसेशन है एसिडिटी सारी चीजें दूर हो जाती है This is Arvind learning, relearning and unlearning.
Yeah, Meena, your question is left.
My question is, phenotypically, type 2 in the young is different from type 2 in the adults because type 2 in the young have very high risk of cardiovascular complications.
Yes,
And they
yes.
fail on oral drugs in maybe 4-5 years.
Yes, definitely. Agree on that. So that is why, you know, I mentioned, and they have more complications are more common, more severe. So we have to be very vigilant there. But we generally don't give importance. Even the parents are not giving. So I think counseling and education of the parents is very important. I have number of patients, you know, who are going to college and school. It's very difficult, becoming very difficult for me. They don't even comply with diet. So what to talk of medications? Yeah, great.
Hello.
Okay, yeah.
Hello.
Yeah, I can hear you.
Echoing.
Yeah, Dr. Karthik.
Echoing.
I think it's an
Dr.
excellent
Anil.
presentation. Just I wanted to know experience because I think if you see the Western literature, the type 1A diabetes, that is autoimmune, is actually more. In India, when compared to type 1A and type 1B, what would be the prevalence of type 1B when compared to type 1A?
I don't know. I don't think we have any study in India, so maybe, you know, people who are seeing more patients can give their comments, but I don't think we have any study, a large study involving, you know, lakhs of or thousands of patients. And you're absolutely right. Type 1 is not that uncommon as we, because, you know, generally these children, you know, they get neglected. So a number of them may not be even reaching or access. They may not have access, especially in rural areas, to reach a hospital.
No, I have an answer to this question.
Yeah.
Arvinda,
So this is
Dr.
observation,
Arvinda,
but we don't have any study.
You're muted.
You're muted.
Dr. Vinod Mittal has double logged in.
No, it has already, it's not there.
That is what the Neelam showed.
I don't know.
Okay, so doctor, I'd like to answer. There is a study from Sanjay Gandhi PGI that type 1A autoantibody positive is more common in the Caucasians as compared to the Indians. Now, I feel that we don't have enough antibody testing. In a city like Delhi, we are only doing GAD antibodies. We are not doing IA2, insulinoma-associated antibody 2, and we are not doing autoinsulin antibodies. Zinc transporter 8 antibodies, nobody in Delhi is doing. We are sending our samples for ZNT8 to Chennai, Dr. V. Mohan's lab. So one reason could be that we are not testing all 4 antibodies. Even if one is positive, we can label the patient as type 1A autoantibody positive. Since I'm doing zinc transporter 8 by sending the sample to Chennai, I am seeing more autoantibody positive type 1A in my patients. So I think we have less autoantibody positive. We have
I think Dr. Meena's video is frozen.
You can conclude the session, Karthik.
Yeah. So if any questions, I think the audience will get to the panelists offline. So it was a wonderful session. I would like to thank Dr. Vinod Mittal for telling us more about it. Thank you, Dr. Mittal.
Thank you.
Thank you, Dr. Vinod Mittal, for the wonderful talk. And thanks, Dr. Karthik and Dr. Vishnupriya, for moderating this session and being a part of our conference. Thank you so much. Thank you. Next, moving on to the next session, we have a talk from Dr. Noha Amin from Egypt. Thanks, Dr. Noha, for being a part of our conference and giving your consent to speak on this topic. To chair this session, we have Dr. Anand Shankar from Patna. They're a very active member of RSSDA Bihar chapter. He was the past secretary of RSSDA Bihar chapter and a very dynamic person. Next is Dr. Sumesh Raj from Trivandrum. He's a consultant physician from Trivandrum. Over to Dr. Anand Shankar and Dr. Sumesh Raj for the further proceedings.
Good evening, one and all, and thank you, Dr. Arvind Jagdisha, for this wonderful symposia which you have conducted, and thanks for your pre-symposia garland and all the mementos. Thank you so very much. Today we are going to have a very important topic to discuss, and that is about the gestational diabetes mellitus. And we are we are running late, and that's why I think I'll ask my co-chairperson to introduce the speaker and start the talk.
Yeah, good afternoon. The session on gestational diabetes is by Dr. Noha Amin, and from Egypt. Dr. Noha Amin is an assistant professor of diabetes, metabolism and lipidology, Faculty of Medicine, Egypt, and she had graduated from Faculty of Medicine in 2004, and she has worked as house officer in Alexandria Main University. She is also serves on the Endocrine Society's Global Engagement Advisory Group, and she is a certified diabetes educator. She is a member of Diabetes Food Care Project and so many publications. Over to you, Dr. Noha Amin.
Good evening or good afternoon, everyone. First of all, I would like to thank Professor Aravinda and his board. I also would like to thank Dr. Kumar for inviting me. It's my pleasure and honor to be with you today. And I definitely congratulate you for such a successful summit with prestigious faculty. Okay, hope my screen is well shared now. Yeah? Yes. Okay, today, inshallah, I will talk about gestational diabetes. Let's say that around 17% of the total pregnancies globally were affected by some form of hyperglycemia. And according to the first global estimate for hyperglycemia in pregnancy, we have like 21 million live births at risk of being exposed to hyperglycemia intrauterine. And GDM is responsible for an estimated 84% out of these hyperglycemia in pregnancy. In addition to the hazards of hyperglycemia in pregnancy, it also added more to the international economic burden. Let's say that it is estimated that each pregnant having hyperglycemia adds additional cost of about 16,000 American dollars, which are for the complications of the mother and the neonatal complications. Before I go deeper into gestational diabetes, I would like first to discuss three common scenarios that we have to differentiate between them. The first scenario, patient A, she has 26 years old, prima gravida, diagnosed as having type 1 diabetes 15 years ago, and she became pregnant 1 month ago. So this is a case of type 1 diabetes who becomes pregnant. The second scenario, patient B, she is 37 years old, G3P2. She doesn't have a history of diabetes, but on her first trimester visit, her physician asked her to do the lab profile for type 2 diabetes. She discovered that she has type 2 diabetes. So she was type 2 diabetes, which was previously undiagnosed and diagnosed for the first time at the start or at the beginning of pregnancy. So the ongoing epidemic of obesity and diabetes has led to more type 2 diabetic patients at the childbearing age. So we have now to do as reasonable to test all women with risk factors for type 2 diabetes at the initial prenatal visit for the presence of undiagnosed type 2 diabetes. The first two cases are type 1 and type 2 diabetes who were previously pre-existing diabetes before pregnancy, and they are diagnosed as the non-pregnant other criteria for diagnosis. And as you see here, this is the ADA criteria for the fasting more than or equal 126, 2 hours postprandial more than or equal 200, or glycated hemoglobin more than or equal 6.5, or single reading in the presence of classical symptoms of hyperglycemia or hyperglycemic crisis. The scenario C is patient C, which is the majority, as we have earlier mentioned, 30 years old patient, she G1P0, and she was diagnosed in the second trimester using the criteria of gestational diabetes. So the first two cases are pre-existing diabetes previous to pregnancy, and the third case is diagnosed during pregnancy. So what is gestational diabetes? The definition of gestational diabetes is any degree of glucose intolerance that was first recognized during pregnancy in the second or the third trimester that was not pre-existing type 1 or type 2 diabetes, and we test for gestational diabetes at 24 to 28 weeks of gestation in pregnant women not known to have diabetes before. According to the Hyperglycemia and Adverse Pregnancies Outcome Study, the HAPO study, which is a large-scale multinational cohort study involving more than 23,000 pregnant women, the risk of adverse maternal, fetal, and neonatal outcomes continuously increased as a function of maternal glycemia at the 24 to 20 weeks of gestation, even within range previously considered to be normal for pregnancy. For most complications, there was no threshold for the risk. So the results of the HAPO had led to more careful reconsideration for the diagnostic criteria of GDM. And here comes another controversy in the gestational diabetes, which is screening. Should the universal screening screen all women at the 24 to 20 weeks of gestation, or should it be selective screening? And the societies will have some such a controversy between the NICE and the Scottish FOMSIDE just selective screening. On the other hand, we find the EDA and the International Association for Diabetes and Pregnancy Study Groups, the ADP-IPS, going for universal screening. And even though the societies were different whether to do selective or universal screening, even the criteria for the risk factors for GDM is different. For instance, the NICE gets a BMI more than 30 kilograms meter squared, previous history of macrosomic baby, previous history of GDM, first degree relative and ethnic backgrounds, while the ADIPS divided them into moderate and high risk. And the biggest risk factors were criteria were those among the ADA, considering such factors such as BMI more than 25, sedentary lifestyle, first degree, relative with diabetes, previous macrosomic baby. Even they included the history of hypertension, dyslipidemia, insulin resistance such as acanthosis nigricans, and history of cardiovascular disease. It was such a bigger risk factors for GDM, but they concluded that we would do universal screening for all women. So how to diagnose gestational diabetes? We have two strategies. We have the one-step strategy, where we perform a 75-gram oral glucose tolerance test with plasma glucose measurements at the fasting, 1 hour and 2 hours. It should be performed after an overnight fast. The patient comes fasting early in the morning after 8 hours fast, and just be diagnosed with gestational diabetes with one value above the normal, 92 fasting, 180 1 hour, and 153 2 hours. Versus the two-step strategy, where we, as a first step, we perform the 50-gram glucose tolerance, non-fasting, and then after 1 hour, we set. If she has her glucose reading more than or equal 130, then she'll move to the others or the next step. If she doesn't, then it's okay. So the next step is to take the 100-gram oral glucose tolerance test, and we diagnose the gestational diabetes based on 2 readings, not one reading, unlike the one-step strategy. And here comes another controversy between the societies, whether we perform the one-step or the two-step, because when we performed only just one reading in the one-step, the prevalence of GDM significantly increased from the 5 to 6% on performing the two-step strategy up to 20%. And this was more burden on the insurance system. And they said that also this leads to more psychic stress. So they asked, according to the ADA, that we have both options, and the ADA confirmed that both options are okay. Go this way or that way. Of course, the risk of uncontrolled diabetes in pregnancy are so important. We tell them, or have to mention them to our patients to get them motivated to get their values within the targets, because this might lead to spontaneous abortion, preeclampsia, macrosomia, neonatal hypoglycemia, and moreover, recently it is found as a definite risk factor for obesity and type 2 diabetes, even in the offspring in the later life, and also increased risk for the maternal, not only type 2 diabetes, but also cardiovascular morbidity later on, or just the presence of history of GDM, especially if it was uncontrolled, puts this lady for the risk for type 2 diabetes and cardiovascular later on. So now let's go to the glycemic targets during pregnancy. The American College of Obstetricians and Gynecologists and the ADA now recommend either the same values, the same targets for gestational or those with pre-existing type 1 or type 2, to get the fasting less than or equal 95 milligram per deciliter, 1 hour less than 140, and 2 hours less than 120. And actually, the evidence now goes that the postprandial monitoring is associated with better glycemic control and lower risk of preeclampsia. So it seems that the postprandial here in this situation would be more important actually than the fasting. The HbA1c in pregnancy has some concerns because the self-monitoring is more important, and observational studies show that the lowest rate of adverse fetal outcomes in association with glycated hemoglobin to be ranging from 6.5 to lower than this. And we cannot depend on the glycated hemoglobin in pregnancy because of the rapid turnover of the RBCs during pregnancy. So if we are going to monitor the glycemic control, we better perform the glycated hemoglobin more frequently, maybe monthly, but in either ways, we will depend on the self-monitoring blood glucose done by the patients. Physiological aspects that we will notice that even women who get pregnant with having normal glucose metabolism, the fasting blood glucose are usually lower than in the non-pregnant state due to the insulin-independent glucose uptake by the fetus and the placenta, and it tends to have postprandial blood glucose is higher. So most of the patients usually they present with a higher postprandial rather than the fasting hyperglycemia. I will go to the treatment of diabetes in pregnancy. Now, this has a set of different points, starting with the patient education, giving her enough information to her and her family, psychological support, nutritional support, encourage exercise, correction of the medications, what to stop before pregnancy and medications to continue on, monitoring the blood glucose to educate her how to have her self-monitoring of blood glucose, how to manage the acute complications, sick days management, good hygiene, breastfeeding, and even postpartum care. Lifestyle management, let's say that differs from culture to another, but up to 85% of women who are diagnosed with gestational diabetes can have their blood glucose controlled even with just lifestyle modification alone, as we have mentioned, the medical nutrition therapy, physical activity, and weight management. The pharmacological therapy, usually we tend to use the pharmacological therapy in GDM who are not controlled by lifestyle, and those who are presented with greater initial degrees of hyperglycemia, like fasting 200 for instance, they are candidate to have pharmacological therapy. And treatment has also demonstrated to improve the perinatal outcomes in 2 large randomized studies, as summarized in the US Preventive Services Task Force review. Insulin is the preferred agent for the management of GDM, especially those who are not controlled by lifestyle and presenting, as I mentioned, with high values or maybe macrosomic baby. So we need to use the insulin, and it has actually the advantage that it does not cross the placenta. It can be tailored according to the problem, which problem to target, whether it is postprandial or fasting hyperglycemia, so that we can tailor to minimize the risk of hypoglycemia. And it can achieve acceptable euglycemic profile within only 2 weeks, even in the initially poorly controlled diabetic patients. Insulin to use: all insulins are pregnancy category B, except for glargine, glulisin, and degludec are labeled category C. And as far as I know, that we have ongoing studies for insulin degludec in pregnancy. And this table summarizes the available insulin, short and rapid acting. You will see here that the regular, the aspart, the lispro, all category B, while the glulisin is category C. And this is the intermediate and long acting. The human insulin pregnancy data were what's known as previous C. Now, how you will do the insulin initiation and titration? The dose and the regimen usually is based on the severity of hyperglycemia. Women who have fasting hyperglycemia may require single nocturnal injection of basal insulin. We usually start with the lowest possible dose point unit per kg to be titrated later on. And if the patient has a normal or within accepted range of fasting blood glucose, so we will only require prandial insulin to control the post-meal glucose evaluation or elevation for the only affected meal. If both fasting and postprandial are elevated, then we can use a basal bolus regimen, either using NPH or insulin once or twice, and short-acting or rapid insulin before meals. And in such case, maybe she will need a higher dose of 0.7 units per kg divided equally between the basal and the prandial, and it will be tailored or titrated according to the patient's needs. How to titrate? We have the CDAPP Suite Success Program offering some guidance on the adjustments, suggesting changes by 2 to 4 units or about 10% in the short and intermediate acting insulin every 2 to 3 days. So in practice, adjustments can be made every couple of days until control is attained. And so we have to make sure that the patient knows how to do the self-monitoring and how to titrate her insulin. During labor, we tend to keep the glucose values between 80 and 100 milligram per deciliter, and an insulin infusion of not less than 0.5 units per hour should be started. If the values increase or exceeds 100 milligram per deciliter, to be adjusted hourly in case of cesarean birth or labor induction. What about post-delivery? Patients with GDM have significant insulin resistance during pregnancy, which immediately decreases following the delivery. Most of them become euglycemic, so we usually tend to stop insulin postpartum because of no need, as they are euglycemic, and because of the lactation effects, which help to reduce any resistance hyperglycemia. And here comes another controversy, whether to use the oral antidiabetic medications during pregnancy or no. Some societies allow the use of metformin because it has low risk of hypo and lower weight gain. And some patients prefer this to insulin, but the ADA was, let's say, said it sharply like 3 years ago, that metformin can slightly increase the risk of prematurity, and patients treated with oral agents should be informed that they cross the placenta, and metformin has a higher level than that in the maternal level, although there are no adverse effects on the fetus, but we don't have long-term studies. While sulfonylureas are definitely inferior to insulin and metformin, and the concentration of glibenclamide or glyburide in the umbilical cord approximately 70% of the maternal levels. Actually, in Egypt, we don't recommend using oral antidiabetic medications during pregnancy. We just go lifestyle. If not controlled, we tend to have insulin prescriptions. Lastly, don't forget to ask the patient to do follow-up. It is recommended to screen for the presence of type 2 diabetes 4 to 12 weeks postpartum using the non-pregnant other criteria for diagnosis of type 2 diabetes, and to do this screening annually or at least 3 years as recommended by the ADA. Once she has pre-diabetes, metformin, in addition to intensive lifestyle therapies, has shown to have additional benefit in the prevention of type 2 diabetes. And thank you.
Thank you, Dr. Noha. Very nice presentation.
Thank you.
Is there any question in the chat box? Dr.
You can ask question, Prashant. Anand, you can ask the question, please.
Yeah, Dr. Noha, I just want to know that you have mentioned about the postprandial sugar monitoring. So fasting is not that important, I think so.
Yeah, some
And
evidence says
in pregnancy, insulin resistance is the core mechanism of the GTM. So why you do a fasting for the diagnosis or challenge test? As in India, we are doing as per the diabetes in pregnancy study group of India guideline, that is a DIPSI guideline, to do a test, the single test to do for diagnosis and treatment, diagnosis and the screening both. You are doing screening separately and diagnosing separately. Your comment on this?
Thank you for this question. Actually, we do here in Egypt, we use most the one step using the 75 gram anhydrous glucose, and then we diagnose gestational diabetes based on one reading. So we do the fasting, the postprandial after 1 hour and 2 hours. We do both of them. And in spite that the evidence tells that the postprandial actually is more important and in relation to the complications, but still we have a percentage of patients who represent with fasting hyperglycemia. They don't have postprandial hyperglycemia. So if we just tackle or we diagnose based on the postprandial, these patients might be missed from the diagnosis of gestational diabetes. They are present, although they are not the common form, but they are present. So I guess, and I believe that's what we do. We have to screen both the fasting and the postprandial.
Okay, that's a great. I just want to have some more insight from you that when we are dealing with a gestational diabetes mellitus patient, our patient does not come in the fasting state. The pregnant lady not advised to do the fasting.
Yes, that's why.
So when the lady came to the when the lady came for the antenatal checkup, and then again we asked to do a fasting and PP, how do you manage to do that? Because in India we have a very poor turnover for this re-investigation.
Yeah, that's why they have both strategies present according to the situation. For my patients, if they are coming from such a rural area, they away from the clinic or the hospital, I advise them while they are coming, please come fasting so that we have this as a single test. If someone is nearby and he doesn't have the problem of the transfer going and coming, okay, then she will come non-fasting, we'll do the two-step, it's fine. So that's why the ADA didn't recommend just one strategy and that's all. They give you the flexibility of having both strategies according to the situation that you have. Because, you know, in Arabic, we call the physician Hakim. Hakim means wise. The physician has the wisdom to choose which method is, in spite of having the guidelines and the rules and the evidence, but still we have some our experience or insights, wisdom. Who is the patient who can come fasting? And who is the patient that I know, if I told her, go and come again fasting next week, she won't come again. Okay, and in addition, because you have this wisdom, and in addition, you have also another thing. These patients are so motivated to have a healthy baby, so you have to educate her that she has to screen for gestational diabetes. And what is actually more important is to educate her physician, the obstetricians. These are the people who need to be attending with us today about when you talk about gestational diabetes, because unfortunately, and I'm happy that I don't see this too much now, when the patient comes at the 8th month of gestation and tells you, now I have my readings and it was not checked before that. So these are the disastrous situation, you know?
Exactly. So how often you people doing in your country the HbA1c in pregnancy?
No, we don't. Actually, we don't tend to do it much in pregnancy for gestational. We don't do it for gestational diabetes. It's not recommended. It will not add a lot because of the rapid turnover of the RBCs. It's not that accurate. But sometimes we need to do it to follow up those patients who have pre-existing diabetes, definitely before they become pregnant, and at the start of pregnancy to know how things are going with her. But for GDM, I don't recommend the follow-up of the glycemic. It won't add a lot.
I have a question.
Yes,
That
please.
for good diabetes control, the values are 1 hour less than 140 and 2 hour less than 120. So in your patient, how do you advise them to do 1 hour, 2 hour every day? That means 6 readings, or 1 week you will do 1 hour and then the next week you will do 2 hours. How do you go about it?
Thank you for this excellent question. Again, it depends on the situation and on your wisdom, because it costs a lot. You cannot tell the patient, do this 4 or 6 readings every day, or it won't happen. So if the patient in general is stable, I just need to have my eyes on following so that we can do the titration, even virtual method. I tell her 1 day do the fasting, next day 2 hours post breakfast, the other day 2 hours post lunch, and follow up. So this is the way. So maybe she has 1 or 2 glucose check every day, and this will give us insight how to follow up without having so much cost burden. This is a major problem.
Dr. Subhash, anything to ask to your teacher?
Yeah, thank you.
I'm the one who should thank you. I really enjoyed this so much. Maybe next time we will be in India or in Egypt, maybe.
You made actually a great presentation over here. I don't need any question, and it was really a great learning experience. And I want to really thank you for joining our session in India.
She's a good Hakim.
Yes.
Dr. Sumesh, you can sum up the event. Dr. Sumesh?
Yeah, it was an excellent talk, Noha, and you have dealt with all aspects of gestational diabetes, and very informative to the audience. And thank you for the excellent presentation.
Thank you, Dr. Noha, for delivering this vast topic in 20 minutes. Is a big ask always. Thank you joining from Egypt, and thank you for being a part of our conference. Thank you, Dr. Sumesh and Dr. Anand Shankar, for chairing this wonderful session. Thank you so much.
Thank you. Keep safe. Thank you, Kumar. Thank you, Dr. Kumar.
Moving on to the next session, we have an important talk now from Dr. Neeta Deshpande from Belgaum. I should say that she is the diabetes reversal lady of India. Because we can see so much of reversal she does, not only in diabetes, obesity, and all those things. By seeing her, I'm sure you'll definitely agree that it is possible, because the way she does this organizations of the conferences and talk about the various reversal aspect is something new and something unique. I think this is one of the things to be learned by all of us. To chair this session, we have got my friend Dr. Ashish Dengra from Jabalpur. He's a consultant diabetologist at Mahi Diabetes Center in Jabalpur. He is also a dynamic person in diabetic awareness events, and he organizes so many conferences. He's a part of RSSDA, and good to see him here. And we have Dr. Har Suman from Bangalore. He is the director of Madhumeha Diabetic Hospital in Bangalore. He is the president-elect of RSSDA Karnataka chapter. Over to Dr. Ashish and Dr. Suman for the further proceedings, please.
Thank you, Arvinda, for inviting me for such a great, wonderful conference going on since yesterday. And thanks a lot for your token of love you have sent. It was really appreciated, and we have loved it. And without wasting much time, I will introduce Neeta. So Dr. Neeta Deshpande, she is a very good friend of mine, and she is MD FRCP Edinburgh, PG Endocrinology London, and ASPB Obesity certified in USA. And she is a director of Belgaum Diabetes Center, Weight Watch Children Diabetes Center, professor and HOD Medicine at MM Dental College, Associate Professor Medicine USM KLE International Medical Program, and several presentations on obesity and debates on diabetes in national and international meetings. She has publications in peer-reviewed journals and textbooks, and past chairman of Karnataka RSSDI. She is principal investigator for several clinical trials, and she was honored with the Karnataka RSSDI oration in 2016, and she has received the most prestigious fellowship of RSSDI in 2016 and FRCP Edinburgh in December 2016. She is member expert committee RSSDI 2017 consensus guidelines. So she will be talking about the reversal that is very important and a need of the hour in the present scenario. So over to you, Neeta, for this excellent topic.
Thank you so much, Ashish, for that kind introduction. And thank you, Arvinda, for having me here and for that effusive welcome. And I know we're running late, so let me cut across straight to sharing my screen. Is it visible?
Yeah.
Okay. Thank you very much, Arvinda, again for giving me a topic which I really enjoy and which I'm very passionate about. And if you notice, it is turning back the clock and reversing not just diabetes, but metabolic diseases, and you will soon know why. So I'm going to give you a slightly different take on this particular topic. I do not have any disclosures for this talk. And I'm going to talk about 3 strategies and give you a little bit of evidence for each one of them. One is talking about the calories, which we definitely look at when we talk about reversal. Second is the carbohydrates, which is another important factor. And as you all know, there is now a lot of evidence, especially from Dr. V. Mohan's group, that rice can cause diabetes and all of that. So that the role of carbohydrates in this reversal thing. And then a little bit about resistance training. So I will give you one by one the important evidences and just one each to set the ball rolling. So here everyone is now familiar with this particular slide. It is the slide of the results of the DIRECT study, and all of us know it is the seminal study of Roy Taylor in reversal of diabetes in a primary care setting. And what he did, all of you know, he used a very low calorie diet. So this is the first strategy that I'm talking about, and that is about caloric restriction. We all know that calorie restriction can reverse diabetes and some of the other metabolic derangements as well. And if you use a very low calorie diet, as you can see in this particular slide, the higher your weight loss, the higher are your chances of getting reversed. So that is the key message here, that people in this category who lost 15 kgs or more, the proportion of patients actually reversing their diabetes was close to 86%, which is really, really very huge. And you can look at this odds ratio of the number of persons achieving remission at 12 months. And you can see here that it is 19.7 and statistically significant. And then this is again percentage achieving more than 15 kg weight loss at 12 months. So that is 1/4 of the population could actually come down more than 15 kgs, which is quite phenomenal. And this is only lifestyle modification, particularly caloric intake. So this is about caloric restriction, one of the most important strategies of reversal of metabolic diseases. Next comes the carbohydrates, and this is a very elegant study that has actually shown you that carbohydrate intake is also very important for improving metabolic parameters. And this is a study that came out last year and talks about dietary carbohydrate restriction improving metabolic syndrome independent of weight loss. So it's only the carbohydrate content. It doesn't talk about the weight loss at all. So what they did was they took individuals who were obese with a diagnosis of metabolic syndrome, and they were given 3-4-week weight maintenance diets that were low, moderate, and high in carb. And the protein was constant in all of the 3, and only they played between the carbohydrate and the fat. And it was isocaloric for carbohydrate across all the diets. So you can see here, this is what they did. They put these patients into 4 weeks for each one of these. One is low carbohydrate, moderate carbohydrate, and high carbohydrate. And as you can see here, the protein is constant, 20%, 20%, 20% in all the 3 phases. And it is only the carbohydrate which goes down from 6% to 32% in the moderate category and 57% in the high category. And you can imagine if 57% is high, in Indians, almost everybody is 60 to 70, so it is high carbohydrate. So moderate is somewhere like 32%. So this is what they did, and they were washout for the same group in between the 3 different feeding patterns of low, moderate, and high carbohydrate. And what did they find? They found here that the low carb, the moderate carb, and the high carb in these 3 different colors. And you can see the results here for the fasting glucose, the triglycerides, and the HDL. And you can see very, very clearly here that the ones with the highest carb are the ones that had the highest triglyceride and the glucose, and the lowest carb had the best results. So you can see here that they were isocaloric. So the calories were not really, the crux of the matter here. The crux of the matter was the carbohydrate. They were isocaloric. And this is what you got when you reduced the carbohydrate. So this is the importance again of carbohydrate restriction in reversing metabolic diseases. So this is what it tells you. If you look at this balance, as the carbohydrate intake increases, okay, you are going to get increased LDL size and lesser small dense LDL. So what I'm trying to say here is that the metabolic parameters improve as you keep going low on the carbohydrate regardless of the calories. So the first evidence was the calorie, second evidence was the carbohydrate. The third now is a combination. Y-weight study by Osama Hamdi et al. From Joslin Diabetes Center. What they focused on was calories, carbohydrates, and they added the third element, which is resistance exercise. It's a real-world study of obese patients with type 2 diabetes, 12-week intensive lifestyle modification, and they were given exercise program which included resistance training, and they were given structured menus, and the carbohydrates were limited to 40 to 45%. So just like you saw in the previous study, the carbohydrates were restricted to almost the level of the moderate carbohydrate in this particular study. And what they found at the end of the 12-week program was that the patients had lost an average of 9.7 of their initial weight, and their average A1C also dropped, and medication use fell. But they did something else beyond that. That is, after 1 year, this same group, based on the weight loss, they were divided into 2 groups and then followed up for 5 years. The first group is the one that maintained less than 7% of weight loss at the end of 1 year. And the second group was that maintained at least 7% weight loss or more. And you can see here that LDL, HDL, cholesterol, triglycerides were not that well maintained in this group. Those who had not maintained their weight loss. But in the second group, those who had maintained at least 7% weight loss, what you could see here was that the cardiovascular risk factor in the 5-year follow-up were very, very beneficial, very, very conducive. And what you can see here also is that A1C also decreased. So those who maintained their weight loss, you could see the effect of on the metabolism even at the end of 5 years. This is one of the longest studies. It is even longer today than the direct study. The Y-weight study is longer. It's been going on for much longer. So you can see here that reversal of the metabolic derangements can happen if you combine caloric restriction, carbohydrate restriction, and add an element of resistance training to it. This is my own data. The impact of a balanced, very low calorie diet, the similar kind that was given by Roy Taylor, on the metabolic health of Indian subjects, and it's a prospective study. So we had 118 patients, mean age was 44.7, and the mean BMI was 32. And we had patients here who are diabetic and non-diabetic, and 54%, approximately half of them had diabetes. And we had patients on insulin. This was in direct contrast to the direct study, which did not include patients with insulin. And the proportion of patients with hypertension was 37%, dyslipidemia was 50%. And what you can see is I'm just showing you here the impact on liver disease, fatty liver disease, because I'm talking here about overall metabolism and not just reversal of diabetes. And you can see very well here that at baseline, 93 of the 118 had fatty liver. And at the end of the follow-up period, which is about 6 months, we had only 19 patients with fatty liver. All the others had just gotten rid of their fatty liver. So this is a huge thing to have happened where we have used the very low calorie diets. This is another data set of just 5 patients, which I'm showing you from my study. And this is the baseline A1C and this is the follow-up and this is the difference. And you can see that you have differences of 2.5, nearly 2%, 2.1%. You can see that there is a difference in A1C, and this is again at the end of just 2 months of the intensive diet, of very low calorie diet. Sorry, this is at the end of 6 months. And what you can see here is that the weight loss in kgs is 14, 11, 8, 6.55. So there is weight loss and there is an A1C that has come down almost in the it has come down into the non-diabetic range, and some of them are pre-diabetic. So this is a data set of my 5 patients. This is another of my studies which was presented this year at the ACE 2020. And what you can see here is what we presented was the impact of a very low calorie diet on reversal of metabolic disorders among Indian subjects. And we use the reversal diet for 6 months over here, and the low calorie diet, same as Roy Taylor's at the base. And then we studied them at the end with 6 months. We did the in-body analyzer also for them. And there were a total of 72 subjects. And there were significant improvements, as you can see here, in body weight, in BMI, waist circumference, hip circumference, as compared to baseline, and systolic blood pressure, fasting glucose, postprandial, body fat mass. Everything was significant. So the conclusion was that a significant impact towards reversal of metabolic disorders was observed following a structured, very low calorie diet intervention in this cohort. Of course, further follow-up studies are currently needed. So this is what we presented this year in 2020. Now, after I have told you about calories, carbohydrates, and resistance training, I am going to add a 4th dimension to this, which is a raging controversy or a conflict in recent times, and that is of intermittent fasting. This is a 2015 review that tells us about fasting, intermittent fasting, which has been effective in reducing body weight, body fat, total cholesterol, and triglycerides in normal weight, overweight, and obese humans. And they have been whole day fasting trials lasting 12 to 24 weeks. And they favorably improve the lipids as well. So I'm harping on the fact that this is not just reversal of diabetes, but this is also reversal of other metabolic problems. And now this is an important 3 cases, which I'm going to show you, where they have used therapeutic use of intermittent fasting for people with type 2 diabetes as an alternative to insulin, reversing the diabetes. So they've reversed diabetes by using intermittent fasting. And these were the 3 patients, 40 years, 52 years, and 67 years, with type 2 diabetes for 20, 25, and 10 years, with some comorbidities. And the fasting was for 3 times a week for 2 patients and alternating days, that is alternate day fasting for 11 months. And what did they find in these 3 patients? They found that the A1C reduced from 11 to 7, 7.2 to 6, 6.8 to 6.2. So 2 patients actually became non-diabetic, and the initial medications were as follows. And the final diabetic medications, 2 of them went off all medication, including insulin. This patient went off the insulin and stayed only on canagliflozin. There was substantial weight loss, substantial reduction in waist circumference, and the number of days that were required to come off the insulin were just 5 days, 18 days, and 13 days. This was intermittent fasting in 3 of these patients. This is my own case report of intermittent fasting causing reversal of diabetes and weight loss. This was a 56-year-old male, type 2 diabetes for 2 years, no hypertension, sedentary life, euthyroid, with a weight of 122, with a BMI of 37, and he came with a metformin of 1500 milligrams per day. We started intermittent fasting and a VLCD for this patient with metformin of 500. But within the first week, we withdrew the metformin, and this was the weight loss of this particular patient at our center with intermittent fasting and a very low calorie diet. He was also advised resistance training. And this patient also came down on his fasting and his PP. And as I said, he became completely normoglycemic without any medication. So to conclude, why should we attempt reversing metabolic disorders? Because it can retard metabolic age, reduce the impact of CV risk factors. This is the reason why we should try and attempt this form of reversal. You may use a combination of anything. You may use calories, you may use carbohydrates, you may use resistance training, you may want to try intermittent fasting. These are all the different modalities of non-surgical ways of trying to reverse metabolic disorders. When can you try this? Well, you can try it at any stage of metabolic disease because some benefits always accrue. I showed you 3 patients of intermittent fasting who were well beyond 20 years of diabetes and they attempted it. How can it be done? As I said, calorie, carbs, resistance training. I put a big question mark on intermittent fasting because we do not have enough evidence to do it, but it is something worth exploring. So whatever it is, it has to be done under close monitoring and close supervision. So I shall stop here and I will be happy to take any questions.
So thank you, Neeta, for excellent talk. And definitely by seeing you that you are becoming young and young, day by day, we will also try the same thing and will promote in our patients. Over to my co-chairperson.
Dr. Suman,
Neeta, I have a question.
Suman, unmute yourself. Suman, unmute, yeah.
Ma'am, I just want to understand, what is your take on the keto diet, ma'am? Is the keto diet is really going to help the patients, or?
Keto diet is a little dicey in diabetic individuals, but in general, as a modality of metabolic derangement reversal, keto diet, we have now evidence for up to 2 years. We do not know its safety beyond that. So it has been done by medical professionals and it has shown good results metabolically. But as far as outcomes and safety data is concerned, we have only data up to 2 years.
Recently, that Bengali actor died, and a lot of
exactly. So so what I would like to say here is that it's very frequently that fad diets come in only because I'll tell you how the cycle goes. The cycle goes as a new concept comes in, and especially if it is a dietary concept. And before the medical community can even start talking about it, non-medical people hijack it. And then what they do is they propagate it, and they do not do it in the with the scientific temper that it should be done with. And because of these kind of Bengali actresses dying because somebody else is doing it not in a scientific manner, the professional community that should actually try and look into this, they become skeptical about it. And they deprive a patient of a potentially beneficial therapy just because non-medical people have given it a bad name. So that is what I would like to say.
Dr. Neeta, very impressive concept, expanding the concept of intermittent fasting and weight loss into metabolic parameters, not just reversal of diabetes. Now that these concepts are very clear, weight loss and intermittent fasting, not all will be benefited. And the new emerging concept is about PFT, not pulmonary function test. It is personal fat threshold.
Yes.
What is your opinion about PFT?
Absolutely. I fully agree with that. It is not just personal fat threshold, it is also a personal BMI threshold. And the personal BMI threshold actually translates into a personal fat threshold. And that is that we have done reversal even in patients who have a BMI of 23. And the only way for these patients to reverse their diabetes or metabolic problems is by further reducing weight. The reason for this is that the BMI at which you drive fat into the liver is your personal threshold.
Correct.
So that is,
So,
I think, the
yes.
personal fitness training also it happens.
Yes. So your personal threshold is the one is where you start accumulating fat rather than in the other adipose tissue. You start accumulating it in the viscera and ectopic sites, and that is your personal BMI. Of course, these are outliers, Dr. Shekhar, because the vast majority of them, the BMI will and the fat stores go in tandem with each other. But there are few outliers, yes, there are few outliers in whom at lower BMIs, typically in many Indians, you will drive fat into the liver at much lower BMIs, and that is why BMI is not a good idea. And that's the reason I showed you the slide about the fatty liver, where we do a simple ultrasound mid-clavicular line size of the liver before launching into any of these. And we have found that those who have a higher fat, a higher liver span, they are the ones who do well.
Fantastic. Even normal weight diabetics can reverse.
Yes, we have done that.
Encouraging, optimistic view. Thank you for it.
I sense a sense of sarcasm, but thank you.
No. Because I am also normal weight. I have become pre-diabetic, so you are giving me encouragement to prevent diabetes.
Yes, sir.
Dr. Neeta, I have a question.
Yeah.
Can we increase non-activity thermogenesis, because we are doing day-to-day activities by doing exercise for a while and then stopping? Is it possible to do intermittent exercise, increase non-activity thermogenesis or expending calories at that time? Students during exams, they don't want to exercise. So can we encourage that, like intermittent fasting, intermittent exercise, to increase the non-activity thermogenesis?
Yes, the NEAT quotient has to be high regardless. Even if you are gymming and even if you are doing structured exercise, it makes eminent sense to increase your NEAT quotient, because that is going to definitely help in many different kind of ways. But having said that, intermittent exercise, the benefits of exercise depend on the age that you're talking about. Younger children lose their fitness after perhaps 3 days of exercise. So yes, they can do it intermittently. But older individuals, after the age of 50, and this has been shown by Dr. Sri Kumaran Nair very elegantly from the Mayo Clinic, where the effects of exercise, the good effects following exercise, the metabolic effects, are lost in 24 hours as you age.
Oh.
So
Dr.
it is okay
Suman,
yeah?
Please. Fine. Because lack of time, I think we will just try and
Sure,
conclude it.
I'm sorry about that.
Yeah. Madam did an excellent job of reversing a lot of things, and hope the reversal continues for a longer time so that Arvind doesn't have to do much of conferences like this.
Arvinda, you are looking very dashing today.
This is all because of this.
Yeah.
Thank you, Dr. Neeta.
And there was one question by Dr. J.K. Sharma, sir. That it is reversal or remission?
I will call it reversal only because reversal is a better term, because it only means that you're going in the opposite direction. Remission talks of a temporary cure. I'm not even talking about a cure for all the patients here. So the deliberate usage of the word reversal, because as defined by Roy Taylor or other people, reversal means 100% reversal. For me, reversal is going in the reverse direction. And this is also what Dr. Bansi Sabu is advocating. And we are trying to bring in that definition, that reversing the process, how far you go down the reversal lane defines whether you go into remission or not.
Definitely. Thank you, Dr. Neeta, for the wonderful session. I think a lot of questions will be there, so we can discuss in person when we meet. So it was a very good session. Thanks, Dr. Ashish and Dr. Suman, for the chairing the session and being a part of the conference. Thanks, Dr. Suman, for the nice DP. You have got a nice DP in the background. Thank you so much. Thank you all.
Thank you, Arvinda. Thank you, Neeta.
Thank you. So moving on to the next session. Thank you. Moving on to the next session, we have Dr. Pramila Kalra from Bangalore. She's from Professor of Endocrinology from MS Ramaya Hospital. To chair this session, we have Dr. Syed Jawad, He's a consultant diabetologist from Bangalore. He's an active member in various diabetes forum. And we have got Dr. Aravind GM. He is my MBBS classmate. He is a consultant physician in Manipal Hospital. Over to Dr. Syed Jawad and Dr. Arvind for the further proceeding, please.
Yeah, thanks, Dr. Arvind, for giving us an opportunity. Okay, I'll just give a brief introduction about Dr. Pramila Kalra. Dr. Pramila Kalra is MD and DM endocrinology, and she's an MBBS from the King George Medical College, Lucknow, MD from same college, and the DM endocrinology from Sanjay HAPGA. And she has a professional interest in thyroid disorders, polycystic ovarian syndrome, and many publications, 67 scientific publications in national and international journals, and 23 chapters in various and presentations in national and international conferences and membership. She has a lot of achievements, like graduate with honors MBBS and Surat Kumari Lal Gold Medal for the best work in Department of Medicine. And she won a prizes in paper poster presentation national conferences, received ICMR scholarship in the year 2006 for DM thesis work, and AR Set Award for the best oral presentation in the ISICON 2006, and best oral paper award in ITSCon in 2013 and 19, and executive committee member of KSRDA for the year 2011-2012, and member of National Academy of Medical Sciences, and FACE Award in 2017. Over to Dr. Pramila.
Yeah, thanks. Thanks, Dr. Arvind, for inviting me for this talk. And I thank the chairpersons for the kind introduction. And I hope my slides are visible.
Yes.
Yeah. So,
you can go ahead. Thank you.
Yeah, I'll start. So I'll be talking about the importance of time in range and glycemic control. Now, we just had an excellent lecture from Dr. Neeta about the diabetes reversal, but when the patient already has diabetes, then also now we are going to talk that what we can do best to prevent the complications and keep the glycemic control to the best possible range. So I'll be talking about, under these topics, need for clear metrics and clinical targets for effective CGM use, that is a continuous glucose monitoring, international consensus on time in range, the time in range visualization in the current healthcare practice and the patient's reports, the role of oral anti-diabetic agents in improving the time in range and glycemic variability, and then there'll be a summary. So why we need this time in range concept? We know that A1C has long been used as one of the key indicators for control of diabetes, both in type 1 and type 2 and any other type of diabetes, and has been one of the factors which takes, with which we can define the long-term diabetes complications, whether they can happen or not, to some extent, to a great extent, I should say, especially the microvascular complications. So though it reflects the average control over the last 120 days to 90 days, but there are still some limitations because we don't know the glycemic variability with that. We will not know how many excursions happened, how many hypos happened in that patient, how many hyperglycemia patient had. It also fails to identify the magnitude and frequency of the glucose variations. And also we know that there are some reasons like if a patient has anemia or some hemoglobinopathy, and in pregnancy, many states where we may not get a very good picture with the HbA1c, though it stays. It's not that this is, we will stop doing A1C. A1C is there, but over and above that, we are talking about a concept which can further better our glycemic management for the patient. And we can say that the utility of A1C is enhanced when we are using it as a complement to continuous glucose monitoring. So like if suppose this shows that like we have two patients who have a similar glycemic control as per the HbA1c, both have HbA1c of 7.7. But what we can see that one patient has less of glycemic variability while the other patient has more of glycemic variability, has more of hypoglycemias, more of hyperglycemias as well. And this is the patient who is prone to get more complications over a period of time as compared to this patient. So tomorrow when this patient comes to the OPD and this patient also comes, this patient might not have complications, but this patient would have got it. So the patient may ask, my HbA1c is also okay, same as this patient, why I have got it? So this is the answer to that question. So what are the recommendations? We have some international consensus recommendations from the Advanced Technologies and Treatment for Diabetes about the time in range target. So this is basically being set for patients with type 1, type 2, older. For pregnancy, we don't have very clear-cut recommendations. And obviously, we have to have some recommendations for children as well. So what they said that in clinical practice, time in range is appropriate and useful, and it is useful as a clinical target and outcome measurement. But it is a complement to HbA1c. It does not replace HbA1c. HbA1c stays, but this is over. Along with that, we can get some better idea about the day-to-day treatment and decision making. So basically, when we talk about time in range, we have three key measurements. We want to see the percentage of readings and time per day within the target range. We have to see the time below the range. We have to see time above the range. So that is what we call as TAR, that is above range. TIR is the within range. And then we call TBR, that is the time below range. And when we are talking about an effective control, we have to see that this increases, time in range increases. We reduce as much as possible the time below range, because that's the place where the patient goes into hypoglycemia. So that basically refers to the percentage of time that the patient with diabetes spends within their target glucose range. Now you can set targets for your patient. Maybe an older patient, you can set a target of 90 to 200 or 100 to 200. For a patient with no comorbidities, you want very strict control, you may set a target of 70 to 160. For a garden variety normal, we can set a target of 70 to 180. So we can set this target range. And that is what is defined for that patient, because one patient may have a different target range, another patient you may have a different target range depending on the age, comorbidities, and many other factors. So we know that time in range has been found to be associated with the development of microvascular complications, especially well studied are retinopathy and microalbuminuria. So it has been clearly seen that more time out of the range and less the time in range, there is more frequency of retinopathy and microalbuminuria as well. And also, there is a direct relationship between the time in range and HbA1c also. But we know that along with this, we also get to see the glycemic variability, which can also tell us, because sometimes the patients may have the same HbA1c as I showed you the previous slides, but they may have different glycemic variability data as well. And if you see, when we call one accurate or good time in range is 70%, it corresponds to HbA1c of approximately 7%. And time in range more than 70% is what we expect for most of our type 1, or we aim for most of our type 1 and type 2. Every 10% increase in the time in range means better control, translates into 0.5% reduction in type 1 of HbA1c and 0.8% HbA1c reduction in type 1 and type 2. So if we have a type 1 or a type 2 or a non-pregnant adult, more than 70% of the time in range is what we expect. But if the patient's age is like less than 25, then A1C is 7.5, then the time in range target should be around 60. Older patients, if at least 50% of the time per day in target range is a good thing to achieve. But we also have to understand that older patients who are at higher risk of hypoglycemia, you may have a little bit lesser, but still we can define the targets. Like we may not keep the lower target at 70, we might keep it at 90. Each incremental 5% increase in the time in range is associated with clinically significant benefits. For pregnancy, the things are not very clear, but what they suggest that for type 1 diabetes pregnancy, more than 70%, for gestational diabetes or type 2, the percentage of time in range targets are not being very, very clear, because we are not very clear studies regarding that. But the more we achieve, the better it is. So even if we achieve 90%, it's nothing wrong. So, but we should not cause more hypoglycemias. So each incremental 5 to 7% time in range increase is associated with definite benefits in pregnancy in women with type 1. That's clearly shown. For type 2 and gestational, the better we keep, the higher we keep time in range, the better it is. But we should not cause more hypoglycemias. So this is just the summary of these time in range targets for different populations. So if it's an older population, you might like to keep maybe 50%. For a garden variety, 70%, and we can set the target range. We can have a little bit lower or upper target range for the upper value. For the lower values, we can change it for older patients as well. But if you want to keep it that way, at least 50% pregnancy, and in type 1, it's more than 70% for sure. with gestational diabetes and type 2 diabetes pregnancy, higher the time in range, maybe 90-95%, the better it is. But the problem is we should also see that we should not cause more hypoglycemias. And if you see percentage of the time in range by levels, how we define, we can say very high, like high target range, we say 70 to 180, low, we say 54 to 69, very low, we say that is the hypoglycemia, severe hypoglycemia range, that is less than 54. And when we talk about the ambulatory glucose profile, we know it's a summary of the glucose values from the report with a median 50% and other percentiles as shown as if occurring in a single day. So this helps us to take treatment decisions, because if we see that the patient's glucose values are falling at some particular time, or they are going beyond the target at a particular time, suppose evening pre-dinner they are going high and post-lunch they are falling. So we know that, yes, we have to modify the dose of the OAD or the insulin accordingly. And each daily profile actually represents a midnight to a midnight periods and individual daily traces we can have for the patients. So if you see, this is how the report looks like for glucose monitoring when we do an ambulatory glucose monitoring with the time in range. So this is how we get the values, and we know, as I said, we have to set the time in range. So we will get how much time patients spent below the target, how many of the readings were above the target. Like here, if you can see, it's 45%, time in target like 55%. So average glucose of the patient is coming around 136. So as we reviewed the consensus that it should be more than 70% of the data of the captured over the 14 days wear time. It's not the single day, it's the 14 days readings what we capture. Out of that, more than 70% of the data should be in the time in range. But here, if we see in this patient, it's like 54%, 57%, 55%. So it's like we see the percentage of time also. So this is what we see, how much of the time the patient is spending in that particular target. So we know that insulin is the option to improve the glucose values, there's no question, but we have some consensus statement on the use of ambulatory glucose profile in patients with type 2 diabetes mellitus who are receiving oral anti-diabetic drugs. So we know it's not like we do it for all type 2s. So we do it only for few type 2s who are on OADs. For insulin, there is no controversy. So when do we do this ambulatory glucose monitoring in type 2 who are on OADs? When there's a disparity between the fasting and the postprandial blood glucose levels and HbA1c, as we saw in the previous slides. HbA1c more than 7.5 with fasting plasma levels and postprandials on target. So that is one place where you would like to do AGP in such patients. HbA1c on target, but fasting and postprandials are not on target. Patients who are at risk or who are coming with hypoglycemic episodes, or you are suspecting hypoglycemic unawareness. Need for patient education. Patient wants to know, and the patient sees that this is the thing which is happening when I'm doing this or when I'm doing that thing, my glucose values are going high, and then they get to know that this is the mistake I'm doing, which I need to rectify. So patients who are not adherent to lifestyle, non-compliant to treatment, they need to be put on this so that they understand that what is happening to their glycemic control, and then they can modify their patterns of diet and lifestyle as well. So when we talk about the role of few of the OADs like gliptins or SGLT2s in time and range and glycemic variability. Now, this was one study which was done with vildagliptin versus sitagliptin. This was one small study which was done with 14 and 16 patients who were inadequately controlled type 2s between the HbA1c target of 6.5 to 8. And they acquired the data over 3 days, first on metformin, and then after that they put 8 weeks after addition of either vildagliptin or sitagliptin. And what they found actually that vildagliptin significantly increased the time in range by 24.2% versus sitagliptin, there was a non-significant increase. So they found that vildagliptin fared better in this particular study of 16 patients as compared to sitagliptin. And also when we talk about glycemic variability, both vildagliptin and sitagliptin improved that glycemic variability, but vildagliptin was found to perform a little bit better control of the glycemic, did a better control of the circadian glycemic control as compared to sitagliptin. So this is what they found in this study. So they found that vildagliptin showed a trend a little bit better, but not statistically significant. Also, SGLT2 inhibitors, if we see SGLT2 inhibitors like dapagliflozin on 24 hours glycemic control in patients with type 2, this was again a randomized controlled trial. And there they gave 10 mg as compared to placebo. Again, 50 patients in both the groups. HbA1c targets range was 7.5 to 10.5. These patients were either on stable dose of monotherapy of metformin or insulin, and with or without up to 2 oral anti-diabetic drugs. And the continuous glucose monitoring was done to see the 24 hours glycemic profile for 7 days pre-treatment and during week 4 of treatment. Again, interestingly, they found that dapagliflozin improved the time in range by 11% compared to the baseline after 4 weeks of treatment. So this is at baseline, and this is after 4 weeks of treatment. You can see 58.4 here. Here it has become 69.6 as compared to placebo. The study was done just 55 versus 52.9. So there was a beneficial effect on the improvement of time in range after 4 weeks of treatment. So this another study which was done versus gliclazide with dapagliflozin, and these patients were again treated with 10 mg of dapagliflozin or 120 mg of gliclazide sustained release, and they again calculated the glycemic variability index, and the continuous glucose monitoring was done at baseline, and again after 12 weeks 97 patients were randomized and 94 completed the 12-week protocol. Again, they found that as compared to the baseline at 12 weeks, the time in range in patients who were on dapagliflozin increased by 24.9%. It also became better with the gliclazide addition, but what they found that it was 17.4% in the gliclazide group, and they found the p-value to be significant, like 0.04. So both improved the time in range, but the better effect was seen with SGLT2 inhibitors as compared to the sulfonylurea. And not to forget, commonly used and beneficial in our patients because of the type of diet our patients take, like high glycemic index, the role of alpha glucosidase inhibitors like voglibose in improving the time in range and glycemic variability. This was a multi-center, open-label, single-arm prospective interventional study which was conducted in type 2 diabetics who had HbA1c beyond 7. Patients were on stable dose of either metformin or metformin sulfonylurea and at least had 2 postprandial excursions above 140 within 2 hours of meals. And the compliance, they checked by using the CGM device during the 14 days prior to the enrollment in the study. And then they did a 14 days ambulatory glucose profile, and they found that they were randomized to either voglibose 0.2 or 0.3, and as an add-on to metformin or metformin plus sulfonylurea for 12 weeks, that is 3 months. And interestingly, they found that metformin and voglibose combination therapy improved the time in range by 7.12%. Metformin plus voglibose plus sulfonylurea combination improved the time in range by 9.7%. Metformin plus voglibose combination therapy reduced the time above range by 7.56%, and the metformin plus voglibose plus sulfonylurea combination therapy significantly reduced the time above range by 11.6%. So this was also significant, and this was also found to be significant. So to summarize, time in range as a metric of glycemic control is one of the things which we need to do in many of our patients, even on type 2 diabetics who are on OADs as well. On insulin, we routinely do it, but it also gives us much more information in these type of patients where the HbA1c and the fasting and the postprandial glucose values are not matching, where the patient is having hypoglycemia unawareness, or the patient is having recurrent hypoglycemias, which we are missing, or the patient is not compliant and is not understanding the importance of lifestyle and the diet on the glycemic control. And we should also aim for achieving an effective and safe glucose control. We should increase the time in range and definitely try to reduce the time below range, because sometimes what happens, we try to bring the glycemic control to the very good range, even in older patients, but we can cause more hypos. So time below range may increase. So that shouldn't happen, especially older patients and even in younger patients. We should avoid that. So the CGM targets for time in range and the standardized report, which has been proposed by the international consensus, this may benefit and facilitate the routine use of CGM. And this can actually help these diabetic patients, not only in prevention of complications, but for a better quality of life as well, because we can avoid many of the hyperglycemias and hypoglycemias, and we can know at what point of time it is happening and can actually take action before the patient lands up in the hospital. So thank you.
Thank you, Dr. Pramila Kalra. Thank you, Dr. Arvind. Congratulations for a conference. And as usual, Dr. Pramila Kalra, a very excellent and lucid presentation. You have shown time in range as a new tool in the management of all type of diabetes in type 1, type 2, and gestational. This is an recently released actually. and time spent by diabetic patient in target range between 70 to 180 milligram per DL while reducing the time in hypoglycemia is a new tool in the management of type 2 diabetes. Congratulations for your excellent presentation. Thank you.
Dr. Arvind, any questions you can want to ask?
One question, Dr. Pramila Karl. Hello.
Dr. Suresh,
Yeah, as we know, this compared to HbA1c, this CGM machines or flash glucose monitoring machines are very expensive. I think it's a time to get some like a generic drug we have in medicines. We should have a generic CGM machines or flash glucose monitoring machines.
Your point is very good.
It will be useful for India, especially Indian patients.
Absolutely. Just yeah, please, Dr. Arvind. Yeah.
Nothing. We have a next session. The pioneer in the field of technology, the master is sitting. He'll tell you the answers about this.
Yeah.
But, Dr. Arvinda, I would like to just ask one brief thing. Ma'am, when it comes to TIR and HbA1c, as you have already told, a good HbA1c may not mean a good TIR. But many a times we see a good TIR, but fasting hyperglycemia is always there. Patient is having fasting hyperglycemia, and rest of the time patient is doing perfectly well. So how do these two things correlate? In such a circumstances, what would you do? HbA1c is also good, time in range is also perfect. Patient is 99% of the time in the time in range, but the fasting sugar is 150, 160.
Yeah, then we have, see, when we talk about glycemic control, we say it's not only HbA1c, it's not only the time in range, it's also for the patients on insulin and some patients on OADs, SMBG, as well as the fasting and the postprandial glucose measurements. So all three together we have to target. It's not only alone HbA1c or time in range alone, or the fastings alone, or the postprandials alone. So if the patient has a higher fasting glucose, okay, we know that the hepatic glucose output is higher, or maybe we also have to check, because if we have checked the time in range, we have to check the time below range also, because these patients might be getting some hypos in the night and there is a counter-regulatory response and is getting a hyperglycemia. So if all that is taken care of and actually the fasting is high, we have to see whether we can increase the metformin or whatever we can do for that patient. Like if it's a basal insulin, we have to increase the dose. So accordingly, we have to manage that also. So it's all three together. It's not one separately. That's how I would put it.
Thank you.
Yeah, can I say something, Dr. Pramila?
Yeah, please.
Yeah, Amit, that is why the American Diabetes Association, you have seen that in the clinical practice recommendations in 2020, there is a model AGP over there. So when you are giving the report, it is AGP report, which includes the AGP as well as the DIR. So the daily graphs are also included. So what you said is true. If there is a fasting hyperglycemia, it is there represented in the AGP, and then the DIR is different. So we have a total of 10 metrics as described by Dr. Pramila. A total of 10 metrics are there. So most of them are independent. So DIR is there, AGP is there, hemoglobin A1C is there, but in a single report, it is made more simplified.
Yeah.
Thank you, sir.
Thank you, Dr. Pramila, for the wonderful talk.
Thank you. Thank you.
Thank you for being the part of our conference. Thanks, Dr. Syed Jawaz, and thanks, Dr. Arvind GM, for chairing this session. Thank you so much for being the part of the session, our conference.
You're most welcome. Thank you.
Next, moving on to the next session, we have Dr. Jyoti Dev. I should say that if any technology in diabetes, you have to be known, you have to ask this person. He is the technology man of India. I should say that very proudly, because because we come across so much of technology. Morning we had a talk from Dr. Nishan Eagle from Canada talking about the technology by year 2025. Now there are so many things to be learned as a doctor. Forget about the patient. As a doctor, we have to know so many things about this newer technology. I think the best person to speak about is Dr. Jyoti Dev. To chair this session, we have Dr. Y.S. Ravi Kumar. He is the professor in medicine, JSS Medical College, Mysore. Along with him, Dr. Hamid Gupta is there, a consultant diabetologist from Noida. Over to Dr. Ravi Kumar and Dr. Hamid Gupta for the further proceeding, please.
Thank you, Dr. Aravinda. You have already told that, Doctor, if the technology has to start from anywhere, then the person has to be Dr. Jyoti Dev, and rightly that Trivandrum happens to be the capital of diabetes technology in India. And I would just request my co-chair, Dr. Ravi Kumar, to briefly introduce Dr. Jyoti Dev.
Thank you, Dr. Amit. Thank you, Dr. Arvinda, for giving me an opportunity to chair this session. The conference is going on wonderfully well.
Thank you.
So, Dr. Jyoti Dev, as you told, is a pioneer in technology in diabetes. He did his graduation and MD from Government Medical College, Trivandrum. He's the chairman of Jyoti Dev's Diabetes Research Center, Trivandrum. He's vice president of Kerala chapter of AIRD. He's a reviewer of more than a dozen endocrinology journals, Diabetes Care, Diabetic Tech, Therapeutics, etc. He's an associate editor of Journal of Diabetology, publishes a monthly internet-based free diabetes newsletter for the past 12 years, first author of Indian guidelines of vaccination, insulin pumps, and glucose monitoring, pioneer in cost-effective treatment of diabetes with use of telemedicine technology, has delivered multiple lectures including ADA, IDF, etc., has lectured in more than 500 forums across India and abroad, and has an IDF recognized Center of Excellence in Diabetes Care and Education. Okay, has many more credentials. I think he is the right person to talk on this topic. I invite Dr. Jyoti Dev to deliver his talk and to guide us about management.
Thank you. Thank you very much. Thank you very much, Dr. Ravikumar, for the kind introduction. And hello to my dear friend Amit. Thank you very much. And congratulations, dear Aravinda, for this mega diabetes mera. So it has been highly successful. So I have been in and out both these days. So excellent, performing extremely well.
Thank you.
And I will try to save some time, at least 10 minutes today. So this is going to be a workshop. So I was wondering how I can do a workshop virtually. So this is also going to be an experiment on a virtual CGM workshop, because workshop means you have to have a small conference hall and you will have the demonstrations in the conference hall. But let me see how we can do it in a very similar and an efficient fashion. Of course, I'll be using slides as well. But since I am in my hospital, I can show you some of these products as well. So let me start with the CGM workshop. Okay. And these are my disclosures. Can someone identify this? This is the Minimed. First is CGMS Gold. And this was FDA approved in the year 1999. And this arrived in India in the year 2005. And this is historically the first continuous glucose monitoring system. When I say historically the first continuous glucose monitoring system, later on, all these devices used to be known by this name, CGMS. Actually, CGMS is the name of the first device. And this is my diabetes nurse. She's still working with me. She's the manager of the hospital now, holding that cumbersome device. And let me show you this device, because this is now preserved in my Diabetes Technology Museum here at Trivandrum. And this is the device. And this is very heavy. Very heavy, and you don't believe patients used to carry some heavy cables along with them. And this is a complete unit from Minimed Medtronic. Amit, is it visible? Visible, right? Yeah. And
yes,
I still remember the patients used to have the sensor, and then 5 minutes after they leave the hospital, we will get a call that the sensor is not working and there is an alarm coming out. So that was horrible days, but we really enjoyed. And those were the first 3 to 4 years from 2005 onwards. And I even had some publications on this. And let me pick up the same one. I even had some publications on this. And if you look back to the size of the sensors, the next one we started using was in 2006. And that was along with the Paradigm 722 insulin pump. And this was the size of that sensor. And this is a video over there. But I won't be showing the video because here we are focusing on this sensor and the transmitter. And over the next few years, and this is in 2007, you can see that the size of the sensor again has shrunken and now it is only this much size. Remember, this was bigger than iPro 2. It was bigger than iPro 2. And I even had an oral presentation at the American Diabetes Association based on these older sensors. They were not accurate, but still we were capable of measuring the trend. And this is the long journey with all those sensors in India. So when we speak about continuous glucose monitoring, though I know majority of those listening to this conversation are aware of this classification, and Dr. Pramila just spoke about the time in range. So we can have the time in range from both professional CGM and personal CGM. So professional CGM used to be the only CGM which is available in the Indian market as a standalone device, except along with the insulin pumps. And these are owned by the physician's office, and these are blinded. We need to download the data at the end of 6 days or 7 days or at the end of 14 days. And the most popular one for a long time used to be iPro 2. And the personal CGM devices are the ones which can provide you with real-time glucose values. And even at those times, and this was in 2014, we could realize the significance of CGM devices not only in diabetes. Let me tell you, I know there are, this is a well-attended conference and thousands are listening to us. CGM is useful for many doctors who are having even pre-diabetes. It is a highly efficient modality, a device for preventing the progression of pre-diabetes to diabetes in motivated individuals. It gives strengths and it gives values. And these were the olden days. And these were the only sensors during those olden days. And there came a big revolution, a very big revolution with this. And this is the iPro 2. And this is the Libre Pro. I'm sorry, Libre Pro. The Pro stands for Professional CGM Devices. And we started this in the 25th of March in 2015. And let me tell you how you can differentiate this from the other sensors. This became very, very popular in India. I know that all of you could have used this Libre Pro at least once. And many of you could have used in hundreds of your patients. Since the device is extremely smaller in size, very easy to use, and this was the first one in India which didn't require a glucose meter for calibrating the device. So that those were the advantages. And this is the Guardian Connect, and this was launched 2 to 3 years ago in the year 2018 in India. But currently we have the new sensor. So that is a new gen sensor. What are the advantages? It is available as seen over there. You can have it on your mobile phone in real time. And this is once in 5 minutes, whereas Libre, it is once in every 15 minutes. And another advantage, you can log in other data, and there is an alarm function, and you can share this information with many others, including your clinics. The disadvantage will be, this is again dependent on your glucometer values, because you should use glucose meter for calibrating this device twice or thrice daily. So that is the biggest disadvantage. And you can go to the settings in your phone or in your laptop, and then you can have the alerts. You can have the rise alert, the fall alert, and the same can be visualized in your desktop or in your mobile. And at the top panel, the sensor value, and this is the sensor graph. And we have been using in hundreds of these patients for real-time glucose monitoring, because everything is visible in real time in my phone, in my laptop, with the diabetes nurses in the hospital. You need to only use the username and the password. And this can also be downloaded from the care link in the website. And in real time, I can even get as a message from my patient in another country in my Apple Watch or in my phone. And this is a browser-based functionality which is available even in the Android phones. Initially, I would tell you that Guardian Connect initially used to work only in the Apple phones. And we have done so many studies. This is a multi-centric study on the use of CGM in India. And we have been documenting the multitude of benefits with the use of continuous glucose monitoring. Of course, I agree that it is a little bit more expensive and you need to spend a little more time analyzing the data. I agree with that. And there are broad indications. And the indications, I believe, vary from clinic to clinic. Let me show you some of these devices from my diabetes museum once again. So when we are using this device, Minimed Medtronic, these were the insulin pumps at those times. The Minimed 508. Some of these devices are still with me. And this was later on replaced by the Paradigm insulin pumps. And now even these pumps are vanishing from the market, and now we have the 640, 670 and so on. And for a long time, you remember, it was the era of iPro 2. And this is the iPro 2 sensor, very tiny sensor, the iPro 2. And this is the charging base over there. And iPro 2 is vanishing. It is phasing out. So probably you won't be using iPro 2 any longer. It will be only Libre Pro and Libre. So Libre Pro, you use it with this reader. That is a weight reader. And this reader, you will keep it in your office and you can use it in any number of sensors. So one reader can be used with any number of sensors. And then you have the Guardian Connect over there. So how will you differentiate? Guardian Connect, you have GC written over there. Over the sensor, there is a GC. And the GC is the one, because both look similar, but the transmitter and the accuracy is quite different. So GC, the sensors are different for Guardian Connect and for the insulin pump. Because insulin pump, the newer ones, they have upgraded so that if you are replacing the transmitter, then you can use the new Guardian sensor. That is a generation 3. And this is much more accurate in terms of lower mean absolute relative difference. So I'll go back to the slides once again. Okay, so we have reached up to Guardian Connect and these indications, and this is changing. This is changing all the time. The accuracy, the mark, because the next speaker is going to be Parthakar, one of the top faculty for this. He is the expert in this area, especially with insulin pumps and sensors. And the mean absolute relative difference represents the accuracy of sensors, similar to the Park error grid zone with the glucometers. And lower the mark, higher will be the accuracy. So when you look at these different sensors, and don't believe the mark, because with every generation of the sensors and with the improvement in the algorithms, this is changing. But as of now, the most accurate system available in India is the Abbott Libre system. The one which is launched in India has got an accuracy of not 9.7, it is 9.2% with a new algorithm. So why do you require a better algorithm? You know, the continuous glucose monitoring systems are measuring the glucose in the interstitial fluid. And there are different mechanisms of measuring the glucose in the interstitial fluid. It can be wired enzyme or it can be voltage, and then it is converted to glucose. And there is a lag time between the interstitial glucose value and the blood glucose value, depending upon how fast is glucose diffusing from the capillaries. And this differ based on multiple mechanisms. So in type 1 diabetes, when the glucoses are going up and down very fast, when the glucose variability is much bigger, much larger variability, then the lag time will be more. And some of these challenges have been resolved with the use of new gen sensors and with the help of algorithms. So this is pretty new in the market, very, very new in the market, and that is the Libre Pro. I'm going to conclude my CDM workshop with the discussion and demonstration of the new Libre. Libre is quite different from Libre Pro. It is a flash glucose monitoring system, which is more or less a real-time system. So we can scan and get the glucose reading every second, and every minute it can change, and it requires only a second for measuring the glucose value. And this has been used in many countries, and it also shows the trend. So I would say that these are some of the pictures I have taken from our patients. It shows the daily graph, the trend arrows. When it is going up, that means that a trend arrow pointing upwards means the glucose is trending up at the rate of around 2 milligrams per deciliter per minute. And so in the next 30 minutes, it is going to be higher by 60 milligrams. And when it is slanting like this, then the trend is between 1 to 2 milligrams per deciliter per minute, up or down. And subsequent to the discussions on time in range, this reader also provides you with time in range. So let me have the demonstration and then stop it here. And this is the new CGM device, the Libre, and I am having a sensor on me. In fact, I am having 2 sensors. And this is a sensor on my left arm. My goodness, low battery, but still it is. I will show it once again. And I don't know whether it is visible from there. And it is 129.
129.
There is a horizontal arrow. So the trend shows that it is not going up, neither going up nor going down. It is almost stable at less than 1 milligrams per deciliter per minute. And there is another option by which you can use the same with Libre Link app, which is not available in India now. And this Libre Link is also equivalent to the same reader, Precision Libre. So I am having another sensor over there, and I don't know whether it will work or not. And this is how it can provide you with the reading. And this is also real time. And Libre Link has got more functionality when compared to the reader. Lot of functionality are there, and the click of a button, I can send the graph, the trend, the daily graphs, the time in target, everything to the doctor's office. And the reader, of course, those who are listening to this are familiar with this, but some of you who are not familiar with this, I can show you that this will also provide you with the information on time in range. Don't look at the time in range here because I have set a different time in range since I don't have diabetes. It should be ideally between 70 and 180. Here I have set it as 70 and 140. And it will also provide you with information on daily patterns, the daily graphs, and the AGP that we have discussed will also appear on the reader as well as on the mobile phone app. So this is the future. So if I keep on discussing about this, it takes another half an hour, but this is going to be the future. And this also provides you with the average once in every 3 hours or once in every 6 hours, and the time in range and the target for the last 7 days, 14 days, 30 days, 90 days, and so on. So I would like to comment and conclude with the remark that we are soon going to have some cheaper devices for CGM in India. And this has been discussed in one of the recent meetings organized by Dr. Benshi in one of the RSS meetings. And I believe this is somehow going to be from China. And this is going to be a generic CGM and supposedly fairly accurate as well. So thank you, Dr. Aravinda, for this opportunity.
Dr. Ravi Kumar and Dr. Amit Gupta.
Thank you, sir. You have very briefly and very using all the technology you have shown, all the devices right from the 2005 till now. My only question to you is that, sir, since the CGM is available since 2005 and from 2015, the availability has increased, but now the usage of CGM is very, very low. We don't find it to be used very widely in India. So despite if we see the cost of the Libre Pro sensor is not that high, even if we compare with the cost of the Libre, which has just been launched, still the usage is very low. So I think something has to be done to increase the usage, because otherwise such a good technology is available and people are not aware about it. So I think there is an inertia on the part of the medical fraternity as well to transmit this information or to give this information to the patient that such a technology has been come and it is available, and it is also a kind of test for diabetes. I think it should be recommended just not as a monitoring device. We do all kind of things like microalbuminuria, we do all kinds of things. It should be recommended as a test. What is your opinion on that, sir?
Dr. Amit, I know that you are heading the diabetes education division because I have also been part of your program from RSSDI, and we can do a lot to promote this and educate the doctors and the patients. Though this device and the technology was available in India since 2005, I still remember the time to be dedicated for analysis and translating this into actionable information. So that means it is a huge investment of time. So that could be the challenge, major challenge. It could not be the money. It is a time. But now you could have seen the consensus from the ATTD, ADA, and the EASD panel. So they were actually trying to make this actionable information much more simpler. Because if you are discussing about how to analyze, you remember those days when we used to discuss about how to analyze a CGM. But now the analysis has become very simpler with just 10 metrics. And here again, when you are handing over the AGP report, because soon the International Diabetes, because you know it is a property of IDC and the Minneapolis-based organization, and all the giants, the device manufacturers will be having this, and all the CGM will have a similar report. But again, you have to spend another 10 minutes describing the pattern and the every day and what he is supposed to do with this pattern. But the new Libre, when you are promoting or prescribing, it is not you as a doctor who will be doing something for your patient. The patient himself need to be motivated and he need to be taught. And I think this takes some time, and now it has become a consumer product. But we should see that our patients are using it only according to our prescription and according to our guidance and using it appropriately. But I think the major challenge will be more and more and more and more of doctors getting trained and educated, both on the insulin pump. The newer devices are coming at the patch pump, because it is underutilized. It is grossly underutilized, and that is quite unfortunate.
Thank you, sir. Thank you once again for an excellent talk. And Dr. Ramkumar, any comment if you want to?
Thank you, Dr. Jyoti, for a wonderful talk. It was really a lucid presentation, and this presentation was really needed actually. And many doctors need to be educated regarding the usage more than the, and definitely it needs to be used in many patients to monitor continuous glucose monitoring. Thank you for your wonderful talk. Thank you.
Dr. Shekhar, any comments, please?
Yeah.
Shekhar sir, hello, how are you?
I'm fine, boss. Thank you. My good friend, you remember.
Yeah, very good friend. Yeah.
Started out similarly in 1997.
Exactly.
As far as Libre is concerned, one point of contention is, the negative point is, the lower cutoff when we put the range is invariably lower than the glucometer. And many of the patients were worried because the Libre shows 50, 48, but their glucose is 70, 75. This is where it has become a little bit less popular, especially so in special population like elderly and type 1 diabetics. They're worried. Less than 50 means we'll go into severe hypoglycemia. I have been trying to convince them, but somehow they are not very convinced about it.
Are you talking about Libre or Libre Pro, the newer one or the older one?
No, Libre Pro, the older one.
The older one, yeah. Because if you when you look at the MAR, there is a huge difference. It is almost 12 in the older one, and in the newer one, it is around 9.2. But again, there is an issue in the lower range, because we have Libre 1 in India, and Parthakar is having Libre 3, I believe, or Libre 2, because our good friend Dr. Partha is over there. So they are having the newer devices, but we have the new algorithm with us. But again, as Dr. Shekhar has commented, in the lower range, you need to be very, very careful. And the lower range is usually below 120 milligram. That is what I have seen. So we need to be very careful. And Libre 2 and Libre 3, they are approved for non-adjuvant use. You don't require a glucometer for confirmation. But for Libre 1, I think we need to be a little bit careful, because initially I also thought that this is very accurate since they are using the new algorithm. But I completely agree with you. You should be careful, and all the major decisions to be made only with the glucose meter. I would like to have a comment, if possible, from Dr. Partha.
Yeah.
No, hi. Yeah, no, I agree. I think one of the issues is that the lower ranges, the Libra 1 does tend to break off. And I think the Libra 2 have got, and I think you'll find that it's like, as I always give the example of like having an iPhone, it's just getting better with each version. And that's what you're seeing with Libra. We've seen that with insulins, you know, Humulin, and then the much more modern sort of analog insulin. So I think it's just a progression of technology. As it will advance, it will become much more accurate. But no, it's absolutely right. So what we tend to use Libra for more is the concept of time in range. That's probably a better marker of using it for, rather than trying to pick up hypos. That's at the moment, that's where we are.
Thank you, thank you, thank you.
Thanks, Jyoti.
Thank you, Dr. Jyoti Dev, for the wonderful session on CGMH. I'm sure most of our audience will be benefited with this, because most of them, in those who are practicing in the remote areas, they may not be aware of these happenings in the field of diabetes. Thanks for updating on these things, and I'm sure most of them will be enlightened with this particular talk. Thank you, Dr. Ravi Kumar and Dr. Amit Gupta, for chairing this session and being a part of our conference. Thank you so much.
I'll be there to listen to Partha. Bye-bye. Thank you.
Yeah. Now, next, moving on to the next session, we have Dr. Partha Kar from UK. Sorry, Partha, we kept you waiting for an hour. This is because there is a very good discussions going on after every session, so we could not stop them. So that is the reason. So Dr. Partha Kar will be talking on diabetes and fixed target in aging population. To chair this session, we have my friend, Dr. Suresh Damodaran from Coimbatore. Once again, he's been trained in UK, and he's a friend of Partha Kar as well. So he's an academic person. Dr. Suresh organizes conferences which related to diabetes and endocrinology, and he spreads the diabetes awareness in Tamil Nadu as well as across India. And along with him, we have Dr. J.K. Sharma, the senior physician and diabetologist, and a very active person in Royal College of Physicians. He's one of the few who has got all the 4 FRCPs from Royal College of Physicians, UK. So over to Dr. Suresh and Dr. Sharma to chair the session and do the further proceeding, please.
Thanks very much for the introduction, Dr. Aravinda. I think it's a pleasure to introduce my friend, Partha. I don't know what to say. I think we trained together, and from SPR days, specialist registrar days. Can you have a Partha slide? I mean, see, that is quite big, actually. I think that will take 15 minutes for me to talk about it, but I'll tell my memories of him. I think he's a guy, I think when we trained, he became the chair of YDF, which is like a youth diabetes, UK's youth area. And we could see the spark in him at that time. And we were as trainees, it's a lengthy 6-year training. So at that time, we could see the spark in him and being a leader. And in our dreams, we cannot expect what he achieved. So it's not flattering words. I think we all migrated from here to there, and what he achieved in his short tenure, I would say, in diabetes endocrine world, from here to there. I think he's currently, I mean, recently you might have seen BBC and other things. He's the chair of NHS England, and also his role of National Clinical Director and Diabetes of NHS England, which is the topmost post leading on developing NHS, right? I think at that time when we trained, Rowan Nielsen was there, if I can remember. So she was my boss in Hammersmith. And recently, she has been involved in CGM. Dr. Jyoti Dev was mentioning about technology research. So Partha is extremely active in social media, and he's given multiple talks in India now. I think he's probably a rising star in India now, I would say, as well. I stop there.
Okay. Thank you very much for the kind introduction. I'm going to start off by just saying thank you to Arvinda for the invite. I think that's much appreciated. I logged on, don't worry about being late, because I was actually listening to lots of the conversations. A lot of them are relevant, fantastic. And I think that's the point of these meetings, is mostly the discussions rather than the presentations, which are more valuable. Plus, I saw Arvinda and I wasn't sure whether I had walked into a Tollywood movie with his fantastic new getup, but looks amazing. So I will do my talk, a slightly different topic from what's going on. So I'll share my screen and hopefully it all works fine. Technology. There we are. So my topic, diabetes in an aging population. And this is not going to be any hugely different from what all of us do try and practice. But I think this is about trying to mix the evidence base with the person in front. So taking things forward, this is the prevalence of diabetes. And as we all know, our population is getting older. So those days when we had people with diabetes and you used to say, well, they would probably die earlier or have worse outcomes due to better care, better drugs, better X, better Y, better Z, people are living longer. And that's across the world. And we all see that in our clinics, people with diabetes of an older population coming in. And this talk is designed more about looking at certain slight nuances and changes that we need to keep in mind. I'm sure most of the attendees do, but this is about not just us. This is about also passing on to our, let's say, next generation, the doctors coming up, our colleagues out there, about the knowledge we take away from these meetings and then passing them through. Just as a matter of example, I'm not just talking about type 2 here. Even type 1 has moved away from the concept that it used to be a disease or a pathology at the younger age. It's now much more found in the older population. For example, in the UK, 50%, nearly 50% of type 1 diabetes are above the age of 50. And they've had diabetes for 20 years, 30 years, 40 years. So I think that's quite an important point to keep in mind. So here is what's happening. You can see the prevalence of this is the diabetes atlas. It's not just UK. 2017, you can see the people and the numbers growing higher as population changes. Older people, this is just an example of type 2 diabetes. I'm not going to spend much time on it, but as you can see, there is a significant proportion of people, and we are blessed in the UK with data. That's one thing we're very good at. We have got data to the absolute detail about every single person with diabetes. And as a result, we know the age group, we know which groups to target, which groups to look into. And as you can see, huge numbers of population are indeed in the higher age group. Look at the three zones I banded out in yellow. So you very much are aware where we are standing with that. What is the impact of aging in type 2 diabetes? Some of these we know, but the most important thing I would probably pick up is increasing frailty. So I think we need to move away from the concept of just age-defined wellness or not, because you can be in your late 70s and be extremely fit and well. Let's take the example, let's say, of Amitabh Bachchan as a Bollywood star doing everything, but you could be actually quite frail at the age of 60 if you've got Parkinson's and other things coming through. So the concept of frailty is more important rather than saying, at the age of 80 or at the age of 75, we're going to change our targets. We have an American president right now who's 78 years old. So let's bear all that in mind about saying, before we just suddenly say, because we need to be careful that as a society, we don't turn ageist and turn around and say, above a certain age cutoff, your management changes. That's not the evidence. The evidence isn't about the age. The evidence is more about the frailty and how they're living with life. So medication choice limitations, I'll go through a few of these things. So there is a particular spectrum that we talk about, and this is one way of remembering functional capacity in older people. And this is not based on age, as you can see. So functionally independent, they live independently, no impairments of activities of daily living, and minimal caregiver support, and they may have some comorbidities. So I give you an example of Mr. Amitabh Bachchan, still in KBC and all that, very much will fit into that zone. Functionally dependent. So there are significant impairments of activities of daily life, and they might have some background dementia or frailty. They've got weight loss, mobility isn't that great. And finally, you have the more important thing, which is the end of life. And these will be people whose life expectancy is reduced to less than 1 year. So it's important to bear that in mind. So taking things So I think it's also important that we keep in mind the evidence base. So these are all the trials that we talk about. Now, very few of these trials actually have recruited people above a certain age group. We talk about UKPD as being a very fundamental trial in our lives of diabetes care. 65 is where it stopped. VADT, Accord, all of these trials didn't go above the age of 80. So we have lots of patients in that age group, so we need to bear in mind. This is a fantastic slide, which I like. more than 65% of trials excluded individuals using an arbitrary age limit. Just picked an age and said, right, we're not going to recruit any more patients above this certain age, 65, 70. And as you can see, then they used other criteria to exclude patients from trials. So if you had so first of all, there's the age barrier. Then they said, if you've got comorbidities, we'll exclude you. If you take too many drugs, we'll exclude you. If you've got cognitive impairment, we'll exclude you. Well, that takes away probably 90-95% of the patients that we look after. And that is an important point to make. And then when you tie in short life expectancy, look at the number. Only 1.4% of trials specifically included older adults. So what we are doing now in our day-to-day life, because of the evidence base we have, we are extrapolating the evidence base from that population, younger population in an older group, and saying, maybe we should achieve and try and attain the same target. Things to remember in mind: 2 to 3-fold increased risk of physical disability is important. Lower skeletal mass, dementia, increased cardiovascular disease risk. So we know all these are an issue as we go forward. What about other things about aging? You got the progression of diabetes itself. You got the potential development of complications, memory problems, big issue. If you don't necessarily have the carers around you, food is an issue, taking the medications is an issue. Or you take the medication, like let's say a sulfonylurea, without the food, you've got issues with hypos. You got visual and manual dexterity problems, people struggling to pick up or take their insulin, draw their insulin, which ties into being able to self-care less for their diabetes. On top of that, we've got a declining renal function, which doesn't need to be a pathology because all of our renal functions do decline as we grow older. And that ties into the increased risk of hypo and reduced hypoglycemia awareness. So important message is that as people grow older, these are all the changes that are happening. Thereby, one rule will not fit all. What is the risk of hypoglycemia? This is something which I would like you all to take away, which is one of the fundamental things which we are changing in the UK, that age appears to affect responses to hypoglycemia, and the presentation is very different to what we would see in somebody who's 40 or 50 years old. They can present simply as dizziness, a bit of delirium and confusion, sporadic confusions, rather than sweating and tremor and the usual symptoms we find. And that is important to remember, because if we look at the hypoglycemia clamp studies, 50% of middle-aged people reported the symptoms compared to 8% of older people. Take-home message: don't try and detect hypos with the same symptoms that we tend to detect it in younger people. And the reason for that is here physiologically. This is how the whole physiology is supposed to work. This is the feedback mechanism of the brain glucose uptake. When it goes down, your growth hormone goes up, the glucagon goes up, cognition drops below, and thereby this is what is supposed to have. This is a feedback mechanism that we have with our counter-regulatory hormones, which is normally is the case. And this is what tends to be blunted when we have a hypo, or in people who have got diabetes, as a result of which you have the levels dropping down even lower. So what you see is this. The autonomic signs, the palpitation, the sweating, the anxiety is much less, while the neuroglycopenic one, the fatigue, irritability, confusion, dizziness, drowsiness, and coma are much more prevalent. So particularly in older people, unsteadiness and lightheadedness are very good symptoms and signs of hypoglycemia. So point of note is that if we are seeing patients or we're seeing carers, I think it's important to ask these symptoms rather than asking questions like, is the patient having sweating and tremor, etc. They may not have it because of the autonomic blunting. So it's important to bear in mind that if we're looking for hypos, we look for beyond just the traditional ones that we would judge younger people on. So it's important, very important lesson for us all to remember, and that will change our medications, because we have heard many a talk about the importance of hypos, but if we are not sure about what we're looking for, or we're not passing the knowledge on to our colleagues, then we might run the risk of missing our hypos, and then suddenly there'll be a much bigger event. So all these are also common in older people without diabetes, which doesn't make things easier. So retrospective data suggests 12.8. So here is some data as to the number of hypos that is going on across the ages, as you can see. 54% expenditure increase in patients increasing hypoglycemia, and it's important to bear that in mind. And that is one of the fundamentals which we have looked at in the UK about the costs in the system. And of course, the quality of life for the individual. Older people have a fracture or something related to a hypo, their recovery process is much more slower. So here is something, there's a paper which came out in Diabetic Medicine, which was done by David Strain and colleagues, and we worked with them on that. And as you can see, this was about simplistic way of trying to review as to whether we feel they have frailty or not. You can see things like clinical review, 4-meter gait speed, get up and go test, which can be done in a clinic setting. By all means, please look at this paper. This is not something that can be done in every setting appreciably, but there are simple good tips that we can do in a clinic to try and ascertain whether the individual in front of us, the elderly, do have a frailty issue going on, which should review or which should prompt us to review their glycemic goals. And that is the important point. You see a patient who's elderly, let's not make a judgment based on the age. Let's try and assess them for frailty. And if they do, that's when we try and shift our management targets or indeed the medications that we are suggesting that they try. So here are some examples of the patient type. You got healthy with few coexisting chronic illness, you got complex, and then you got very complex. And we all see these patients in our day-to-day lives as we go ahead. So what do we have here? Here is some examples of the fit older people. These are the targets. These are targets that have been changed in the UK. And you can see this is not based on age. Here what we are saying is that if you've got a fit older adult with diabetes, no signs of frailty, your target is 7.5% or below. Avoid initiating new agents anyway that might cause hypoglycemia or may exaggerate weight loss. Moderate to severe frailty, 8% change goes up because there is no evidence of tightening it below that. And very severe frailty, where you really are worried about their well-being, health, how long they might survive, 8.5% is very, very reasonable as to what we're trying to achieve, because quality of life has to be the most important factor when we're dealing with individuals with all these issues in their background. I'm not going to spend time on this. You have all seen this colorful chart, ADA EASD guideline. This is actually going through repeated revisions with all the new trials coming out. You know, we got new exciting times in type 2 diabetes, GLP-1 analogs, SGLT2 inhibitors, talking about reduction of heart failure, kidney problems, CV events. Fantastic. So in there, what we do need to realize, people talk about the compelling need to minimize hypoglycemia. They talk about DPP-4 inhibitors, which is why I always talk about, there's a lot of talk whether DPP-4 inhibitors have any space anymore. I think they do. I think we need to think about why we're using the drug and what is the end organ that we are trying to achieve. And most importantly, what side effects that individual will have to live with. Because we are not the ones taking the drugs, we are passing it on to somebody else, and they have to live with the positives as well as the side effects of that particular drug. That individual decision has to be based on their well-being, their frailty, etc. So here are some de-escalation thresholds. What we are saying in the UK is that if you've got a fit older adult with diabetes and the HbA1c is 7% or lower, you evaluate some of the sulfonylurea insulin therapy just to make sure that you're not tightening it up too much. Moderate to severe frailty is 7.5%, and very severe frailty is 8%. This is the juncture at which, so the last slide you saw is the levels we should aspire to be. This is at where it should prompt an intervention to think. Doesn't mean that you have to, but I think it should raise the questions. If you've, for example, got somebody with very severe frailty and HbA1c 8%, we should start thinking, do they have hypos? Is this benefiting it? Should we review the suitability of, let's say, NPH insulin, etc.? And let's not forget, in the elderly, especially the frail, weight loss is not what we are going for. This is not usual standard type 2 diabetes treatment, because that weight loss can cause sarcopenia and thereby even worse outcomes as far as fractures, etc. goes. So we have worked with NICE, and NICE has now changed their standards. They recognize frailty as a priority for assessment and different treatments. And via this talk, that's what I wanted to pass on, is a slight change in what we do. We do that anyway in our day-to-day. We make the decision based on the person, but it's about slightly changing our mindset, which should not be based on age, but should be based on the concept of frailty. And I think that's what we are asking everybody to look into. So here is a NICE, she's now the chief exec, not the deputy anymore, Gillian Leng, number of NICE indicators, step towards helping enable the greater personalization of care. So absolutely we should target where we need to target, but we need to reduce the risk of treatment-related harm. So we're very proud in the UK to try and get that now in the system, that not everybody needs to be at the same target. We are looking at what we say targets, we're looking at frailty, we're looking at the individual, and thereby making those changes. And finally, some little tips from our end. Lifestyle advice and reinforcement still continues to be important in intervention. Early intensification of oral agents offers effect. We know all that. Consider the highest risk of hypoglycemia in people aged more than 65 years. And also remember, there are differences within the class of DPP-4 inhibitors, which we know more the renal function side of things. And always it's about avoiding the treatment inertia, right treatment for the right time for the right patient. That is a bit like asking all of you to do what you normally do. But I think the important point is that the take-home messages are a paper to look at about frailty, how to assess frailty, look at the individual, and then make those choices, a slightly different thinking mindset about our change in targets towards HbA1c as we go ahead. So thank you. I'll finish there, and any discussion. Thank you.
Thank you.
J.K. Sharma.
Thank you, Dr. Partha, for a very wonderful deliberation. And as you have rightly said, we have to consider many factors when we look after the elderly people, especially the diabetics.
Sure.
We cannot see each type of patient, elder, children, like the GDM and the elderly people with one eye. We have to set our targets differently, and definitely we cannot put the results of the trials to all age groups, because the real world data are not much available regarding the elderly people. So you have very well explained what we have to look for, and people who are going to look after the elderly, which we all will be at one time, we have to look them separately. So any questions?
I have a comment. It is a very succinct and commendable talk by you, Dr. Partha. You brought fresh air of how we look at elderly diabetics. But more important, looking at you, I'm reminded of Sir Cliff Richards, one of my favorite singers from the 60s. He was a rock and roll superstar. And in the 70s, he was a popular music icon with a song called Devil Woman. Please look it up. Thank you.
Except songs, he is a superhero only, sir.
Dr. Partha, one question is there in the chat box.
Yeah, I'll just read for it. Dr. Partha, I'm heading a geriatric department. I'm so happy to listen to you on the assessment of frailty. What's your take on loss of subcutaneous tissue in elderly and bioavailability of OHAs in elderly?
That question was asked by me. I'm Dr. Pratibha. Yeah. As I'm traveling, I can't come on the video, but Dr. Partha, I'm so excited to hear your lecture. I want to know insulin and subcutaneous tissue. There's loss of subcutaneous tissue in elderly. So yes. How do we judge the subcutaneous insulin in these elderly? And secondly, bioavailability of OHA. So I think these two matter a lot along with social issues. I'd like you to comment on these two.
So two things which I would say is that I reference the paper which I'll send across to Aravinda and his group, who can cascade it. So that actually, so David Strain and his colleagues have done a really good amount of work on exactly what you've just said, the loss of subcutaneous tissue and the impact it has on insulin, because the absorption factor does change a lot. And I think this is where we go back to the being careful about what we are advising as regards diet to our elderly colleagues as well, about what you should and shouldn't have, because it does cause, because in our drive to make weight loss happen, we end up causing a lot more harm in certain groups because of the frailty. So I think by all, that's absolutely the right thing. And the bioavailability of OHA, again, does differ to a certain extent. I must say, I don't know a huge amount about that, but the subcutaneous fat is certainly an issue. And I would suggest you have a look at the paper, or if you want, please contact me. I can send you the paper to have a look at, and then I always can have a conversation. No problem.
Thank you very much.
Dr. J.K. Sharma? Yeah. Dr. J.K. Sharma, you got anything to ask? Sir, you have to unmute yourself, sir. Unmute yourself.
So, if there is no other comment or question, I thank Dr. Partha for a wonderful talk. And we should all keep our eyes open when we're treating the elderly, not only at the age of 65, but we should also treat people at the age of 85. But we have to keep our targets different. Thank you, Dr. Partha.
Thank you. Thank you very much.
Thanks, Aravinda. Thanks.
Thank you, Dr. Partha, for being a part of our conference and delivering a wonderful talk. And thanks, Dr. Suresh and Dr. JK, for chairing this session and being a part of our conference. Thank you so much. Much appreciated. Thank you.
Thank you, Dr. Jagdish.
Thank you. Moving on to the next session, we have Dr. Irina Vlasenko from Ukraine. So she'll speak on an important aspect of adherence to diabetes treatment, a global challenge. It's a very important topic. To chair this session, we have Dr. Lily Rodriguez, the consultant physician from Hyderabad, and Dr. Babu Rajendra Naik. He is from Bijapur, is a consultant diabetologist and a very academic, enthusiastic person, a friend of mine. Over to Babu and Dr. Lily for the further proceeding, please.
Thank you, Dr. Arvind, for that kind introduction, and thanks for giving us an opportunity to be the part of ADC. It's very wonderfully organized and going very extraordinary way. With respect to Madam, shall I hand over?
Yeah, you can carry on, please. Yeah.
So let me introduce today's speaker, Dr. Irina Vlasenko. She's a board member of International Diabetes Federation Europe, and she's a PhD of Pharmacy Associate Professor at National Medical Academy of Postgraduate Education, Ministry of Ukraine. She is a supervisor of the international PhD students. She has got very much interest in research activities, especially in the pharmaceutical care for the people with diabetes and the reform of the healthcare, the development of technology of new complex action medicines. Dr. Irina Vlasenko is a responsible editor of the scientific journals, especially pharmaceutical journal. She's the editor of Diabetes and Life. She has more than 155 publications as of now to her account. She's a member of National Diabetes Council. She is additionally, in 2003, she became an active member of the strong team of the Professional Ukrainian Diabetes Federation. Her CV is a very big one, but looking at the time constraint, let me make it short. And she's been a member executive committee of Association of Football of Invalids in Ukraine. Over to Dr. Irina for an excellent talk going to be.
Introduction. Hi, thank you so much, Dr. Aravinda, for invitation. I'm very happy to be useful for our diabetes community. I love India very much from my childhood, but only a few years ago I came to India thanks to Professor Shaukat Sadikot. I never forgot him. He did a lot for our diabetes community over the world. Thank you. My purpose, just a moment, I share screen. I only want to add that I'm not now a member of European International Diabetes Federation. Now I'm vice president, thanks to our community who chose me last year. And also I'm member of European Medical Agency, working party with patient and consume. And this is my new position. I can share with you this news that I member steering groups of the European Network and Center for Pharmacoepidemiology and Pharmacovigilance. It's like a representative EMA for this. My topic is, from my side, is very, very important. That is global challenge, adherence to diabetes treatment. If you look at information from WHO and another studies, the adherence to medication in chronic condition is only around 50–60%. 59 patients forgot to take their insulin. If patient takes 1 or 2 oral hypoglycemic drugs, adherence is only 46%. Adherence to insulin treatment amongst patients with type 2 diabetes is also 82–84. Patients with type 2 diabetes using both oral hypoglycemic drugs plus insulin, only 64%. There is a strong evidence for advantages of exercise, or however adherence for this treatment long-term exercise program still vary between 10 and 80%. We yesterday speak about this, but only 10 and 80%. We must work on this. And of course, it's a significant cost budget of healthcare system. And annually, it's like approximately $370 billion. I want to start from, this is a good study which make our colleagues from UK, that poor adherence associated with increased complication and mortality. And I want to say that therefore evident that healthcare professional might need to focus on implement of adherence prior to consider additional therapies, particularly in the currently climate of cost-effective prescribing. And I'm not sure that you are very happy with this result, that only one of third patient with type 2 diabetes fail achieve hypoglycemic A1 level less than 7.5. You spend a lot of time for education. You spend a lot of time to deliver this best care for our patients. But something wrong with our system, and this is time for change this. And we look on this adherence definition. Sometimes it's many definitions and this little bit curious. And this is, I take by only WHO, the extent to which a person behavior taking medication, following a diet, and of executing lifestyle changes corresponds with agreed recommendation from a healthcare provider. It also includes concordance, compliance, persistence. But also we must remember that through adherence, we have two different styles, like intentional non-adherence occur, that when patient decide not to follow your treatment, this is groups in this very difficult work with him, but it's also possible. But mostly your patient want to follow your treatment, but sometimes they cannot affordable for this for different reasons, not able to do so because in factor beyond their control, problems with using equipment and tools related to treatment and inability to pay for this treatment. We spoke about this yesterday. But what I want to say that I like this slide very much. I find from another author that this is problem not only diabetes care. This is problem for all of treatment. Look at this plummeting adherence level across therapeutic area over time. During only 1 year, 12 months, look how dramatically decreased this adherence. And if you look depression and obesity, which also our area, look 10%, 8%. This is catastrophic. I think it's not good result. And also our diabetes treatment during 1 year is decreased 38%. Of course, this is a very big problem because a lot barriers. I understand this little bit too much in this slide, but I only want to show that it's a big problem. This is around patients, healthcare system, healthcare provider, and a lot of specific barrier. And if you look at social, economic, low education level, we spoke yesterday also about this, condition related, health system related, therapy related, and patient related. A lot of specific barrier. We must know this for improving the situation. And of course, we have specific for our adherence to glucose lowering drug and perception of treatment, complexity of treatment, polypharmacy, adherence effect, hypoglycemia. I think it's hypoglycemia. This is main barrier for good glycemic control because patients afraid these adverse effects and maybe try to little bit more because afraid hypoglycemia. And of course, insulin specific. This is also people afraid and even start for this. You know exactly as a doctor. But what I find this is in another research, that fear of infection and embarrassment of injection in public. It's also our work and also work our Diabetic Federation, because we must change view of a patient of society, and this is barrier is impossible. Of course, big economical aspect, medication adherence, and yesterday we speak that it's also limited factors. But look, this is a very good study shows the cost of diabetes treatment may result in nearly diagnosis, patient not seeking medication care after diagnosis. This is because cost, because many barriers. But a 20% increase in adherence can save $1,000 for 1 year for one person. This is very cost. This is important to educate patients that saving money today, but by non-adherence to treatment may mean spending much more money in the future because complications. Clinical inertia, the failure of healthcare providers to initiate or intensive. They intensive in our case. We speak this before my colleagues from UK exactly explain this, that it's very important, and the therapy when indicated. Important that not receive prompt treatment intensification, but in same time when need, the intensification therapy is also not in time. And you see one research shows that 11% patients with diabetes were potentially overtreated, and the therapy was deintensified for 14% of overtreated diabetic. And then deintensification was less common for those over age 75 years. But this is very important for us. You listen previous report that is very important because aggressive diabetes treatment decline with age, and there is increase. Factors that contribute to clinical inertia in diabetes is healthcare providers time, individualized pharmacotherapy plan take times, and also doctor must speak about implementation this plan and resource. Sometimes you have no technology resource or another resource. And patient, we have already said that afraid and many barriers. For this big and multi-problem, we must use multi-strategies which improve adherence. And this include a lot of aspects: improving dosing regime, increase provider availability, patient education, miscellaneous strategy, and communication patient provider. From my side, we can improve this immediately. Communication patient provider. I like this topic because communication now is very important, not only for a doctor, also for another healthcare provider. Now it's not enough to be a great doctor with super knowledge and modern knowledge. It also must have skills for delivering this care. I can promotion this communication skill for the healthcare provider was sent to me by Professor Nosky, who know that I'm interested in this area. Look, use this link, because sometimes you must pay for this, but this is link only for free. General guidelines to follow with patients. It show respect and compassion. Practice unconditional positive regard. Show concern and interest. Practice objectivity, but objectivity does not mean aloof and not caring. And enhance awareness on observation skills. Of course, unfortunately, this is a big book. but I think you find for your practice very many things. But short, if you want to short, few pages, which was developed by American Diabetes Federation. It's a fostering medication taken. You can find also very interesting and short information. It's only a few pages, which give you possibility indicate individual and high risk of not taking medication in your patient, and also prediction on poor adherence. And little bit positive things, that emotion at a lot of study, which I find emotional and physical performance are important determinants of good diabetic treatment adherence, and same time good adherence has beneficial impact on lipid, BMI, and glycemic control. Also, electronic monitoring system were useful and improve adherence for individual patients. And also, it could help healthcare provider determine patients which need additional support. And that study from Singapore groups that this is very important for nearly diagnosed diabetes patients, and if it has good adherence, less hospitalization and less problem. And finally, the adherence patient-centric approach is device and technology. A device and sensor can increase self-monitoring and management, and also technology for doctor, not only for patients. Gamification and analytic technique can be used for identifying and judge patients and bring about behavior change, and also connect this system which join infrastructure, IT infrastructure, which help to us analysis and make reaction. And what I want to say, unfortunately, is in the absence of the time and resource needed to appropriately educate a patient about new treatment, therapy intensification is less likely to occur. The implementation multidisciplinary care is option for maximizing resource in complex care system. And I want to show this, sorry for this slide because it maybe not so good picture. A few days ago, I was participating in IDF Europe symposium, and where Foundation of European Nurse in Diabetes presented some research which they do at a big impact, and patients very appreciated this, and we can use our nurse for our more than now. Make nurses make difference, you know about this year, the World Diabetes Day. But my point, I'm pharmacist. I promote long period. This is idea that the pharmacist is big part of multidisciplinary team. This is he can to prevent clinical inertia from negative impacting patients' care. Pharmacists have the breadth of knowledge, are uniquely suited to educate prescribers, assist patient-specific factor, and for patient is reduce risk and maybe improve benefit. But unfortunately, research which show by UK show that the physicians are not yet aware of the role of pharmaceutical community as member of multidisciplinary healthcare team. And you see that many studies evidence that this is big input. But I was very happy this year because I promote this pharmaceutical care long period. But thank you for my idea position and idea of board who accept this. That my idea. Thank you, Shakta, member of our board, Global International Diabetes Federation. That we want to improve international update maybe our communication with International Pharmaceutical Federation. And this year, this organization, which involves 149 national organizations, pharmacists, make this video like World Diabetes Day. The pharmacists make a difference too. I hope that we are together make more than now. This is very important because we have a moral responsibility to address a curable problem. Thank you so much for your attention.
Dr. Babu.
Thank you, Dr. Irina, for that lucid presentation. And indeed, it's a global issue, you can say so, about the adherence of the by the type 2 diabetes patients. It does need continuous motivation and bombardment to keep them on the targets. Thank you, madam. Thanks for that nice presentation and making a few more doubts clear in your lucid presentation.
Irina, that was an excellent presentation, because the concept of adherence to diabetes management is a big issue, even in all the countries, even if the best of the best countries like US, UK, it's a big issue where we can advise so many things to the patient, but at the same time, there is always a question why the diabetes is not controlled. When we go into the depth of the patient's scenario, then we come to know that they are not taking the medicines properly. Maybe they are not understanding our explanation. And so as a team effort, like being a doctor, pharmacist, a nursing staff, as well as the diabetic specialist nurse, everybody plays a role in educating the patient. Education should be a constant process so that the patient takes the medications regularly in a long term, preventing the diabetes complication. Thank you for the wonderful talk, much appreciated. And thanks for being a part of our conference from all the way from Ukraine. Now I'm sure that you are in Norway now. You are a member of IDF and you are a very busy person. Thanks for giving time and preparing these wonderful slides and being a part of our conference. Thanks, Dr. Babu and Dr. Lily, for chairing this session and being a part of the conference. Thank you so much, much appreciated.
Thank you.
Thank you, Arvinda. Thanks once again. Thanks a lot.
Next, moving on to the next talk is by Dr. Tarek Al-Reni from Egypt. So we have an interesting talk, actually, something different, because we talked about so many things. We talk about sometimes alcohol and health disease as well. Now this is smoking and diabetes. Like whether there is any link between smoking and diabetes, that is a interesting talk to come about now. To talk about this, to chair this session, we have Dr. Sambit Das, the consultant endocrinologist, a close friend of mine from Bhubaneswar. He is a very active member in Bhubaneswar RSSDA chapter and a very active member in organizing so much of diabetes related conference and workshops, and name anything, is a very active member in Facebook as well. And we have Dr. Prakash Keswani, is a consultant physician and diabetologist from Jaipur. He was the organizing chief in the last year held RSSDA conference in Jaipur. So over to Dr. Sambit Das and Dr. Prakash Keswani for the further proceeding. Thank you.
Thank you, Dr. Arvinda, for giving this opportunity to me to be a part of this nice conference. As you have already mentioned, we usually talk about the calorie intake, carbohydrate intake, exercise, sometimes alcohol, even about the sleep. But we forget to talk about the smoking, what role it has. It has a significant role. And for this, we have a brilliant speaker for this from Egypt. I will request my co-chair, Dr. Sambit, to please introduce our speaker for this session.
So thank you, sir. Thank you, Dr. Arvinda. It's getting a very wonderful conference, and I was listening to the last topics. So as sir has told, we always talk about diet and other things, exercise, about diabetes, but hardly ever we speak about this interesting topic, that is smoking and diabetes. And to speak on that, we have a very prolific speaker from Egypt, Dr. Tarek Al-Reni, and he's the General Secretary of Egyptian Cardiodiabetes Association. and he's also an internal medicine and diabetes consultant. So over to Dr. Tariq.
Unmute yourself. Unmute Dr. Tariq.
Thank you very much for this introduction, my dear friends. I wish to thank my dear friend, Professor Dr. Aravinda, for inviting me to such a well-organized and good talk within this summit of diabetes, and I'm very happy to share you in this event. Well, first of all, I want to disclose. My disclosure, I have no actual or potential conflict of interest in relation to this presentation other than my interest in helping our patients to keep smoking. Let's talk first of all about Egypt and India. Egypt-India relations are bilateral. Modern Egypt-India relations go back to the contact between Saad Zaghloul and Mahatma Gandhi on the common goals of their respective movements of independence. In 1955, Egypt under Gamal Abdel Nasser and India under Jawaharlal Nehru became the founders of the non-aligned movement. During the 1956 war, Nehru stopped supporting Egypt to the point of threatening to withdraw his country from the British Commonwealth. Also, India supporting Egypt during the Six-Day War. But unfortunately, India and Egypt are facing two monsters. Those are diabetes and smoking. India has the second highest number of diabetes patients aged 20 to 79 years as of 2019 ITF Atlas of Diabetes. Also, Egypt ranks number 2 in the number of diabetic patients in the MENA region. The prevalence reached about 15.2% and total cases are about 9 million. Meanwhile, smoking problem in both countries is also prevalent. Regarding India, 34% of adults are smokers, 14% use tobacco smoking, 25% adults use smokeless tobacco. The absolute number of male smokers has grown from 79 million in 1998 to 108 million in 2015. Also, we have the same problem here in Egypt. There are 34,000 tobacco-related cases in each year according to statistics by CDC's morbidity and mortality weekly reports. Also in Egypt, nearly 60% of men use tobacco in some form. Egyptians consume 80 billion cigarettes annually, equal to 4 billion packs of cigarettes. So we have talked about the epidemiology of diabetes and smoking. Now we are coming to what is the link between smoking and diabetes. Decades of research show an intimate connection between cigarette smoking and diabetes, and the link is two-pronged. First, smoking raises the risk for type 2 diabetes by 30 to 40% according to CDC. American Diabetes Association guidelines mention that smoking may increase the risk of diabetes. Also, in a prospective cohort Korean study stated that more than 70,000 individuals, it was found that there is an association between smoking and new onset diabetes. The association showed a dose-dependent pattern. A higher daily amount and the longer duration of smoking increased diabetes risk. Development of type 2 diabetes. Studies show that certain chemicals in cigarettes cause insulin resistance, which can lead to type 2 diabetes. Smoking is also associated with the accumulation of abdominal fat, another risk factor for diabetes. Exposure to passive smoking has been shown to increase the risk of developing metabolic syndrome, glucose intolerance, and type 2 diabetes. Combining the two devils, smoking and diabetes, is like doubling up on the damage. The condition snowballs in the form of inflammation, high levels of the stress hormone cortisol, toxic abdominal weight, vascular constriction. These all affect each other, and you are being hit from all directions. People with diabetes are already 3 times more likely to die of cardiovascular disease. The damage from smoking increases that risk by another 50%. Compared to non-diabetic, non-smoking diabetic patients, smoking diabetic patients have been associated with the following: decreased insulin sensitivity, impaired control of glucose and lipid metabolism, increased blood pressure, total cholesterol and obesity, increased risk of hypoglycemia in type 1 diabetes. Smoking is linked with the development, progression and poor healing of diabetic foot disease. In a meta-analysis, smokers were more likely to have a diabetic foot amputation, major or minor, than non-smokers. Increased risk of coronary heart disease, stroke, and peripheral vascular disease in type 2 diabetes. Also increased cardiovascular risk and all-cause mortality in type 1 and type 2 diabetes. So, what is the benefits of quitting of smoking for pre-diabetic and diabetic patients? Smokers who quit should avoid substantial weight gain, as there is an analysis of 3 cohort studies found that the risk of developing type 2 diabetes increased during 2 to 6 years after stopping compared with current smokers. Thereafter, the risk gradually falls. This temporary increase in risk was proportional to weight gain and was not seen in those who did not weight gain. However, regardless of weight gain after smoking cessation, cardiovascular and all-cause mortality fell. You must discuss this with patients. Various diabetes forums emphasize the increased risk of diabetes after smoking cessation. Stopping smoking reduces the risk of developing diabetic complications, and if developed, it reduces its severity. Decrease the risk of developing coronary heart disease. Within 11 years, the risk decreases to that of non-smoking diabetics. It slows the progression of nephropathy in type 2 diabetes. Stopping smoking can also decrease risk in all-cause mortality, cardiovascular and case mortality. By the way, it resembles SGLT2 inhibitors. Within 11 years, the risk decreases to that of non-smoking diabetics. How could we have important consideration for diabetic patients regarding smoking? Number one, the prevention and cessation of tobacco use are important components of clinical diabetes care. It's vital to emphasize to young patients with diabetes how important it is not to start smoking, which is very important when we deal with type 1 diabetic patients, because once they acquire the habit, they may find it difficult to give up. Tobacco users with diabetes are often inadequately informed about the benefits of quitting and or available options to support cessation. Meanwhile, evidence suggests that patients with diabetes do not easily adopt smoking cessation interventions, and cessation success rates are often low. Unfortunately, diabetics who quit smoking are likely to experience deterioration in their glucose control for up to 3 years, says a study. In this period, we must have close monitoring of diabetic patients and adjustment of anti-diabetic medications to maintain effective glycemic control following smoking cessation. skidding as a priority. The smoking cessation interventions should include a combination of behavioral counseling and pharmacotherapy. There are several examples of smoking cessation programs implemented in primary or secondary health care setting, which have shown beneficial effects for smoking cessation among diabetic patients. Let us talk about barriers for quitting. There are specific barriers for quitting smoking in the form of individual characteristics and medical care. Individual characteristics evidence suggests that patients with diabetes do not easily adopt smoking cessation interventions, and cessation success rates are often low. Advice to quit smoking, which has been shown to be a successful form of intervention among other disease groups, has lower impact on diabetic patients. High rates of dropout from smoking cessation program has been reported. People with diabetes frequently explain their inability to stop smoking by saying they are already too restricted by the diabetic treatment regimen, particularly the diet, and that they develop a craving for cigarettes when deprived of nicotine. The marked and almost unbearable unpleasant experience after abstinence from nicotine often induces a desire to eat sweet carbohydrates, which appear to modulate and improve mood, and eventually can lead to weight gain and impaired glucose tolerance. Second, diabetic patients are also more likely to suffer from depression or anxiety, conditions known to hinder efforts to stop smoking. Third, several misconceptions about the association between diabetes and smoking might be present, including the perceived hazards of quitting, including fear regarding weight gain after cessation that may make quitting challenging. Adolescents with diabetes are of particular concern despite presumed awareness of health risks. Also, reasons for their cigarette use behavior include pure experimentation, identity development, the need to conform to group norms, and the denial of health risks. Young people with chronic conditions may feel a greater need to be accepted by their healthy counterparts with engagement in risk-taking behaviors, including cigarette smoking, serving to improve their fitness and reinforce their self-esteem. Let's talk about medical care barriers, and this belongs to us as a physician and diabetologists. Despite frequent contact between diabetic patients and their healthcare professionals, different studies have reported low involvement of healthcare professionals in assessing and advising smoking cessation among diabetes patients. The barriers to delivering advice and counseling for smoking cessation for both patients with diabetes as well as persons at risk for developing diabetes include lack of time, motivation, or training of healthcare professionals for the delivery of smoking cessation interventions, a disease management approach which focuses more on glycemic control, lowering cholesterol levels and blood pressure versus smoking cessation, inappropriate funding and limited access to smoking cessation services in some countries. Lastly, be your patient role model. If you smoke, don't be seen by your patient while you are smoking, unless you will be a bad role model. What about pharmacological interventions in dealing with smoking cessation? Approved pharmacotherapies for smoking cessation that have also been recommended as first-line treatments include various forms of nicotine replacement therapy, bupropion, and varenicline. There is very little data on the efficacy of these pharmacotherapies in individuals with diabetes mellitus. Nicotine replacement therapy is available in the form of the long-acting patch and short-acting gum inhaler, spray, and lozenge. Nicotine replacement therapy has been shown to double quit rates in the general population of tobacco users and triple quit rates when two forms of nicotine replacement therapy are used in combination. Nicotine replacement therapy is used to assist with reducing cravings and withdrawal symptoms related to quitting. Nicotine replacement therapy dosing is gradually reduced over time. Diabetic patients should be advised to monitor their blood glucose level or blood sugar level more closely than usual when first using nicotine replacement therapy products, as catecholamines released by nicotine can affect carbohydrate metabolism. Bupropion is a non-nicotinic therapy for smoking cessation available in tablet form by prescription only, which has been shown to be effective in increasing rates of smoking abstinence in the general population of tobacco users. I am about to end my presentation. The prescribing information for bupropion should not be appropriate for use in patients with diabetes treated with hypoglycemic drugs. Lastly, varenicline, which is a selective partial agonist of the omega-4 and beta-2 nicotine acetylcholine, can be used. Regarding safety profile, varenicline appears to be safe and well tolerated by patients with diabetes. However, in patients with diabetic neuropathy or renal failure, the dose should be halved and administered with caution. Lastly, is there an anti-diabetic drug preferred in diabetic smokers? Actually, there are two studies running right now. That preclinical and clinical studies have demonstrated that a Food and Drug Administration approved diabetes drug with the generic name of exenatide has a different mechanism of action and holds promise for pharmacological treatment of smoking and possibly other addictive behaviors that can reduce the consumption of food and other addictive substances such as alcohol and nicotine. Also, nicotine abusers face a 30% higher risk of developing type 2 diabetes. The researchers suggest that pioglitazone may help diabetic smokers keep by lessening the physical and emotional withdrawal symptoms while reducing insulin resistance. Lastly, my take-at-home message: smoking is, together with diabetes mellitus, one of the main risk factors for cardiovascular disease. Diabetic patients have unique features and characteristics that cause smoking to aggravate the effect of diabetes and impose difficulties in the smoking cessation process. Healthcare professionals dealing with diabetic patients should target issues of smoking, either avoidance and helping patients in quitting. And thank you. Hoping we will meet soon, but in Egypt. Thanks.
Dr. Tariq, very nice talk. My psychiatric colleagues reminding me to use the phrase tobacco use instead of smoking. What is your opinion? Continue to use the word smoking?
I don't understand. I don't listen well, please.
You can remove that. You can remove that.
Okay.
My psychiatry colleagues say, use the phrase tobacco use, not smoking. What is your opinion?
I think of smoking is hazardous regarding diabetic patients, all types, not tobacco smoking. I think all types of smoking are hazardous for diabetic patients.
The question is, instead of using smoking, you can use as tobacco use. That is most appropriate. So that when you're addressing the patient as a smoker, you can tell him as a tobacco usage rather than a smoker.
No, there are a lot of people,
They use chewing tobacco.
Actually, I don't recommend the patient to be dependent on nicotine replacement in spite of being dependent on smoking. He will be already dependent on this thing. Actually, I prefer my patients to be not dependent at all for anything rather than his will to stop smoking.
Dr. Sambit?
So, yeah, that was the wonderful talk, Dr. Thank you for the nice talk. I think we are going to
Dr. Prakash, anything to kind of sum up the talk?
Well described all of the smoking in development of diabetes and how can we avoid various cardiovascular and peripheral vascular disease component of it.
Actually, I don't.
Thank you, Dr. Tariq, for the wonderful topic. It's a different topic, smoking and diabetic. You did a justice for your talk. Thank you so much for being a part of our conference. Thank you, Dr. Sambit and Dr. Prakash, for chairing this session and being a part of the our conference.
For our inviting us.
Thank you, sir. Thank you. So moving on to the next session by Dr. Harish Kumar Darla from Mysore. He is my classmate, MBBS classmate. He practices diabetes and endocrinology in Mysore in his own Darla Health Center. To chair this session, we have got Dr. S.S. Daria. He's a consultant diabetologist from Jaipur. And we have got Dr. Ashna Patil, the young diabetologist from Mumbai. So over to Dr. Daria and Dr. Ashna for the further proceeding and chairing the session, please.
Thank you so much, Dr. Arvind Jagdisha sir, for giving me this opportunity to be involved in this large academic feast. I'm really thankful to you. And the topic regarding the immunization in adult, it's a need of hour because we are living in this COVID pandemic era. So without wasting much time, I'll request my co-chair, Dr. Patil, to introduce our speaker. Over to Dr. Patil.
Unmute yourself, Dr. Ashna, unmute yourself.
Yeah, hello. A very good evening to all esteemed international and national speakers and panelists present here today, and to also our lovely audience who has been with us both days. And at the outset, I would like to thank Dr. Arvinda sir for giving me this opportunity. Thank you so much, sir. It has truly been an academic feast so far. And as all good things come to an end, we are almost ending at the end of our summit with 4 more sessions to go. So not wasting time, I would like to introduce our speaker for today, Dr. Harish Kumar Darla from Mysuru. Sir is a visiting consultant at Apollo Hospital, Mysore. He has worked in UK for 5 years at various positions, and he has various publications and chapters to his credit, some of which are proteinuria secondary to hyperthyroidism, novel coronavirus, chapter in clinical updates on lifestyle medicine, chapter 6 in mind, body and spiritual health, integrating lifestyle interventions into clinical practice. He is a principal investigator in various clinical trials and also a member of various national and international bodies. And sir is an apt speaker at various state and national level conferences. So it is my great honor to invite Dr. Harish Kumar sir today to present the topic adult immunization in diabetes. Over to you, sir. Thank you.
Thank you, Chairperson. Hope I'm audible and visible also. Am I audible?
Yes, sir. Audible.
Yeah. Thank you. Thank you. Yeah. At the outset, I'll just share my screen. Okay. Yeah. So at the outset, let me thank Dr. Arvind, who's my classmate, for this wonderful extra. So it's very difficult to get the Doyen, 2 Padma Shris, and also my guru, Dr. Baswan Godappa, on this platform. And it is a great honor and privilege to share this platform with them. Now, Dr. Mohan has yesterday told that, Dr. Arvind has got everything in his agenda of A, B, C. Now, we have time and again heard about glycemic control, A1Cs, hypertension, dyslipidemia, a lot of new gadgets which has come also. But at least I have attended quite a few conferences, but I have never heard about adult vaccination, or maybe I was not present in one which was, this was presented. So this is, when we were discussing, we thought, no, we should be presenting adult vaccination, particularly confining to diabetes. Now, we all know that it is most cost effective and cost saving vaccination. If you give a vaccinated person can either be prevented from developing an infection, or at least the morbidity and mortality could be reduced to a greater extent. Also, a vaccination does it reduces the community spread. So it is very important for us to vaccinate all our patients, not only the children. So this is my disclosure. I don't have any conflict of interest. Now, my aim with this talk is to raise the awareness among our treating physician and general public is to prevent, reduce the morbidity and mortality and the spread of vaccine preventable diseases. And I'm going to specifically look into diabetic patients. Now, the vaccine word comes from Latin word, which is called vacca or cow, which was first discovered by Edward Jenner in 1796. So just I wanted to tell that vaccine is come from the word cow. Now, what does this pandemic has done? So this pandemic, we have seen that the admissions are come down, the investigations are come down, a lot of vaccination has come down. This is because of lockdown, lack of transportation, or fear of getting COVID. And a lot of people would go to over-the-counter medication. So this has done a lot of injustice to all our patients. Now, apart from that, what did the healthcare suffer? Yes, there was a lot of physical assault, there was psychological assault, and cyber attack as well. So we have gone through a lot and hope that we end this year with, we are going to end with mask, and probably next time we'll end with a mask and a vaccine. So there are two sides. This one has shown that there was an emphasis on 117 million children who would risk not getting measles vaccine during this pandemic. Now, again, there was a thought that this could lead to a pandemic of measles. Now, if you see, there is most concentration on children, but never has been spoken about an adult vaccination. So a coin has two sides, one who's for vaccine and one who's against vaccine. If you look at this gentleman, who's Robert F. Kennedy, a niece or a nephew of John F. Kennedy, who said that CDC is not an independent agency. And again, this gentleman, we all know who he is, and he says that if you take vaccine, and probably I know where he comes from, is it could lead to autism. These are against vaccination. But then we have a gentleman, the great gentleman Nelson Mandela, who says life or death for an young child too often depends on where he is born, in which country he is born, whether they have vaccines or not. And we all recognize this gentleman, Mr. Justin Trudeau, Canadian PM, who is for vaccine and says vaccine cause adult. So now just taking this point, is are vaccines only for children? No. One of us or your adult patient could be at a risk for vaccine preventable disease. It could be because of the age, the kind of job they do, the lifestyle they have, travel or health condition. And India in the last 3 decades has come a long way in childhood vaccination. Obviously, we are going strong with childhood vaccination, but looking at adult vaccination, the coverage is very negligible, both in disease or in a healthy person. So our best shot is the importance of adult vaccination is very, very important for us. So we are going to look at the data from United States, what happened in the previous century and in 21st century. So we are going to look at vaccine preventable diseases, whether they had come down or not. And if you see, we had completely eradicated the first disease to be eradicated by vaccine was smallpox. So in 20th century and in 2011, you see there are 0 cases, diphtheria, 0 cases, paralytic polio, 0 cases. So, and all the other diseases have already come down by more than 90%. So this is the effect of a proper immunization schedule in infant and childhood immunization program. So what you can achieve if you have a proper program in place. So what are the reasons, what are the compelling reasons for us to vaccinate an adult, and why should we be vaccinating? I mean, a person can tell that he's got all the vaccination done as a child, and why should he or she get vaccinated as an adult? Now, we know that the protection from childhood vaccines would wean off over time, and most importantly, you have diphtheria, tetanus, and pertussis, where the protection would wean off over a period of time, and in adults, we give acellular pertussis. Or it could be virus and bacteria changing over a period of time. And if you take a classical example of influenza, if you take 1918 Spanish flu, and until today where we have COVID, the lot is changed in the viruses and particularly influenza. That is the very reason why we'll have to vaccinate our patients with influenza vaccine every year. Now, again, as we get older, our immune system weakens. So older patients are more at a risk of influenza and pneumococcus. Then adults with chronic condition, and we are specifically going to target diabetes or immunocompromised condition such as HIV, AIDS, or patients who are on chemotherapy agents or chronic steroid. They all are immunocompromised agents, and they are more prone to develop shingles, pneumococcus, or influenza. And adults, it's not necessarily that only the children can infect adults, but adults who are unvaccinated and developed either mumps or pertussis, they can infect infants who are not fully immunized. Again, when we look at what are the death and hospitalization rate because of vaccine preventable disease, and again, particularly looking at the data from the United States, each year there are about 2.5 lakh people who are hospitalized because of influenza, and almost 3,000 to almost 49,000 people die because of influenza or its complication. And this is a major factor which can be prevented. When you look at pneumococcal infection, around 32,000 cases have been reported with invasive pneumococcal disease. Now, not all pneumococcal infections are called invasive pneumococcal disease. Somebody who's developed meningitis, or there you can isolate pneumococcal or streptococcal pneumonia, septicemia, or if you can isolate the organisms from peritoneum, pleural fluid, deep-seated abscess, these are called invasive pneumococcal pneumonia. And again, there are about 3,300 deaths because of pneumococcal pneumonia or invasive pneumococcal disease. About 8 lakh to 14 lakh people suffer from chronic hepatitis, again, which is preventable because, with a vaccine, and around 2,000 to 4,000 people die in the United States because of either cirrhosis, liver cancer. And about 1 million people get shingles, and it has a lot of morbidity more than mortality. If you look at the global data, because of streptococcal pneumonia, in 2016, there were about 23.8 lakh deaths all over the world, and of which 50% was because of streptococcal pneumonia. And in that, almost 11.9 lakhs, about 6 to 8 lakhs died because of invasive pneumococcal disease, and this is a preventable cause. Now, we all know that diabetic patients are risk for respiratory infection. If you look, they are 6 times more higher risk of getting hospitalized during a flu pandemic, and 3 times more likely to die because of pneumonia in a flu. And if you look among diabetic, the death rate is about 5 to 15% during a flu pandemic. And case fatality rate because of flu is around 12%, but because of pneumococcal infection, it is about 21 to 36% death in a diabetic patient if they get infected. So why is protecting our adult diabetic patient from vaccine preventable disease such as pneumococcus or influenza? Now, what are the place in the health system is, if you look at the cost, there's about $8.7 billion which has been spent either direct or indirect on influenza treatment in US. For pneumococcal infection, almost about $3 billion and $2.5 billion for the work loss and death and disability. So it is a huge impact on our health system and on the GDP of a country. For hepatitis B, they spend around 700 million on the complications. And shingles, though the per admission cost is low, about 3,500 to 7,000, but the morbidity is very high. So these are all the economical factors which has an impact on the GDP of a country as well. I mean, these data, we have got it from US, but I'm sure it is much more in India. So why do we need a vaccine? Whenever we look at a vaccine, it should be cost effective and it should save cost also. So whether a pneumococcal polysaccharide vaccine does that, preventing invasive pneumococcal disease, yes, this study has shown that if you are going to vaccinate, you are having both cost saving and cost effectiveness. you can save a lot of amount, as I've showed you, the morbidity and mortality, and the amount which is spent on patients who have not been vaccinated with the disease process. Just by giving a vaccine, you can prevent that. And this study was done in 11 countries across Europe and US. So what are the bottlenecks? I mean, why does that we don't immunize our adult patient? So there are limited perception. There is an inertia from the physician and from the patient's point of view as, oh, is it that I'm going to develop a serious infection because of pneumococcus or influenza? So there is a limited perception from the physician's point of view. And again, when somebody says that I have already lived for 60 years, why should I take a vaccine? Whether it is safe for me to take or is it effective? And then adult immunization is not universal, it is very selective. Each country has their own immunization schedule. And again, to get a healthy volunteer, to any adult to have a vaccine done, it is very difficult to convince them. And particularly in India, where a patient has to pay from his pocket, already suffering with diabetes and on polypharmacy and less income, probably corona is taken away and a lot of things from them. Again, to vaccinate them is very difficult for us. Now, what are the major reasons why somebody would not?
Harish, unmute yourself. Harish, unmute yourself. Unmute yourself.
I'm so sorry. I'm so sorry.
Okay. Yeah.
The reasons for inadequate immunization is lack of funds. So as I'm telling us, this is not something which has to be taken every day. There are only very simple schedules which are available, which has to be given. So if we can convince our patient, they would be able to take it, but then we need to spend an extra minute with them to convince them to take this vaccine. So this is a schedule from CDC, 2000 United States. I mean, there are a lot of vaccines which are given in adults, but I'm going to confine myself to influenza, pneumococcus vaccine, and hepatitis B. So there is a government organization, CDC, which looks at vaccination of all the adults in, at a risk, or all the adults, healthy adults more than 65 years, who needs to get vaccinated in US. And again, in Canada, you have Immunize Canada, which also looks at those things. But in India, the need for adult vaccination and the importance of vaccination for high-risk group, who are at a high risk. Now, if you look, any elderly patient, I don't know whether 50 years is called elderly or not now, but anybody who's more than 50 years, whether they have a morbidity or not, whether they are diabetic or not, they are at a high risk of developing pneumonia because of pneumococcal or developing influenza. Any individual between the years of 19 to 64 with comorbidities such as diabetes, asthma, COPD, heart, liver disease, or alcoholism, they need to be vaccinated with condition that weakens immune system, as I've told you, HIV, cancer, or immunotherapy, or if they have asplenia or probably splenectomy done for various reasons, and with cochlear implant or cerebrospinal fluid. And especially the last talk we had is about smoking cigarette. Somebody who smokes are also at a high risk of developing pneumococcal infection and influenza. If you look, community acquired pneumonia is the second most common reason for death from infectious disease. Yesterday, Dr. Bajaj has already told that tuberculosis is one of the top reasons of death in India because of infectious disease. Community acquired pneumonia comes second. Out of all that, 36% isolate from community acquired pneumonia is streptococcal pneumonia from Shimla. And about 40% of all community acquired pneumonia have invasive disease due to streptococcus. So this is a huge problem we have got in India, and we need to tackle it. And the best way to tackle is to vaccinate them. Now, if you look at invasive pneumococcal disease in adults, diabetic are 3 times more prone, but surprisingly, chronic heart disease and lung disease are 6 times more prone to develop invasive pneumococcal disease. Alcoholism, again, it says that chronic alcoholic are 11 times more prone to develop invasive pneumococcal disease. And then with cancers, they are almost 23 to 48% more risk. And this is a study which was done in India, where they have taken 1,000 plus adult subjects who presented with fever or invasive bacterial infection. When they isolated, they could find that 40% of them had streptococcal pneumonia been isolated in invasive as an invasive pneumococcal disease. So that's a huge amount. It's only about 60%. All the other things such as influenza, others and non-pathogens are seen, but majority they have streptococcal pneumonia. And if you look at the risk factors, diabetes scores very high. Somebody who's diabetic is more prone. And when you look at invasive pneumococcal disease, the death case fatality rate anywhere between 20 to 37 in these patients. So what are the recent articles about adult immunization and why should we be doing? As I told you, if you vaccinate, you can prevent the health complications because of those diseases. And even again, it is very important that you just don't start them on vaccination, but you have to adequately vaccinate them. And incomplete vaccination can again lead to both hospitalization and unnecessary costs. WHO, UNICEF, you take any organization, even in India, the first priority is given to childhood vaccination. There is no focus yet on adult immunization. Adult immunization in India is the most ignored part of healthcare services. And again, it is least emphasized in our daily practice who practices diabetes. So what are the recommendations for pneumococcal vaccination in adults? Now we have both global and Indian data, which we are going to see it. Now, if you look at this advisory committee of infectious practice in November 2019, it is very, very simple. Anybody who's diabetic more than age 19 to 64, they should get a polyvalent pneumococcal vaccine, 1 dose. And once they become more than 65 years old, they have to get a 2nd dose. So a polyvalent pneumococcal vaccine is given only twice if the age of the patient is less than 65. And if the patient is more than 65, it is only 1 dose which is given. So by that way, you can prevent a lot of invasive pneumococcal disease. And if you look at the Diabetic Care or ADA 2020 guidelines, this also says that all the diabetic patients, whether type 1 or type 2, but here if you look at the younger ages, 2 years and above, up to 64 years, they should receive a pneumococcal polysaccharide vaccine, 23 valent. Now, what does this 23 valent means is there are 23 serotypes of pneumococcal bacteria in this vaccine. There are about 90 serotypes, of which these 23 contribute to around 80% of invasive pneumococcal disease. So that is why this vaccine is given. And there is another one, pneumococcal conjugated vaccine 13, which has 13 serotypes, but is mostly advisable in patients less than 2 years old. And if they are more than 65 years, regardless of their vaccination history, they should get the vaccination again after the age of 65 years. If you look at influenza, just because there is change in all the influenza viruses every year, so you have to target that particular year vaccine, and it has to be annually vaccinated to all the patients more than 6 months old. Hepatitis B, as we know, we have either 2 or 3 doses which should be given, and if they are unvaccinated and more than 60 years, you have to give them 3-dose series should be given for hepatitis B vaccine. So again, this is the same thing with ADA is 19 to 64, 1 dose, and more than 65 years, another dose of pneumococcal vaccine should be given. And coming to the Indian data with RSSDI and Endocrine Society of India, again, they recommend that any diabetic more than 2 years old up to 64 should receive a polyvalent pneumococcal vaccine, 23, and immaterial of when they have received the first dose, if the patient becomes more than 65 years, they have to receive a 2nd dose of pneumococcal vaccine. And when you look at Geriatric Society of India, again, the recommendation is very similar to RSSDI and ESI. Now, with this prevailing COVID situations, everybody would be worried as whether I immunize my patient with pneumococcal vaccine or influenza. If you look at WHO, National Foundation on Infectious Disease, or American College of Cardiology, they all say that your diabetic patient should be up to date with their vaccines, both for influenza and for pneumococcal. So despite strong recommendations, still adult immunization remains quite low. Now, how low is low? Again, if you look at an Indian data from Sher Kashmir, from Kashmir, they have seen that there are only about 10% or less than 10% who are vaccinated for both influenza and pneumococcus. So that is dismally very, very less. I mean, it is which is available in our backyard, but we are not using. But we are looking at gadgets which would look at time in range and other things. But this is as important as looking at time in range or maybe having gadgets put in continuous glucose monitoring. But this is as important as that which we'll have to emphasize. And again, if the patient is not receiving adequate vaccine or on time, the chances of them getting invasive pneumococcal disease is very high. US data shows that 92% who have not received their vaccine or missed a vaccine could be more prone to develop invasive pneumococcal disease. So adequate vaccination and proper completion of course is also as important as starting it. So how do we improve our adult vaccination? Is standing orders. When you say standing orders, is at least you have to have a standing orders in your own organization that somebody who's a senior nursing staff or somebody who's a pharmacist can give vaccine based on their risk. So you should have a standing orders for each institution. Chart reminders have an immunization card which you can be given to the patient, and one can be kept in the patient's record to know when he or she has had their immunization. Computerized record, again, all have HIMS, so we can know when the last vaccine was taken and we can remind them, probably by a mail or telephone reminders or WhatsApp. And patient education is paramount because most of these patients are already burdened with polypharmacy and a lot of expenditure. So on top of that, having a vaccine is still much more going to tax their pocket. So this is what I was telling is standardized standing orders is authorize your nurse or pharmacist to administer vaccine. And who are the most who can influence their patient to take immunization? And it is us as a personal physician or primary physician or the family physician is who can influence adults to take those vaccines. It is not even a public figure. It might not be even Amitabh Bachchan or somebody who's going to influence them taking. But yes, we treat, a lot of people treat our actors as gods, so probably even they might be useful there. And I just got a few cards from CMC Vellore, which says about adult vaccination. This is from Apollo about a vaccination card. And Dr. Mohan's, I'm sure there are a lot of other centers which also uses this, but these are the ones which I got. So I'm just showing it here. So my take-home message is, we have to display banners, posters, or audiovisual media to encourage adult vaccination. Treating physicians should give more emphasis on vaccination to discuss the pros and cons and why he or she should take their vaccine. Make it as a part of your treatment protocol. I'm sure we all do, as for example, as retinal screening. We all tell them that every year you have to get the retinal screening unless and unless there's a problem. So again, we have to make it as a treatment protocol. Reminders to the patient through various media, could be WhatsApp, could be email, could be a telephonic call, just to tell them that they are due for the vaccine. And treating physicians should make sure that all patients receive a complete vaccination. And what do I expect from our government, or what do we expect from our government, is at least a lot more funds for adult vaccination program. Make vaccination cheaper and probably, in a government setup, give it free of cost, which is done for children. Subsidized rate of vaccination, either you give some tax concession because most of them are imported, or make it as an essential product where the rates will come down. To create awareness on all platforms, maybe audio, visual media, where they can create with public figures, and you can have a public-private group models or NGOs. We have to target risk patients. So here I would suggest is prevention is better than cure. Leaving with this gentleman, I'm sure everybody recognizes him. He's the Southern superstar Rajnikant. मैं किसी काम में उतरा गया तो पूरा किए बगैर नहीं छोड़ता और नहीं होना वाला काम लेता ही नहीं. So this is achievable, this is doable. As Dr. Shashank Joshi did tell that we are going to get over even diabetes, cure diabetes. So I'm sure this is what we have right now. Curing diabetes is still a long-term goal, but this is what we have in our backyard. So please use it and use it efficiently. Thank you so much.
Thank you so much, Dr. Harish Kumar, for a nice presentation. As you said that adult immunization is much needed in this pandemic era. It's almost, there is a child vaccination, and in geriatric population, there is already advocacy for the vaccination is there for your influenza and for that. But it's a really we should include in our history also. There is a there should be a one asking about the vaccination. If somebody has already got vaccinated in childhood, then still we should ask about the vaccination in our history part when we are treating the patients. So congratulations for nice presentation.
Thank you, sir.
Yes, Dr. Harish, that was a good innovative topic. Actually, as you mentioned in your talk in the beginning, say the immunization is one thing where always immunization is thought it is because for the children. So when it comes to adult immunization, I'm sure all of us, during this, especially during this tough corona pandemics, everybody is asking about immunization. Even the adults are aware of immunization and they keep asking about this thing. Your talk made it very useful, I'm sure, for all the doctors, for all the audience here, are enlightened by your talk. Thank you so much. Thank you. Any questions is there? Dr. Ashna, you want to ask?
I'll ask Harish. You presented a very nice picture of vaccination in India. We did a study in our state and we found that only 20% of people, diabetic population have received the vaccination, and we did write that paper to PMO also. So do you think government should take up and at least vaccinate for these two vaccine, influenza and pneumococcal, even before they could find out an answer for COVID?
I think Dr. Subhash, that's rightly said, and I did show you that government should take up, because adult vaccination is least looked upon. I mean, as I presented, that 9% was who were vaccinated, but there's another study which says that it is less than 2% who have been vaccinated. So we have to target, because the cost after somebody gets the disease is too high and the morbidity and mortality is too high. So government should take up, at least in government sector or government or somebody below the poverty line or whoever it is.
I think some network issue, Harish?
Should at least get free of cost. Somebody who can afford. Yeah, hello. Can you hear me?
Yeah.
Can you hear me? Hello.
Yeah.
So that's what I'm telling is government should take it up and take it up seriously.
Yeah. I think Arvind has to write a letter to PMO, because he has the holding a position now that he can influence government as well. Because we tried at our level writing from RSSDI Bihar chapter, as well as my own study, which we forwarded to the PMO, especially quoting that our 80% high risk population are not vaccinated, and you have a huge fund at least for safety of these people now. So before that vaccine, you at least give this vaccine to have some protection for these poor people. Thank you.
Thank you.
Dr. Shekhar, any words, sir?
Oh, I'm admiring the handsomeness of these two people, Harish and Arvind. But the passion with which Dr. Harish spoke, it speaks volumes, because you look at cost effectiveness, you look at benefit risk ratio, you look at morbidity and mortality, nothing can come near a vaccination. No drug can match a vaccination. Kudos, Harish. Thank you.
Thank you, sir. Thank you so much, sir. Yeah.
Thank you, Dr. Harish, for the wonderful talk. So thanks for anybody. Vishwanath, you want to
thank you so much, Harish. And I think, thank you, sir. It's important talk.
Thanks, Dr. S.S. Daria and Dr. Ashna Patel for chairing this session and being a part of our conference. Thank you so much.
It was a great pleasure to be with you. Thank you so much, sir. Thank you, everyone.
Thank you.
So I think we move on to the next topic by the man himself on Inspire study. He's going to talk, who has been inspirational, and I have to welcome him. I request two chairperson, Dr. Mahiya Sikdar from the Bardhaman district of Bengal, and Dr. Sukrit Prakash from the city of Patna to chair the next session. It's on the Inspire study, and the speaker
Thank you,
is
sir.
Yeah, please, sir.
Yeah.
I request the
Thank you so
chairperson
much,
to
sir. Thank you. Thank you so much, sir, for inviting us as a chairperson in your esteemed meeting. And we have to introduce Dr. Aravinda Jagadisa, who is the organizer himself.
I'll go to
He
the top
doesn't need any
directly.
introduction. So, and also I want to congratulate him for organizing for this successful meeting for last 2 days. We are hearing all across the globe, we are hearing different speakers and also across the country. So I also invite Dr. Prakash to just say one few words for Dr. Aravinda.
Thank you, Dr. Arvind sir, for making this conference very wonderful and extraordinary level. And we learn a lot from you. And by every speaker, the conference is getting even higher in class. And education-wise, also it is very good. Thank you very much. And I congratulate you from my heart that you have made this conference very wonderful. Thank you, sir.
Thank you. Thank you so much. Okay, I'll go to the presentation. Are you able to see my slides?
No, not yet. Not yet.
Not yet.
Now?
Are you able to see my slide?
Not yet. So.
Okay.
It's not seen. It's not seen.
1 second. I think now you can be able to see my slide.
Yes, yes.
So good evening, everybody. The last but few talks. I'm sure everybody will be waiting for the next talk by Dr. Deepak Jumani. I'm sure you'll all enjoy that session as well. My topic is on this particular study, INSPIRE study, Indian real world evidence on remogliflozin. So this is one of the talk where you can come across, because since yesterday we are discussing about SGLT2 inhibitors, DPP4 inhibitors, and various other aspects of diabetes. So till now we had this very economical SGLT2 inhibitors, remogliflozin in our armamentarium. I would always used to tell remogliflozin as the poor man's SGLT2 inhibitors, especially in our country. So what are the real world evidences? Is there any real world evidence with regards to remogliflozin? Is there any study? Yes, there is one study, that is INSPIRE study, which was recently published. That is what I am going to discuss now. So SGLT2 inhibitors, a class of drugs, have provided with promising armamentarium in type 2 diabetes management. Starting from left side, you can see way back from 2015, starting from EMPA-REG study, then came the CVD real study, then in 2017, CANVAS study and CANVAS-R study, then the CVD real 2 study, DECLARE-TIMI, CREDENCE study, this year, DAPA heart failure and EMPEROR reduced. All these studies have been, if you see, from past 5 years, the SGLT2 inhibitors is making a big news and is one of the wonder drugs in the treatment of diabetes. If you see the cardiorenal effects of SGLT2 inhibitors, can potentially address the distinct profile of Indian type 2 diabetes. If you see starting from top, on the left hand side, you can see because of the SGLT2 inhibition, that leads to a glycosuria. Glycosuria ultimately leads to negative caloric balance, leading to decreased inflammation, and it reduces the HbA1c, decreases inflammation and glucose toxicity. It causes increased uricosuriya, leading on to decreased plasma uric acid, leading on to decreased atherosclerosis and cardiac renal protections. On the right hand side, you can see because of the natriuretic effect, there is a decrease in blood pressure, decreased arterial stiffness, and second point, you can see increased tubuloglomerular feedback occurs and afferent arterial constriction, resulting in decrease in intraglamerular hypertension and decrease in hyperfiltration, leading on to cardiac renal production. On the extreme right, you can see the decreased plasma volume decreases myocardial stretch, decreases ventricular arrhythmia, activation of ACE2, and ultimately leading to cardiac and renal protection. So you can expect 0.7 to 0.9% reduction in the HbA1c, 2 to 4 kg weight reduction. Most important is the visceral fat loss is seen. Systolic blood pressure of reduction of 3 to 5 millimeters of mercury, diastolic blood pressure reduction of 2 to 3 millimeters of mercury. So it decreases in the interstitial volume. So remogliflozin is the most recent addition to this class available to Indians. Like we know that Cana, EMPA, and DAPA is there in the market. Now the latest addition in the last 1 year is remogliflozin. So we are going to talk about the phase 3 studies and the real world experience. So if you see the developmental program of remogliflozin, starting from 2017, you can see there is various studies like dose finding and PK studies, drug interaction studies, formulation studies, specialized studies, special studies. It's all in phase 1 study. That is 22 studies were done in phase 1. Then the phase 2 studies, there the 800 patients were recruited was done. Then the phase 3 study, 900 patients were recruited. So in 2019, there is a development study in Indian population. That is the phase 3 study. That is a pivotal study. So early development as per the US FDA requirements, while late development as per CDS code guidelines. So pivotal registration phase 3 trial was robustly designed study. You can see the treatment allocation, blinding, double blind and double dummy study, and you can see the sample size. The comparator most important was the DAPA 10 milligrams OD. The study site, like 58 sites across India were involved in this study. So you can see the HbA1c reduction at 24 weeks. So DAPA is the blue one, the Remo is the red one. You can see the HbA1c reduction at 24 weeks was 0.58 to 0.72, and FBG reduction nearly 20 milligrams. And at week 24, you can see that random blood sugar of 32 to 39. So what is it? What that this say is remogliflozin 100 milligrams was found to be non-inferior to DAPA 10 milligrams. So comparable to side effects, you can see the side effects profile here. Almost the side effects were matchable in both of them. However, there are few male UTIs were a bit more in remogliflozin when compared to dapagliflozin. Otherwise, other parameters were equally matched with dapagliflozin. So post-marketing development, you can see 4 clinical studies in India, more than 11,000 subjects. It's a real-world assessment forming large database of evidence with any SGLT2 inhibitors in India. So INSPIRE is the real-world experience in clinical practice. What does INSPIRE stand for? Indian type 2 diabetes patients of remogliflozin safety and effectiveness, a real-world experience study. This is the methodology. So any Indian, what is the selection criteria is any Indian adult type 2 diabetes patients on remogliflozin based regime as per routine practice with 3 months follow-up completed. Data of eligible patients was retrospectively captured and analyzed. So you can see remogliflozin was put across almost all the drugs like available. Like it is used with along with the metformin alone, metformin sulfonylurea with DPP4 inhibitors, with glitazones, with alpha glucosidase inhibitors, all the parameters in various parameters of diabetes armamentarium, these drugs were used. The most commonly used was after metformin and sulfonylurea, the remogliflozin was tried in this study. So if you see the glycemic parameters, so you can see the baseline, compared to the baseline, if you see after 3 months, the HbA1c reduction of 0.95, fasting plasma glucose reduction of 42, postprandial glucose reduction of 69. Metabolic parameters, there was 2.6 weight reduction in 3 months, body mass reduction of 1, blood pressure, systolic blood pressure of reduction of 3.3, diastolic blood pressure reduction of 2.3. So subgroup analysis also shows in the various, you can see in this chart, if you see these HbA1c subgroups as well as the body mass index subgroups in the various HbA1c like 8 less than 8.5, 8.5 to 10, and HbA1c of more than 10, you can see the reduction of HbA1c. In the when regards to body mass index as well, less than 25, between 25 to 30, and more than 30, you can see the efficacy of remogliflozin. Subgroup continuously, you can see the HbA1c reduction of point in the various parameters of HbA1c. You can see that on the left hand side, when the HbA1c is less than 8.5, you can see the reduction of HbA1c, fasting plasma glucose, postprandial glucose, as well as the weight. In the middle, you can see when the HbA1c between 8.5 to 10%, that is at the baseline, you can see the good reduction of all the parameters. On the right hand side, you can see HbA1c of more than 10, you can see a very good reduction of HbA1c, fasting glucose, as well as postprandial glucose and the weight. This is the body mass index. Once again, in all these three subgroup analyses, the efficacy of remogliflozin was seen. Coming to the adverse effects, adverse events, not like like any other SGLT2 inhibitors, there were genitourinary tract infection, which was noted in 12.5%. Other parameters like adverse effects like acidity, body pain, bowel disturbances were noted. You can see the laboratory parameters, not much of significance things are noted. When it comes to electrolyte concentration, whether it may be sodium, potassium, calcium, or chloride, not much difference was changed when compared to the baseline. So equivalent effectiveness versus other SGLT2 inhibitors. Coming to the other study, that is SGLT2 inhibitors real world evidence. When it comes to forefront study with dapagliflozin, real world evidence with canagliflozin, real world evidence with empagliflozin. So you can see the remogliflozin equally giving the competition with a reduction of 0.95%. So equivalent efficacy when switch over from any SGLT2 inhibitor. This is another question commonly asked, isn't it? If the patient is not affordable, if the patient is not affordable expensive SGLT2 inhibitors, whether they can be changed to this remogliflozin, is there any scientific data? This one study explains that. So you can see in this study equivalent efficacy when switched over from any SGLT2 inhibitors. This was the selection criteria like adult type 2 diabetes on dual therapy with metformin plus any other SGLT2 inhibitors for at least 6 months. They were changed to remogliflozin. You can see the efficacy parameters of with regards to HbA1c, fasting plasma glucose, postprandial glucose, weight, and body mass index. Safety parameters: no hypoglycemia, no unusual adverse events. Incidence of UTI and GTI was comparable with the other SGLT2 inhibitors. Another robust reduction observed in the clinical practice. You can see this remogliflozin in Indian type 2 diabetes patients, a real world study. Once again, you can see that reduction in HbA1c of 1.3%, fasting sugar of 17, postprandial sugar of 56, reduction, and weight of 4.2 kg reduction after 6 months of treatment. A robust reduction was observed in the clinical practice. So this is the comparison of switchover. This was presented in ADA 80th scientific session. This was the once again the parameters were seen with good reduction of HbA1c. What does this study says is remogliflozin is equally comparable with other SGLT2 inhibitors like DAPA, EMPA, or CANA. So this is the EMBRACE study, the similar effectiveness in the individual clinical real world studies. Once again, you can see what I'm showing is all the 3 studies which was published recently in ADA and endocrinology conferences which shows the effectiveness of rimogliflozin is comparable to dapagliflozin or empagliflozin or canagliflozin. It's always a question asked whether whether this rimogliflozin have a long-term clinical data. That is always a question asked. So recent studies have shown the beneficial which are comparable to other SGLT2 inhibitors. You can see in this study as well, the reduction of HbA1c, systolic blood pressure, diastolic blood pressure, and weight gain, weight reduction, all comparable to the other SGLT2 inhibitors. This is another article published, a comparison of rimogliflozin and canagliflozin as an add-on therapy in Indian uncontrolled type 2 diabetes. Once again, here remo was compared with canagliflozin. You can see the comparison, almost rimogliflozin comparison with canagliflozin with regards to HbA1c, fasting sugar, postprandial sugar, maintenance of HbA1c less than 7, and body weight reduction. The rimogliflozin was equally comparable to canagliflozin. So when it comes to reducing microalbuminuria in individual patients, in patients with microalbuminuria, randomized to rimogliflozin or metformin, significant reduction in albuminuria compared to placebo was noted in this particular study. So key pointers to rimogliflozin continuum is rimogliflozin had been demonstrated to be efficacious and safety agent for type 2 diabetes in phase 3 clinical trial equivalent to currently established SGLT2 inhibitors. Real world evidence of rimogliflozin reinforces effectiveness in both glycemic and non-glycemic parameters with no major safety concerns in both large real-world studies as well as investigator-initiated research studies, again equivalent to current available SGLT2 inhibitors. Remo has a large evidence base available and planned in exclusively Indian patients. So when cost is a major determinant in clinical practice, even you can see the ADA ESD guidelines, they have stored on the bottom you can see, which is marked in red, SGLT2 inhibitors with lowest acquisition cost can be used. That is the ADA ESD guidelines as showed. So thank you for your patience hearing. Only thing I want to conclude by saying is the rimogliflozin is equally comparable to other SGLT2 inhibitors. However, the long-term cardiovascular data is lacking in that, but it has been comparatively, what I've shown is comparative study with other SGLT2 inhibitors like canagliflozin, dapagliflozin, empagliflozin, the equal efficacy has been observed. But now the challenge for the rimogliflozin is the DAPA cost has come down now. There will be a tough competition for rimogliflozin. However, the what I have shown in this study, that is especially the INSPIRE study, there is a evidence to say that the rimogliflozin equally matches with dapagliflozin. Thank you. Thank you for your patience hearing. Over to the chairperson for further proceeding.
Thank you so much. Thank you so much, sir. It was a wonderful lecture. Actually, surely rimogliflozin is taking Indian market because of not only because of the efficacy, but also the other advantages like PP reduction, weight reduction. But one thing in my practice, I have seen a few very little percentage of my patients on rimogliflozin complaints of sleep disturbance at night. But could it be due to its twice daily dosing or something else? Yet we need to know. I just ask to this August faculty list, do you guys have also have similar experience?
No, rimogliflozin, see, basically it's a BD dosage. If you put it as a OD dosage, it may not be effective because of its short half-life. It has to be used twice a day. If you're telling sleep disturbance because of urination, that is a possibility. Because any SGLT2 inhibitors, if you noticed, they have this increased urination. That is also poikiluria. You say it as poikiluria is repeated passage of small quantity of urine. So that may be a initial symptoms till the patient gets adjusted to this molecule. Once the patients are used to this molecule, definitely they will continue this drug.
Okay. Thank you, sir.
One more comment, Arvind.
Yes.
Some of the patients with remogliflozin had diarrhea, frequent diarrhea and all, which is not seen with other SGLT2 inhibitors. Your comment on that?
Yeah, few patients, yes, it has been seen diarrhea. That now, if I see in my presentation in that study also, there was few adverse events seen as the GI side effects. Even in CANA, EMPA, and DAPA also GI side effect was noted. But it is one of patient. It is may not be statistically significant in the study as shown in the studies. But commonly seen side effect is the genitourinary infection, especially with remo. What in that study, INSPIRE study, was shown little bit of male urinary tract infection was more compared to the dapagliflozin. However, we can expect our patient to have a urinary tract infection with any SGLT2 inhibitors because of the glycosuria.
I just have a comment, Dr. Arvind.
Yeah.
Now, regarding SGLT2 inhibitors in the evening hours, I would rather prefer it taking a little early in the evening, so that at least if they have to pass urine, they finish it by about 8, 9 o'clock or 10 o'clock. So they have a good night's sleep. And regarding the diarrhea part, yes, canagliflozin at 300 milligrams has shown to have an effect on the SGLT2 inhibitors in the proximal intestine. And it might act as same as oglipose. So you can have some patients having diarrhea with higher dose of canagliflozin, and it is noted.
But only with 300 milligrams of canagliflozin.
Yes, yeah.
At that time, it says it is because if you see canagliflozin, it has a dual blockage effect compared to other things.
Correct.
Here there is a dual blockage of SGLT2 inhibitor transiently in the intestine.
Correct.
That may result in diarrhea.
Correct. Yeah. That's only seen in higher dose of canagliflozin.
Yes, yes.
One supplement here. When I was looking into these glyphosins, which have become a superhero concept in diabetes management, I was just looking at any X factor in these things. I was surprised to see one paper which states, it's a hepatology paper of NAFLD and glyphosins. Remogliflozin, compared to CANA and DAPA, has a very significant antioxidant activity. I will share the reference with you people. It was surprising. In mouse models, in NAFLD and whatever insulin resistant component they were looking at, remogliflozin showed significant amount of antioxidant activity vis-a-vis CANA and DAPA. It has not been seen in real world. I don't know. Maybe they should work on it. Very nice, Dr. Arvind. Very nice.
Thank you, sir.
Thank you very much, Dr. Arvind sir, for enlightening us regarding the remogliflozin. Thank you very much.
Thank you, sir, Dr. Sukrit and Dr. Dr. Mohuya Sikidar. I think your network is a problem. Dr.
Thank you for.
Yeah.
Yes.
Yeah.
Yes.
Thank you, Dr. Mohuya and
Thank you for having us, sir. Thank you.
Thank you, Sukrit, for sharing this session. Thank you so much for being a part of the conference. Thank you. Now, moving on to the next session is from none other than Dr. Deepak Jumani. So it's a much awaited talk from all the faculties across India. So he'll be talking on an interesting topic, that is erectile dysfunction is the correctile dysfunction. To chair this session, we have Dr. Abhyuday Verma, the consultant endocrinologist from Indore, and Dr. Swaraj Vardhanakeri is an young upcoming diabetologist from Gulbarga. So over to Dr. Swaraj and Dr. Abhyuday for the further proceeding, please.
Thank you, Dr. Arvinda. Good evening, everybody. And I think, as rightly told, this is much awaited topic to be discussed. Real topic by a stalwart in this field, Dr. Deepak sir, a very well-known person in this field, and I think definitely today we would be learning a lot of things from Dr. Jumani regarding the erectile dysfunction and whether this is a correctable dysfunction, and correction of this would be able to do justice to the erectile problem, or maybe it may help in correcting the cardiovascular diseases also. We would be seeing in our sir's presentation. So without wasting much of time, I invite Dr. Deepak Jumani sir to kindly deliver the lecture.
Thank you, sir. Thank you for that wonderful, sexy introduction. I also thank Dr. Arvinda for inviting me here and giving me an opportunity to share my thoughts, views, concepts, and passion. Let me tell you at the start of my talk that our body is a reflection of our lifestyle. Our bodies are gardens, and our wills and our choices are our gardeners. So it depends upon what we do to our body and what we put in our body. That is what is important. Sex is not a matter of life and death, but yes, it does affect our self-esteem, our confidence, and the zest of life, and of course, interpersonal relationships. A healthy sex life is not a preserve for people who are 20, in 20s or 30s. Of course, sex at any age is beautiful. We should understand one thing, that sex is the most important part of the quality of life which we all deserve. In this next 20 minutes, I'll give you some nuggets of wisdom as to how men suffer in their bedroom because of this one common sexual dysfunction, which is the erectile dysfunction.
Gururvishnu Gurudevo Maheshwara Gurur Sakshat Parabrahma Tasmai Shri Guruve Namaha.
I thank my teachers and I beseech them to bless me always. When I met Dr. PM Modi, look at his hands are down. He said, I have offered GST and of course lockdown for your benefit. Then he told me, you also offered something. So what today I'm going to offer is, I'm going to offer my GST. And my GST to all of you is great sex therapy. And of course, I would always like you all to look down and enjoy this great sex therapy. When we look at the history, erectile dysfunction is not unknown. Way back in 2000 BC, Egyptian papyrus also found out that difficulty in erection was all because of some supernatural evil charms and spells. Hippocrates also found out that it was because of excessive horseback riding. Aristotle felt that it was nothing but influx of air which failed. Then Leonardo Vinci, who was a very good painter, he found that the patients who were hanged to death, they had their penises erected and the blood was leaking out of it. But it was Ambrose Pare who wrote books on reproduction. And look at what he says, that when a man becomes inflamed with lust and desire, blood rushes into the male member and causes it to become erect. So the real understanding was given to us by Ambrose Pare way back in 1590. Today, DSM-5 criteria tells us that most of the experience of having difficulty in attaining erection or maintaining erection until completion of sexual activity for at least 6 months with significant distress can be attributed without any mental disorder, can be defined as erectile dysfunction. Erectile dysfunction affects 50% of male population across the globe over 40. When I Googled, I found Viagra had 196 million web pages and aspirin had only 53 million web pages. Love is a matter of chemistry, friends, and sex is a matter of physics. But yes, science of intimacy is both chemistry and physics. Now let me give you a little deeper perspective of erectile dysfunctions. This is a schematic diagram of an endothelium and the penile vasculature and the penile muscles. This endothelial cell produces endothelial nitric oxide synthetase, which potentiates the nitric oxide, which is the main chemical signaling molecule, to enter into the corpora cavernosa smooth muscle cell and convert GTP into cyclic GMP with the help of an enzyme called guanylyl cyclase. This cyclic GMP, through various mechanisms, relaxes the smooth muscles and allows the blood to flow inside the penis. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5. So if we look at erection, a good erection, what does a man need? Basically, he needs good endothelial nitric oxide synthetase, which means he needs a normal endothelium. He needs nitric oxide, he needs guanylyl cyclase activators and stimulators, he needs cyclic GMP to be there in more bioavailable form, and he needs phosphodiesterase 5 inhibitors, which allow the cyclic GMP to be present in the smooth muscle cell. And we have this in our armamentarium today in the form of medicines like pharmacotherapy, like sildenafil, tadalafil, sildenafil, and vardenafil. So evidence that endothelial dysfunction is there is proven by presence of endothelial microparticles. So penis has now become the barometer of the endothelial health. And erectile dysfunction is nothing else but penile angina or penile attack. Mechanisms why endothelial gets disturbed is because of apoptosis. We all know about it. There are a lot of other stimuli like as oxidative stress, endoplasmic reticulum stress, metabolic stress, genotoxic stress, and so many other things. The main important thing we need to understand is the endothelium-derived nitric oxide has now been proven to be an anti-atherosclerotic molecule. It is also an anti-thrombotic molecule. So that's what is very important we need to understand, because of which the whole issue begins. So when we say ED is nothing but a barometer of men's health, and we have 4 deadly quadrant of patients who have endothelial dysfunctions. These are diabetics, hypertensive, obese, and dyslipidemic. And 70% of men whom we see with erectile dysfunction all have comorbid diseases like cardiovascular disease. And a man who gets erectile dysfunction is associated with severity of coronary artery disease, which is an Indian study. And the onset of ED precedes the symptoms of coronary artery disease by at least 2.5 to 3 years in most of these patients. So we have this much time to counsel our patients to reduce his reduce his metabolic syndrome, correct his addictions to smoking, alcohol, etc., and give him all the advices on lifestyle measures and correcting all the metabolic syndrome to retard the onset of critical events like myocardial infarction or stroke in him. So hence here, I would like to say that asking a history of erectile dysfunction as early as possible is very, very important in all our diabetic patients. So the triad that erectile dysfunction, endothelial dysfunction leading to cardiovascular disease is proven beyond. Now let me give you another important aspect of it. Cardiovascular disease is an important and most leading cause of mortality on death. And Indians die 10 years earlier than the other people across the globe. 50% of mortality in the non-communicable disease is due to cardiovascular disease. We all know that erectile dysfunction is the earliest marker of myocardial ischemia. Montessori in his artery size hypothesis has clearly proven this. So there is wealth of compelling evidence that erectile dysfunction is a risk factor for coronary artery disease. So I call it penile attack equates heart attack. So today, let us see what are the causes of erectile dysfunction. It can be psychogenic, it can be vasculogenic, neurogenic, hormonogenic, drug-induced, and even genetic. Most of the common causes we see are either psychogenic or vasculogenic. Now, how do you differentiate between psychogenic and organic causes? If your patient is less than 40 years and if he's getting morning erections, please ask one simple question: that do you get erections when you get up in the morning in last 10 days or 15 days or a month? If he says yes, he has psychogenic erectile dysfunction. He does not need PDE5 inhibitors or any medications. All he needs is a good counseling. Diabetes, friends, is a sexual health tsunami of our century. Diabetes decreases the nitric oxide bioavailability. It also increases the capillary basement membrane thickening. So that's why we see a lot of diabetics, mostly every diabetic suffering from erectile dysfunctions. Hypertension also causes erectile dysfunction, and antihypertensives add salt to their wounds. We have to avoid beta blockers in this. In case if you have to give beta blockers, please give nebivolol. Diuretics again cause harm, cause sexual dysfunction in younger patients. If at all we have to give diuretics, give them indapamide. Amongst calcium channel blockers, amlodipine is good, we do give it, but best is to give cilidapine. Cilidapine with its pleiotropic action has also now proven to be improving the endothelial functions. So how do we treat erectile dysfunction? We have first line as oral therapy and counseling. Second is injection of papaverine in the intracavernous tissue and counseling. Vacuum therapy, intraurethral prostaglandins and counseling. Surgery, if all the first and second line of treatment fail, we send our patients to urologists who do penile implants or anastomosis. But counseling forms the mainstay of treatment for erectile dysfunction till date. So we have 4 PDE5 inhibitors: sildenafil, tadalafil, sildenafil, vardenafil. All are very effective. All have their own, all have a very, very good pharmacokinetic actions, but the duration of action. But for the best for diabetics is to give them a small dose, 5 milligram of 10 milligram of tadalafil on a long-term basis. It really, really improves their sexual functions, and they start getting early morning erections, physiological erections, etc. We have a lot of other therapies also. Do we have something to give to our patients who do not respond to PDE5 inhibitors? What we are doing is, by giving PDE5 inhibitors, we are just forgetting that we are not focusing on the desire, which forms the foundation of a male sexual response. And desire is, so there exists a therapeutic gap. She has a desire and he does not have a desire. So the desire is mainly because of free testosterone, which is the drive hormone or the libido hormone. And all diabetics are testosterone deficient. We have phytonutraceuticals which we can give, because giving synthetic testosterone, we are putting them at a risk of cancer of prostate and heart failures or azoospermia in younger people. And giving them L-arginine with fenugreek also produces endogenous testosterone in them, which increases the desire. It displaces the testosterone from the bound globulin and albumin, and raises the doubles the free testosterone. This is a medical food. What is the science beyond nitric oxide? What does nitric oxide do? Basically, it expands the blood vessels by 26%. This also gets lowered as we age. So it is ethical to give L-arginine to our diabetic patients, because we know that there are nitric oxide levels decrease by the age of 60. They will have only 15% nitric oxide left. So there's nothing wrong in giving to our patients L-arginine and fenugreek combinations, which can take care of nitric oxide in their body and also improve their desire of this. So if you do not have nitric oxide, you cannot have sex. And nitric oxide, you get it from L-arginine. Enough studies to prove that if you supplement L-arginine to your patients with ED in diabetics, they have shown better improvement in erectile dysfunction. A lot of studies to prove my point. Let me give a newer perspective, my last aspect of my slides. There are 5 cities across the globe where people are living more than 100 years. These are called longevity hotspots. They are in California, Italy, Japan, Greece, and Costa Rica. Dan Buettner, who's a National Geographic scientist, have identified these blue zones. And he went and studied these people, stayed there for months together, and found out why they are living sexually active for more than 100 years. So we need to understand, we are also going to grow above 60 years. How do we want to live 60 plus gifted years? Do we want to live in autonomy, dignity, grace, and be sexually happy? Or do we want to be diseased, depressed, dependent, unhappy, or sexless and emotionally crippled? The choice is with us. We need to bridge the gap between the lifespan and the health span. Is it possible? Yes, it is possible. Now, let me give you my ethical perspective of what I'm going to say to you. Loneliness and social isolation are the risk factors for coronary artery disease. We all know about it. The key to keeping good sexual health and the key to understanding what actually you do to see that erectile dysfunction can become a correctile dysfunction for your whole life is, we know about DPP results. For 15 years, patients were put on diet and exercise and patients improved without taking medication. So diabetics was reversed. Even recent study by Dr. Paresh Dandona says that diabetes can be reversed. Direct trials, so many studies are saying that diabetes today can be reversed. So the important cause of erectile dysfunction can be reversed. Metformin is now shown to improve the endothelial health and erectile dysfunction. It is also given as an adjunct. My study, SGLT2 inhibitors, is a novel approach, because what SGLT2, Arvinda beautifully explained, it improves HbA1c, patients reduce weight, hypertension, dyslipidemia, everything is brought under control. So all the vasculogenic causes, which are the common causes of erectile dysfunction, they all improve just by giving them the medicines for diabetes. So here in these patients whom you give SGLT2 inhibitors and metformin, they don't need additional drugs like Viagra or PDE5 inhibitors or any other surgical procedures. Dr. Dean Ornish beautifully studied 48 patients with complete blocks on lifestyle measures. What he did, he put them on 10% fat, whole food, vegetarian diet, aerobic exercise, stress management training, smoking cessation, good psychosocial support for 5 years. And he found that their blocks improved, their blocks opened up, and they had a good quality of life. They started getting good erections. Genes, we are worried about the genetic issues. We say, oh, this is genetic, how can it go? No, 20% of how long an average person lives is dictated by your genes, and 80% is dictated by your lifestyle. It has been proven. And 30% variance in life expectancy is due to genes, and 70% lifestyles are important. So if lifestyle is very important, it can also show that even if you have genetic problems, this can be corrected with these things. Epigenetics, biological mechanisms that will switch genes on and off by life circumstances, habits, exercise, nutrition, telomere shortening. When we see studies have linked unhealthy lifestyle factors such as smoking, sedentary lifestyle, poor diet with telomere shortening. This shortening is associated with cellular aging. So all these things can be reversed today. What are the risk factors? The commonest risk factors are all behavioral risk factors which we see today. They are tobacco, smoking, low physical activity, and dietary factors across the globe, not only in India, but all over the world. And the risk factor burden in India is nothing but hypertension and dyslipidemia and diabetes. And we see blood pressure also is very, very, I have yet to come across a family in whose family there is not 1 or 2 patients of hypertension. So this has to be brought under control. The onus of good sexual health of our patient lies with the physicians. We need to see that at the age of 30, these patients reduce salt, oil, and sugar to reduce hypertension, dyslipidemia, and diabetes. Now, this beautiful paper by Benjamin and Prabhakaran says there is look at the green bars. They show improvement in smoking, improvement in BMI, improvement in physical activity. I find gyms everywhere in Mumbai. Every lane has 2 or 3 gyms. So people are aware, they are doing a lot of exercises. The lipids are improving, the blood pressure is improving, the diabetes is also improving. But still, the cardiovascular diseases are on the rise. Why it is so? When there is so much of improvement across the globe, improvement in every risk factor, what is important is look at the red bar. What is important is that we do not have a healthy diet, which is important. That is why we have increased risk of cardiovascular disease in our country. Let's think deeper. And a nice paper or a review or a study done by Cleveland Clinic by Esselin, he says that we send our patients for bypass surgery, for angioplasty when they have blocks, etc. Well, they do improve, but they are not therapeutic, they are not curative. They will improve at that time, but they do not stop or halt the onset or the progress of coronary artery disease. When they did give nutritional intervention, they found that these patients in their perfusion studies showed complete opening of the myocardium. Look at this big plaque. Without stenting, they have opened up the artery just by lifestyle or nutritional intervention. So nutritional intervention is the key, plus correcting all the metabolic syndrome which we have, avoiding smoking, avoiding stress is the key to having good sex life for our patients. So So the doctor of the future will no longer treat human frame with drugs, but rather will cure and prevent diseases with nutrition. So my take-home messages to all of you is the onus of sexual health of our patients lies with us. We have to ask one simple questions to our patients that do you have problems in making love? It will open up a Pandora's box. You will be surprised that your patients were waiting for you to initiate a dialogue on this aspect. So don't forget to ask these patients to every male or a female or a couple who about 30. Take a detailed history of everything. The 2018 revision of the process of care model of management of erectile dysfunction says that you need to counsel. First line of medical therapies, counseling is very important. Before you start giving them therapies, counseling is extremely important. 17 years we have given PDE5 inhibitors to our patients. What have we learned? We live in an era where multiple drugs are given by our physicians, etc. But every patient needs to be given a tailored drug therapy, and because they have expectations. So what they need is adequate counseling to each patient is equally important to improve the adherence of the therapy for their patients. So now the treatment modality is first line is oral therapy, counseling, and lifestyle measures. Similarly for second and third. So lifestyle measures have been added in the therapy of erectile dysfunction, which is very important. So oral drugs may be important, but what is more important is counseling and lifestyle measures. What is lifestyle? It should be a medicine. You may be Hindu, you may be Muslim, but make lifestyle as your religion. You to have plant-based food, 150 minutes of walk per week, sleep 6 to 8 hours, avoid certain medications, avoid smoking alcohol, reduce your stress in whatever way you can, increase your psychosocial attachment, and use supplements like L-arginine and fenugreek. All metabolic diseases can be reversed with lifestyle measures. Avoid smoking, do little workouts, sleep deprived. We did a study in JJ Hospital. All the doctors were sleep deprived. And when a patient was sleep deprived, the sizes of the testes decreased. We did it with orchidometers, the studies, and we found that their testis size has reduced from 25 to 15 ml, the volume of the testis. And once the volume of the testis reduced, you know what can happen with the functions. Yoga is very beneficial. Try any relaxation technique which you can. But remember one thing, my last few slides, a woman is a masterpiece of God. She needs to be adored, admired, trusted, and respected. Feminism needs to be adored, admired, trusted, and respected. If a man who doesn't adore, admire, trust, and respect feminism, I pray to God that he should get permanent erectile dysfunction. Look at what Mahabharata is. Look at what Ramayana. What do we study from all these things? Yes, we need to trust and adore and admire feminism. What is the secret of being sexually happy? There is nothing secret. There is the understanding is that our sexuality is ever evolving. It changes. What felt good to us one time may not feel good at another time. Our desire may be high on one time and may be low at other time within relationship, within ourselves. So we must try to reclaim our pleasures. We must prioritize our pleasures. We must give time to our partners. We must adapt and adopt lifestyle measures. This attitude shift is very, very important in all our patients, including ourselves. So the secret of sexual fitness is you need to love yourself. Avoid salt, oil, and sugar. Choose lifestyle modifications. Have a regular rhythm of sex life. Be connected with your partner all the time. Touch is very, very important. We find couples hardly touching each other after a certain age, which is so wrong. Unless we love and are loved, each one of us is alone and deeply lonely. Friends, wrinkles don't hurt. All PDE5 inhibitors which are there, they do not increase the desire. And we have 40% of patients who are non-responders. The badsha of all testosterone we give for desire, but we need to give it with caution. We can give it in a short course, a dose of testosterone on everyday basis, but on a short course. But we need to take care of azoospermia. We need to see that if we give it to younger patients today, gymnastics, younger boys, they all are azoospermic. So that should not happen. Heart failure in elderly patients, prostate issues. We should not invite trouble for all of them whom we want to give them good sex life. So the Raja of all today is, amongst the therapies, is L-arginine, fenugreek, and lifestyle modification. Look at his fingers too. So nutraceuticals and lifestyle modifications are the key to keeping your patients healthy. Even female sexual dysfunctions, all the pro-inflammatory milieu is changed. Insulin resistance improved, oxidative stress improves, endothelial dysfunctions improve, and there is reduced burden of sexual dysfunctions in these patients we have seen. So one must understand that we have a life because we are born and one day we are going to die. Do anybody have a choice beyond this? No. But whatever happens to us between birth and death is all because of the choices we made. So we have wisdom. So let's make right choices. This is a beautiful thing which we all need to understand. We need to choose lifestyle modifications. All dysfunctions, erectile dysfunctions, may be due to any cause. They're all modifiable. All can be halted and reversed today. So erectile dysfunction is a correctile dysfunction with lifestyle modification, nutraceuticals, and correcting the metabolic syndrome. If you have patients of erectile dysfunction, please don't send them to quacks. You evaluate them. If you cannot, send them to good sexologists like me. We will see that he gets a good erection, and we'll correct their all metabolic syndrome, and we give them good sex life. Friends, this is my book, Sex Has No Expiry Date. If you could read it, it's available on Amazon. My last slide. Erectile dysfunction is the tip of an iceberg. Is the earliest marker of coronary artery disease. It is an endothelial dysfunction. L-arginine supplement with fenugreek is a boon. A heart that loves is always young. Age, weight, height are just numbers. Lifestyle measures can reverse the metabolic syndrome. Erectile dysfunction, hence, is a correctile dysfunction. And if you correct your dysfunction, friends, your sex will have no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have.
Dr. Arvind, can I come in?
Yeah, please.
Sir, there's an age-old, I think to begin with, I think we should thank Dr. Jumani sir for giving such a in-depth scenario of what is happening. So there was one old saying when I was young, it was, I had read that the sex lies between the ears and not between the legs.
Absolutely.
So, and that is what you reaffirmed today. It's a wonderful talk, sir. Thank you for taking your time out from your busy schedule and helping us out. Thanks, Dr. Arvind, for having us all of us glued to his talk. He was so passionate when he was talking. That's really appreciable. Thank you, sir. Thanks a lot.
Thank you, Arvind.
The whole idea is like when Dr. Deepak Jumani speaks, there will be a lot of humorous along with the science. That is most important thing is there. So most of his slides and presentation and the way he delivers the talk is most admirable across India. I'm sure all of you would have enjoyed this. Like, because we always think that the sex is an issue where it is neglected, because when you ask the history in our patients as well, whenever that in my proforma also, in my hospital proforma also, we have got that history. Whenever there is the question to be asked, there will be so many issues to be discussed, because there will be so many family members or the children or somebody will be there. So there will be some hesitance in openly asking that. At the end, when they were gone out, I'll be asking this question just to fill the proforma. Then we come to know there is so many problems to be addressed. Then once they come back with the reports, we address the issue. There will be always an initial hesitancy in coming out with this. But once you open up and as a doctor you ask them, definitely they come out with their various issues and they'll start discussing. So when they start discussing, they feel very comfortable. They give importance in diabetes management, blood pressure management, as well as the dyslipidemia. So when all these things are corrected, as Dr. Deepak Jumani rightly pointed out, the erectile dysfunction is a correctile dysfunction. Thank you so much, Dr. Deepak Jumani, for being a part of our conference and giving a wonderful lecture.
Thank you all the chairpersons for the time.
Thank you, Dr. Abhyuday and Dr. Swaraj, for chairing this session. Thank you so much. So next, we have a final batsman and the final talk of our conference. So just before the conclusion, before the final talk, I'll say to a few words because all of you are here. So it's very, from Dr. Arvind Diabetic Center, Bangalore. We wholeheartedly thank for all of you being a part of our conference. I sincerely thank from my heart. So especially our chief patrons, Dr. V. Mohan, Dr. Munichudappa sir, our organizing chair, Dr. Banchi Sabu, Dr. Shashank Joshi, our mentors, Dr. M.A. Shekhar, who was there since yesterday continuously, along with Professor Basangodappa sir. Thanks for all your encouragements. Our national advisors, all because of all of your support and encouragement, we kept this conference going on, and it was a successful one. So you can see Dr. Shekhar still attending the last talk as well. So thankful to him. And in fact, he has suggested me a few topics, like the two debates topics, like had, that is atherosclerotic diabetic dyslipidemia, and yesterday's we had one more debate which was suggested by Dr. Shekhar only, and which was widely appreciated debate. There was, it's not a debate actually, it's a total science which was involved. And not to forget, like I'd like to thank our pharma partners who helped in the success of the programs, in registration and all those things, because without the pharma partners, the success of the conference is not possible nowadays. So I thank wholeheartedly USV, Micro, Novo Nordisk, Acumentis, Sanofi, the Biocon, Sardia, Eris, Wockhardt, Torrent, Corona, Ipca, Boehringer Ingelheim, Sun, Intas, Abbott. In all these pharma people had joined for the success of this conference. Though it was a virtual conference, though they had some inhibition from their things, but they did their best to in the success of this conference. Thank you so much for all of you. Now over to the last session by Dr. Praveen R. So he'll be talking on the balancing the evidence and advantage of biosimilar insulin. To chair this session, we have two dynamic young diabetologists from Bangalore. One is Dr. Praveen Gangadhar, practices in Dr. V. Mohan's Diabetes Specialty Center. He's an young upcoming diabetologist who is very active in academics. Nice to see him seeing him practice and coming into the forums. And next is Dr. Preeti. Once again, she is an young diabetologist, always active in academics. I have seen her in so many conferences participating actively. That is very important as an upcoming diabetologist. And they in the future, these are the people who will carry on the diabetologist field in Karnataka as well as in India. So over to Dr. Praveen and Dr. Preeti for further proceeding, please.
Thank you, Arvind sir, for this whole opportunity as well as introduction. It has been a real academic feast over the last 2 days and a great learning curve. So coming to the topic, it's a very last but not the least, the important one regarding the balancing the advantage of biosimilars in our evidence as well as the usage in our daily practice. We all know in our country, cost is an important factor, and in patients who require multiple daily injections, a cost-effective options is a very important choice to have a right compliance in their therapy. So to discuss further, we have Dr. Praveen R. would be giving us the insight into this topic. Thank you.
A warm good evening to all of the international delegates present here. I would thank Dr. Arvind, rather congratulate him on this successful diabetic symposium that's going on. So without much delay, let's invite Dr. Praveen Raj, who's the Associate Director, Medical Affairs, Biocon. So over to you, sir.
Thank you to chairs, and thank you, Dr. Arvind, for inviting us. It's a really pleasure to be on board to talk on this very important piece of the biosimilars from the current perspective. And it's been really pleasure for the last 2 days to have this kind of scientific treat. Considering the time, I will just move ahead with my topics, and I hope my screen is up and live.
Yeah, visible.
Thank you. So the topic for the current, the next couple of minutes, I would like to put across that the balancing the evidence and advantage of biosimilar insulin in the diabetes management. So I would not take much time in understanding taking us through the biosimilar perspective, but when I say about biosimilar, it critically talks about the 4 critical aspects or the pillars in the diabetes. One is biosimilar is a biological product, and it is highly similar to the reference product. It is not that copy paste of what we have been doing, but yes, it is highly similar. Being a proteinous subject, it has got a primary structure, secondary, and the tertiary structures. Now, it has got no clinically meaningful, significant difference with the reference. And when I say it has been FDA approved, it undergoes a rigorous evaluation and testing. These are the 4 critical aspects. I would like to make a pitch about the biosimilar, where now there's a new concept called as the totality in evidence is coming up. So that makes a call very clear. It is not by saying that I did a phase 3 study and I got an approval. No, it is not so. The regulator checks the analytical studies, the animal studies, the clinical studies, and it undergoes a rigorous review. Followed by approval, it actually goes into a post-marketing studies. That's how we say that it's called the totality of the evidence. Now, or the biosimilar insulins is the way forward. The question being put across. Now, I would not talk about yes or no, but I would leave it to the physicians amongst us where they can take a clear-cut pitch on that. When I say biosimilars, the rationale for it is that in US, I'm just trying to put a data which could save around $40 billion to $250 billion in the next 10 years. Is it the same in India? The question is, yes, I would like to refer to one of the author who published the study from Chennai. It made a very clear-cut impact. Even in India, there's going to be a huge cost saving, and it's going to be accessible and affordable because it is lesser of cost. And the moment when I say it's been lesser in cost, and yes, it's making a price check in the competitor's mind. So it is not me, it is the many other who is going to come on board, who is going to make the drug more affordable and more accessible to who really need the drug. Now, considering this as a discussion, let me put across what is the guideline, because when I say it as a guideline, not every country has got a specific guideline about biosimilar, but yes, the Association of British Clinical Diabetologists, the reason for me to quote that, the British Clinical Diabetologists, is that because we all know what is the healthcare sector in that particular scenario, they really put a pitch. The article got published in 2018, which clearly states that consider a biosimilar insulin as a first treatment option for insulin naive patients, where they represent the cost effective advantage. Now, is it only for them? Let me put across the swing in that. It also supports a biosimilar insulin for all newly diagnosed patients with the type 1 who have not been exposed to a reference. And also in patients with T1DM who require the therapy due to poor control, you can still shift from a reference to a biosimilar insulin. So patient can expect a similar blood glucose lowering effect and safety profile as that of a reference. That's been spoken about by the British Clinical Diabetologists Association. Now, what is the need for biosimilar insulin? I am not going to touch upon the slides because considering the time is critical and it has been spoken in various topics of today and yesterday. This is something which I would like to put across. Though a bit old, what it clearly spoke about is the 50 most life-saving breakthrough in the history, where insulin is talking about it has saved almost 15 million lives, starting from smallpox, including pasteurization on the technique. It also captured insulin is one of the critical element which could really save life, which we all aware of it. When I say insulin is when it's critical, but is it being affordable? This is the data which clearly talks about. If you could see that amber colored line, which actually talks about the price of insulin, which steadily went up from 2006, 7, 8, 9. The prices have tripled compared to the various drugs used to treatment of diabetes. That's actually making patients not affording to the therapy. I am not getting into this left hand side considering the time is critical, but I would like to focus something about the right hand side. Dr. Sanjay Basu has actually written an article. They did a mechanistic calculation saying that if insulin is affordable to everyone, what it could really bring on to the table. If you could see this, when you achieve a A1C of 7 with insulin across, with accessibility, with affordability, we could able to prevent almost 3,31,101 DALYs, the disability adjusted life years could be saved by year 2030. That is the potential what we are actually up to. When I say all this, the biosimilar, the relevance of insulin, as a strong contender from Indian perspective, we are very proud. We did a study across the globe, though starting from India, but yes, we did study in US, we did study in Europe. Obviously, yes, we did a study in India and Japan, Malaysia. So across the globe, yes, we did a study. I will not take you through the entire aspect of it, but what is the message I am trying to put across in the couple of minutes is very critical. This is the key global studies what we have done, INSTRIDE 1, INSTRIDE 2 and INSTRIDE 3. INSTRIDE 1 has been done on type 1 diabetes, INSTRIDE 2 on type 2 diabetes and INSTRIDE 3 on type 1 diabetes. I will take you through the couple of minutes about what is INSTRIDE 1 and what is the message it's coming out. And these are the trials which we actually portrayed to US FDA for the approvals. INSTRIDE 1 is done on type 1 diabetes. Around 560 patients have been taken. The inclusion or the selection criteria is as per that recommended of patients with T1DM of 18 to 65-year-old, and those who are already on once a day daily glargine with HbA1c of lesser than 9 with a BMI of 18.5 to 35. Looking at the study design, we did the randomization with 1:1. We divided into 2 groups. As I told you, it's a randomized open label. I cannot do a closed label study because the pen has been given. So I cannot do a closed label. So it has to be an open label study. So we did a 1:1 randomization with the arm receiving a biosimilar insulin glargine with a Lispro being type 1 diabetes. Similarly, the arm B received Lantus plus Lispro. We ran up almost for a span of 1 year. What came out in the 1 year is very critical. From baseline to almost 1 year, the HbA1c, you could see the lines ran parallelly. It did not differ. It did not have any significant change. At the same time, as a basal insulin, yes, FPG is very critical. Yes, you could see that lines again. You don't really appreciate the 2 lines, but yes, at some point you might appreciate 2 lines, but yes, the lines are almost superimposed to one another up to a span of 52 weeks. And that's where we conclude that the Biocon's insulin glargine is clinically equivalent to the reference insulin. And yes, the safety part is already addressed, saying that the incidence or the types of AE or SAE is similar between the 2 arms. This is from the type 1. Can I able to extrapolate to type 2? When we went and spoke to the regulators, they said like, no, you need to do one more study to show that in type 2 population. Yes, we did that for INSTRIDE 2 study. Again, a open label, randomized, multicentric study in type 2 with 560 patients, powered enough to prove that we are at par, where the patients were stabilized a dose with OAD. 80% of them were with OAD, and almost 20% those who are with a stable dose of reference insulin glargine with the HbA1c of less than 10.5. Now, what we did try and seeing this, you could see that we did a randomization, 2 arms again, the biosimilar insulin arm and then the reference insulin arm ran up for a span of 24 weeks. And then this is what you could see. Best screening, baseline, and then to till 24 weeks, you don't see any difference between the 2 insulins that is a biosimilar insulin and the reference insulin. So there is no significant difference between from the HbA1c window. This is very important. The reason for me to tell you is I can achieve the same HbA1c by increasing the dose of glargine. So now they also very clear in asking what is the dose of glargine being used to have the same HbA1c. You could see that yes, the reference and the biosimilar insulin almost use the similar insulin range to bring at the starting from the baseline till to a span of 24 weeks that could have the same HbA1c efficacy endpoint as a primary endpoint. So ultimately, yes,
Excuse me, Praveen, you're running short of time.
Sure, sir. And another couple of slides I will be run through with another 3-4 slides. Thank you very much for putting it across. And yes, biosimilar insulin glargine is equivalent to the reference insulin glargine type 2 diabetes. I'll come up with my last slide, which talks about the INSTRIDE 3, nothing but the switching arm. Here we have type 1 diabetes with 127 patients, where you could see the design. Those who are completed, those who are having Lantus, we split them into 2 arms. This Lantus arm ran up for a span of almost 36 weeks. But here in this arm, we switched from Lantus to biosimilar insulin, and from biosimilar insulin again to Lantus, and then again Lantus to biosimilar insulin. What did we prove while switching is very important. You again don't find any difference in the HbA1c, and then with respect to the fasting plasma glucose, no significant difference, and the SMBG values again between the 2 arms, you don't find any difference. That's where I conclude by stating that there is no difference between the biosimilar and the reference insulin glargine. And this is where we have traveled. And from India perspective, almost more than a decade we are in India, and we went up all the way and launched up a molecule in US FDA or US by 2020, and we are almost 28 countries across Europe and Australia. That's where I conclude. Thank you very much for the time, sir.
Thank you, Praveen, for that wonderful presentation and giving us the insight on the biosimilar glargine. And also congratulations for those approvals you have shown us. I think most of us would agree that we do have the similar experience even in our practice. Even when sometimes you have to switch the basal insulin, the efficacy and the HbA1c sometimes is maintained. So that is something, it's always a welcome change. Thank you.
Dr. Preeti, anything to add up?
No, sir. It was a wonderful presentation.
Thank you, Dr. Praveen, for the wonderful talk. And thanks, Dr. Praveen Gangadhar and Dr. Preeti for chairing this session and for being the part of the conference. Thank you so much. Thank you. So that's bring to the end of this conference. We had a 2 days of full scientific extravaganza, starting from yesterday 2 o'clock to evening 9 o'clock. Today morning, starting from the postgraduate diabetes thing till now, we had an exclusive scientific sessions. Thanks to all the faculties and delegates to be part of this event and making this event successfully. But with not to forget, like without any delegates, any conference will not be as successful. We were able to see 2,670 registrations overall till now, and at yesterday the highest peak logins was 1,300 at a time. 1,300 logins were there. Today morning for the debates time, around 1,200 logins were there at the time. And for Dr. Jumani's session, there were logins of 900 logins. So that is the total success of the conference, I should say. All this is because of your presence and your blessings. So this conference has been successful. Mainly contributions from all my professors, especially Professor Basan Godappa, Professor Shekhar, who has been the backbone of this conference. Especially Dr. Shekhar has given us so many insight and so many ideas about the ongoings of the conference. He used to tell me the various aspects to be included in the conference, especially when it comes to the scientific topics, as well as including the postgraduate activities. So that makes the conference full. His idea was much appreciated and well taken in this conference. I thank wholeheartedly Dr. Shekhar sir for being a part of these things. And Dr. Basanagowda sir is my professor, and he is always in the encouragement, like in the sense whenever I say in any doubts I ask him, he'll be there at any point of time. He'll support me with all his encouraging words. And not to forget Dr. Vishwanath from Ramaya Hospital. Like anytime, like 11 o'clock, I used to go, Dr. Vishwanath, how is the preparation for the postgraduate diabetic? Like he still used to answer, and he prepared the whole idea, and he made the postgraduate diabetes league one of the innovative things which was done in this conference, and it was a huge success with this conference. And another with the background events is like Mr. Banu was there, who was there. He was my technical team, who was there to support me in all this aspect in doing folders and marketing, and all those things is done by Mr. Banu, who was the main person behind all these folders activities and marketing activities. And not to forget RX events. Did an amazing job. I'm sure all of you will agree with that. With led by Dr. Hardik, Ms. Neelam, and Darshan, Prashant, all of them did a wonderful job. We conducted this conference without any technical glitches at any cost. We didn't face any apart from minor things, but nothing major. All the international speakers were able to catch up. All the national speakers were able to do their presentations very comfortably. Thank you one and all. And I already mentioned the pharma people. So thanks all the pharma industry people, starting from the senior positions like president and vice president, till RSM, zonal sales manager, and till the medical representatives. All of them were be a part of this event. All of them took interest in conducting this conference and made this conference a fruitful one. Dr. Shekhar sir, anything to say, sir?
Oh, I'm full today. Yeah. I do not know if I can see a program like this again, but I wish many more will come from you. And I want to see you as an IDF president.
Sir, thank you, sir. Thank you.
Aim high. RSSTA is good, but IDF is better.
Yes, sir. Yes, sir.
I think we should give him a round of applause, sir. A big round of applause to Dr. Arvind.
Thank you. Thank you. We are thankful to all the international faculties as well. So Dr. Professor Nosy Yusuf, you can see still logged in and being a part of this conference. Dr. Tarek, Dr. Partaka, Dr. Nisha Naigil, all Dr. Nohi Hamad, all these were the part of our conference and made this conference a huge success. Thank you, each one and you all. Thank you. See you next year. Bye-bye.
Good night.
Bye.
Thank you, sir.
Thank you so much. Great conference. Thank you a lot.